Okay, good morning, everybody. We had a very productive workshops yesterday. We can start today the official program of the Congress. And just to remind you that tonight, this is the opening ceremony. And we expect some authorities, and specifically to the Minister of Health, Konstantinos Plevris, to welcome us. And afterwards, we have a very good organized night somewhere in the ocean, near to the ocean, with live music and very nice Cretan food. So, Venerino, this is your side. I leave the Grande Professore to chair the session.
I'm a little bit embarrassed because the smaller one.
No way.
Good morning to everybody. Many thanks for this invitation and thanks for having given me the opportunity to be in the cradle of our culture. I think this is the most important element to consider. And so we start with Vassilakopoulos COPD, an umbrella term.
Thank you very much. First of all, I would like to thank the organizers for the kind invitation to be here in this magnificent city. In fact, every time I visit Heraklion, it keeps on improving. So it is one of the most impressive changes over the years that has happened to Heraklion. I have a quite liberal title, which could likely require a whole week of small discussions for the beginning. But what I've chosen to do is just to take the new guidelines or suggestions by the COPD and try to figure out what is new. What are the changes over the last version of the guidelines, so that we could focus on this probably. And this is the pathophysiology, and I would like to mention, do you have any pointer?
It's not nearby the DC.
Oh, sorry.
Yeah.
My mistake. Okay, perfect. So, what is important here is that in the guidelines, they're talking about the etiology of COPD, and they mainly focus on smoking and pollution, but I don't know how this works. Okay, I'll do that. They're talking about, no, but it doesn't show here. No, the problem is you cannot focus it. I'm an idiot. Sorry, I don't know how it works.
Well, it's because we saw that.
Okay, anyway, let's not lose a lot of time.
The cable, maybe it's out of the. Yeah. Okay.
No. It is totally. You cannot focus it.
Yesterday was fine, but maybe something happened.
Okay, as long as you are trying to solve it, because we don't have a lot of time. Okay, let's move on. All right, I would like to focus here on something on the etiology. And I would like to say that we were used to think of COPD like the obstruction caused mainly by cigarette smoking. you had to smoke to have COPD. But nowadays, widespread in the guidelines and in the text explaining the guidelines, there is even a discussion of whether we can include patients that have obstruction really early on in their life, and even they don't smoke. And I'm really confused about that because, to my understanding, things are quite pathophysiologically different when you smoke and you develop the consequences of smoking. No matter what time in your lifetime, they are going to come based on the genes you're having and other host interactions. But when you have never smoked and you have just an infection in the early childhood that has made you have obstruction, spirometrically proven, this is quite a different type of obstruction, and I think we should really treat them differently. So, if I want to summarize, in fact, they have done the work for me. They are describing the changing they're having in various tables, the main changes. So, one of the changes that I would like to comment specifically is this specific figure, this specific table adopted from a paper from the ERJ that in fact describes how we should treat inhaled corticosteroids or patients with inhaled corticosteroids based on the eosinophils, and this needs a lot of discussion. Main points are changes in the vaccination proposals. Of course, now the COVID have been incorporated. Okay, this is something very, very clear. But what else has been added? The singles vaccination against zoster, which was not previously in the evidence, and of course the triple vaccination to include pertussis for whooping cough if you have not been immunized when you were in your childhood. And you see here that COVID vaccination is everywhere. And of course, all vaccinations are highly recommended, which means that we have to persuade these patients from the beginning to be vaccinated against all these either microbes or viruses. And in fact, that different countries have chosen different reimbursement protocols for vaccination does not mean that vaccination is bad for the rest that have not been reimbursed. It's totally different, the cost-effective analysis for the health system and what the health system pays, and it is quite another story what is beneficial for patients. Something really good is that we have started to focus on physical activity and how to improve physical activity early on. And of course, we have learned something from the very bad way, from the horrible COVID experience, that some measures like mask wearing, minimizing social contact, that is even worse, and frequent hand washing, which is good, is something that can prevent exacerbations and lead to better outcomes. Okay, let's move now to some points that are really interesting. One point is in the first chapter, the definition of early COPD. I apologize for the Greek slide. That was by mistake because as a usual Greek, I have not read the instructions in detail. And this is my fault, I apologize. But what I want to say is we have to understand definitions. What does the term early mean? If early means the beginning of the biological process, this is very good. This is something that should be used for COPD. It's the beginning of a biological process. But from the beginning of the biological process up to the moment that the derangements that have come out of the working of this biological process start giving symptoms or objective measures of derangements, like spirometric derangements. This is something different, and the suggestion is to use this term early for only the biological process and not for the start of either spirometric or pulmonary function derangements or development of symptoms. Then another word is mild, and myself, I was included in an effort of 6 societies to define quite earlier what is mild. And in fact, what the goal suggests is to abandon the name mild, because teleologically mild is something that then becomes worse and even worse. And in some or quite a few patients, they developed mild COPD without even ever getting into the worsening scenario. So it's not very appropriate to use the term mild, and this should be abandoned. The most confusing thing for me is this one, is the COPD in young people. And this includes people between 20 and 50. In the previous versions for COPD, it was clear it should be above 40 and 10 years of 10 pack years of history. But now we know that lung development peaks early on around 25, and you have different patterns of decline. In some patients that develop COPD out of cigarette smoking, you have a rapid decline, but there is another nearly 50% of the patients that develop COPD that in fact had never attained the maximum predicted pulmonary function early on, like at the age of 25. And then they started having not an accelerated rate of decline, but with a normal rate of decline, keep on smoking. They developed obstructions and obstruction, and this is the second subvariant of COPD. But to include other terms in there, people that have never smoked and have infections in early life, or other types of obstruction in this chronic obstructive pulmonary disease, teleologically ideologically might be reasonable because it's chronic, okay? It's obstructive, it's pulmonary disease, that's okay. But then pathophysiology might be totally different. If you have a severe asthma, you had a lot of infections early life, you have bronchiectasis, and you might be having chronic obstruction. Is it COPD in pathogenetic mechanisms? I'm not quite sure. This needs a lot of work to be done there. Of course, there's a term that keeps on coming and going out. It's pre-COPD. It's people that have just some symptoms, that smoke and have no physiological derangement. Sometimes it's included, other times it's excluded from these guidelines. A lot of things have to be done there. Let's go to chapter number 2, and here you have the impact of dyspnea and how we should search for dyspnea. And in fact, there is a clear statement that usually women present with higher levels of dyspnea compared to men with the same level of derangement and smoking history. For me, this is very reasonable. Women are more sensitive, generally speaking. But if you go to see how we can use that, it's quite impressive. Canadians made a real interesting study. And what they have done, they have compared the level of dyspnea as measured the Modified Research Council scale in patients with COPD, either COPD stage 1, spirometric stage 1 or stage 2, and then with smokers and with never smokers. And the interesting finding here is that you see that in mild COPD, stage 1 COPD, let's not call it only mild, stage 1 COPD, the percentage of patients that are having MRC scale 1 dyspnea is exactly the same with the smokers and even the never smokers. And it's only when COPD becomes moderate spirometrically that this thing changes, this percentage declines, and the percentage of patients with MRC2 and of course MRC3 increases, which means that people develop different symptoms, more intense symptoms, and probably they are going to seek medical advice quite a long way into the COPD story. And one good way probably to make an earlier diagnosis of these patients is to use, even in the primary care setting, the CAT score, which is much greater in these patients than in others. A very crucial point is now we have recognized in the guidelines that fatigue is very important, and we should really ask our patients about fatigue development, and if especially they have a lot of easy fatigue, they should go into rehabilitation programs incorporating nutritional support, and we'll come to that. Now let's go to the pharmacological therapy. Now, okay. The guidelines incorporate a meta-analysis of 9 studies of pharmacotherapy showing that if you start pharmacotherapy, you reduce the rate of decline of FEV1 early on compared to placebo. And these are the forest plot. And to my surprise, in pharmacotherapy, you have N-acetylcysteine, which of course does nothing for decline. But no matter if you include this study, which I don't know how it was included, the average is these 5 ml per year. If you include only inhaled corticosteroids, that according to the rationale of Gold for many years was really killing people out of pneumonia, then you gain 7 ml per year. If you do bronchodilators long-acting, you gain like 4.9 ml per year. So if you add the famous low-dose theophylline that I remember to be discussed from the time I was very young, like a resident. Unfortunately, you can do nothing. It's a busy slide, but the central message is no matter when you add it, at what dose, you get nothing. And for all of us that have done also basic research, this is a very good example of the thing that what you find in the cell culture system might not be applicable to humans, or it is ages away from what happens in humans, and it is only hypothesis generating. Okay, now let's go to the eosinophils, and there is a clear here discussion, sorry for that here, that, look, if you are between 100 and 300 eosinophils, then you might consider using inhaled corticosteroids. You should never use it against the use if you are less than 100, which is something that I totally agree, and it's strongly recommended above 300. Then, sorry, but what's this here? Okay. Then I went in one of the 3 studies, let's say one of the 2 studies, or of the many studies that have tested the use of inhaled corticosteroids superimposed on LABA-LAMA combinations on double bronchodilation, and the effect of eosinophils. So when they modeled the effect of eosinophils, this is the impact study, the same holds true, exactly the same for the ethos study. Look, something interesting. When you start getting out of 100, the reduction in the exacerbation you are having is 11%. And it is gradual, exactly the same in ethos. And I don't have time to discuss it probably in the next session. The FLAME trial that was so influential in shaping the GOLD guidelines for 5 years, had found a reduction using LABA-LAMA combination in the catarrhol glycopyrronium versus salmeterol and fluticasone propionate of 12%. The reduction they got was 12%, and that was enough to change the guidelines. Now the reduction is more than 11% progressive, but between 100 and 300, which is like 25 to 30%, they are not sure what you should do. But if you want to compare double bronchodilation with LABA ICS, they were sure. I'm quite confused. Now, what is very interesting is that now they say that recent data suggest a beneficial effect of adding triple therapy versus LABA-LAMA combinations on mortality in symptomatic COPD patients with a history of frequent or severe exacerbations, which is something unheard of to be included in these guidelines. They have specific suggestions when to consider replacement therapy for antitrypsin, but they have also something very important, and we're far here in Greece from achieving that. We're very underdeveloped in terms of pulmonary rehabilitation, and this became very clear now that we have the COVID. Very few centers have developed rehabilitation programs, and this is really very bad. But look what they have found published in JAMA. If you start rehabilitation early on, which means within 90 days after you go out of the hospital after a COPD exacerbation, then you have a decrease in mortality. And if you delay rehabilitation, this increases mortality. So it is something that which all pulmonary physicians in Greece should start thinking of how we can implement this. And in fact, what is interesting is a Cochrane analysis saying that telemedicine is equally effective with direct telemedicine rehabilitation using all the modern technology is equally effective with on-site rehabilitation in improving outcomes. No real change. Okay, there were some funny things like how good is Tai Chi in COPD patients. I don't know what about karate. Okay, but Tai Chi is an old technique, very good for these patients. One very good, very important thing is nutritional support. Very conflicting results, very conflicting data, but you have quite a lot of patients that are malnourished, and these patients are having bad functional status. If ever they are intubated, it's very difficult to win them from the ventilator. So we have to work there through a combination of nutritional support and rehabilitation programs. Now, I finish with the shielding measures, which is, to my understanding, very important. Probably out of this, I'm not in favor of social distancing, but at least COPD patients should start thinking of wearing a mask when they're in crowded places without their friends. That might be a good choice for them. And also, lung cancer screening, it is suggested with low-dose CT, and in fact, the recommendation has changed now. The age is not 55, it is 50 years to 80 years, and not 30-pack years of smoking exposures, but 20-pack years. This is enough to start doing this. And what is really impressive is the percentage of patients that have been documented of having bronchiectasis. Like half of the patients on average in various studies are having bronchiectasis. These are patients that are having nearly worse outcomes. There is a working group that we are glad that we have two Greek fellows in there. I apologize. Okay, and they have done very nice work trying to score the problem, to develop a tool to score the problem. This is the tool that is having radiographic criteria, spirometric criteria, but also symptoms. And of course, I will repeat that COVID vaccination is imperative for these patients. And with that, I would like to finish and just to invite you to our small respiratory failure congress that will be going to take place in the Lake Plastira after Greek Easter. Thank you very much for your attention.
Thank you very much. I think we'll have discussion at the end. Or will you want to hear? We have discussed something more.
I think the discussions are here. I want to have a comment.
We have discussed
Any of the discussants wants to make a comment? Just a short comment.
Thank you very much, Professor. You accurately covered all the topic. The only comment I have to say, I think that I agree with you that we all, as a clinical doctor and the scientific community, we have to give an extra effort and big attention to identify the patients covered in 10 early COPD. Thank you very much.
I would also like to make a comment for pre-COPD patients that therapy should be considered for those patients, and spirometric findings, whenever and if they are normal, may not may not stop the provision of therapy to these patients.
I'm not sure that I totally got that. You mean that we should start giving drugs to patients with no spirometric derangement?
No, yes, probably I was not very clear, but antibiotics and vaccinations, I mean this kind of therapies.
Yeah, but the most important thing for me is smoking cessation in these patients.
And
this is the
non-pharmacological interventions. Yes,
this
you're
is
right.
the most influential intervention.
Can I make a question here from Athens?
Oh.
Good morning.
Good morning.
Comment? Go ahead.
Good morning, everybody. Thank you for the invitation. I would like to make a question to Professor. Despite the annual recommendations, COPD recommendations, and the changes in the definitions, the big issue is always the appropriate treatment. So I would like to ask when, I mean at which stage or point of the course of the disease, triple therapy could be considered as a first-line choice and not as an escalation therapy in patients with COPD.
Okay, this is a really easy question.
Another lecture.
I will try to answer that in the second debate. No, I'm not talking about science, but about personal bias. This is my personal bias. What I'm telling now is that the earlier we institute aggressive treatment in COPD at a phase that we have a lot of inflammation and less destruction, the more likely it is to change the natural history of the disease. But this needs randomized controlled trial proof, which is very difficult to implement. And because we have some very important people here in the audience, like Professor Siafakas, who used to be president of the ERS, Professor Poletti, I think that the big problem that we're having as a respiratory society in contrast, as opposed to cardiologists, is that we don't really design and execute randomized controlled trials, not driven by industry, but driven by science to answer these questions. There could be no real pharmaceutical company that is going ever to invest in a study that lasts 10 years or 7 years to prove something, because then they lose the patent, and we have to do that. Sometime we have to come to that level of organization to do that.
I fully agree with you. The industry is tricky, as usually, and always, because COPD is an umbrella disease. If you choose the proper sample, you can find whatever you wish. If it is emphysema and you use IC corticosteroids, you don't find anything. So it is imperative, as you said, the society to design and implement a study that has specifically, correctly collect the sampling and then choose the treatment. With that, thank you very much indeed, Dr. Professor Vassilakopoulos. And do you have a question?
Yes. No,
Yeah.
not question. Something in this, as a representative of ERS, because I'm actively the secretary of the Assembly 5, which is COPD. This is a great, and I will take this up. I just want to point out that lately, ERS, like you suggest, have initiated this we call Clinical Research Collaboration, CRC, that is finance good projects, and there is one of COPD exacerbation, for example. So this is something that is going on, but it's not the same.
I understand, and this is something I would like to congratulate. However, I think they're giving 20,000 euros for this.
Less.
For this RCT is like
I know this, but it's the first, but very, 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 very small step. But that's just the thing that started. But you're totally right. Thank you.
It gives me a great pleasure to introduce to you Professor Bakakos of Athens University. He's an expert in asthma and all other diseases in respiratory medicine. His topic is about asthma and allergic rhinitis. What's new, Professor?
Hello, good morning to everyone. I would like to thank the organizing committee for inviting me to this very interesting summer school. And I will try to be within my time limits. So we know that the current concept of approaching asthma, and mainly the most severe forms of the disease, is phenotyping. And when we use the term phenotype, we mean some observable characteristics of a patient or of an organism that originate from the interaction between the genetic background and the environment. So, apart from the term phenotype, we can use the term clinical phenotype, which includes the clinically important characteristics of the patient, and the endotype, which means that there is a specific and well-defined underlying mechanism that may explain the phenotype. Why this is important? It is very important because this interaction between genes and environment defines the phenotype, which is linked with the clinical expression of the disease. And this is important because this is strictly related to the response of treatment in many asthmatic patients. For example, we see this study that shows that among asthmatic patients, most of them, the majority responds better to fluticasone propionate, but there is a minority of asthmatic patients that respond better to montelukast. So we try to see what are the features, what are the characteristics of this minority of asthmatic patients that makes them respond better to montelukast instead of fluticasone. Historically, the classification of phenotypes was based on the etiology of asthma and the triggering factors. So the first classification of phenotypes was extrinsic and intrinsic asthma back in 1927, occupational asthma, exercise-induced asthma, aspirin-induced asthma, which is now called aspirin-exacerbated respiratory disease. Later on, we defined asthma phenotypes by the pattern of airway obstruction. So we had brittle asthma, we have morning deeper asthmatics where the PEF was lower early in the morning, and even more recently, we defined the asthma phenotypes by pathology based mainly on induced sputum, and we have eosinophilic asthma, neutrophilic asthma, and polygranulocytic asthma. As you can understand, this classification is quite heterogeneous. It is descriptive, and it is focusing only on one particular dimension of the disease. The current concept of defining phenotypes is that we may use many parameters such as symptoms, the pattern of airflow obstruction, of course demographics with late and early onset asthma, response to treatment, BMI, pathology, and of course the atopic status where we will discuss today. So the most common phenotype of asthma is the allergic asthma. If you see the total asthmatic population, most studies show that the percentage of allergic asthma is between 45 to 88% of the asthmatic population. There is no doubt that the prevalence is higher in children, and we defined allergic asthma by allergic sensitization plus minus clinical association. When we say allergic sensitization, we mean that we should have at least one skin prick positive test or one specific IgE test, what we call RAST, for an allergen. And when we say clinical relationship, which is desirable, it means that we may have symptoms throughout the year with sensitization and exposure, or we may have seasonal symptoms. This is very important because there are few patients that may present a positive skin prick test or a positive RAST without any clinical expression of asthma in terms of exposure to this allergen. So we need allergic sensitization and symptoms at the same time. Allergic asthma is more prevalent in younger people. As we said, it is mainly an early onset asthma. It is common to have a family history of allergies. It is more common in males compared to females. And of course, there is seasonal symptom variation, which is more common compared to non-allergic asthma. Regarding severity, there are conflicting data whether allergic asthma is more severe or less severe compared to non-allergic one. And of course, in allergic asthma, it is more often to have symptoms from allergic rhinoconjunctivitis. The main treatment for severe allergic asthma is omalizumab. Omalizumab is a monoclonal antibody for IgE. The indication is severe allergic asthma not controlled by a high dose of inhaled corticosteroids plus another controller medication. And we define allergic by a positive skin prick test in at least one perennial and not seasonal aeroallergen. The medication is given subcutaneously once or twice a month, and we have plenty of data from randomized controlled trials, but from real-life studies as well, showing that this medication is effective in reducing exacerbations of asthma, in reducing the use of oral corticosteroids, and of course, in reducing the healthcare using resources. Some concerns about omalizumab is the dosage. We know that the dose of omalizumab is based on a calculation of body weight and the initial Ig level before the initiation of treatment. So the indication is for patients with allergic asthma having an IgE level between 30 and 1500 international units. And you can understand that in overweight or obese patients with a high IgE level, then the predefined dose is outside the limits of the indications of this medication. The second thing is that we need to have a defined skin prick test, positive skin prick test to a perennial and not seasonal allergen. The third thing is that there is no biomarker for defining the response to this treatment or the duration of this treatment, and I will comment that later on as well. Safety concerns were very strong in the beginning, but they are not now. I remember that at the beginning, when we started prescribing omalizumab to the patients, we were advising them to have an auto-injection of adrenaline, but this is now not happening anymore. And this is because we found out that more than 80% of the severe allergic reactions were after the first or second dose of administrating omalizumab, and in the first 2 to 6 hours after the first or the second injection. So we have no safety concerns anymore, as this is the case for the other monoclonal antibodies in severe asthma as well. Regarding the duration of treatment, this is a very nice study performed, I think, in Crete and Cyprus. This study evaluated the effect of omalizumab throughout 4 years after the initiation of treatment and shows very elegantly that we have a reduction in exacerbations that is maintained throughout the 4-year span of time. And the same applies to the ACT and the lung function FEV1, which is improved in the first year, and this improvement stays stable after 4 years. And this is the longest study from the Greek asthma group, 12 years of following 45 patients who received omalizumab. And as you can see, here are the exacerbations. They go down from 4.1 to 1.1 in the first year, and then throughout 10 years' time, the number of exacerbations, the rate of exacerbations remains very low. And the same applies to oral corticosteroids. As you see, this is a reduction of the mean oral corticosteroid daily dose from the first year, and it goes down and down throughout the 12 years. Regarding asthma control as measured by the ACT score and lung function as measured by FEV1, we see the same pattern. There is an improvement in the first year, and this improvement is maintained throughout the 12 years. So what about allergic asthma and eosinophils? We know that eosinophils are increased not only in late onset non-allergic eosinophilic asthma, but both in allergic asthma as well. There was a study by Nicola Hanania which showed that omalizumab was more effective if the number of eosinophils was above 260 cells per milliliter. But later on, another study came, which is the Stellar study, which again evaluated the effect of omalizumab in severe allergic asthma, and this study showed that the effect of omalizumab was irrelevant to the number of eosinophils. Regardless how high were the absolute eosinophil number count, the eosinophil count, the omalizumab was effective in the same way. So there are some comorbidities that are related to allergic asthma, and this is because there is a type 2 inflammatory mechanism underneath. And one of these comorbidities is allergic rhinitis. As you can see here, both allergic asthma and allergic rhinitis are driven by the same type 2 cytokines, IL-4, IL-5, IL-13. And the same cytokines that are produced by epithelial cells, what we call alarmins, IL-2 IL-25, IL-33, and TSLP. And again, in this inflammatory mechanism, eosinophils and IgE are extremely important. So we see comparative underlying mechanisms. This is from the ISAR study. This is the study called PRISM, which investigated the relationship between severe asthma, allergic asthma, and comorbidities. And as you can see, allergic rhinitis, with the blue bars, is the most common comorbidity of allergic asthma. So when we have allergic asthma, it's very likely the patient to also suffer from allergic rhinitis. And this is very elegantly showed in many other severe asthma registries. These are studies of registries of severe asthma showing that allergic asthma is the most common phenotype of asthma, even in the severe forms of the disease, ranging from 60 up to 80%. This is a study showing that not only in young patients, 12 to 17 years old, which are the black bars, but even in older patients, among patients who are treated with omalizumab for severe asthma, allergic rhinitis is the most common comorbidity. And another important thing is that the severity of these diseases goes the same way. The more severe asthma is, the more severe is allergic rhinitis. The coexistence of allergic rhinitis in a patient with allergic asthma is associated with more exacerbations. This is showed in this study, which from Bousquet, which shows that in patients who have asthma and rhinitis, there is a significant increase in the rate of asthmatic exacerbations. And of course, when we talk about rhinitis, it's not a single entity, it is not a single disease, but there are many phenotypes. And the three most important and most predominant phenotypes is the allergic rhinitis, the infectious rhinitis, and the non-allergic, non-infectious rhinitis. But maybe sometimes these phenotypes may coexist. For example, we may have allergic and infectious rhinitis at the same time. Allergic rhinitis has a high burden in childhood. So the natural history in most of the times is that the patient has allergic rhinitis and after a few years develops allergic asthma. And as you can see, the percentages are very high in young ages and are even higher when the children have one or two allergic parents. This is indicating how important is the family history of allergies. Another important thing about allergic rhinitis is that it affects learning. Allergic rhinitis has a detrimental effect in the education of children, and this is showed in this study in UK, where it showed that it was associated with an increased chance of failing in examinations for young children, and most of them were receiving sedative antihistamines. In terms of symptoms, if we want to understand how we would diagnose allergic rhinitis, we need to have two or more of these symptoms. Rhinorrhea, which is watery, in contrast to mucopurulent rhinorrhea in non-allergic rhinitis, sneezing, nasal obstruction, and nasal pruritus plus or minus conjunctivitis. On the other hand, if we have not allergic rhinitis, then symptoms are mostly unilateral and not bilateral. We have, as I said before, mucopurulent rhinorrhea. We have pain, maybe epistaxis, and anosmia. So the link between allergic rhinitis and allergic asthma is very strong, and that's why the ARIA guidelines, which is something like GINA for asthma, ARIA for allergic rhinitis, suggest that allergic rhinitis is one of the risk factors identified for asthma development. we need, in patients with persistent allergic rhinitis, we need to evaluate them for the presence of asthma, and the other way around, in patients with asthma, we need to evaluate them for the presence of allergic rhinitis. And we should use a combined strategy to treat both diseases. Not even to mention that up to 50% of patients with allergic rhinitis present bronchial hyperreactivity. There are many suggestions about the mechanisms that could explain this strong link between allergic asthma and allergic rhinitis. This is not very well known what is the exact mechanism, but there are some speculations, such as the drainage of inflammatory material from the upper to the lower airways, the presence of some nasofaryngobronchial reflexes, the fact that if you suffer from allergic rhinitis, then you lose the air warming and humidification because you breathe from the mouth and not from the nose. And of course, most likely, the most probable mechanism is the systemic effect, the systemic spillage of inflammation from the lungs to the nasal cavity. It is very important to say that most patients with allergic rhinitis are treat themselves, or they are treated with medication over the counter taken from the pharmacist. So not many patients with allergic rhinitis, apart from those with severe disease, are treated by their doctors. In the pharmacotherapy of allergic rhinitis, we've got 4 options: antihistamines, either oral or intranasal, the intranasal corticosteroids, leukotriene receptor antagonists, and combinations of intranasal corticosteroids plus antihistamines. This is the only slide that I have in Greek, and this is in Greek because this was published in a Greek journal. This is the Hellenic guidelines for the treatment of allergic rhinitis, which is based in the ARIA 2020 guidelines, and these are 2 tables for patients who had never received a treatment for allergic rhinitis before, or who have received treatment before. And this algorithm is based on the severity of symptoms as defined by the visual analog scale score evaluated by the patient. As we said, leukotriene receptor antagonist is one treatment choice for these patients, and you can see here that this study compared budesonide, an inhaled corticosteroid, in a dose of 800 micrograms, and the other arm was half the dose of budesonide plus montelukast. And if we see the subgroup of patients who suffered from allergic asthma and allergic rhinitis, in this subgroup, the addition of montelukast to budesonide was better in improving the primary endpoint, that was the morning PEF. It was better than the doubling the dose of inhaled corticosteroids. And one last thing is that we have a therapy which is allergen immunotherapy. We chest physicians are not so familiar with allergen immunotherapy, but allergen immunotherapy is the only immunomodulatory treatment for allergic rhinitis. Why is that? Because allergen immunotherapy resets the function of dendritic cells. It reduces the activation of many effector inflammatory cells such as eosinophils, mast cells, ILC2 cells. It increases interferon gamma levels, so it causes an immunomodulation for allergic rhinitis, which seems to be even important in the prevention of asthma. This is a hypothesis. It is not proved by very robust data, but there are data which showed that allergen immunotherapy, by suppressing the Th2 responses, might delay the occurrence of asthma for some time. And this is extremely important. Thank you for your attention.
We And since the next speech is about asthma too, I think we should discuss both, if you agree.
I agree.
So we can,
Yes,
you like
I
to
invite
introduce
Professor Bossios, Biologic Therapy in Severe Asthma Recent Advances. Thank you very much.
Thank you. It's a great pleasure to be today with all of you. And I'm very honored, and I must say that I'm extremely thankful to the organizing committee for their kind invitation, Professor Tzanakis, Schiza, and all. So this is, in the next 20 minutes, I would like to discuss to you about biologic severe asthma. And I would like also to try to make a journey to understand why biologic is important, not just to make studies, this and that, because I think it's what you are missing. What is very important is to understand the tools. You must understand so you know how to use it. So this is my disclosure. So we are going to hopefully to see an overview of severe asthma, then to understand how biologic work, then to update on current biologic, take a look at what is coming in the next year or two, and then think a little what is the next step. This is how our patients feel about asthma. This is asthma for our patient. They cannot breathe. And this is asthma for us. And heterogeneous disease, like Petros have very nicely showed, that is characterized by chronic inflammation. I must say now you understand that I love inflammation, so I'm a little biased. So let's see a little inflammation to understand. I like these slides. I even use to my patient to persuade them to take their steroids, young patient. So I encourage to find it from Fahi. So this is biopsies from people that they have done car accidents. And this is a healthy individual. And you see here that the epithelium is so nice. A little mucus is this pastenic, this color. Then we have the smooth muscle very nicely. Look here, a patient with uncontrolled asthma, full of mucus. Everybody, even myself, non-pathologist, can understand that we have inflammation here, in the base membrane. And importantly, we have this remodeling. This patient has symptoms and is lacking the airway obstruction, the reversibility. So I know that I have discussed that earlier with Professor Vassilakopoulos. Many of those patients, they have COPD. Because if you do spirometry on them, they have airway obstruction without reversibility. So you have to think that as well as umbrella. So those patients, when you have this pathology, they have symptoms. And these patients are against us, among us, sorry. So this is a study that we performed some years ago in Gothenburg, studies that it's easy to do in Sweden. So here we call like 30,000 randomly patients in Gothenburg, 18,000 reply with a very long questionnaire. We pick up the one that they have said that they have asthma, physician diagnosed asthma, and 2,000 randomly. We pick them up, we do a very good evaluation, like 8 hours. This is patients that they are coming from their house, from their job. They are not like emergency or whatever, so they are stable. And they are all by physicians. And you see here that 1/3 of those, they have one sign that we say that is uncontrolled or severe asthma. Either they have symptoms over the day, or they take steroids, go to the emergency, they wake up in the night, they use SABA, and of course they have airway obstruction. 11% of them have airway obstruction. So the problem exists, and what we can do, I say, treat them. How we do it? Gina. And this is easy. Easy it's not, but let's say that's easy. We just go up, giving steroids, inflammation, up, until we come here, step 5. And here we say, okay, high dose LABA, and they're starting like to measure the cytokines, something targets like Petros have pointed out, for example. Here, we are in the stage that we're discussing about severe asthma. This is the best definition we have. There is a big discussion now in the ERS and among that perhaps is not good because we are based on the treatment. So should we keep that? But So far, so good. This is the best we have. So the patient that we have to go all the way up, they have high medication, and they are still uncontrolled, or we use this control to keep the minimal, this medication to keep the minimal control, and they also take OCS. Here I would like to take the next 2 minutes to discuss this a little, because now that biologic have come up, there is a lot of pressure from us, physicians, but also from patients to get biologic, even if they are not the target group. Because let's face, this is a problem that we discuss. A lot of patients, they will prefer to get an injection every month. Now there are coming medication that will be 1 time per 6 months, instead of having 2 or 3 puffs every day, or 6 puffs, or 10 puffs. So this is something that we really need to understand, because we don't want to lose this excellent effect we have. So let's say that one patient, I have one patient with asthma symptoms, I send it to Petros to check up. Petros, he's going first to ask to check, have this patient really, we should take to step 4 or 5. We cannot say that patient is uncontrolled severe asthma if we have 1 with the sonid in the morning, 1 in the evening, 2 in the middle of the day, and 1 whatever. So the first step that Petros will ask me, Apostolos, have you really did your job and go the patient up? No. But please, this is a patient with arthritic asthma. So Petros will send him back. Apostolos, do your job. I did that. So I wake up all the ways. And still my patients have symptoms. Then we are discussing that we have patients that have uncontrolled asthma. This is, as we said, a big group. After that, what you need to do is to assess the patient. Does the patient get the medication? The first question. It's not easy. We have a lot of that. That's a big problem. You know everybody. Then, should the patient take the right way? Even a bigger problem. Then also, what other things? That smoking, comorbidities, obesity, or we should not forget a patient that does not really reply to the therapy. We always must have it here. Does the patient really have only asthma or just asthma? So let's say that I did that all, and then the question, has the patient still symptoms? If no, then we're discussing difficult to treat asthma. If yes, then we have the severe asthma. And we must go deeper. And to go deeper, we must understand what you're seeing. And thanks to Petros, I will go be on time, because I have to skip many things now. So this is the classical that came like 10 years ago, that asthma is not a disease. I will skip that. It will be based on the eosinophil or the type 2 helper cell CD4 and the allergic flavors or not. But this did not reply to all our questions, because many of our patients, they reply, for example, okay, I got my asthma attacked when I'm near here and someone has a stark perfume. Or like in Sweden, when I go out in the morning in -20 and have eosinophilia, and I'm not allergic. Well, now we know why. Because like 10 years ago, we found these guys in innate lymphoid cells. In innate lymphoid cells, there are lymphocytes in the middle of adaptive or innate immunity. They do not express this TCR receptor. They do not act specifically, but they act very, very quickly and very robust. And let's go through why. So the classical is that I am in the allergy. In Sweden, I get, I'm atopic, so I get allergy in birds, like everybody after 5 years. So birds come to me, my dendritic cell pick it up, and then I come to the T0 cells, to the CD4. And depending if I have the atopic predispositions or not, my cells either are going to be this way, Th1, Th17, and come to neutrophilia. And here we have innate lymphoid 3 cells that also act the same way. Or they're going to be Th2, that then I'm going to produce all these cytokines, IL-9 mast cells, IL-4, 13 B cells produce IgE, like Petros pointed out, and IL-5 to have eosinophils. What we know now that the same pollutants that they are not allergic, like virus, smoking, and this can be one thing also, that COPD is smoking. Another way that smoking is acting to the COPD, or pollutants. They affect the airway epithelium, they produce this alarmin, like Petros pointed out, and they directly stimulate these innate lymphoid cells that we have in the mucus. They're also in the blood, but it's like 0.0005%. So, when you have this, we need to do something more. And this, I take the liberty to think a little how we have come to biologic before. And let's take eosinophils, because I was very happy that we discussed about that earlier. When myself and Petros, sorry Petros, you are my research minds now. When me and my Petros were medical students, this is what we have learned, eosinophils. That they are cells that they are, 150 years old, they are there, they have these granules, their job is to kill the parasites. But what I want to point out here, these slides, and because there is confusion still, we learned that the normal, and you take these values today, is between 0 and 500. And now we have heard from Professor Vassilakopoulos, we have heard from everybody, from all the studies, 150, 300, but this is normal values. And this is a problem because sometimes the primary physicians or the community or the physicians that they see patients with COPD and asthma, they do not refer patients to the special centers with biologic because they are normal. Let me think that these values, they are not pulmonary respiratory allergy values. They are hematology values. So this is set up by hematologists, the normal. And to point out this one, this is a study that we perform, that we take individuals, there are 16 individuals with moderate asthma from this big study, and we pick them up, we take the blood, and also we get induced sputum. And we take the patients that they are within normal values of eosinophil, between 0 and 500, and we cut up, this is control, eosinophil low, below 200, and the one that is between 200 and 500, so normal. What he did that this one that is between 200 and 500, the normal values, they have up to 6-8% eosinophils in the sputum. So they have eosinophilic inflammation, and this you must remember. Eosinophils does not like the blood. They're just going through. They produce from the bone marrow, they need 6 hours to go to the lungs if there is a stimulus. So when I go out, or Petros is coming to Sweden and sit to Perts, then his bone marrow, he's inhaled that, bone marrow get the signal, he starts producing eosinophils. In 6 hours, if they are fast, they are in the lungs. So what we see is very like a picture. And here what we see also is that we also evaluate the progenitors, and you see that also there are progenitors. So there are all the way, here is in the blood, here is the sputum. So we have eosinophil immature cells that they are traveling from the bone marrow to the lung. This is stable, moderate patient with asthma. They are not that time, they are not in the guidelines to get biologic that time, okay? But there is the problem. So we know that this is the way that we discuss, that Petros gets his bird's pollen, go to the bone marrow, simulate them, go to the migration, go to the lung. And all that is IL-5. IL-5 is the bread and the air for eosinophils. They make them produce in the bone marrow, they make them mature, they make them to go, to leave the bone marrow, they go to the lung. If they are immature, they maturate there. If they are mature, they survive with IL-5. So they cannot live without IL-5. And to point out, it's so important that they even produce themselves. So this is an Wayne experiment to set up the method from a healthy individual. It's me, it's my blood. Give it to the lab, to the postdoc to make the experiment. And this is my cells from the blood. We see the lymphocytes. And here we see that the lymphocytes here, eosinophils, granulocytes, monocytes. And if we see here, we take them out and send them for IL-5. That eosinophils, they have intracellular IL-5. They're going to release it. And even mature. So it is so important that even themselves produce IL-5, except the T cells. And when that happens, we have this picture that we know today that they are doing everything eosinophils, you name it. They are very powerful cells. And what you're interested here is that produce these granulocytes that is very affected to the airway epithelium. So we can come to this mature airway inflammation permanent that we have seen earlier. So having done all that, we learn more and more, and we start thinking, not us like a scientific community, what to do. So let's take the history how we got to biologic. This is a eosinophil's example, cortisone. You know, the best medicine. Our patients love it, in the beginning anyway. Then we take ECS, that changed everything. Then we start to understand all this pathology, what's happening, and we come all these maps. How we get that? Well, these guys. These guys published this initial paper in Nature in '75 when they saw the way how to produce monoclonal antibodies, because normally we know our B cells, they produce in variety. So we have a bread to pick everything. But these guys, they saw the way that they put it, B cells together with the tumor cells, hybridoma, so they are immortal, and they saw the way to produce, to pick up only one. And they take the Nobel for them, 84. So we go to the biologic. This is from a state of art that we have made position paper in allergy. Biologic, we're talking about medicine that produced by living organisms. This is easy, but important that they are for a specific target, cytokine or receptor. And when this come up, it goes like heaven for immunologists and respiratory and all immune-mediated disease. Rheumatology is leading the way. So it was El Dorado. So we stop blocking everything, first in mice, then in humans. Some of them, this is an example. Many of them didn't work. Like, for example, when you block IL-4 or IL-13 by itself, the asthma has no effect. Like Professor Vassilakopoulos showed, from mice cells to the human, two different worlds. Some of them work, like TNF, but we have biochemical like malignancies. So what happened by the end of the day? Here we are today. This is the biologic that they are EMA and we have in Sweden. So this is the taken from our FDA. So we have omalizumab. I will not say more. Petro did the job. We have mepolizumab. When now the indication we have is severe asthma, chronic rhinosinusitis with polyps, EGPA, and even eosinophilic syndrome. This is in gray is the one that is outside the airways, but we have patients with both. We have reslizumab, say here, with severe eosinophilic asthma. We have benralizumab the same, dupilumab, type 2 severe asthma that we discussed, chronic rhinosinusitis, and also dermatitis. And here very good because we have like 10 years now. And then it's on the way to Europe, we have tepelizumab, ADTSLP. It's approved the FDA in December last year. We are waiting to approve in Europe by the end of the year. Let's go very quickly what we have. I will skip this one. This is the slide we have generated from Nordic Severe Asthma Network for teaching. So, ADL5, the indication, patient with severe asthma, eosinophilia, OCS. And here we have 3 antibodies, 2 categories. Mepolizumab is injection, reslizumab is infusion. They both block IL-5, so the eosinophils cannot have IL-5 and they are starving. Benralizumab injection have another mechanism, it blocks the receptor, IL-5A receptor. So IL-5 cannot go to the receptor, and they have also another mechanism that we call ADCC, antibody antibody cytotoxicity. That means that when the antibody goes there, they give a signal to NK cells, this is a bad guy, come and eat it. So they act very quickly. And the clinical effects, we have reduced exacerbation, reduced OCS. Some patients, they get improved lung function. I have one patient, one of my first patients, it was in MEPO, they start, she got 1 liter in FVC. It was amazing. And symptoms. And then predictors, it's like eosinophil exacerbation, adult asthma nasal polyposis. Then we have Dupi. Dupi, what does, it blocks the receptor A. And this is the common unit that both IL-4 and IL-13 they use. Remember I told you when you use to block the cytokines by themselves, it didn't work, probably because the other do the extra work. The IL-4 receptor they express in many cells, epithelium, airway, smooth muscle, B cells, eosinophils. And we have seen effect in exacerbation, airway hyperresponsiveness, and mucus production. This is important. We use also in patients that have extensive mucus production because they block mucin 5AB and they have extremely good effect. So this is a good if we have this phenotype. And also the same exacerbation OCS, nasal polyposis in Sweden. I think the rate was the first DUPI, the first indication was about nasal polyposis, not the first in after atopic dermatitis, but it's the only one that got, the first that got nasal polyposis. But now also other like MEPO has the same. And we have also eosinophils NO. It's important to know because IL-4 and IL-13 induce the enzyme EOS that induce the production of NO. So IL-4 give the signal to the synthase from airway epithelium to produce NO, so it's a very good marker to use it. And then you go to the new one, to the last 5 minutes to have the new one, Tzanakis BAB. This is one of the first study that is came, and this is similar to the studies that they have come to approve the IDL-5. Patients with severe asthma exacerbation. And you see here what you want to see that they look that the exacerbation goes down, no matter if you have eosinophils below or above 250, no matter if you have NO below or above 24, and this is combined. So it seems that work in both. This is the new. Why is that? If we go a little back, because I think it's important to understand what you are targeting, so to evaluate our result. TSLP was like 30 years, and the first they found it in the supernatant of a cell line. They have tried to have it to support the B cells, thymic stromal cell line, that got the name. And what is here, we see that they express from airway epithelium to a numerous of stimulus, from the classical environmental pollution, cytokines. So if we have a low-grade inflammation like TNF-alpha and all that, protease, even progranulin is a neuroinflammatory mediator. And they produce TSLP. We see here that steroids block it, go to the cells, and they produce themselves. Mast cell produce TSLP when there is Ig cross-leading. So there is a variety. And they have a variety of cells, type 2, classical, but also here, macrophages and smooth muscle cells. So what you get here is this late study, when they have the medium dose, they have choose, and they see here that we have a reduced exacerbation no matter the phenotype. It can be altogether, can be, if the eosinophils, they are different cutoff, 300 to 150, if we have allergy or not. So this is very important. So what we know today, and this is if someone wants to understand about biologic, I recommend to use this Nuclear Journal of Medicine review from Guy Brussel. Except for this busy slide, I want to focus that SLP blocks here also smooth muscle cells, but also it blocks the work that the dendritic cells does when they present something to the TH cells to become either TH2 or to become TH17. So that can be one mechanism that block both. So what else new? Well, another disalarmin was IL-33 that was very promising and has a lot of studies, even in COPD, if it does not get positive results. What they did in this study published this year, they tried to block the whole inflammation. So they say, we should use 2. And forget about exacerbation that was until now. So what they did, they take patients in the moderate studies, fluticasone. They have placebo. This is IL-33. They have IL-33 and DUPI, the 4, IL-4 or IL-4 by itself. And they take the LABA, and then they step down the ECS and see when the asthma is getting worse. And when getting worse, we mean that you have lost 30% of your PEF, you increase like 6 puffs of SABA. In 2 days, you have 4 times more ECS, you have asthma, you need OCS, or you go to the emergency. And what they found here, that of course, when you do that, the patient, the placebo group is worse. But here we see that each of them, DUPI and IL-33, have effect. Together, it's not better, as expected. So it's very complicated biological. This is a time, it's 1 year. We don't know what happened in 10 years. And but IL-33 by itself works as well fine. I have this slide to point out eosinophil numbers, that in DUPI, eosinophil goes up. Then another thing that is update or the upcoming or very hope that we don't know is true or not is this FEVP-PRAD, that it block the DP receptor. Prostaglandin D2 receptor that we know that it's expressed on the T2 cells and also in the airway smooth muscle. And this is nice because that was a pill, a tablet every day. That was miracle. It's like the fibrotic. Unfortunately, the clinical trials did not have significant effect, both if they have nasal polyposis and asthma or severe asthma. What is interesting, when they do an analysis from the Christopher Bradin from the Leicester group in patients that they have those patients or the one that they get MEPO in the beginning, from this group biopsies they had, they found that they reduce the airway smooth muscle mass. So it has some effect, but can be a long effect. I remember when it came at the fibrotic and I was a resident, the first, it was not like marvelous result. So we were a little skeptical. We know it works now perfectly. So it can be something for the long-term patient to slow down the remodeling. I don't know. So what we have now, we have all this thing to what to choose, and you have if you have eosinophilia or not. And the important is here to point out that we need also to have if it's allergic or not. And from this point is to see that even if you have non-allergic asthma, TSLP is an option. There are questions, however. First, do they work in real life? Yes, they do. I'm very proud of this study as a Greek, because from the Greek college, that they had the mepolizumab, that was the first one, and they found that in real life, the results is even better. It's like 70%. So excellent work, everybody here. What is now that we discuss? How we are going to assess the response. Here is some thoughts and experience from our center. We are a tertiary center in Karolinska, so we treat with biological all the patients from the region. So we have like more than 200 patients biologic. So we do 4 months and 12 months. And now 4 months, it seems to be general a good point, because people say that if you do not have effect in 4 months, you should not have later. Then what is respondents? Very big discussion now.
Yes.
We have to discuss that. So we have the super respondents that they have effect in everything. They get a new life. No exacerbation, no OCS, increased lung function. Then respondents. In the studies we had, it was like 50% reduction of exacerbation. Here you must know what is your patient. Do you have exacerbation? This is your focus. Do you have Apostolos that does not have exacerbation, but he's like in 15 milligram prednisolone daily, and he developed diabetes? My target for Apostolos is to take out the steroids. So we must have the outcome that we need for individual patient, like Petros have pointed. Then you have poor responders below 50%. Here, what we have found in our experience, many of them have stopped to take the ACS. They have stopped that because they are feeling their thing, yes. And that here, what you should know that now to remember is that many of the patients that they have take IL-5 and block them and start taking out the steroids, there is EGPA below that is coming up. Then with IL-4, there is blood eosinophilia. 30% of the patients get eosinophilia up. We must follow them. The majority goes down again, but some of them stay. And of course, when you have OCS, going down that adrenal insufficiency. The open questions, and this is my last slides. How long? Should we keep it for 30 years? Start early? Should you leave a young woman or man, 25, 30-year-old, to become really severe to start when he's 50? Because now what is the next target is asthma remission. and modification. Biologic pregnancy. Are women they take biologic, they are fertility age. There are some data. Why not to combine? So the summary, and in my own goals, we must really phenotype the patient, like Petro said. They are working beautiful, more on the other way, but we really have a plan. It's not a medicine that you take one, live a prescription, bye-bye within 2 years or 1 year. And the next gold step is disease modification. This is the target, because the exacerbation is, we have used that. And this is most. And I would like to thank you. This is the hospital, and this is the new lab that we are moving now. But this is my son in February. This is the sea below our, near our town, our house. So this is the sea. My son is working on that. So it's not only positive to big Sweden. And with that, thank you. And sorry for the delay.
Thank you. Thank you very much. We are out of time, so we go directly to the next speaker.
Which is you. Professor Poletti does not need an introduction in Crete because he's part of the department. He collaborates with Professor Antoniou for so many years, and he's the expert in interstitial lung disease in Italy and in Europe. Professor Poletti.
Thank you very much again for your kind invitation. I would like to understand how it works. It's not a bronchoscope, so I have some problem. Can you help me in order to have the presentation mode? Okay, perfect. Okay, thank you very much. It's a pleasure, a great pleasure to be here with you again, to meet friends and to meet experts and colleagues, and to be in the cradle of our culture, because I think we were born here a long time ago. And we were born very well. So we already discussed about bronchiolitis, because asthma is a bronchiolitis, or at least in part is a bronchiolitis. COPD is at least in part bronchiolitis, but we will focus on disorders that mainly affect bronchioles, that are small tubes without cartilage plate that have a diameter of 2 or 3 millimeters. First of all, we have a morphological classification for clinicians for bronchiolitis. We can distinguish cellular bronchiolitis, proliferative bronchiolitis, cicatricial bronchiolitis, and bronchial metaplasia. Cellular bronchiolitis means we have inflammation inside the lumen and in the wall of the bronchiole. This is a very typical form of bronchiolitis observed in post-transplanted patients. You see, this is the lumen almost destroyed by lymphocytes. We have a specific form of cellular bronchiolitis that is called follicular bronchiolitis. We have follicles with germinal centers that impinge the lumen. And we have another specific form of bronchiolitis, cellular bronchiolitis, called diffuse panbronchiolitis, first observed in Japanese. You see, we have chronic inflammation in the terminal and the respiratory bronchioles, but also we have an accumulation, a specific aspect, accumulation of foamy macrophages in the interstitium around bronchioles. Proliferative bronchiolitis, we have polyps in the lumen, granulation tissue polyps that are occluding the lumen of this small bronchiole. In another example, and we have cicatricial or constrictive bronchiolitis. You see here the lumen is reduced because we have fibrosis around in the wall of the bronchiole. Interestingly, when you have constrictive bronchiolitis, you can have in other part of the lung dilatation of the lumen. So from the pathological point of view, when you see dilatation of the lumen of a small bronchiole, you have to think about the existence of cicatricial bronchiolitis a little bit in another part of the lung. This is the differentiation between proliferative bronchiolitis, the polyp is inside the lumen, and cicatricial bronchiolitis, the fibrotic tissue in the wall. Another entity described quite recently is the peribronchial metaplasia, or is a very strange term, Lambertosis. It means epithelial bronchial cells that are around the bronchiole, along the Lambert pores. And it has been described by Tom Colby almost 20 years ago. And it is important to know it because the differential diagnosis is not so easy to do as it is with atypical adenomatous metaplasia. Because the boundaries between bronchi and bronchioles and alveoli is not so clear. When we have bronchiolitis, we can have the coexistence of bronchiectasis, mainly in autoimmune disorders. And when we have bronchiolitis, we can have also an involvement of the alveoli around the bronchioles. It is typically observed in hypersensitivity pneumonitis in the cellular or non-fibrosing phase. We have inflammation around the bronchioles and also in the parenchyma besides bronchioles. So having in mind histology, we can understand radiology. And we have two aspects to consider. Indirect effect of the bronchiolar lesions that can appear in the CT scan, not in histology, and the direct effect of the inflammation of fibrosis that can appear in the CT scan. So indirect signs are related to the reduction of vascular feeding. So we have mosaic oligoemia, because we have a reduction of the vascular flow, and expiratory air trapping. The direct effect we see in the CT scan what is happening. So we have centrilobular well-defined nodules or ground glass nodules, 3 in bud, and of course we have a mixed pattern. So indirect sign, mosaic oligoemia, you see here we have part of the lung that are blacker compared to the rest. So, and the differential diagnosis is with vascular obliteration, mainly microneoplastic thrombosis. And the differential diagnosis is done when you make an expiratory phase. With bronchiolitis, you have an increase of the dark area. Direct sign, we can have just nodules. It depends in which way you see the bronchiole. You can have nodules in the centrilobular part, and mainly you see it in follicular bronchiolitis, or you can have less well-defined nodules, so-called centrilobular ground glass nodules is typically observed, for example, in hypersensitivity pneumonitis, but can also see in other form of bronchiolitis. And you can have 3 in bud pattern. You see the branching structures that are bronchioles filled by mucus or inflammatory cells. And here another example. And the third aspect is the so-called 3-density pattern. We called it a cheese pattern because this is a typical salami. In Italy, you see we have at least 3 different density in the salami. If you have in mind, you have to consider, for me, CT scan is a form of morphological analysis of the lung. So when you analyze the CT scan, you have to consider what is in the histological background. Having said that, the clinical definition of bronchiolitis is still elusive because you see we have bronchioles in different parts of the lung, and we have a lot of causes that can be at the basis of the bronchiolitis, and the cause is usually chronic, but it may be acute or subacute. The symptoms and signs are not specific and polymorphous, and so on. And we don't have specific laboratory markers to identify bronchiolitis. Probably one important sign is the presence of inspiratory squeaks. And also, the pathophysiology is not so evident because bronchioles are so considered the silent zone, the area in which the airflow becomes greater and greater, and so the resistance when you have resistance, the damage of the bronchioles is quite evident. Then we have a clinical classification that is related to the causes of the syndromes in which bronchiolitis appear. Inhalation bronchiolitis due to toxic fume inhalation, irritant gases, or organic dust infectious and post-infectious bronchiolitis, chronic aspiration, drug-induced bronchiolitis, collagen vascular disease-associated bronchiolitis. This is very nice or very difficult entity to recognize. Paraneoplastic pemphigus-associated bronchiolitis, inflammatory bowel disease-associated bronchiolitis, post-transplant bronchiolitis. In this list is also included a paraneoplastic disease because it was recognized at the beginning as a fibrotic bronchiolitis, but is a neuroendocrine and hyperplasia with bronchial fibrosis that is typically a disease of females, diffuse bronchiolitis, cryptogenetic forms, and miscellanea. So we will see some form of them, toxic-related bronchiolitis. I think that we have some pneumoconiosis identified quite recently, nylon flock-associated interstitial bronchiolitis, and bronchiolitis observed in workers that have to do with microwave popcorn production. And of course, an epidemic of bronchiolitis was observed during the Iran-Iraq war. We have a lot of cases due to mustard gas bronchiolitis, and my friend Marco Chilosi was part of this investigation. And you see here we have also bronchiolitis related to the military, to the exposures of soldiers to dust in Iraq and Afghanistan. And there is in the United States a kind of epidemics related to this exposure. And also, vaping-induced lung injury is important. We have seen quite recently a very young girl, 16 years of age, that was admitted to the hospital with this kind of damage, and it's very difficult to recognize it. We had the diagnosis or the hypothesis after cryobiopsy. We made a correct clinical history only after histology. It sometimes can happen. And there is a new, probably entity recognized in the Brompton Hospital. If is smoking, usually acute story and association with bronchiolitis and Goodpasture syndrome. And this patient needs ECMO and, of course, treatment of renal failure. Infectious and post-infectious bronchiolitis, I think, is the most common form of bronchiolitis. A lot of bacteria can induce bronchiolitis, Haemophilus influenza, Mycoplasma pneumonia, Mycobacteria, and so on. But we have a post-infectious bronchiolitis called Swire-James or McLeod syndrome. We don't know what was the first author that were able to identify the diseases. A post-acute bronchiolitis due to an viral infection in early age of life with also involvement of the vascular development. Usually you have a asymmetrical involvement of the lung, and usually they are asymptomatic. So you have the radiological diagnosis that can impress the radiologist, but from the clinical point of view, usually is not important. And also, this is another overlooked entity, bronchiolitis due to chronic occult aspiration, usually in elderly, in patients with Parkinson's disease, for example, or other neurological disorder. You have recurrent fever, low grade fever, and you have a trim-bath pattern in the lung. And you can recognize also the presence of gastroesophageal hernia, and this is part of the entity. Drug-induced bronchiolitis, we have a long list of drugs that can induce bronchiolitis. The first report was with dipenicillamine and gold, and now we have also cases due to immunocheckpoint inhibitors and imatinib, and of course nitrofurantoin. we observed recently a case with Rimbat pattern and due to centrilobular nodule due to immunocheckpoint inhibitors. This is an important entity, collagen vascular disease and bronchiolitis, usually observed in patients with a Sjögren's syndrome or patients with seropositive rheumatoid arthritis and an evident exocrineopathy. In Sjögren's syndrome, the lesion is usually follicular bronchiolitis. We have centrilobular nodules, and you can have, of course, expiratory air trapping. This is another case. You can have several forms of bronchiolitis in Sjögren's syndrome, and as reported by Bruno Crestani. And in rheumatoid arthritis, the majority of the cases have observed as cicatricial bronchiolitis and not follicular bronchiolitis. And this is a case of Sjögren's syndrome that can appear as cyst in the lung. So the differential diagnosis between follicular bronchiolitis and LIP is not so easy. And also, this was a case that was sent us with a diagnosis of LEM. She was a young lady, and the Sjögren's syndrome was not so evident, and this was the lung, and the histology was an LIP or follicular bronchiolitis. This is a very rare entity. It is important because usually it is confused with the acute bronchitis, because you have vesicles in the tracheal tree that become infected, usually by Staphylococcus aureus, is an entity due to autoantibodies that develop usually in patients with Castleman disease or lymphoproliferative disorders. And you see here is a very severe form of rapid progressive respiratory failure, obstructive respiratory failure, and usually patients die with this disorder. You can have bronchiolitis in also inflammatory bowel disease, mainly Crohn, a little bit rarer with ulcerative colitis. This was a male with ulcerative colitis and coexisting sclerosing cholangitis with dyspnea. You see here we have a typical mosaic oligoemia and air trapping, and also bronchiectasis. This is an important point to consider. When you have bronchiolitis and a combination with bronchiectasis, you have to consider autoimmunity in the background. Post-transplant bronchiolitis is a very known entity due to lung transplant and also stem cell or bone marrow transplant. This was a patient with, in that period, bone marrow transplant. You see here, we have bronchiectasis again. And one of the forms of graft-versus-host disease could be only bronchiectasis and mosaic oligoemia. You see here, at the beginning, we have a lymphocytic bronchiolitis, and then we have a very constrictive form of bronchiolitis. This is a very, for pathologists, just a curiosity. The so-called up and down epithelium is a typical aspect of graft-versus-host disease. These are the risk factors associated with bronchiolitis syndrome. I have to say that one of the main risk factors is acute cellular rejection and lymphocytic bronchiolitis. Interestingly, now the distinction between obstructive and restrictive graft-versus-host disease is becoming more and more important. We have a form of graft-versus-host disease that is restrictive and is called CLAD, is manifesting with pleuroparenchymal fibroelastosis, and probably we will have new markers. You know, now we have a surveillance bronchoscopy for these patients, but donor free cell DNA will become probably in the near future the marker of allograft damage that can avoid investigations. Of course, we have bronchiolitis after this transplant. At least this is my experience. Bronchiolitis observed after lung transplant and after bone marrow or stem cell allogeneic transplant. We have a very long experience with the Institute of Hematology, and I remember here the father of Italian hematology, Professor Tura, that was one of my mentors that died 1 year ago. And this is an entity called, discovered in New England Journal of Medicine more than 20 years ago, almost 30 years ago, by a guy and others. There is a bronchiolitis. The CT scan is very typical. Why? Because you have a very diffuse mosaic oligomedia and you have nodules. And it is a female, and the main manifestation is chronic cough. When you make the biopsy, you have cicatricial bronchiolitis, but also proliferation of neuroendocrine cells. You see another example, and some tumorlets or even carcinoids. If you make an analysis of lung tissue in carcinoids, this bronchiolitis is quite frequent. But the clinical entity is quite rare, so we should have a systemic or at least a lung manifestation of this neuroendocrine proliferation. This is the course of the disease. We are now collecting more than 30 cases, and I have to say that in the majority of the cases, the main symptom is cough. You cannot have drugs for that cough, but the progression of disease is usually very slow. Sometimes, in a few cases, the progression is not affordable and you need lung transplant. This entity was described by a Japanese group this was a very famous article in Chest, and we described the first case outside Japan in 1990, and it's peculiar because the diagnosis you made in this is productive cough with chronic bronchitis and COPD. But the chest X-ray is full of nodules. The lesion is just around bronchioles, you see here, and typically you have inflammation with lymphoid follicles and also these foamy cells. This is a typical example year and year and year of three-in-bud pattern, and in fact you have bronchiectasis and a lot of three-in-bud patterns. This is our case. You see here a lot of nodules in the chest X-ray, and this is associated with pansinusitis. So the combination is very typical. The prevalence, of course, is a rare disease. We have observed a bunch of cases also. Ulrich Kostabel observed this entity. We have some genetic predisposition. We don't know exactly what happens in these patients, but we know that macrolides can have a role. And this was at the beginning of the saga of macrolide in chronic bronchitis and COPD. You see here our patient, when you don't have a huge involvement, macrolide can improve the lung function and can contribute also to the disappearance of the lesions in the lung. Macrolide at low dose, not as an antibiotics. This is one of the last but one slide. So we have documentation of bronchiolitis. We can distinguish between cellular infiltrate and fibrotic infiltrate, between intraluminal, mural, lymphocytic, or lymphoid aggregates with this list of differential diagnoses. Proliferative, these are the list, and also constrictive. So because of the large cross-sectional area of the peripheral airways, symptoms and physiological changes of diseases involving the peripheral airways develop late in disease and can be silent. Bronchiolitis can be broadly categorized in inflammatory, proliferative, and constrictive. Inflammatory and proliferative are more prone to treatment compared to constrictive bronchiolitis, and certain form of bronchiolitis respond to macrolides, antibiotics at low dose. And the constrictive bronchiolitis is the dominant aspect of chronic lung allograft dysfunction. And you see here that we have some new entity in this field that is more and more complicated, and of course, bronchiolitis obliterans is also a manifestation of a graft versus host disease. Thank you very much for your attention.
Thank you, Professor Poletti, for this excellent review of bronchiolitis. I think we have run out of a lot of time, so we can leave the chair and invite the next one.
We are immediately move on for the grand debate with two very experienced speakers that will make us happy to have only 10 minutes each. Please.
Thank you very much. Do I have to do anything, or they are going to open it?
The question,
No.
the question of using of ICS raised in previous decade
Okay.
when we had the lama at our head. Now we are starting to have the opposite position, and I think that the most pulmonologists are in favor of using ICS. That's what we're waiting to hear about.
Thank you. Now I need an extra minute.
Yes.
Because he
10
has
minutes.
stolen one. Okay?
10 minutes.
All right. Now, trip therapy in COPD. First of all, when they took biopsies long time ago from the Vancouver group of COPD patients, very interestingly, what they found is that even the old stage 0, which is now the pre-COPD or whatever, and then stage 1, stage 2 and 3, and stage 4, at all stages you have inflammatory cells. So inflammation is not a late event in COPD. Destruction is a late event. And one of the most influential investigator-initiated studies, not industry-initiated studies, the glucocol study, what they did, they got COPD patients, okay, that were corticosteroid naive. They had never received corticosteroids. They gave to them inhaled corticosteroids and combination of inhaled corticosteroids and salmeterol, and they did a very simple experiment. They did 3 times bronchoscopy at 0.0, at 6 months, and at 30 months, and they compared the lung biopsies and the inflammation in the tissue, in the lung. So, to make a long story short, people that were taking corticosteroids, inhaled corticosteroids, but were corticosteroid naive, had a reduction in all markers of inflammation, and if you were keep having corticosteroids, you were having this reduction stable. If you were removing glucocorticosteroids, inhaled corticosteroids, you had a rebound. Okay. Second very important point. This is the most influential study that formed the way of thinking of GOLD. It's the FLAME study that has shown this 12% reduction in exacerbations. But what I want to mention here is this is moderate or severe exacerbation after having LABA/LAMA. And what is important? You have a 50% chance of having moderate or severe exacerbation at 1 year despite receiving LABA/LAMA. So, if we add to that an anti-inflammatory drug like inhaled corticosteroids to LABA/LAMA, can we earn anything? First study, 4 years ago now, in Lancet. You know all the tribute trial? Beclomethasone, formoterol, and glycopyrronium in the formulation of Chiesi, you see you have a reduction of 15% in moderate to severe exacerbation. Of course, if you subanalyze severe, you get no statistically significant reduction. The rate ratio is, again, less than minus, but this is because they had no power to show that, very few patients. Let's go to the big trials. Trial number 1. You all know the IMPACT trial, New England Journal of Medicine many years ago. Triple versus LABA-LAMA, LABA-ECS, same formulations, same device, same drugs, so only the effect of corticosteroids. You know the inclusion criteria. You could have either less than 50% with one moderate or severe exacerbation, or between 50 and 80%, which means stage 2, but 2 exacerbations. Here you have the reduction in the exacerbation rate with the triple, the time to the first COPD exacerbation. So you have a significant reduction of the exacerbation with the triple compared to the others, very, very clear. And because a lot of criticisms was that they included only patients with very high exacerbation history, and this is why they have shown that effect. Okay, look, in that trial, like 45% had only one exacerbation in the previous year. And what they found, okay, let's be quick, 18% reduction in the exacerbation in patients that had only one exacerbation history. Okay? So it's not because they had a lot of exacerbations in their patients that they have seen the result. Now, what about the eosinophils? All right. If you have more than 150, you get greater reduction. If you have less than 150, you get 12%. I have shown this slide before. It says that above 100, you have a gradual increase on the benefit of adding inhaled corticosteroids. The more eosinophils, the better the benefit. And in fact, this very small increase, 11% in those having 100 or around 100, is very comparable to the 12% reduction, to the 11% reduction in the exacerbation in the FLAME trial. That was considered influential, this 11%. The other 11%, the previous one, was not very influential. And of course, very interestingly, in the initial report in the New England Journal of Medicine, an impressive 42% reduction in mortality. And when they gathered all mortality data, survival data, extensively from all the patients they could, they didn't match this 40-something%. They made it less, only 28% reduction in mortality. So let's go to the final study. Yeah, free slide.
Study. Okay.
Sorry, the final study, which is the Ethos trial, again, New England. Again, 4 groups of patients, 2 different doses of inhaled corticosteroids added on LABA-LAMA or LABA-ECS. Similar inclusion criteria, some tiny differences. You had less than 65% predicted of FEV1. So we don't have 80 to 65, we have from 65 and onwards. The other are very similar. These are the high dose and the small dose, and the 2 combinations, LABA-LAMA, LABA-ECS. Let's go again to the reduction in exacerbation, clear reduction in the exacerbation. Let's go to mortality. A big reduction in mortality, very impressive. Again, a lot of missing data. Then they did it. They got all the missing data and they had a 49% in mortality. So I'm really now quite happy that I was so many years biased about the effect of inhaled corticosteroids, because if you add them, especially in patients that have more than 100 eosinophils and at least 1 exacerbation, then you might definitely get a reduction in the exacerbation, improvement in lung function. The president didn't give me any time to show that, but you have big chances, not primary outcome, yes, but predefined pre-specified to reduce even mortality. And of course, don't forget Kazarma.
Etc., etc., yes. Thank you very much. Thank you. I can confirm that Theodoros Vassilakopoulos is persistent in the support of ICS in COPD, and now his opponent, another COPD guy, Kostas Kostikas, remotely will play his opponent. Kostas.
So I'm really sorry I'm not there, and the big reason for that is that we would have a great opportunity to do a debate like this. If you have not watched these Cretan videos, you should watch them. So my argument is not against triple therapy. It's against doing this in all the patients, because this is what we know. After 10 years, everybody gets triple therapy. And this is the case also in Greece. These are data from the Relico study. Tzanakis is the first author there. 1 out of 4 patients in gold groups A and B receive triple therapy. Do we do it with any rationale? No, we do it randomly. This is the 5 big countries in Europe, and you can see that 1 out of 3 patients with 0 exacerbations and less than 150 blood Eos receives inhaled corticosteroids, and 1 out of 4 with frequent exacerbations and without high blood eosinophils don't receive inhaled corticosteroids. So we do it randomly. And my argument is against providing the big suit to all the patients out there. I will argue in 2 basic arguments. So first of all, triple therapy versus LABA/LAMA for exacerbations. The scenario of triple therapy versus LABA-ICS that some people claim, it's the addition of an additional long-acting bronchodilator, so no arguments around that. So I agree with Theodoris. He's absolutely right. There is a mortality benefit, but in which, apologies for the mortality, there is an exacerbation benefit, but for which patients? For the ones with multiple exacerbations, and the pattern is the same in all the studies. Triple therapy versus LABA/LAMA reduces by 25% the rate of severe or moderate to severe exacerbations, but only by 15% the time to the first event. Patients who benefit are the ones with frequent events. Oh, by the way, Theodoris, just because you showed that, in the IMPACT trial, 50% of the patients receiving triple therapy had at least 1 event. Second thing, higher blood eosinophils, I will not argue around that. The only problem is what is the cut point? I would argue above 150. Which types of exacerbations? We have some data from FLAME, post hoc analysis that we did. Patients who will benefit more from inhaled corticosteroids, LABA-ICS versus LABA/LAMA, are the ones having exacerbations treated with systemic corticosteroids. Last but not least, inhaled corticosteroids, and we have a lot of evidence around that, don't work in current smokers, so better exacerbation prevention in ex-smokers. And this is not only the IMPACT study that you will see here, but also data from the whole IGNITE program, LABA/LAMA versus LABA-ICS. Shall we provide triple therapy for symptoms, and shall we provide it for improvement of lung function? Yes, we get 50 ml, and this is something like a universal finding in the studies by adding an ICS to a LABA/LAMA. And we have a modest improvement in St. George's Respiratory Questionnaire, but not for all the patients. So in that case, my argument would be, if you want to provide some symptomatic benefit in your LABA/LAMA patients, and this is the BTS guideline, provide a triple therapy trial for 3 months. But if the patient does not improve, go back to LABA/LAMA, they will not benefit. This is also the data from real-life data. Patients will have an exacerbation prevention effect with triple versus LABA/LAMA when they have more than 3 exacerbations and more than 350 blood eosinophils. The additional thing, have we gone crazy talking about ICS withdrawal in disease that is progressive like COPD? Well, it seems that GOLD is suggesting that a couple of years now in patients who had a pneumonia, an inappropriate original indication, or lack of response to ICS. And I know the pneumonia argument, and I will not provide that one, but I will provide the bacterial colonization. This is salmeterol fluticasone versus salmeterol, an Alberto Papi study with Marco Contoli as the first author. 1 year of inhaled corticosteroid in the high dose, we need to remember that, patients had higher rates of bacterial colonization by the common pathogens, Streptococcus pneumoniae, Haemophilus influenzae, and Moraxella catarrhalis. And also, and these are our data with David Price, there is an increased risk, again in the high doses, more than 500 of fluticasone propionate in diabetes, and we have a greatest risk of diabetes onset and diabetes progression. So besides GOLD, also ERS went crazy, and they have a guideline, and they are suggesting that there is a conditional recommendation for ICS withdrawal in patients who have less than 2, so 1 moderate exacerbation without hospitalization in the previous year, and less than 300 blood eosinophils based on 2 trials, Wisdom and Sunset. And I proudly accept all the responsibility for this analysis in the Sunset trial, where we have shown in a predefined analysis that if a patient who is on triple therapy at least for 6 months gets their ICS withdrawn, then if they have more than 300 blood eosinophils, and these were 1 out of 4 patients, they have an 80% risk of having an exacerbation. 3 out of 4 of these patients will not have an exacerbation risk. When do these exacerbations happen? In the first month. So what we see in many of the mega trials is an exacerbation and an ICS withdrawal effect. And this is the analysis of Sami Suisa in the Tribute and the Impact study. So we need to be very careful in which patients we withdraw the ICS because they may need it. At the last argument, have we reached the holy grail by triple therapy? Yes, we have the impact mortality analysis. There was a 42% reduction in mortality in the initial exploratory analysis. In the full data set, there was a 28% reduction in mortality, and Thodoris showed elegantly the Ethos data with a 49% reduction in mortality. Number needed to treat in the order of aspirin, 80 patients should receive triple therapy versus LABA/LAMA to prevent 1 death in 1 year. Is it a new effect? No, it's not a new effect. We know that because patients in the 2000s lived longer than the patients in the 90s, and the difference in therapy was not inhaled corticosteroids. You can see that, no difference. Almost everybody was receiving inhaled corticosteroids also in the 90s, but they received more long-acting beta agonists and more tiotropium that was the only available LAM at the time. The additional thing is that we need to remember and look at details. Patients in the Ethos study who were receiving ICS at screening had a decrease in mortality by 59%. When they were not receiving an ICS, the effect goes on the other way. So doctors know what they are doing. 1 question mark to doubt a little bit the mortality results because there are some number tricks there. And an analysis in the UK CPRD database from Sami Suisa shows that in new initiators of triple therapy versus LABA/LAMA, there is a 17% increase in mortality, a 19% increase in severe exacerbation, 29% increase in pneumonias, and 50% increase in severe pneumonias with a fatal outcome. Those patients who did not have a bad outcome were the ones that had a concurrent asthma diagnosis, and those that did not have, that had a history of prior exacerbations. So, and we need to be very honest here, this is a selection bias effect because we all provide triple therapy to our more severe patients. This is not the right way to analyze data, but nevertheless, we need to remember that not all data show the same. And this is our 2 cents in the data from mortality from the mega trials. So the trials designed to show an ICS benefit on mortality, Torch and Summit, negative. ICS LABA versus nothing, versus placebo. Impact and Ethos, they do show a mortality benefit. I urge you to look at the numbers of mortality here. 1.4% in Flame, 2.43 in Impact. Again, similar numbers in Ethos. Less patients die, less and less patients die in 1 year trials in COPD. So we have effective therapies, but we need to provide personalized treatment, and more and more, we need to urge the big companies, or we need to do an investigator-initiated trial on triple therapy for mortality and COPD. This is our suggestion in our editorial to Sami Suissa's paper. I think that I have convinced you all that we shouldn't provide the big suit to all our patients. I think this is the time for personalized medicine. This is what the EU suggests, and I will not use for today, I will not analyze for today my favorite slide from Diana Stoltz and Mark Miravitles, but I will show you the MVP, the most valuable patient for triple therapy versus LABA/LAMA for exacerbation prevention. These are the exacerbation prone, at least to moderate or one severe hospitalized exacerbations, the ones that have OCS-treated exacerbations, the patients with higher blood eosinophils, and the ex-smokers, ideally, for symptom relief, for survival benefit, for disease modification. I will ask Theodoris to show me the money. Thank you very much. And of course, besides Kasarma and before Kasarma, you all know what you will be doing in September in Ioannina. And again, 11 minutes, dear presidents, I think we are okay.
Thank you.
Thank you very much for your attention. And thank you very much for the invitation. And again, apologies for not being there.
We are running out of the time. I would like to have two comments, one from my co-chairman and another one from the audience. I will pick up one afterwards.
Thank you. Thank you both. It was really a grand debate from the two cornerstones of Greek pulmonology. The key point I want to stand in the presentation of Theodoris Vassilakopoulos is the term inflammation, and we all know that COPD is the chronic inflammation disease, and we don't stop to think about using ICS in these situations. And then two take-home messages is one is the first time we have the signal of a reduce of mortality by using ICS, and the second is that we have to be more accurate thinking personalized medicine, as mentioned Professor Kostikas. We have only time for one question from the audience.
No, one comment. One comment from the audience. I will pick up Petros Bakakos.
A colleague raised her hand.
Okay.
I'm from Tikon General Hospital. I think that in medicine things are gray and not black or white. So is there any reports or studies about a new phenotype or a new pathogenetic subsequent phenotype as a new obstructive airway disorder? So can we say if we can cure specific this kind of a new phenotype? Not asthma, not COPD, but something new, an intermediate phenotype with a different pathogenetic pathway. So we can explain the results, the conflict results. I don't know if there are any studies about this. Thank you.
Kostas?
A very brief comment. There are no studies, at least no big studies in ACO, unless we consider one of those impact as one of those studies, because it has included some patients with asthma. The thing is that we have put in the bucket of COPD a lot of different phenotypes, and this is bad for the outcomes of the studies. We need to define better the subphenotypes of COPD and provide more personalized treatment. Biologics will help in that, and also hopefully some additional new treatments that are being tested. But nevertheless, I don't think we have more data on a specific treatment phenotype, with the exception, of course, of the chronic bronchitis and roflumilast.
So, Professor Siafakas, the last comment. Petros Bakakos dismissed.
Against using triple therapy in all the patients is because the general practitioners are using that. I mean, it's easy for them to write a prescription for the 3 drugs and take the job out of the pulmonologist, because the pulmonologist can make the differential diagnosis and find the proper phenotype and use the proper drug. So I think we should advise more for the individual, the personalized treatment, and not prescribe everything for all the patients that triple study. Support Kostas.
But we have here very advanced GPs like Desmos Rodiakonou, who is almost pneumologist because trained in our department.
I would declare myself as a pulmonologist, but I could say that I think in the past maybe there was less personalized approach to people with respiratory medicine from the primary care point of view. However, at least in Greece now, there are registered protocols and the pulmonologist should initiate the treatment. So I think what we see today is the practice of pulmonologists more than what is the recommendations from primary care physicians with respect to COPD patients. So I will defend GPs on that point.
Okay, thank you very much all of you. So we will back with a very nice sleep breathing disorders session, 11:30. 11:30. Thank you.
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognizing excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations, and best practice through ERS events and conferences. Increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the 2 pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis and treatment of lung disease. ERS and ELF come together to provide support and information for patients, raise awareness about key issues affecting lung health, and campaign for healthy lifestyles and the prevention of disease. Each year, we host the largest gathering of respiratory professionals in the world at the ERS International Congress, a showcase of excellence for respiratory medicine. It's one of the world's major platforms for the release of new data. Additionally, giving access to live sessions and recordings to tens of thousands of virtual delegates, sharing new thinking and inspiring the respiratory community. The ERS International Congress is an essential ingredient for the advancement of respiratory medicine. The European Respiratory Society, supporting its members in advancing respiratory medicine and improving patient care, offering access to the highest quality unbiased medical education to all healthcare professionals around the world, raising awareness of unmet research and educational needs, and promoting lung health to meet the needs and hopes of our members and our patients worldwide. The European Respiratory Society. Every breath counts.
This year marks my first year as ELF chair. Unfortunately, it's been a year marked by COVID-19, relatively physical distancing, remote consultations and meetings. I know it's taking a toll on many respiratory patients, but we hope it will be different in the coming year. But it's also been a year that has revealed our community's resourcefulness, our adaptability, our innovation, our fresh ideas and approaches to deal with uncertainty. This is also true for the European Lung Foundation. In the past year, we have managed to get a new ELF chair in position. We have adapted a new strategy with 6 strategic goals: to be patient-led, to increase knowledge and understanding, to engage effectively, to have a strong voice, to ensure good governance, and to increase our resource and outreach. We have also modified the ELF Council so it's now a 50-50 split between EIS leadership and patients. This spring, we launched our new website, which ensures better synergies and link with EIS web resources. Amongst other things, it has better usability and is more people-focused. We have also strengthened the visual content on the website to ensure a more diverse communication of contents. The website also contains patient input process details and a new section on fundraising. In general, the new website has helped us to strengthen our patient input. We have developed and focused our disease-specific patient advisory groups to better match the interest of patients and to strengthen the links and synergies to the EIS assemblies. This year, we have added 4 new patient advisory groups and giving us 13 in total. We have provided patient input to more than 35 EIS projects in the course of the last year, including 20 task forces and 15 TRCs. One of the new innovations that we introduced in the course of the last year is a format that we call the Patient Conference. The idea with the Patient Conference is to have our disease-specific patient advisory groups lead on defining the content and co-host the Patient Conference with EIS professionals. In February, we had our first patient conference on bronchiectasis, and in July, we had our second on long COVID. For both events, we had just under 2,000 registrations, with half attending on the day and many more watching the videos afterwards. This is a format that we plan on developing further in the coming year. Another innovation for ELF is the development of a fundraising strategy. We have developed documents and processes for driving our fundraising forward. Our first venture into fundraising was the Virtual Conference Challenge, which took place in conjunction with the 2020 EIS Congress and helped us to raise more than £4,000 for our Healthy Lungs for Life campaign. This year, we have launched the Take the Active Option fundraising campaign. I hope you join it. You'll find more details on our supporter section on our website, which is created to help income generation to improve lung health globally. This past year has been extraordinary in terms of developing and strengthening patient input through digital tools and platforms. We hope to develop this further in the coming year, but we also hope we get to see each other, to meet, to think, to discuss, and to develop together. Because this is the essence of what ELF stands for.
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognizing excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations, and best practice through ERS events and conferences. Increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the 2 pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis and treatment of lung disease. ERS and ELF come together to provide support and information for patients, raise awareness about key issues affecting lung health, and campaign for healthy lifestyles and the prevention of disease. Each year, we host the largest gathering of respiratory professionals in the world at the ERS International Congress, a showcase of excellence for respiratory medicine. It's one of the world's major platforms for the release of new data. Additionally, giving access to live sessions and recordings to tens of thousands of virtual delegates, sharing new thinking and inspiring the respiratory community. The ERS International Congress is an essential ingredient for the advancement of respiratory medicine. The European Respiratory Society, supporting its members in advancing respiratory medicine and improving patient care, offering access to the highest quality unbiased medical education to all healthcare professionals around the world, raising awareness of unmet research and educational needs, and promoting lung health to meet the needs and hopes of our members and our patients worldwide. The European Respiratory Society. Every breath counts.
This year marks my first year as ELF chair. Unfortunately, it's been a year marked by COVID-19, relatively physical distancing, remote consultations and meetings. I know it's taking a toll on many respiratory patients, but we hope it will be different in the coming year. But it's also been a year that has revealed our community's resourcefulness, our adaptability, our innovation, our fresh ideas and approaches to deal with uncertainty. This is also true for the European Lung Foundation. In the past year, we have met.
Okay. Good morning again. We would like to welcome you in this hopefully very interesting session that is regarding the various forms of sleep breathing disorders beyond obstructive sleep apnea, beyond central sleep apnea. All the sessions, the two upcoming sessions, this one and the other one, will covering various areas of sleep breathing disorders that can be developed in respiratory diseases. And without any further delay, I would like to introduce my co-chair that she will take over from now on. In fact, Anita Simonds doesn't need any specific introduction. She's well known not only in European but in international levels. She's a professor of respiratory and sleep medicine in London, and also she has a long-standing commitment and career within ERS, starting from various positions, ending up as a president. Now she's past president. But further than that, what I would like, if I may, would like to point it out, it's the huge support in young people, in young researchers, in young scientists that they want to join not only to the sleep field, but in general to the respiratory field and to the ERS as well. And she's a great supporter to all of us. Thank you so much for being here. Thank you for all that you offered to us all these years and that you continue to offer. Thank you, Anita.
That's wonderful. I'm really grateful to you, Sophia, and to Katerina and all your colleagues for inviting me here. In fact, I haven't been to Crete before, and it already exceeds my expectations hugely. Just to quickly pick up your point about the ERS and young people, I first went to the ERS Congress with my poster, struggling to put it up, hoping it wouldn't fall down, worried that no one would come and look at it. This, of course, was many, many years ago, and I never thought that I would work through the assemblies. But I promise you it's possible, because if I could do it, you can, and you can work through to become secretary, head of assemblies. You can work through on the education, science, advocacy side, and you too can become president. I can do it, you can. Just to add that. So as Sophia said, it's a wonderful sleep program, really imaginative. And we're going to start this session with Winfried Randerath, Professor Randerath. Winfried is professor in Solingen in Germany. And at the moment, he's head of Assembly 4, the Sleep Assembly. And he too is doing an enormous amount together with Sophia for sleep in the ERS and the wider world. So Winfried's going to speak on the pathophysiology, clinical implications and treatment approach for central sleep apnea. Winfried.
Thank you so much, Anita. It's really a pleasure to be here, and it's an honor. I thank you, Sophia, and all your team of organizers very much for inviting me. It's really a pleasure.
Pleasure is ours.
I would like to add something to Anita. You know that we re-established our Assembly 4, focused on a sleep and breathing disturbances assembly, and we were very lucky that we had during this time your wiseness, your support, and your help in implementing this new approach. Thank you so much. So what we would like to discuss is some aspects of central sleep apnea. Central sleep apnea, as you know, focuses on breathing disturbances without any effort from thorax, abdomen, no impulse from the brain to generate respiration. We have the subgroup of periodic breathing on the right-hand side, which is a part of central sleep apnea. It's not a specific group, but it's a subtype, which is very typical for different situations. There are different categories or different nomenclatures for central sleep apnea. On the upper part of the slide, you see the International Classification of Sleep Disorders, which divides central sleep apnea in 6 different groups. Central sleep apnea with Cheyne-Stokes breathing, due to a medical disorder, without Cheyne-Stokes breathing, high altitude, medication, primary, treatment-emergent central sleep apnea. This classification is currently being revised, and it's under discussion, and it seems that there will no substantial change to these classification systems at the moment. On the other hand, you can also divide central sleep apnea based on pathophysiological aspects. And this is shown in the lower part of the slide. You can ask, how do central breathing disturbances generate? Do they generate from reduction of the impulses from the brain, leading to hypoventilation, and also associated with apneas? And this is called hypercapnic central sleep apnea. For example, in some very specific disorders like central congenital hypoventilation, Arnold-Chiari malformation, and so on. So diseases which we know best from non-invasive ventilation, from respiratory failure. But some of these patients also present with central sleep apnea. However, much more frequent is non-hypercapnic central sleep apnea. That means there is no reduction of the breathing stimulation, but an increase, an overshoot of breathing stimulation. And therefore, at the end, we have a hyperventilation. So that means central sleep apnea is here, generates here from an imbalance between hyperventilation and apnea. And this is very frequent, or it happens almost to all persons in high altitude, above 2,000 or 3,000 meters of height, heart failure, in some specific situations like renal failure or opioid-induced sleep apnea, which is increasingly frequent especially in the States. For Europe, the most important question, the most important entity is heart failure, leading to non-hypercapnic central sleep apnea, leading to central sleep apnea due to hyperventilation. That means to overshoot and undershoot of the ventilation. And in the rest of my presentation, I will focus on this phenotype. If you have questions, we can also address some of the other aspects in the discussion. So, central sleep apnea in heart failure patients, does it really matter? Is it only a phenomenon which we measure, which we see in PSG, or does it have any impact on the outcome of the patients? Here are some studies showing the relevance. On the right-hand side, you see a review of different studies asking for the prevalence of central sleep apnea in heart failure. And you can see here, how does it work? Thank you. Yeah, thank you. Here you see different studies. Here you see the inclusion criteria. So these studies had a level of HI of 15, 10, 5, and so on. And here you see the prevalence of breathing disturbances during sleep, so both obstructive and central sleep apnea. And what you can see here is in patients with heart failure, with an ejection fraction below 45 or below 55 in the different studies, we have at least a prevalence of 50% breathing disturbances in these patients. And it's also half by half central and obstructive sleep apnea. And if you go to the to the left-hand side study, you see a prospective cohort in more than 1,100 patients. They were hospitalized for acute heart failure. And at the end of the hospital stay, so when they were stabilized again, then they underwent polygraphy or polysomnography. And what you can see here is a follow-up of 3 years of these patients. And what you can see is there are some patients who had obstructive or central sleep apnea, obstructive in green, central sleep apnea in red. And if they were not treated, they had significantly higher mortality as compared to those patients without breathing disturbances or who were treated for their breathing disturbances. So it seems that central sleep apnea matters to these patients. It's not only a phenomenon of PSG. And this has been confirmed very recently by this study from Naito from Japan. And they performed a retrospective analysis of their patients, stable heart failure patients with an ejection fraction of below 50%, NYHA stage at least 2, an HI of 15. And what they found was, again, a significant reduction in survival in those patients with a higher portion of central breathing disturbances. So this is a retrospective study, and I brought it to you because it showed that CPAP actually improved outcome of these patients. So positive airway pressure seems to influence outcome in these patients with central breathing disturbances. So from that point of view, we should not discuss if central sleep apnea, periodic breathing is something beneficial for patients. It kills patients. It matters for patients. And therefore, we have to search for the optimal treatment. I'm not sure if we already found it, but I think we should search for it intensively. When searching for the optimal treatment, we should ask for the pathophysiology, for the underlying causes of these phenotype of breathing disturbances. And especially periodic breathing, which is the most important phenotype in heart failure, has a very specific pathophysiology. I think you all have discussed the loop gain, an engineering term, which was brought to medicine, especially by Wellman and Eckert and their group. And they showed that there is the plant gain, that means the ventilation, the outcome of the result of our breathing stimulation and breathing generation. And then with a circulatory delay, the changes of oxygen and the change of CO2 is measured at the feedback gain, that means the chemoreceptors. And this stimulates respiration in the brainstem. And then it is transferred to ventilation in the plant gain. Patients with central breathing disturbances with hyperventilatory in the hyperventilatory stage are characterized by chronic hyperventilation, and this is the case for heart failure patients. They often present with a CO2 in the night slightly below the level of normal, so 32, 33 or so, indicating the chronic hyperventilation. What's the reason for that? And there are different reasons leading to this chronic hyperventilation. For example, you can see here data from Doug Bradley's group, and they actually measured the fluid shift from the legs to the upper body composition. And what they found was the more fluid is shifted from the legs to the upper body compartments, that means to the lungs, to the neck, the higher is the neck circumference and the higher is the number of breathing disturbances. That means if you shift fluid to the lungs, you increase ventilation. This leads to hyperventilation. And the idea is that vagal efferent nerves from the lungs stimulate the brain, and they are stimulated by the fluid shift in the lungs. So what's the second point? The second point is hypersensitivity. So we have, on the one hand, we have the higher volume in the lungs as one reason for stimulation of the vagal receptors, efferents in the lungs. And the second point is that the chemoreceptors are on a higher level. That means they react more intensively to changes of oxygen and changes of CO2. And this is shown here. You have here heart failure patients, normal persons, and patients with idiopathic central sleep apnea. And here you see the reaction to CO2, so the hypercapnic ventilatory response. Heart failure patients with obstructive sleep apnea are on the same level of the hypercapnic response as healthy persons. As healthy persons and as heart failure patients without breathing disturbances. However, heart failure patients with central sleep apnea have a much higher sensitivity to CO2 as compared to normals or the other groups. And this is the same for patients with idiopathic central sleep apnea. So that means we have at least two components: higher stimulation than the lungs, higher sensitivity of the chemoreceptors, both showing an increase of ventilation. The third component is the response of the brain. So that means components like arousals, brainstem activity also may contribute to the loop gain, to the increased level of the loop gain. So a major role is given by the CO2 level. And I would like to try to explain it with the term of the apnea threshold. This is an apnea threshold. It's a kind of virtual level of the CO2. And as long as the actual CO2 in the blood is above this level, patients breathe regularly. When you hyperventilate, when you reduce your CO2 level below the apnea threshold, then you produce an apnea, a central apnea. If your CO2 is very close to the apnea threshold, then you only have to increase your respiration 1 or 2 breaths, and you will generate central sleep apnea. So that means you switch above and below the threshold, and therefore you come to the periodic pattern of periodic breathing. So please keep in mind this term, the so-called CO2 reserve. That indicates the difference between the actual CO2 and the apnea threshold. You can imagine, in this situation, we have a high CO2 reserve. That means you have to breathe intensively to make your CO2 fall below the apnea threshold and produce an apnea. On the other hand, here, the CO2 reserve is small. That means you need only small hyperventilation, very limited hyperventilation to produce periodic breathing. Please keep the CO2 reserve in your mind for the pharmaceutical discussion. Vaheri nicely showed that central sleep apnea is not always the same. It's not the same between different nights. It may depend on position, it may depend on volume shift, what else? And it's also changing over the course of the night. What you can see here is an increase of the breathing disturbances, here in green, central sleep apnea, over the course of the night. That means in the first part of the night, you have less central breathing disturbances as compared to the last part, the last portion of the night. And they discuss different reasons. For example, worsening of heart function throughout the night, that means increased fluid shift, might contribute here. Hypoxemia, repeated hypoxemia induced with apnea might increase the hypocapnic ventilatory response. And also, apneas might induce arousals, and arousals induce central sleep apnea. So you could come over the night into a vicious circle, leading to increased numbers of breathing disturbances. This is a strong argument against half-night PSGs. So, what did we discuss about pathophysiology? There are vagal efferents from the lung parenchyma. There is an increased chemosensitivity. We have discussed the apneic threshold as a most important aspect. We have discussed about ventilatory responsiveness, arousals. Which role do these pathophysiological components play? What are markers of outcome? And what could be therapeutical targets based on these pathophysiological findings? Let's discuss about some pharmaceutical aspects. For example, one drug being used is azetazolamide. And this is a study from Ginter and colleagues. They used the so-called model of spinal cord injury, a disease which delivers a high risk of central sleep apnea. And they performed the placebo-controlled RCT on azetazolamide for 3 days with a 1-week washout. And here you see what they did. They ventilated the patients, stopped ventilation, and asked how long it takes to develop central breathing disturbances. The result was that azetazolamide actually reduced the number of breathing disturbances, of central breathing disturbances. And what they discussed as possible reasons was that azetazolamide leads to a widening of the CO2 reserve. That means the gap between the actual CO2 and the apnea threshold increases, and therefore makes it improbable to develop a central sleep apnea. And this was actually shown because they found a decrease of the hypocapnic apnea threshold. Second, azetazolamide reduced the HI, the breathing disturbances, by reducing the plant gain, so the ventilation in the lungs. So azetazolamide decreases the susceptibility to hypocapnic central sleep apnea due to these different factors. Azetazolamide is a drug which is effective in central sleep apnea. We have to discuss side effects, but it's effective as it intervenes with the pathophysiological considerations. A second drug, buspirone. It's a serotonin receptor antagonist, similar like trazodone. And again, they were used in the model of patients with spinal cord injury, a small group, 8 male patients. They suffered from breathing disturbances. And again, buspirone interfered with the pathophysiology. Again, it interfered with the CO2 reserve. It widened the CO2 reserve, making it improbable to develop central breathing disturbances. But in addition, it also decreased the controller gain, so the chemoresponsiveness. So a different approach as compared to acetazolamide. Both widen the CO2 reserve, one additionally influencing the controller gain, the other the lung function. What about arousals? Arousals, that means the brain component. And therefore, different hypnotics have been studied. For example, zolpidem, non-benzodiazepine hypnotic. And once again, it influenced the pathophysiology on a different aspect. It did not have an influence on the CO2 reserve. It did not have an influence on the arousal threshold, but it influenced the number of respiratory arousals and the number of the HI. So that means we can use pharmaceutics, we can use them to interfere with the pathophysiology of central sleep apnea on different levels. We can try to influence alveolar ventilation like acetazolamide does. We can try to interfere with chemosensitivity like buspirone does, and we can influence arousability. That means the probability to get an arousal. That means to break the vicious circle, for example, with hypnotics. And as we discussed, the one very important aspect is to increase the CO2 reserve to make it improbable to develop central sleep apnea. What about other treatment options? And you know that CPAP is an option. You saw that CPAP reduced central sleep apnea in the first study, one of the first studies in the Japanese study, and it actually reduced mortality. However, CPAP reduces central sleep apnea only by 50%. And we know from Doug Bradley's CanPEP's study, which showed these data very nicely, and they didn't find in this prospective study an improvement of survival. So we cannot recommend CPAP as a treatment improving survival in these patients. However, it improves the number of breathing disturbances. We all know that adaptive servo ventilation, which counterbalances the pathological pattern of hyperventilation and hypoventilation, it improves it optimally. We have to ask if it's really effective and if it's appropriate and allowed. And we know the discussion from the SURF-HF trial, which did not show any significant difference in the primary outcome parameter. But as you know, secondary outcomes were negative for ASV. And you also may know that there are a lot of critics to this study regarding the population, regarding differences in drug treatment, regarding compliance, shift between groups, and so on. So we are waiting for the results of ADVENT-HF. But nowadays, we have to say we have to be cautious with adaptive servo ventilation, and we must not use it at the moment in a very specific group. That means in those patients with predominant central sleep apnea, heart failure, ejection fraction below 45, only in this group, it's not possible at the moment. That means it is a small group of patients with central sleep apnea, but if these conditions are given, we must be very cautious at the moment. However, there are many other data showing different findings. Unfortunately, not prospective, not randomized controlled trials. So again, we have to wait for ADVENT-HF. This is a huge study from Rami Kayat, prospective study, cohort, not randomized controlled. And what you can see is that, again, there is a significant difference between those who were treated with ASV or with CPAP as compared to the untreated patient in terms of survival. Better for ASV and better for CPAP as compared to no treatment. And if you compare ASV alone with untreated patients, again, there was a significant improvement with ASV. So the jury is out for discussion. We have to wait for additional results. But the question is, can we better define possible risk factors of central sleep apnea leading to mortality, leading to poor outcome. We are discussing a lot about phenotypes, and the next speaker will also focus phenotypes in obstructive sleep apnea. Is it right that we discuss central sleep apnea as a homogeneous group? One fits all. I don't believe so. Therefore, we have to ask for factors which differentiate, which may show us who is at risk of dying, who is at risk of, who will benefit from treatment. So do we have heart failure subgroups? Do we have clinical phenotypes? Are there specific pathophysiological characteristics showing the risk? Are there biomarkers? Let's have a look again in SURF-HF, into SURF-HF, and what we see is that not the whole group had a significant poorer outcome, but only those with an ejection fraction below 30, and those with a high amount of periodic breathing. So one hint from a clinical study showing that not 45, but 30 seems to be the highest risk factor, so very severe heart failure patients. The second point is periodicity. So this is, again, CANPAP, 50% reduction. And if you ask which patients had a better outcome, a better improvement with CPAP, better response to CPAP, there were substantial differences. Here they tried to measure the loop gain. And as you can see here, you have a period of ventilation, a period of apnea, and you have the amplitude of the ventilation. And what you can see here in these different examples, you see here a low amplitude, here a high amplitude, here a short period of apnea, a long period of apnea. And those patients who had a low amplitude, a short apneic period, that means a dampened loop gain, not such a high overshoot of ventilation, they had a better response to CPAP as compared to those with a high loop gain, with high amplitude and long apneic period, short hyperventilation period. So there seems to be differences in terms of the responsibility. What about the chemosensitivity? Very interesting data from Giannoni from 2009. And what they measured was the response to hypoxia and the response to hypercapnia. And they found different phenotypes. They found patients with low hypoxic and hypercapnic response, so a low chemosensitivity, and those with a high response to hypoxia and hypercapnia. And again, those with a high overshoot of the ventilation had the poorest outcome. So again, the higher the overshoot is, the higher the periodicity is, the poorer is the outcome. Third, you can have different patterns of ventilation. You can have a so-called positive pattern. That means the end expiratory lung volume is increased as compared to the negative pattern. And these patients with positive pattern had a better outcome. And it's suggested that the positive end expiratory lung volume stabilizes the heart, leads to better outcome. And finally, you can ask on the hypoxic burden, not on the HI, but on the question how much hypoxia do the patients deliver throughout the night. And what you can see here is the higher the hypoxic burden is, the poorer is the outcome. So it's not the HI, it's the periodicity, it's the chemoresponsiveness, and it seems to be the hypoxic burden. A very interesting study has been done in the French group by Jean-Luc Papin's group. Tamizé is the first author. And they asked from a huge population from the France healthcare system. And they asked if there are differences in outcome, if there are clinical phenotypes describing central sleep apnea better, and comparing it with outcome. And what they defined 6 groups, 6 different phenotypes. And these phenotypes were closely associated with outcome, with death, hospitalization of any cause, and so on. And the the phenotype with the poorest outcome was clearly defined. It were middle-aged male patients, only slightly overweight, and defined by the highest level of periodic breathing. So the phenotype determined survival, not the treatment, the type of treatment. Do we have alternatives? One alternative which is intensively being discussed at the moment is phrenic nerve stimulation. So you implant a pacemaker, a system like a pacemaker, you put into a lead into the vein and stimulate the diaphragm whenever the patients develop a central apneic event. And there are different studies. This is data from a pivotal study, a pilot study, but there are also follow-up data. And they show, yes, that this transvenous neurostimulation significantly reduces the severity of the disease. It improves also other parameters like oxygenation, quality of life, and also sleep parameters. However, I recommend to be cautious with final conclusions because nobody knows if there are also any data showing improved or reduced survival. So it's not the holy grail, this situation, but we have to focus it very closely as we have to focus on drugs. So to put these aspects together, should we treat central sleep apnea? Yes, I'm absolutely convinced that we should treat central sleep apnea, especially in patients with poor outcome in heart failure. Who should be treated? First of all, we have to ask for symptoms. At the moment, we cannot recommend central treatment to all patients, but we have to focus on them, on those who are symptomatic. We have markers of poor outcome which can guide our treatment. Those with a high loop gain, high overshoot, a high chemosensitivity, a high hypoxic burden are ideal patients for treatment. We can also focus on the phenotypes. So patients with heart failure with preserved ejection fraction, non-ischemic heart failure, and patients with deep oxygen desaturations. First line treatment is CPAP, but it works only in 50% of the patients. Second line is ASV for those patients which we are allowed to treat with. And there are some alternatives, phrenic nerve stimulation, oxygen, pharmaceutical agents, but we have to be cautious because for none of these alternatives we have outcome data, long-term outcome data. I would like to say thank you with our colleague Asklepios, the god of health. And I had the pleasure to visit the Archaeological Museum yesterday, and it was nice to find this. So again, thank you so much for your hospitality.
We could take a couple of questions. Are there any questions? I have this. Yes, please.
So thank you for the excellent talk. I want your opinion on that. Change dog's breathing is killing. Yeah. So we have to do something. But many physicians try to find the magic number 5. They want to see number 5 in the device, it's CPAP, BiPAP, ESV. So they try to find this number. I believe it should be 15, 20, doesn't care. And they try to do more. And the more they do, the more they increase the pressures, they reduce the preload, they cause hypotension, they can cause dangerous arrhythmias. So I have the feeling, and I want your opinion, that ESV is not killing people. Physicians are killing people when they are not know how to use the device and what they have to try with this. Not the number 5. We're treating patients and not numbers.
Yeah, I absolutely agree. Once again, I have to be very clear. We cannot give ASV at the moment to everybody, although I'm very convinced of the treatment, but we have to be cautious, just to say it again. But I absolutely agree. We should not treat a number of phenomena in the PSG. I think we have to be not only 15 would be a different level, but symptoms, if the patients become better in symptoms, if they suffer from symptoms. And also, what about their heart failure situation? Does it improve? Does it reduce hospitalization, which is only can only see over the long term? But I would agree. I would, and if you need a number, I would rather I'm close to you with 15 rather than 5. So not reduce the number to the lowest level. Yeah.
Thank you very much. We're going to move on now. That was brilliant, Winfried. We may have time at the end for further questions. And just to add to Winfried's point and answering your question, the SERV-HF trial did control apneas and hypopneas, but it had a poor outcome. So just controlling AHI doesn't tell you the whole story. So, excellent. We move on. And we move on to Sophia. And she's going to talk about now phenotyping in obstructive sleep apnea and how this can help us make treatment decisions. Thanks so much, Sophia.
Thank you, Anita. Thank you all for being here again. Thank you, Winfried, for this really excellent presentation. And you make my life easier, because in some of these treatment options you referred in detail. So I will take the floor from there and adapt it to obstructive sleep apnea. And I will try to skip some slides for time purposes. And of course, when we are speaking about obstructive sleep apnea, I will not refer to the definition. We had extensive discussions yesterday. But we have to keep in mind that we are dealing with a multifactorial disease, not only regarding the various pathophysiological existing until now traits, but also the heterogeneity regarding the clinical phenotypes, the appearance, and the various comorbidities that one patient can have within the same disease severity, whereas someone else doesn't have. And of course, the definition of OS until now highly depend on the method of the sleep study that use the scoring criteria and the arbitrary definitions of sleepiness, the presence or absence of sleepiness. And it is well known in this very important study from the Ipnolow study that they try to compare the three different major criteria for the scoring that we have for scoring: the Chicago criteria, 1999, the 2007, and the latest one, the 2014. And what they found is important, more or less accordance between the Chicago criteria and the latest one, the 2014, whereas 2007 underestimate apnea hypopnea index, resulting potentially, leaving out potentially mild obstructive sleep apnea. And it is well known in our field that even mild OSA with specific phenotype and can result in an increased risk for comorbidities. Additionally, intrathoracic pressure swings, recurrent arousals, and intermittent hypoxia that resulted from apneas and caused by apneas and hypopneas can stimulate all these intermittent pathways like autonomic dysfunction, metabolic dysregulation, inflammation, and oxidative stress, resulting in an increased risk for cardiovascular disease. And of course, in the presence of obesity further exacerbates all these deleterious cascade, leading in an increased risk for cardiometabolic consequences like hypertension, coronary artery disease, stroke, diabetes mellitus, even sudden cardiac death, and daytime consequences, work and traffic accidents, especially if we have the classical sleepy phenotype. And it is well known, the famous task force from ERS and regarding the evaluation of drivers. These consequences, the cardiovascular consequences, are not only related to the disease severity, to moderate or severe obstructive sleep apnea, but as shown from the Greek team within the European sleep apnea database, integrating a huge number of patients. This can be applied to the mild OSA, especially between the range of 11 and 15 apnea-hypopnea index, which shown that can be an independent, as you can see here, a risk factor for systemic hypertension. And as very nicely illustrated by Marisa Bonsignore in this excellent review, OSA and comorbidities form a very, very dangerous relationship, because OSA, compared to other sleep disorders and no disorder, seems to gather the majority and the most severe comorbidities, forming a very dangerous liaison. And of course, again, by Marisa Bonsignore, illustrated very, very nicely some years ago, the need for enhancing the personalized approach and personalized medicine in our field as well, meaning a holistic patient approach, not only regarding the clinical presentation, but only deep phenotyping, identify the pathophysiological traits that are most that are present in each and different patient, and integrating also comorbidities, age, sex related, and environmental factors as well. Therefore, we have to answer, in order to decide the specific therapeutic and individualized therapeutic plan, who OSA patient suffers from clinical significant OSA, who should be treated, what is the optimal therapy, and how we can identify responders versus non-responders. And also, it is well known this bidirectional relationship between pathophysiological and clinical phenotypic traits that, along with comorbidities, can end up in a specific individualized therapeutic plan. And nowadays, we are speaking about combination therapies as well in OSA patients. And there are at least 8 different clinical phenotypes integrating the presence or absence of symptoms, not only sleepiness, but cognitive impairment, fatigue, etc. The gender, incorporating gender issues as well. The severity of obstructive sleep apnea as defined, unfortunately, until now by the apnea-hypopnea index, but in our field, we are all know that we incorporating other parameters as well beyond the apnea-hypopnea index, as the next slide will show, and also the response to treatment. However, yes, we have different clinical phenotypes incorporating all these parameters, as I said, but in this excellent meta-analysis incorporating all the studies for the existing studies regarding the phenotypes in OSA, they show very nicely that we have a long road to cross still, because all these phenotypes are big identified include predominantly middle-aged to older Caucasian men predominantly. Therefore, leaving outside a huge number of OSA patients, because we are lacking of different age cutoff, sex, male to females, and race, ethnicity, that it is known that plays a role in the appearance. It's another thing to be North or to belong to the Mediterranean, or Chinese or Japanese people, that they have different anthropometric or structural different anatomy of the upper airway. And yes, fortunately or unfortunately, like the COPD guys, that they have the FEV1 for disease severity categorization initially, and still they have in the COPD field, we have the different cutoffs for deciding the therapeutic plan. This is many years ago, but still existing as a guideline. I will not go through because we already discussed this yesterday. However, it is well known that apnea-hypopnea index has huge limitations because assume that apneas and hypopneas are equal in their biological effects, but they are not, does not allow us to know the magnitude of oxygen saturation. We can have a patient with exactly the same number of apneas and hypopneas per hour, but maybe the one can spend a total sleep time below 90% with a significant number, like 15 or 20% of the total sleep time, whereas the other one spend only 5% of total sleep time in a saturation below 90. So there is huge differences, and the apnea-hypopnea index can't reflect this important hypoxic burden during sleep. Does not consider the distribution of nocturnal events, supine versus non-supine, REM versus non-REM, does not account for gender or age-related changes. And as I said, two OSA patients with similar apnea-hypopnea index may differ in terms of severity depending on their age, occupation, daytime symptoms, and of course, comorbidities. And we already utilize other parameters with strong publication, like as an add-on. We don't want to abandon apnea-hypopnea index. We can still use, because we can extract important information from this. However, like in the COPD field, as an add-on parameter, we can utilize hypoxic burden, sleep architecture parameters like the WOSO, the arousal index, the frequent sleep stages, etc., and of course biomarkers that are very hot in our field as well, not only for risk stratification but maybe for treatment follow-up as well. And this Baveno classification, Winfried was the leading author of this very, very important paper in our field. And this Baveno classification is a multi-component grading system for OSA severity, integrating the presence or absence of symptoms, either sleepiness or insomnia, because we all know that insomnia is included in the definition of OSA. The presence or absence of cognitive impairment and vigilance, and of course the presence or absence of comorbidities, and these were further validated using a huge number of the patients from the ASADA cohort, and still in progress for further validation. And we can use this not only for disease severity categorization, like we did in the ABCD classification in the COPD field, but also for escalation or de-escalation the treatment. And in this excellent, very, very recently published review from Jean-Louis Pepin, shows very, very nicely the heterogeneity of OSA patients that has pointing out the necessity of deep phenotyping and the holistic approach initially. Deep phenotyping meaning from endotypes to clinical appearance, and also divide the treatment indication and treatment, identify factors for treatment indication like environmental factors, socioeconomic factors, lifestyle behaviors, symptoms and disabilities, and of course what is very, very important, and we have to focus more towards this in our field as well, it's the PROMs, the patient-related outcomes, and the patient preference for the treatment, when we will explain to the patient and to patient's family why we choose this treatment, the advantages and disadvantages. And also we have to acknowledge the factors that are affecting long-term treatment outcomes, and it's comorbidities, a major and huge issue, the hypoxic burden, the sympathetic activity, and the sleep alteration, along with apnea-hypopnea index, for stratify the risk and also for the disease severity categorization, as well as a very, very important topic regarding treatment adherence. And of course, there are existing guidelines regarding the use of PAP with strong evidence in moderate to severe OSA or in mild OSA with the presence of comorbidities. And of course, in these guidelines, there is a strong recommendation, as we revealed yesterday, for educational activities and educational before the initiation and close follow-up of the treatment, not only for the patient, but for the family as well. And we know, as shown last year in this very, very nice publication that gathers all the compared all the existing randomized control trials with using CPAP and with the outcome evaluating the effect of the CPAP in the cardiovascular outcome, and they show very, very nicely that what we know about the adherence, it's not maybe the useful definition, and we have to move on and revise it. And fortunately, it's one of the topics that we will deal with in this task force that we are fortunate to receive from ERS very, very recently, starting in a while to start recruit patients around Europe. And one of the points, the major, the primary points is the role of adherence when we use CPAP. And this shown that Ricazza study that had the most, more than 5 hours per day, 7 days a week, showed the better response in the cardiovascular parameters. However, the bias of Ricazza is that included only patients under CPAP treatment, that they use the CPAP. And they categorize differently according to different adherence cutoffs. And of course, we know that there is a still debate, as shown in this systematic review and meta-analysis regarding the effect of CPAP, but this on cardiovascular outcomes. However, the concern raised is the risk of bias, the CPAP adherence, and the population included in each RCT. Therefore, we need prospective studies incorporating different phenotypes, utilizing the need for specific sleep tests for evaluating the disease, for the disease severity, the disease first of all, and then the disease severity categorization using parameters as an add-on to apnea-hypopnea index with specific and deep phenotype of the pathophysiological traits and of the clinical appearance, comorbidities, and adherence. We are hoping that this task force, after 3 years, will end up in specific answers to all these questions. And of course, we can abandon what the CPAP offer until now to millions of people worldwide, because there is a debate. We are here, we are not only here, but in the European and international level to solve the problem, and the questions come from the clinical observations that we have to do if we are close follow up our patients. And some days ago, this was out by the French registry, by Jean-Louis Pepin as a first author, showing that in a huge number of patients from the French national health system, they are fortunate to have a long-term data collection and follow-up of these patients, like similar one that they have in England as well. They show very, very nicely that the people that they terminate the CPAP, they have a significant increase in cardiovascular risk and the development of cardiovascular comorbidities, whereas the other that maintained the treatment, they reduced all-cause mortality in this patient population. And this is an important finding supporting the use of CPAP connected to adherence. And of course, there are also non-CPAP therapies. Months ago, last year to be exact, it was out the European Respiratory Society guidelines for non-CPAP therapy. We are fortunate to have with us one of the two chairs of this guideline, Winfried Randerath, who is the leading author in this paper. I will go through very quickly some aspects due to the time. I will not deal with the answers, the PICO questions. You can find it there, as well as the summary in the recently published also in the ERR. And what I want to mention is that beyond the CPAP, there are strong recommendations also, and also we have guidelines for this, for oral appliance in specific patient population, patients with simple snoring or mild OSA or moderate OSA that are CPAP refusers. However, they had to be evaluated by a sleep orthodox dental doctor that he's involved. He's accredited in the sleep field, and we have to follow up them after the initiation of oral appliances. And seems that oral appliances, when compared to CPAP, of course, CPAP has a more positive effect in decreasing apnea-hypopnea index. However, patients exhibit more preference to oral appliances, of course, and there was no significant difference in Epworth after therapy between the two groups, as shown by this meta-analysis. Here you can see the various forms of oral appliances, and their practice points with evidence, with level of evidence regarding the OSA patient, the clinical phenotype of OSA patient that can be that we can proceed with oral appliances. The clinical characteristic seems to be lower age, female, lower BMI, smaller neck circumference, and you can see that the level of evidence is strong. Craniofacial characteristics like retracted maxilla and mandible, narrowed airway or shorter soft palate, strong evidence, and moderate evidence is less severe OSA. Strong but positional OSA is moderate evidence. And of course, physiological characteristic, primary oropharyngeal collapse and a high therapeutical CPAP pressure, but with a weak evidence. And there are different options for positional therapy if we are dealing predominantly with POSA, meaning developed mainly in supine position, and there are specific definitions for in order to POSA to be defined. And from traditional Tellis ball techniques that it was at least uncomfortable for a patient to sleep, we are moving to more sophisticated vibratory positional therapy devices. However, we have to test them throughout the years, not only for mortality and morbidity issues, especially connected to cardiovascular, but also what they may cause to the sleep architecture when they vibrate and may cause arousal. So it's not for everything. One size doesn't fit all. And what it's important currently in our field, in OSA field too, it's the various forms of pharmacotherapy that we can use, leaving surgery for very, very selected patients with specific indication, like tonsillectomy, mainly in pediatric OSA or in adults with enlarged tonsils, of course, maxillomandibular osteotomy, and of course, bariatric surgery in selected patients. Therefore, this bariatric surgery, as you can see in the following slide, that unfortunately I have to skip it to make it shorter and leave the others to present, especially Marisa Bonsignore, but this has evidence and there are practical guidelines out. We will refer briefly, this is the osteotomy. We will refer briefly to the role of weight management in the treatment, the lifestyle interventions that we have to to advise our patients to. And as you can see here in the guidelines, there are specific recommendations not only for calorie, the number of calories that the patient has to take. Of course, this is adapted to the patient that you have in front, but also for the level of physical activity with specific recommendation that we may give, again, depending on the patient that you have in front and you are evaluating. And as I told you, there are guidelines for the surgical consultation and especially for bariatric surgery, with strong recommendation. However, as a first option, only in CPAP refuser patients. And you know also it's a holistic approach for peri and pre-operative evaluation in this patient population, because untreated OSA can be a factor that can cause a lot of consequences in this, not only in bariatric surgery, but in surgery procedures in general. Winfried referred more extensively in the upper airway nerve stimulation. Here we speak about upper airway nerve stimulation as another treatment option. However, unfortunately, we don't have so good results in our field towards this. We have some results still to wait, and it's a therapy that it's not abundant, but we need to be careful to patient selection with a specific identified pathophysiological trait like the muscle dysfunction of the upper airway, and more than that, we are lacking of long-term effects regarding morbidity, mortality, and of course the influence of all these devices in sleep architecture, and additionally the cost. And we are fortunate, I'm sorry about this, this is pharmaceutical interventions, but I'm sorry, it's in Greek language, it's pharmaka, it's pharmaceutical interventions that are targeting the ventilatory control stability, the poor upper airway response, the impaired anatomy, and of course the low arousal threshold that can be combined, if needed, to CPAP or in the future to oral appliances or to upper airway stimulation or to myofunctional therapy or to other treatments that may coming in our field as well. And regarding the ventilatory instability, oxygen, not many studies, but still waiting for some results in a long-term one. Oxygen and as you heard before, carbonic anhydrase inhibitors like acetazolamide. However, we are lacking of long-term studies for the limitations that are already discussed by Winfried. Ventilatory drive, some things as a stimulator, and of course acetylcholinesterase inhibitors. Regarding the anatomy, the major one is the drugs that are already available for weight loss purposes that can influence anatomy, because when you lose weight, when you lose fat, you may lose it also along with exercise from the neck circumference and changing the waist to hip ratio that is important in our patient. However, not as a sole treatment. Some studies, they utilize the use of diuretics, nasal decongestants, especially when we have a severe obstruction of the upper airways. Also, we have a lot of studies regarding the upper airway muscle stimulation, and especially the SSRIs, the serotonergic pathways, the noradrenergic, the combination of noradrenergic and antimuscarinic, and some small study utilizing the use of cannabinoids and nicotine agonists, trying to increase the response of the muscles of the upper airways, if this is the predominant pathophysiological traits that could be easily to define from PSG as well as PG studies, as we discussed extensively yesterday. And of course, it's the arousal threshold that we can, let's say, approach with drugs that, like the one that Winfried previously discussed, not benzodiazepines, especially if we have hypercapnic patients to deal with, but we have a very, very good available Z drugs, antidepressants, GABAergic drugs for the GABA pathway, that if we have a patient with a low arousal threshold, we can combine these drugs with symptomatic treatment with oral appliances or CPAP, etc., and reevaluate step by step, because we don't have safety studies, long-term safety studies using in a long-term with a long-term follow-up using these drugs. And of course, we have to remember that we can utilize e-health and part of e-health, telemedicine nowadays, and especially after COVID. It's a good thing that the COVID left to us, but not, of course, as a solid parameter. And also have in mind all the pitfalls and the caps that the telemedicine can have. So we have to identify the positive effect, and eliminate the disadvantages, and also trying to implement it around Europe with a homogeneous approach, because, for example, in our country, there isn't any formal telemedicine procedure and reimbursement procedure. And I would like to close using this summary, this slide from, again, this very, very nice review that I think that summarizes very nicely what we discussed until now. We are in an era, many years now, that we are moved from this traditional PAP model, without abandoning the PAP, of course, that specific collaborations existing with the sleep physicians, sleep laboratories, and some level of healthcare providers, to a most holistic approach, patient-centered approach, integrating very, very carefully the identification of OSA endotypes, the clinical and sleep phenotypes, monitoring of outcomes in relation with specific treatment goals, that it's different from patient to patient. This is why we are speaking about personalized medicine, and all this leads to specific patient-centered outcome. And how we can do this? We can use beyond the face-to-face consultation and diagnosis with in the sleep laboratories. We can use all the utilities that the e-health can provide to us until now, acknowledging potential gaps and pitfalls. And also we need a multidisciplinary team and combination therapies, because what matters is what the patient takes in the end. Thank you for your attention.
Wow, that was a tremendous tour de force. You covered so much ground, Sophia. What we can do now, and it was brilliant, is we can take one question, and I'm sure both Winfried and Sophia will be happy to chat to you with further questions over lunch. So any immediate questions for Sophia?
I think that we should leave it for lunch or later on and move.
I'll just do one quick thing, because I know we're late, and that is, a lot of people say in the clinic, this is fantastic work on the phenotypes, on the Baveno classification at a population level. Mm-hmm. But there is so much overlap between the clusters. So what does it mean to me in the clinic? I see a guy, a middle-aged guy, he has a AHI of 30, he has some ischemic heart disease, he has hypertension. I don't know his loop gain, I don't know his arousal threshold, I don't know his tendency to upper airway collapse, I don't have this other information. So how does it translate through to day-to-day clinical practice?
Well, there is two answers in this. The everyday clinical practice that refers to the respiratory physician or to the respiratory departments evaluating patients with potential sleep-breathing disorders that are not diagnosed. Mm-hmm. First of all, that with simple taking into consideration that utilizing questionnaires that are accredited along with anthropometrics, and they can refer without having the possibility of phenotyping. However, the sleep physician and that is in the sleep laboratories, if has a patient like this in front of him, has to and has the sleep study, can have important information from the sleep study regarding the pathophysiological traits, but most importantly, has the clinical appearance in front, as you said, has the potential treatment options based on the comorbidities to decide either CPAP or non-CPAP therapies based on what the patient also follow. And the most important thing is the education of patient and family, irrespectively of the phenotyping and the pathophysiological traits and the close follow-up.
Brilliant, you're right, thank you. In fact, we'll move on now. You catch your breath. I'll introduce the next speaker, and that is who's attending virtually, I hope, Professor Marisa Bonsignore. Marisa was she's here, Marisa. Hi, hello, Anita. So she was previous head of Assembly 4. She's played a wonderful part in the ERS, and she's done so much basic translational and clinical research in sleep-disordered breathing. And she's going to tell us about a really important area that we need to understand more about, which is sleepiness and cognitive impairment in OSA, from evaluation to medico-legal aspects. Marisa, thanks ever so much.
Thank you, Anita, for this nice introduction, and thank you for the invitation to participate to this meeting. I hope you have a good signal from my screen. And I'm really sorry I could not attend the Heraclion meeting because I was in Lisbon at the beginning of the week, so I couldn't make it. So my task is to talk about sleepiness and cognitive impairment. I have no conflicts of interest. So one problem is the definition of excessive daytime sleepiness. This is defined as the inability to stay awake during the day, should be distinguished from fatigue, but unfortunately it's a common symptom in many medical conditions. So besides sleep disorders like sleep apnea or upper airway resistance syndrome, it is a major symptom in periodic leg movements and in narcolepsy. But there are also neurological conditions such as Parkinson's disease. The most important cause of sleepiness is short sleep or lack of sleep, which is very common and increasingly common in our 24-hour type of culture. There are also medical conditions such as depression. Obesity by itself, independent of age, can cause sleepiness, but also diabetes and hypothyroidism. And also medications such as opiates, antiepileptics, or antidepressants can cause sleepiness. Alcohol increases sleepiness, caffeine decreases sleepiness. There are other recreational drugs, so the overall picture is quite complicated. Another major point of question is how we measure it. And this is what we usually do, is consider the Epworth Sleepiness Scale, which is based on situational questions. So the probability to get sleepy under certain condition, but this is not the same as asking, are you sleepy, which also is an important question we should ask always to our patients. The Epworth Sleepiness Scale is a subjective scale, so the patient can also cheat, which is a major problem in release of driving license, especially for commercial drivers. There is no quality of life assessment. There could be a discrepancy between what the patient thinks and the scores of ESS. In addition, we consider abnormal score higher than 10, but there is about 15% of subjects randomly selected in their population that score 10 or more for different reasons. And clearly there is a gray area about between 9 and 12 to be considered borderline. The problem is not only that it is poorly reproducible, even in the same patient, but it also is modestly correlated with AHI and objective assessment. But if we go to the objective assessment, we all have here tests that need the obtaining a polysomnography the night before performing the test. And also because sleepiness varies during the wakefulness period, so during the daytime, you should repeat the test at different times of the day. And this requires a huge amount of effort because you need to have a technician to do objective tests during the day, being either the maintenance of wakefulness test, or the mean sleep latency test, or the Oxford sleep resistance test. Also, the psychomotor vigilance task can be investigated, but this again, the outcome would be the reaction time or lapses in attention. This is typically done during driving simulation. So this practically is done rarely, except for commercial drivers, especially the maintenance of wakefulness test, or specific situations where another disease is suspected. For example, narcolepsy needs mean sleep latency test to be diagnosed. So yeah, we are left with the subjective scales, and the Epworth is by far the most common one. So we do have a problem with sleepiness assessment. But originally, sleep apnea was considered a disease where there was excessive sleepiness during the daytime. However, we now know that there are different clinical phenotypes, including minimally symptomatic patients, meaning patients with a high AHI who have no symptoms and no sleepiness. There are those, as Sophia said before, with insomnia. So they mostly complain about disturbed sleep. And we have the excessively sleepy phenotype that here has been extended to a moderately sleepy phenotype. And the excessively sleepy phenotype has the highest symptom burden. So it is the full-blown syndrome, not only for the mean ESS score or the questions regarding sleepiness, but also other symptoms like being tired or snoring or sudden awakenings and so forth. They also are the highest, they show the highest prevalence of taking naps because, of course, if you are excessively sleepy, you tend to sleep whenever you can. Importantly, the excessively sleepy phenotypes has been reported to show an increased incidence of cardiovascular disease, and not only coronary heart disease, but also incident heart failure. This is a recent study, so we need confirmation for this, but it appears that our efforts should be especially devoted to try to prevent worsening of the medical situation in the excessively sleepy patients. We also know that daytime sleepiness is associated with an increased risk of accidents while driving. But as you can see from this famous figure, you can see that there are patients with a high ESS score with very low or no accidents. On the other hand, patients in the low medium range can have an increased rate of accidents. So the correlation is poor, but it is still significant. The importance of sleepy patients who do not show accident rates is due to the fact that, for example, a patient who recognizes that he's too sleepy will avoid, for example, driving at night. There are lots of patients who no longer drive at night because of fear of having accidents. So the determinants of the actual risk for motor vehicle accidents are not only sleep apnea, but also behavioral and psychological traits. For example, it has been reported recently that patients who tend to have risky behaviors in general, they also tend to have, as expected, more accident while driving. So this is a very complex issue, and we are actively working on this to sort out what the best markers are and also what the best test would be. What we know, however, is that CPAP is effective in decreasing sleep apnea, and this is the effect is larger in those with severe sleep apnea. And we also know that this is the important study by Terry Weaver in 2007, that the reason why 4 or more hours per night was the number chosen was that at that point you kind of reach a plateau. But still, only 60% of patients who sleep more than 4 hours have a resolution of sleepiness. And if you use CPAP for over 7 hours, the percentage increases, but there are still a lot of patients who remain sleepy. And the question of the residual sleepiness is an important issue nowadays, because also we have new drugs that can be used to address this excessive sleepiness. Weaver found that about 20% of patients remain sleepy after 3 months of CPAP use for 8 hours per night. Jean-Louis Pepin in 2009 reported that about 6% of patients remain sleepy after CPAP for 1 year. And residual sleepiness on CPAP has been estimated variably between 13 and 14% in other studies. So what we addressed recently was what happens in the ASADA cohort. So we looked at the percentage of patients remaining sleepy, which means Epworth sleepiness score higher than 11 points, higher than 10, so from 11 on. And we had the first follow-up visit at different times. So we stratified the patients according to the timing of their first follow-up visit. And you see that 40% of patients seen between 0 and 3 months were still sleepy, but this percentage halved in those seen at 3-6 months, and it declined progressively over time. So it is possible that there is a time effect, so the length of treatment plays a role, but it is also possible that those returning between 0 and 3 months were those having problems with CPAP treatment, so things that had to be fixed, or for example, the residual AHI, emergent central sleep apnea, or mistakes like need to apply mistakes in applying the mask, or a mask that was not fitting well, so leaks. So this high percentage at 0-3 months should be considered with caution, because it might be caused by other factors. There is also a discussion about why people remain sleepy after starting treatment. Animal studies suggest that there is a permanent reduction in wake-promoting catecholaminergic neurons. You can see that here there is a rarefaction of fibers during long-term intermittent hypoxia. And so we do have evidence from animal studies of a possible irreversible damage. But however, we have no evidence in humans yet. And so this is an important point to consider. So in summary, sleepiness is a complex symptom. Not all sleep apnea patients are sleepy diagnosis. However, those who are sleepy are showing increased risk of cardiovascular events and motor vehicle accidents. CPAP has positive effects on sleepiness. Some patients remain sleepy, but we do not know if it is irreversible damage. In this regard, I should say that we analyzed recently some data from the ESALDA cohort, and it appears that in the countries where there is a higher percentage of, a higher prevalence of depression, there is also a higher percentage of sleepy patients compared to other countries with lower rates of depression. So depression is recognized as a very major cause of sleepiness together with sleep apnea or independently of sleep apnea. So there's a lot of research going on this. So let's go to the problems of cognitive effects of obstructive sleep apnea. This is another very complex topic, especially because cognition is made up of several domains. And you see that this is a meta-analysis showing a decrease in a lot of things. The effect size is considered medium if it is 0.5, large if it's higher than 0.8, very large if it is higher than 1. So if you look at the figures here, you see that we have an effect size from medium to large in several domains of cognitive function. Caused by sleep apnea. And prospective studies on the relationship between sleep disorder breathing and risk of cognitive impairment in the general population also show a positive effect, so suggesting that sleep apnea actually increases the risk to develop cognitive impairment. This especially regards decreased executive function, whereas there was no effect on global cognition or memory. In this respect, we also know that there are defects in frontal cortex function that do not disappear on CPAP treatment. So we are also imaging data. And if you do cross-sectional studies, you also see that there are some, for the same things, there is especially a decrease in executive function with no effect on global cognition and delayed memory. This is the same study as for the prospective studies. But what we know is that after treatment with CPAP, we do have positive effects. So CPAP is able to limit the negative effects of sleep apnea on executive dysfunction. And this is again in the medium to large range of effect. So there are problems with the results of meta-analysis. The included studies in these meta-analyses were performed during a long time span. And you know, as Sophia pointed out, that there have been changes in the thresholds and in the criteria for sleep apnea diagnosis. In addition, these studies, especially the old ones, do not report adjustment for premorbid IQ or education, that are important variables, or compliance to CPAP treatment. In addition, the duration of CPAP treatment was variable, and also the heterogeneity in results is partly secondary to use of different tests. And these tests were not always designed to assess specific cognitive domains. Few studies, in addition, were specifically designed to test for the effects of aging. And everybody knows that aging is associated with impairment of cognitive function. So this is a major factor that should be taken into account. Another point was that sleep apnea severity did not turn out to be significant in any meta-analysis. So maybe we should increase the sensitivity of our analysis by taking into account factors such as hypoxemia or sleep deprivation or fragmentation. So this cognitive function studies issue in general is complicated because it requires a multidisciplinary approach, and that is not always very easy in the context of our clinically busy activity every day. This is a study in which the role of sleep disorder breathing on cognitive decline in the elderly was assessed. This is a big study. This is an Alzheimer's disease neuroimaging study. However, the sleep disorder breathing were self-reported, and CPAP use was also self-reported. However, if you concentrate on these two panels, you see that CPAP appeared somehow to slow this is incident MCI, so mild cognitive impairment. So CPAP was possibly useful in delaying mild cognitive impairment. However, it had no effect on Alzheimer's disease incidence. And there are studies, important studies. This is an Italian study, but it's a very good one too. So it's not, there is no patriotic feeling on my side. In this study, they looked at patients who complained about subjective cognitive impairment, but had no cognitive deficits at objective neuropsychological testing. And the subgroups were controls, mild sleep apnea, moderate to severe sleep apnea, and sleep apnea treated with CPAP for at least 1 year with good compliance and efficacy. And they sampled the cerebrospinal fluid for biochemistry routine, including lactate, T-tau, P-tau, and amyloid beta 42, but they also did neuropsychological assessment. First of all, the first important result is that the beta amyloid was decreased in sleep apnea patients, but the level was restored in patients treated with CPAP and was similar to controls. And the levels were proportional to oxygen saturation. For the other variables, CF-tau and p-tau were significantly correlated with PSG variables and cognitive function. And as for cognitive tests, the neuropsychological test did improve. I'm always in the middle of my way. The neuropsychological tests were decreased compared to controls, but they improved towards the control values on CPAP. So this study is important because it suggests that something, at least, is not irreversible as regards cognitive function. And so this is an important issue we should consider. Now, I think personally that patients who are very sleepy, who have a sleep quality that is poor, of course they improve cognitive function when this is a clinical hint. It's not, I have no proof for that, but the cognitive impairment also depends not only on hypoxia and intermittent hypoxia, but also on sleep quality. And I think an interesting model is this one by Ivana Rosenzweig that speculates that intermittent hypoxia up to a certain point may activate the surveillance mechanism. So activate kind of compensatory mechanism. So the pathology is when this results in inflammation, phagocytosis, loss of plasticity. So there could be some positive effect of intermittent hypoxia, but if it is too much, you get only negative results. So it is possible that sleep apnea first may increase vascular risk, causing mixed dementia, so at the cerebrovascular level, but the cognitive symptoms are only the latest steps of this process. So I think this is a very good new paradigm on which we can actually design good studies. So in summary, the positive effects of CPAP treatment on cognitive function are shown. We have had in the last 15 years functional imaging and metabolic studies that have improved our understanding of the complex effect of sleep apnea on the brain, and which for reason of time I couldn't show you. Sleep apnea could hasten the development of dementia, but CPAP may slow it. But the studies in patients with both sleep apnea and dementia are too few and too small. So no conclusion is possible at this stage. Just a few words on medical legal implications. Patients sleepy at diagnosis must be informed about the danger of accidents associated with sleepiness, and they should not drive until they initiate CPAP treatment. Sleep apnea has been included among the causes of sleepiness at the wheel in Europe, and this is the EU Commission directive of 2000, I think, and 15 or 14. However, we have a big challenge because we do have simple methods to assess sleepiness and driving risk. The thing is worsened by the fact that clinicians do not behave all in the same way. This is a very smart British study commissioned by the British Thoracic Society. So there were a lot of big nets to clinicians that they had to respond on a web-based survey. And both the evaluation of sleepiness at baseline and the evaluation of residual drowsiness on CPAP show a high level of lack of consensus among clinicians. So clinicians should also be very alert, because this is a medical legal responsibility, not only on the patient side, but also on the clinician side, even though the restrictions for commercial drivers are certainly larger than those for people who drive normal distances in a year, so usual patients. As ERS task force, we have tried to write down a flowchart for release or renewal of driving license. Definitely the patients with no previous accident that is negative, a clinical examination, at sleep apnea screening questionnaires as a normal Epworth sleepiness scale and does not have other relevant disease, you can quite safely go green, so release the driving license. But if there are previous accidents and they appear sleepiness related, it is very important to ask whether a patient has experienced sleepiness at the wheel, because this is the highest risk group. So here it's necessary to do clinical examination, clinical questionnaire, Epworth, search for risk factors like insufficient sleep, which is the main cause, drugs, obstructive sleep apnea, or other disease with EDS. But in this case, the patient has to be referred to the sleep specialist, and objective assessment of sleepiness is definitely important to do. And if sleep apnea is already known, then we have to verify the Epworth, the clinical examination, including changes in BMI, the adherence to treatment, and if everything is all right, so the compliance is reasonable and there is no EDS, driving license renewal can go green. But if there are EDS, still sleepiness, or previous sleepiness-related accident, we should not release driving license until verification of treatment effectiveness and compliance. The same is true for suspected sleep apnea. If sleep apnea is confirmed, then CPAP should be started, and the release of the driving license should be only after we are sure that the patient is effectively treated and has no residual sleepiness. To conclude, there is a lot of current discussion on sleep apnea clinical phenotypes, as Sophia has beautifully shown. But the sleepy sleep apnea patient is at high risk for not only motor vehicle accidents, but also for cardiovascular complication, and should be considered a high-risk group that requires all our attention and dedication to the problem. The sleepiness is a complex symptoms influenced by several factors. Just this morning, I saw an editorial commentary on meta-analysis, scoping review on the tests to assess EDS, and they concluded even maintenance of wakefulness test is not good to assess sleepiness. So we are starting from scratch still after many years. Cognitive impairment is also associated with sleep apnea and may be the first step towards dementia, but we still do not have clear evidence on the clinical impact of sleep apnea or on the role of CPAP treatment. We still have many uncertainties on the evaluation of fitness to drive in sleep apnea patients. We should make a careful history of sleepiness at the wheel because of the increased risk associated with it. And at least we should always suggest to patients sufficient sleep, because this is a common and the most common cause of sleepiness in general, in the general population, and also in sleep apnea patients. So we need to stress that sleep is necessary for health. And we should also assess adherence to CPAP to consider renewal of the driving license in sleep apnea patient. I hope to have covered reasonably all the fields I was assigned, and I again apologize for not being with you today, and thank you for your attention.
Thank you so much, Marisa, for this extraordinary overview and also for providing with the practical algorithms and information regarding drivers' evaluation connected to their ability to drive. Next year is a promise that you will be here and not virtually. It's a promise, it's a date. So I know that we are running out of time, but we have one more because we are delayed to start. It wasn't our fault. And we have time for one urgent question, because Marisa is virtually and all the others are here and we can discuss it during lunch. But is there any question for Marisa? Well, Marisa, just a short question with a short answer. Are there any data in humans connected hypoxic burden and arousals with the pathophysiology of sleepiness, especially as affecting these two parameters in the histaminergic neurons? Until now, because this is important for the drugs that we have in our hands potentially.
Well, the data, of course, point to both an effect of hypoxia and also disrupted sleep. One field that has been disregarded in the literature is the measure of mechanical factors like the efforts, and we know that the clearance of bad stuff from the brain is also dependent on slow wave sleep and on the changes in pressure during the effort could somehow affect the clearance from the brain of metabolites, and this is completely not studied yet. And for the new drugs, actually, these new drugs could be a good way to assess whether treating sleepiness will improve other factors, for example, cognition, but we don't have this data yet. What we know is that use of solriamfetol, it has been recently published, does decrease the incidence of with sleepiness at the wheel, which is expected because it's a wake-promoting agent, but we still do not have very many data on this topic.
Okay, thank you so much, Marisa. We have to move on. Thank you. We will be together.
Congratulations for
shortly.
this excellent session.
Thank you. Thank you so much.
Good luck for the Congress.
Yeah, and don't forget, we will be shortly together again.
Yes, I know.
Thank you. So we are moving
like
to...
we work.
Yeah. The last but not least presenter is Paschalis Styropoulos, Associate Professor of Respiratory Medicine in the University of Thrace and sleep specialist as well, and well known also in our field. So we are looking forward to hearing his presentation regarding obesity hypoventilation syndrome. It's a very broad title, and this is why you will make it short.
I'll try to keep it short. But first of all, I would like to thank you for the invitation and, of course, for the hospitality. Actually, this is the outline of my talk. After a short introduction, I'll discuss with you the current definition of obesity hypoventilation syndrome, the epidemiology, its diagnosis, some data regarding pathophysiology, its management, and the prognosis. Actually, the true pandemic is obesity. And this is the problem not only in developing countries, but also in developed countries. And at least 13% of the general population, adult population, are obese worldwide. And you can recognize that obesity is a respiratory problem because obese patients have increased work of breathing. And for those who adapted with an increased respiratory drive and increased ventilation, there is no problem. But there are some obese patients with obstructive sleep apnea, and they suffer from intermittent hypoxemia. And we have also obese patients with hypoventilation during wakefulness. And this is actually the obesity hypoventilation syndrome. And the definition, the current definition is the combination of obesity, body mass index greater than 30, awake daytime hypercapnia, and sleep disordered breathing in terms of obstructive sleep apnea or pure hypoventilation, or of a combination of sleep apnea and sleep hypoventilation. And of course, we have to exclude any other causes of hypercapnia, like obstructive airway disease, interstitial lung disease, neuromuscular disorder, or chest wall disorders. And from a historical point of view, the current definition is from 1999, from the American Academy of Sleep Medicine, but the first case was described in 1956, as you can see here. Of course, from the American Academy of Sleep Medicine, we have the definitions regarding sleep hypoventilation. So we have sleep hypoventilation when we have an increase in the PCO2 levels or surrogate markers like end-tidal carbon dioxide or transcutaneous carbon dioxide greater than 55 millimeters of mercury for 10 minutes, or an increase of PCO2 levels at least 10 millimeters of mercury from awake supine value greater than 50 millimeters of mercury for 10 minutes. So we have actually obesity hyperventilation syndrome, which is a sleep-related hyperventilation disorder, which is the most common one, actually. But of course, this is also the case for the increasing prevalence of obesity hyperventilation cases for candidates for non-invasive ventilation at home. Regarding epidemiology, there are several data conflicting, actually, because we have problems with the population studied. But a rough estimation of obesity hyperventilation syndrome in general population, as we can see here, it's below 0.5% of the general population. But we know that when BMI increases, we have an increase of the prevalence of obesity hyperventilation. This is the figure regarding hospitalized patients. This is the figure regarding patients who were referred to sleep centers. And of course, the problem is that we have a problematic diagnosis. And first of all, the clinical presentation of those people is not specific. They report symptoms of sleep disorder breathing, like excessive daytime sleepiness. But as we can see here, they report also dyspnea, which is not a common complaint for sleep apnea patients. They report also waking headaches. You can see the peripheral edema or hypoxemia in awake. And of course, in cases of unexplained polycythemia, you may consider the diagnosis of obesity hyperventilation syndrome. And actually, the diagnosis of obesity hyperventilation syndrome can be done in two situations, two scenarios, clinical scenarios. One is during an acute exacerbation of chronic respiratory failure. And the other one is during a routine evaluation or in a sleep center or in a respiratory department because of the dyspnea or because of suspected obstructive sleep apnea. Unfortunately, the typical diagnosis occurs during the 5th or 6th decades of life of a patient with obesity hyperventilation. And you can see here the main clinical features of patients with obesity hyperventilation syndrome. You can see that they complain for dyspnea, as we can see here, and maybe they are also more somnolent than the typical sleep apnea patients, but this is just a red flag, maybe. We know also that a hyperventilation occurs during sleep in healthy people, but regarding the obesity hyperventilation syndrome, we have three major mechanisms. One of them is the obesity-related changes in the respiratory system. The other one is alteration in respiratory drive, and the other one, which is included in the definition, is the presence of breathing abnormalities during sleep. Let's move in some details. Of course, we have sleep-disordered breathing, and as I have already mentioned, this is the case of upper airways obstruction or sleep hypoventilation, mainly rapid eye movement hypoventilation. We have reduced respiratory drive, and the obesity-related changes in the respiratory system is decrease of lung volumes, increase of work of breathing, of CO2 production, and the central leptin resistance. And as you can see here, you can see that the changes in respiratory mechanics are more pronounced in obesity hypoventilation syndrome than the normocapnic sleep apnea obese patients. And the work of breathing is also increased in hypercapnic obesity hyperventilation syndrome, actually, compared to normocapnic sleep apnea patients. And there is also a reduced respiratory muscle strength. So we have a respiratory muscle weakness, as we can see by maximum voluntary ventilation, MVV. And another factor related to the pathogenesis of obesity hyperventilation is that the elevated CO2 production, which is attributed to the greater degree of obesity in those patients. And also we have leptin resistance. You know that leptin is an adipokine, which is a stimulant of ventilation. We have, in obesity hyperventilation syndrome, we have central resistance to leptin. And the other one is sleeping, the disorders of sleeping. Actually, we have long-lasting apneas or hypopneas, and the post-event ventilatory compensation, the hyperventilation after the obstructive events, are insufficient for the compensation of CO2 production. And the carbon dioxide overload during sleep contributes to the diurnal hypoventilation at the end of the night. And this actually decreases ventilation with the increase of bicarbonate levels. So we don't know why do some obese patients develop hyperventilation and others don't. But I think that you can realize that we have a pre-obesity hyperventilation state. And this is actually the case for the bicarbonate levels assessment. And several years before, they state that maybe the bicarbonate levels could serve like glycated hemoglobin in obesity hyperventilation syndrome. And actually, I think that that was the case for the ERS task force staging proposal for obesity hyperventilation, where 3 parameters were evaluated: hypercapnia during sleep, hypercapnia during wakefulness, and serum bicarbonate levels. And I think that it is a very useful staging proposal, because we want to screen an obesity hyperventilation patient in early stages and to avoid the further complications. But still, we have to prospectively validate this proposal. Of course, when we have the case of obesity hyperventilation during an acute exacerbation, we have to face the patient in terms of non-invasive ventilation. There is a proposal for the EPAP and IPAP titration here in this paper. And regarding the stable ambulatory patients with obesity hyperventilation, we have to state that both CPAP and non-invasive ventilation improve clinical symptoms, quality of life, gas exchange, and sleep disorder breathing. So in this specific cases with severe sleep apnea, which are the 70% of patients with obesity hyperventilation syndrome, we can use as a first line CPAP. And non-invasive ventilation, we can use it in the minority of patients with obesity hyperventilation with milder forms of sleep apnea or pure hypoventilated patients. And of course, the non-invasive ventilation could be BiPAP in different modes, like spontaneous type or more sophisticated types like ST or AVAPs. And this is the algorithm regarding the management in stable patients. You can see here that if we have a case of obesity hyperventilation with severe sleep apnea, we should try CPAP. And for those who don't respond, we can switch to non-invasive ventilation. Actually, these are the recommendations also from the American Thoracic Society Clinical Practice Guideline. As you can see, there are 5 recommendations based on systematic reviews. I'll show you just the titles. Clinicians should use a cutoff point of bicarbonate levels of 27 in order to think the diagnosis of obesity hypoventilation. The stable patients should receive PAP treatment, but actually in terms of a stable hypoventilation patient with severe OSA, we should use CPAP. For those who are hospitalized with respiratory failure, we should use non-invasive ventilation, and we should see them after 2 or 3 months in the sleep lab. And of course, there is not only the respiratory abnormalities. We have an obese patient, so we have to face the problems related to obesity, like cardiometabolic disorders. So we have to promote weight loss intervention to those patients. For those who are interested, these are the systematic reviews regarding the role of positive airway pressure and the role of weight loss interventions in these specific populations. And these are, I think, that the major studies from Spanish Sleep Network regarding the use of non-invasive ventilation in the form of continuous positive airway pressure in patients with obesity hyperventilation and severe sleep apnea, and those without severe sleep apnea. And of course, we have to face weight management changes, of course. Regarding the stimulants like ketozolamide, there are no long-term studies, but that should be in our mind that oxygen treatment should be avoided as monotherapy. We could use oxygen treatment supplementary. And finally, just 2 questions regarding the cardiovascular disease, which is more prevalent, I think, in obesity hyperventilation syndrome, especially pulmonary hypertension. And we have data regarding the comparison between obesity hyperventilation syndrome and sleep apnea without hyperventilation. Under treatment and the prognosis, you can see here the 5 years mortality is poorer in obesity hyperventilation syndrome. And the same is with a new Finnish study with a longer follow-up of patients under treatment. So thank you for your attention. And I think that you know what to do at 7 and 9th October.
Okay,
2020.
yes.
Okay.
Yes, thank you so much, Akis, because
I was running.
No. Very, very effectively, in a very short time, you managed to give us an overview for obesity hypoventilation syndrome from pathophysiology to clinical appearance to the different treatment options and the cardiovascular consequences. Thank you so much for this. Unfortunately, we will discuss this during lunch because it's unfortunate from one hand that we have to stick to the program. We have to be there in this room again at 2:15 because we have the opening ceremony at 8 and we can't delay for this, not only for the dinner purposes, but because fortunately or unfortunately, we will have to get with us, fortunately, I'm just joking, the Ministry of Health that will address and participate in the opening ceremony. So we have to give floor to him and to Archbishop as well, and to the Dean of the university, along with Professor Tzanakis. Thank you so much for this excellent session. I think that
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognizing excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations, and best practice through ERS events and conferences. Increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the 2 pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis and treatment of lung disease. ERS and ELF come together to provide support and information for patients, raise awareness about key issues affecting lung health, and campaign for healthy lifestyles and the prevention of disease. Each year, we host the largest gathering of respiratory professionals in the world at the ERS International Congress, a showcase of excellence for respiratory medicine. It's one of the world's major platforms for the release of new data. Additionally, giving access to live sessions and recordings to tens of thousands of virtual delegates, sharing new thinking and inspiring the respiratory community. The ERS International Congress is an essential ingredient for the advancement of respiratory medicine. The European Respiratory Society, supporting its members in advancing respiratory medicine and improving patient care, offering access to the highest quality unbiased medical education to all healthcare professionals around the world, raising awareness of unmet research and educational needs, and promoting lung health to meet the needs and hopes of our members and our patients worldwide. The European Respiratory Society. Every breath counts.
This year marks my first year as ELF chair. Unfortunately, it's been a year marked by COVID-19, relatively physical distancing, remote consultations and meetings. I know it's taking a toll on many respiratory patients, but we hope it will be different in the coming year. But it's also been a year that has revealed our community's resourcefulness. our adaptability, our innovation, our fresh ideas and approaches to deal with uncertainty. This is also true for the European Lung Foundation. In the past year, we have managed to get a new ELF chair in position. We have adapted a new strategy with 6 strategic goals: to be patient-led, to increase knowledge and understanding, to engage effectively, to have a strong voice, to ensure good governance, and to increase our resource and outreach. We have also modified the ELF Council so it's now a 50-50 split between EIS leadership and patients. This spring, we launched our new website, which ensures better synergies and link with EIS web resources. Amongst other things, it has better usability and is more people-focused. We have also strengthened the visual content on the website to ensure a more diverse communication of content. The website also contains patient input process details and a new section on fundraising. In general, the new website has helped us to strengthen our patient input. We have developed and focused our disease-specific patient advisory groups to better match the interest of patients and to strengthen the links and synergies to the EIS assemblies. This year, we have added 4 new patient advisory groups and giving us 13 in total. We have provided patient input to more than 35 EIS projects in the course of the last year, including 20 task forces and 15 TRCs. One of the new innovations that we introduced in the course of the last year is a format that we call the Patient Conference. The idea with the Patient Conference is to have our disease-specific patient advisory groups lead on defining the content and co-host the patient conference with EIS professionals. In February, we had our first patient conference on bronchiectasis, and in July, we had our second on long COVID. For both events, we had just under 2,000 registrations, with half attending on the day and many more watching the videos afterwards. This is a format that we plan on developing further in the coming year. Another innovation for ELF is the development of a fundraising strategy. We have developed documents and processes for driving our fundraising forward. Our first venture into fundraising was the Virtual Conference Challenge, which took place in conjunction with the 2020 EIS Congress and helped us to raise more than £4,000 for our Healthy Lungs for Life campaign. This year, we have launched the Take the Active Option fundraising campaign. I hope you join it. You'll find more details on our supporter section on our website, which is created to help income generation to improve lung health globally. This past year has been extraordinary in terms of developing and strengthening patient input through digital tools and platforms. We hope to develop this further in the coming year, but we also hope we get to see each other, to meet, to think, to discuss, and to develop together. Because this is the essence of what ELF stands for.
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognising excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations, and best practice through ERS events and conferences, increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the two pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis and treatment of lung disease. ERS and ELF come together to provide support and information for patients, raise awareness about key issues affecting lung health, and campaign for healthy lifestyles and the prevention of disease. Each year, we host the largest gathering of respiratory professionals in the world at the ERS International Congress, a showcase of excellence for respiratory medicine. It's one of the world's major platforms for the release of new data. Additionally, giving access to live sessions and recordings to tens of thousands of virtual delegates, sharing new thinking and inspiring the respiratory community. The ERS International Congress is an essential ingredient for the advancement of respiratory medicine. The European Respiratory Society, supporting its members in advancing respiratory medicine and improving patient care, offering access to the highest quality unbiased medical education to all healthcare professionals around the world, raising awareness of unmet research and educational needs, and promoting lung health to meet the needs and hopes of our members and our patients worldwide. The European Respiratory Society. Every breath counts.
This year marks my first year as ELF chair. Unfortunately, it's been a year marked by COVID-19, relatively physical distancing, remote consultations and meetings. I know it's taking a toll on many respiratory patients, but we hope it will be different in the coming year. But it's also been a year that has revealed our community's resourcefulness, our adaptability, our innovation, our fresh ideas and approaches to deal with uncertainty. This is also true for the European Lung Foundation. In the past year, we have managed to get a new ELF chair in position. We have adapted a new strategy with 6 strategic goals: to be patient-led, to increase knowledge and understanding, to engage effectively, to have a strong voice, to ensure good governance, and to increase our resource and outreach. We have also modified the ELF Council so it's now a 50-50 split between EIS leadership and patients. This spring, we launched our new website, which ensures better synergies and link with EIS web resources. Amongst other things, it has better usability and is more people-focused. We have also strengthened the visual content on the website to ensure a more diverse communication of content. The website also contains patient input process details and a new section on fundraising. In general, the new website has helped us to strengthen our patient input. We have developed and focused our disease-specific patient advisory groups to better match the interest of patients and to strengthen the links and synergies to the ERS assemblies. This year, we have added 4 new patient advisory groups and giving us 13 in total. We have provided patient input to more than 35 ERS projects in the course of the last year, including 20 task forces and 15 TRCs. One of the new innovations that we introduced in the course of the last year is a format that we call the Patient Conference. The idea with the Patient Conference is to have our disease-specific patient advisory groups lead on defining the content and co-host the patient conference with ERS professionals. In February, we had our first patient conference on bronchiectasis, and in July, we had our second on long COVID. For both events, we had just under 2,000 registrations, with half attending on the day and many more watching the videos afterwards. This is a format that we plan on developing further in the coming year. Another innovation for ELF is the development of a fundraising strategy. We have developed documents and processes for driving our fundraising forward. Our first venture into fundraising was the Virtual Conference Challenge, which took place in conjunction with the 2020 ERS Congress and helped us to raise more than £4,000 for our Healthy Lungs for Life campaign. This year, we have launched the Take the Active Option fundraising campaign. I hope you join it. You'll find more details on our supporter section on our website, which is created to help income generation to improve lung health globally. This past year has been extraordinary in terms of developing and strengthening patient input through digital tools and platforms. We hope to develop this further in the coming year, but we also hope we get to see each other, to meet, to think, to discuss, and to develop together. Because this is the essence of what ELF stands for.
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognizing excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations, and best practice through ERS events and conferences. Increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the two pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis and treatment of lung disease. ERS and ELF come together to provide support and information for patients, raise awareness about key issues affecting lung health, and campaign for healthy lifestyles and the prevention of disease. Each year, we host the largest gathering of respiratory professionals in the world at the ERS International Congress, a showcase of excellence for respiratory medicine. It's one of the world's major platforms for the release of new data. Additionally, giving access to live sessions and recordings to tens of thousands of virtual delegates, sharing new thinking and inspiring the respiratory community. The ERS International Congress is an essential ingredient for the advancement of respiratory medicine. The European Respiratory Society, supporting its members in advancing respiratory medicine and improving patient care, offering access to the highest quality unbiased medical education to all healthcare professionals around the world, raising awareness of unmet research and educational needs, and promoting lung health to meet the needs and hopes of our members and our patients worldwide. The European Respiratory Society. Every breath counts.
This year marks my first year as ELF chair. Unfortunately, it's been a year marked by COVID-19, relatively physical distancing, remote consultations and meetings. I know it's taking a toll on many respiratory patients, but we hope it will be different in the coming year. But it's also been a year that has revealed our community's resourcefulness, our adaptability, our innovation, our fresh ideas and approaches to deal with uncertainty. This is also true for the European Lung Foundation. In the past year, we have managed to get a new ELF chair in position. We have adapted a new strategy with 6 strategic goals: to be patient-led, to increase knowledge and understanding, to engage effectively, to have a strong voice, to ensure good governance, and to increase our resource and outreach. We have also modified the ELF Council so it's now a 50-50 split between EIS leadership and patients. This spring, we launched our new website, which ensures better synergies and link with EIS web resources. Amongst other things, it has better usability and is more people-focused. We have also strengthened the visual content on the website to ensure a more diverse communication of contents. The website also contains patient input process details and a new section on fundraising. In general, the new website has helped us to strengthen our patient input. We have developed and focused our disease-specific patient advisory groups to better match the interest of patients and to strengthen the links and synergies to the EIS assemblies. This year, we have added 4 new patient advisory groups and giving us 13 in total. We have provided patient input to more than 35 EIS projects in the course of the last year, including 20 task forces and 15 TRCs. One of the new innovations that we introduced in the course of the last year is a format that we call the Patient Conference. The idea with the Patient Conference is to have our disease-specific patient advisory groups lead on defining the content and co-host the Patient Conference with EIS professionals. In February, we had our first patient conference on bronchiectasis, and in July, we had our second on long COVID. For both events, we had just under 2,000 registrations, with half attending on the day and many more watching the videos afterwards. This is a format that we plan on developing further in the coming year. Another innovation for ELF is the development of a fundraising strategy. We have developed documents and processes for driving our fundraising forward. Our first venture into fundraising was the Virtual Conference Challenge, which took place in conjunction with the 2020 ERS Congress and helped us to raise more than £4,000 for our Healthy Lungs for Life campaign. This year, we have launched the Take the Active Option fundraising campaign. I hope you join it. You'll find more details on our supporter section on our website, which is created to help income generation to improve lung health globally. This past year has been extraordinary in terms of developing and strengthening patient input through digital tools and platforms. We hope to develop this further in the coming year, but we also hope we get to see each other, to meet, to think, to discuss, and to develop together. Because this is the essence of what ELF stands for.
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognizing excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations, and best practice through ERS events and conferences. Increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the 2 pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis and treatment of lung disease. ERS and ELF come together to provide support and information for patients, raise awareness about key issues affecting lung health, and campaign for healthy lifestyles and the prevention of disease. Each year, we host the largest gathering of respiratory professionals in the world at the ERS International Congress, a showcase of excellence for respiratory medicine. It's one of the world's major platforms for the release of new data. Additionally, giving access to live sessions and recordings to tens of thousands of virtual delegates, sharing new thinking and inspiring the respiratory community. The ERS International Congress is an essential ingredient for the advancement of respiratory medicine. The European Respiratory Society, supporting its members in advancing respiratory medicine and improving patient care, offering access to the highest quality unbiased medical education to all healthcare professionals around the world, raising awareness of unmet research and educational needs, and promoting lung health to meet the needs and hopes of our members and our patients worldwide. The European Respiratory Society. Every breath counts.
This year marks my first year as ELF chair. Unfortunately, it's been a year marked by COVID-19, relatively physical distancing, remote consultations and meetings. I know it's taking a toll on many respiratory patients, but we hope it will be different in the coming year. But it's also been a year that has revealed our community's resourcefulness, our adaptability, our innovation, our fresh ideas and approaches to deal with uncertainty. This is also true for the European Lung Foundation. In the past year, we have managed to get a new ELF chair in position. We have adapted a new strategy with 6 strategic goals: to be patient-led, to increase knowledge and understanding, to engage effectively, to have a strong voice, to ensure good governance, and to increase our resource and outreach. We have also modified the ELF Council so it's now a 50-50 split between EIS leadership and patients. This spring, we launched our new website, which ensures better synergies and link with EIS web resources. Amongst other things, it has better usability and is more people-focused. We have also strengthened the visual content on the website to ensure a more diverse communication of contents. The website also contains patient input process details and a new section on fundraising. In general, the new website has helped us to strengthen our patient input. We have developed and focused our disease-specific patient advisory groups to better match the interest of patients and to strengthen the links and synergies to the EIS assemblies. This year, we have added 4 new patient advisory groups and giving us 13 in total. We have provided patient input to more than 35 EIS projects in the course of the last year, including 20 task forces and 15 CRCs. One of the new innovations that we introduced in the course of the last year is a format that we call the patient conference. The idea with the patient conference is to have our disease-specific patient advisory groups lead on defining the content and co-host the patient conference with EIS professionals. In February, we had our first patient conference on bronchiectasis, and in July, we had our second on long COVID. For both events, we had just under 2,000 registrations, with half attending on the day and many more watching the videos afterwards. This is a format that we plan on developing further in the coming year. Another innovation for ELF is the development of a fundraising strategy. We have developed documents and processes for driving our fundraising forward. Our first venture into fundraising was the Virtual Conference Challenge, which took place in conjunction with the 2020 EIS Congress and helped us to raise more than £4,000 for our Healthy Lungs for Life campaign. This year, we have launched the Take the Active Option fundraising campaign. I hope you join it. You'll find more details on our supporter section on our website, which is created to help income generation to improve lung health globally. This past year has been extraordinary in terms of developing and strengthening patient input through digital tools and platforms. We hope to develop this further in the coming year, but we also hope we get to see each other, to meet, to think, to discuss, and to develop together, because this is the essence of what ELF stands for.
The European Respiratory Society is the largest scientific and clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognising excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonising the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks.
I will start. Okay.
No, I will briefly. Good afternoon again. Fortunately or unfortunately, we have to start because we have to be on time. So we have the honor and the privilege again to have Wilfried with us. And once again, thank you for responding positively to our invitation and be here with us. And basically, he will coordinate this important session. And I will try to support him as much as I can. Wilfried, thank you again.
Thank you again, Sophia, for the very kind invitation and introduction. It's my pleasure to be here as the chair for this session number 3, because I think you raised very important points and put together a program which really focus on the edges of sleep-disordered breathing. And it's my pleasure to introduce Bakakos Pharynidis, who will talk about sleep breathing disturbances in COPD.
With stress relief techniques for Michael.
Yeah, I want to thank you, the organizing committee and the chairs of this session, for their invitation. Okay. Okay. Yes, my presentation is about sleep breathing disorders in COPD. To begin, this is a definition of COPD. I think everybody knows this, but I have to focus on this. Sorry. That comorbidities may have an impact on morbidity and mortality. and sleep breathing disorders belong to these comorbidities. And we see here that comorbidities are very important in the management and the follow-up of COPD patients. The goals of effective management of the disease is to relieve symptoms, to prevent disease progression, to improve exercise tolerance and sleep and health status, and to prevent exacerbation and complication, so to result in a reduction of mortality. These are the guidelines, gold guidelines for COPD, and the ERS guidelines recommendation for NIV for the management of COPD. This is the recommendation for ventilatory support to COPD patients, and it is for patients after acute exacerbation with hypercapnic respiratory failure that persists after 2 to 4 weeks after the event of hospitalization. In this patient, we have to start the NIV treatment, and this recommendation based on mainly on this study. This study has 2 groups, one with home oxygen alone and one with home oxygen plus NIV. It showed that after 12 months, the risk of readmission or death was 70% reduced in the NIV group. These are the main sleep disorders in COPD: altered sleep architecture, insomnia, sleep-related hypoxemia, sleep hypoventilation, the overlap syndrome, restless leg syndrome, and central sleep apnea. I will focus mainly in the sleep breathing disorders, but first I have to mention that insomnia is very important in COPD patients with 2 main mechanisms. The one is difficulty in initiating sleep, either because of cough or excessive mucus production, and the second is due to breathing disorders such as hypoventilation, increased VQ mismatch, and reduced FRC, mainly in REM sleep that result in hypoxemia, dyspnea, and increased respiratory effort. And finally, the patient has difficulty in maintaining sleep. Insomnia is correlated with symptoms of the disease. We see here with a CAT score over 20, we have 60% of patients with clinical or subthreshold insomnia. To assess insomnia in these people who have many indexes, such as Insomnia Severity Index and Athens Insomnia Scale. Normally, during sleep, we have alteration in respiratory control, respiratory muscle function, and lung mechanics. And in normal subjects, this result in hypoventilation, hypoxemia, and hypercapnia. But in normal subjects, this is not clinical significant. But in COPD patients, we see that there is an increase in load, a decrease in capacity, and decrease in drive. And we see here all the mechanisms: increased upper airway resistance, reduced tidal volume and minute ventilation, hyperinflation and flattening of the diaphragm, diminished hypoxic and hypercapnic drive, and diminished tone and activity of accessory muscles of respiration. And finally, reduced FRC. All these result in increased respiration rate, reduced mean ventilation, increase in dead space, and finally in alveolar hypoventilation. There are some interactions between COPD and OSA, both promoting and protective factors. The promoting factors for OSA is rostral fluid shift, cigarette smoking and inflammation, skeletal muscle weakness, and medications such as corticosteroids. We have protective factors for OSA, low BMI, hyperinflation, diminished REM sleep, older age, and some medications such as theophylline. But I have to point out here that maybe these factors are protective for OSA, but may result in hypoventilation due to emphysema and lung hyperinflation. And there are some conditions that increase the prevalence of symptoms for both COPD and OSA, such as reflux disease, allergic rhinitis, obesity, and smoking. Here is the sleep-related hypoxemia. Daytime oxygenation is an independent predictor of nocturnal desaturation, and this is why these patients have a wake saturation between 90 and 95%. And they are here in the oxyhemoglobin dissociation curve. They are in the steep part, and it is more. These patients have more nocturnal desaturation, and there are studies before here that there is a good correlation between lowest saturation during sleep with mean saturation during awake. And nocturnal desaturation is an indication of nocturnal hypoventilation, and these patients have worse survival. The overlap syndrome, first introduced in literature in 1985 by Flenley as the overlap syndrome, and is the concurrent presence of COPD and OSA. The diagnosis made by in-lab full PCG in a patient who presents with sleep-related complaints. Typical PCG features are episodes of apneas, hypopneas, arousal, and oxygen desaturation and/or hypoventilation, mainly in the REM sleep. And why this is important to have both diseases? Because from this review, patients that are diagnosed with overlap symptoms have greater nocturnal oxygen desaturation and an increased sleep time spent with saturation below 90%. And this is associated with more cardiovascular morbidity, poor quality of life, more frequent COPD exacerbation, and increased medical cost. These are the interactions between the two diseases, COPD and OSA. Both of them result in hypoxia. Both of them share common risk factors such as cigarette smoking and adipose tissue that result in inflammation. And all this inflammation result in endothelial dysfunction, atherosclerotic plaques, and in the end, cardiovascular morbidity. Here is one of the first studies for overlap syndrome and the only one with treatment until now. We see here that patients with overlap have worse survival and more exacerbations than patients with pure COPD. When we treat these patients with CPAP, here and here, we see that survival is better. And here we can see that patients that use CPAP over 4 hours have a survival similar to OSA. As for the cardiovascular, we know that these patients have greater prevalence of pulmonary hypertension, arrhythmias, and here we see a recent trial showed that patients with overlap have greater mass index, right ventricular mass index, than patients with pure COPD. RLS, here are the criteria for RLS, but we have to point out here that 1 of 3 patients with female predominance have RLS and COPD, and the severity of RLS is correlated with daytime breathlessness and subjective sleep quality. COPD result in hypoxia and hypercapnia, and through the VEGF pathway result in reduced dopamine synthesis and RLS. Other factors are nicotine and low ferritin levels. Central sleep apnea is not so common in COPD patients, but is common in patients with comorbidities or complications such as pulmonary hypertension and diastolic dysfunction of left ventricle. These are very important, are the symptoms and findings which are indicative for sleep disorder breathing in patients with COPD. First, we have the classical symptoms such as snoring, gasping, choking, and nocturia or morning headache. increased daytime sleepiness measured by scales such as Epworth scale, signs of obesity, BMI over 30 in men, 35 in women, reduced daytime oxygen saturation below 93, daytime hypercapnia if they have pulmonary hypertension or right heart failure, polycythemia in patients who use opioids and hypnotic, and comorbidities such as atrial fibrillation, end-stage renal disease, diabetes, heart failure, and difficult to treat hypertension and stroke. The optimal sleep diagnostic test is a test which can determine the degree of hypoxemia and hypercapnia, the exact breathing disorder, if it is central, obstructive, or if we have hypoventilation, and the degree of sleep disturbance. Until now, there are no specific diagnostic guidelines for COPD patients with suspected overlap syndrome or hypoventilation. The diagnostic tools that we have is the overnight pulse oximetry, but we can use this only as a screening device. Home sleep studies has limited or no use in COPD patients. And the gold standard is the full in-lab ECG with simultaneous carbon dioxide measurements, either by end-tidal carbon dioxide or transcutaneous carbon dioxide tension. So we can diagnose the full range of sleep-breathing disorders, such as hypoventilation, central apnea, airflow limitation, either respiratory or expiratory, and arousals. Here we see patterns of oxygen desaturation in a patient with OSA. In a patient with pure COPD, we see here the hypoventilation with sustained hypoxemia and hypercapnia. And here we see a patient with overlap, which is a combination of these two. Sleep hypoventilation, we see here a patient with hypoventilation. We have decreased flow and effort, sustained hypoxemia, and an increase in transcutaneous carbon dioxide levels. And during this episode of hypoventilation, we have tachycardia. The treatment depends on which of the two conditions prevails. If we have mainly OSA, upper airway collapse, we can treat these patients as classic OSA patients with CPAP or an alternative anatomical therapy. If we have a patient with pure COPD, first we have to give the optimal treatment with bronchodilation, maybe pulmonary rehabilitation, and oxygen, and of course tobacco cessation. If we have hypoventilation, we have to use NIV. These two are recent studies that show the impact of PAP treatment adherence on outcomes in patients with overlap syndrome. We see here, after 1 and 2 years of treatment in the patients who were adherent with treatment, that there was a significant reduction in hospitalization, emergency rooms visits, acute exacerbation, during the 2 years follow-up. And here we can see patients that treated with CPAP, there was a reduction of both sleepiness and fatigue. And this was as with these patients with OSA and patients with overlap. And we see after treatment they have both results. The take-home message is in a patient with COPD, always to see if they have symptoms of sleep-breathing disturbances. These patients have blunt symptoms, and we have to be very careful during examination, and not to forget the correlation with severity of COPD and sleep-breathing disorders, fatigue, and some features of insomnia. And here are the main breathing disorders: nocturnal desaturation, hypoventilation, and overlap symptoms and their clinical outcomes. I want to thank you for your attention.
Thank you very much for this excellent overview. And you showed the broad spectrum of possible correlations or association between COPD and sleep apnea. Are there any questions? We left us some time for questions. I would like to start with a question on the problem that COPD is a very frequent disease. OSA is a very frequent disease. What is your recommendation? How should we find the patients which we look for sleep apnea in COPD? Would you recommend we should screen everybody, or are there any ideas how to find out from?
I think we can't screen everybody because there are too many patients. We can use the table I showed that a patient may have daytime hypercapnia or some pulmonary hypertension or right heart failure. We should have a sleep study in this patient. And we can use questionnaires, but they are not so sensitive and specific in this patient, especially in COPD patients. And we can use an overnight pulse oximetry as a screening in patients high risk for a sleep breathing disorder.
Mm-hmm. Okay. Yeah.
If I may add something further to the question, and the answer is, of course, complete. If we have in front of us in our outpatient clinic a patient with COPD, that the severity of daytime saturation, along with the presence of hypercapnia or the bicarbonate, doesn't correlate, or the presence, as Michalis said, of pulmonary hypertension doesn't correlate with the severity of the COPD disease, then we have to ask some very common questions, because frequent ones, because there isn't any stabilized questionnaire, as far as we know, focused in this patient population, like if the patient snoring every night, or if the patient feels fatigue, or if expresses difficulties maintaining or initiating sleep, because usually this patient population doesn't report so much sleepiness, because they mixed up sleepiness with their other forms of the disease, like dyspnea, and because dyspnea limits their activity. So I think that if we have blood gases along with spirometry and findings for the cardiovascular that doesn't correlate to the severity of the disease, with two simple questions along with a night oximetry, we can easily refer this patient to the sleep specialist for further evaluation. And maybe this can better handle the effectiveness of the treatment if we initiate combination therapies that can reduce the morbidity and the mortality, as the latest studies shown.
Mm. Other questions or other comments? If not, I would like to add to that point. I'm not sure if we focus on symptoms, we come to the same problem as in sleep apnea in general. If we only focus, or mainly focus on those patients who present with typical symptoms, either insomnia or sleepiness, then we might oversee those patients who have poor outcome. Mm-hmm. And unfortunately, we do have only cohort studies on outcome. We need, of course, prospective studies, but it's difficult, of course. But the difference in outcome was only based on the association of COPD and OSA, not on symptoms in this study.
Yes.
So the question is, is it enough to focus on symptoms? And when we look for comorbidities, then it's again on the end of the course. So if you want to be earlier, we need?
But if you have a saturation level of below 93%, as the authors suggest, along with increased bicarbonates that are not of metabolic origin, of course, or signs, and of course it's the advanced phase of pulmonary hypertension, but these previous two ones that are not correlated with the severity of the disease, even though the patient is compliant with all the bronchodilators that are given to the patient, then we may have some objective measurements for this. Of course, there is also the gender issue that can add on further to what you mentioned correctly. So I think that we have a long road still to cross, but we have to identify specific parameters, objective and potentially subjective, phenotyping further the already COPD existing phenotypes along with the sleep breathing disorder phenotypes. I totally agree with you regarding the symptoms.
Mm-hmm.
My name is Katerina Plami. I am from Athens.
I got the microphone. Just a second, please.
A comment. Maybe COPD
patients are patients with a lot of comorbidities, and I mean cardiovascular comorbidity especially. So it is not, I think it is not very weird if we ask, if we must ask them about sleep disorder breathing. As a comorbidity, such as we ask them for hypertension, for arrhythmia, for other problems. So I think that inside the clinical and medical history of these patients, we should have, or we must ask them about breathing sleep disorder, regardless of symptoms, or if we have in front of us an obese patient with COPD, or even a patient with emphysema because they have insomnia or all of the other sleep disorders. So I think we must be a lot of much about the sleep breathing. Open.
Yeah.
Yes.
Yeah.
Okay.
Thanks a lot for this comment. I think it's important that we do not only discuss it in the Sleep Society, but bring it to the Pulmonary Society. But this is a congress or meeting which includes both. Thank you so much. Thank you again, Michael. You see, you brought up a big discussion. Thank you. Our next speaker is Babis Mergikikis. I'm sure I do not have to present him or introduce him in this audience. He's the head of the Henri Dunant Sleep Disorders Center, and he will present on an important, interesting topic which is not very often addressed: interstitial lung disease and sleep apnea. Thank you. Or sleep disorders.
If I may, before Charalambos starts, Babi starts, it was the first one that brought this idea after his specialization in States regarding the other overlap, or the first, let's say, as he will present overlap syndrome. And he introduced the idea originally in our medical school. And we start with a PhD back many years ago, and we are continue. So I have to acknowledge that it was the father, it's the godfather, the father of the idea, whatever. Thank you, Babis.
Thank you so much, Sophia. Dankeschön. Mein Name ist sehr schwer. Das ist Charalambos.
Charalambos.
I told him, Babis. I told him, mea culpa.
Yeah. Okay, thank you so much. So let's start. Probably I'm going to present things in a different way. Actually, because I was directly involved in this issue. But I believe that at the final, you are going to learn some interesting things about IPF and sleep. So, no complicated interest. Let's go back. 2005. I don't look the same, but at that time I was a sleep fellow at the Cleveland Clinic Sleep Disorder Center, and in the past I was as a pulmonologist involved in IPF. Actually, I was a member of the Greek IPF society, and when I was in the first month of my sleep fellowship, I was very surprised by the fact that I haven't seen a single one guy with IPF referred for a sleep study. And it was strange because in a huge lab with 4,000 to 5,000 patients, every year, there were plenty of patients with COPD referred for a sleep study. And there was always a talk about
sleep staff, sleep physicians, sleep technicians, related to the overlap syndrome, namely the coexistence of COPD and sleep apnea. So I thought this is interesting, and I have to try something. I have to make a research. So when I go back to history, I saw that actually David Flenley didn't say that COPD is the only disease with an overlap syndrome. Actually, the same term could be applied in other chronic diseases such as IPF. And if somebody wants to think about, it's easier to explain why sleep apnea may be more common in IPF, because it is an old theory by Van der Graaf. It's the tracheal traction theory, named decreased lung volumes decrease the caudal traction of the trachea, and this may increase the collapsibility of the upper airway. So this may be a reason for increased sleep disorder breathing in patients with restrictive lung diseases. And this is another paper from 2003. So you actually can see here that increased lung volumes, such as hyperinflation, the pink puffer guys of COPD, actually have a low collapsibility of the upper airway. So probably they cannot have sleep apnea. It prevents against sleep apnea, contrary to the other guys with the small lung volumes that have an increased collapsibility of the upper airway. So it's obvious that this may be a case that these people may have sleep apnea. So this is not from that time, but this is from the same issue of chest. And this is the group, the COPD group, and this is our group. And actually, it's the first time ever I saw, Professor McNicholas wrote that lung hyperinflation actually protects against OSA. That was the first time, the first review, at least written. And actually, by saying that, he agrees with us. We have the main theory all over the time that the decreased lung volumes may be a reason for sleep apnea in patients with IPF. So that was the mid-80s, some dark ages. Actually, there are some reports, there are some papers pointing on physiology, even though they discourage, physicians from making sleep studies in patients with IPF because they thought there is no sleep apnea. Even though I read also the small letters of the papers, and I saw actually that there was an evidence even in these two papers that people with restrictive lung diseases may have OSA. So the next step was to stand in front of the research committee and to tell them why I want to start research. So there are several causes for pulse rate quality in IPF. So I have to start with the most popular one because all people want to talk about sleep apnea. But in my opinion, there are other things that may be even more significant. For example, depression, anxiety that can produce insomnia. For the disease by itself, the way these people breathe during the night, the nocturnal cough is very, very cumbersome. And there was another study in 2005, and let's see that these people with IPF may have all kinds of insomnia, sleep onset insomnia, sleep maintenance insomnia, and probably the most common cause of that is nocturnal cough. The famous partner of COPD, already a lot of papers, you saw that before, insomnia was already reported in COPD. So why not in IPF? IPF is also a 24-hour disease, not only COPD. So my main question was, why are patients not referred for a sleep study? And then I went to Dr. Chapman, who was the director of the department who was for the IPF guys. And I told him if his physicians were aware about sleep apnea. And he told me, yes, they send patients to the sleep lab. So then I had to go into the raw data. I have to make a big dive in the files of patients and the raw data. And I was so surprised by the fact that they had almost 900 patients with confirmed IPF during the time I was in Greece. And I was belonging in the Greek team of IPF. These numbers are huge. I have never seen such numbers. But the most interesting was that I actually had right. Less than 1% of the patients were referred for a sleep center, for a sleep study, for a sleep evaluation. And even more interesting was the fact that the majority of these patients had sleep disorder breathing. So the main aim of my research was to grow the awareness among healthcare providers, physicians, pulmonologists, people who are involved in patients with IPF. Do not defer a sleep study, a sleep evaluation from these patients because they point only on daytime symptoms of dyspnea and cough and forget that people also sleep during their life. So this was a small study, a small retrospective study with several limitations, even though, as you can see, pulmonologists at the Cleveland Clinic sent only obese people for a sleep study. And also, it was the time that they used corticosteroids in order to treat IPF, so they had huge necks, the fatty position. It was obvious that there was be a correlation between the severity of sleep apnea and BMI. And in this small and retrospective study, our theory, especially during REM sleep, showed a correlation between the EHI and the severity of functional impairment of the lungs. So, but the most interesting thing is that in this study, I found that the main symptoms that patients were sent for a sleep study was excessive daytime sleepiness. Hold this because I'm going to tell other things after that. And snoring. I haven't seen a single patient with insomnia. But you know, that was the time, the sleep boards, the main question in the sleep board was when we are going not to perform a sleep study. It was in insomnia cases. That was that time. So no one from the physicians would write down that the patient had insomnia. Otherwise, a very expensive procedure in the United States, such as in-lab PSG, would not be covered, by the insurance companies. So the main events that have been scored were hypopneas and obstructive in nature. So the equipment used in the past study, was probably not good enough to find all these events. Another thing is that I found increased PLM index and also some patients with RLS. The same thing has found Prado in patients with scleroderma some years ago. But if you know the guidelines for PLMs during that time was 5. So if you had more than 5 events per hour of sleep, that was abnormal. Right now, it is 15. So I have the feeling that this is of no meaning with the data and the guidelines we have right now. But still, the famous other part, COPD, restless legs, is common. So we have to find if the same exists in IPF. This is something we have to find with new research. So after that, there was the first prospective study performed also in the United States by Lancaster. She had 50 patients with IPF. Actually, the main limitation was that the patients were under treatment, and she found a huge number of patients having the magic number of above 5. But if we find patients above 15, that's what 68%. But these patients who had an EHI above 15 should have treatment irrespective of symptom based on guidelines. So she found no correlation between pulmonary function testing and EHI, and I think this is the correct, because actually we make all these tests with the patient in the upright position, in the seated position, and not in the supine position. And also she finds that the events were obstructive in nature and actually almost only hypopneas. Another interesting thing was that she found that the patients were not sleepy, at least by using this scale. And many patients had a normal upward sleepiness scale, contrary to the things I told you before. So then I went back in Greece and I met Sophia for the first time. We tried to begin from zero, from scratch, and to find treatment-naive patients. It's a multi-center study from Greece, 36 patients, and full in-lab polysomnography. We found that 60% of the patients had EHI above 5, namely sleep apnea. It's interesting, though, to show that only 14% of these patients had moderate to severe disease. We found, contrary to the retrospective study I told you before, that the main symptoms was insomnia and daytime fatigue. Those are the things we are going to see in patients with IPF having a sleep study, hypopneas, especially during the vulnerable REM period. And these are the numbers. They differ significantly from normal population, even though there is a significant difference among the two studies. And after that, there was great research. The gate was open, and actually, most of the researchers report the same thing, that it is possible that patients with IPF have obstructive sleep apnea. But we have to point that there is a phenotype. You always want to hear about phenotypes. Yes, these people have not a normal phenotype. You have to try to find these people because they have usually insomnia, and no one really wants to deal with these patients. They are difficult patients. They have daytime fatigue, and they have nocturnal cough. These are the main symptoms of these patients and not sleepiness. So if you go to the hypnograms of these patients and by the hours, you can realize that the main problem of this patient is sleep onset insomnia, sleep maintenance insomnia, multiple awakenings during the night, early awakening in the morning, and inability to fall back to sleep. So there are several reasons this patient may have insomnia. It's not only sleep disorder breathing. It's the way these people sleep, the way the oxygenation alterates during sleep in these patients. Dyspnea, cough, other disorders, such as I said before, depression and anxiety, very common in this population. And now we know that we can perform a PSG in patients with insomnia in case we really believe that the main reason of sleep maintenance insomnia in general is obstructive sleep apnea. And you can see we are living in a real world. Patients don't have only one disease, they have multiple diseases. So they may have IPF, hypertension, heart disease. And the more diseases they have, the more possible it is to have more severe insomnia during the night. From all questioners, probably the only one who is sensitive and has sensitivity and specificity is the stop bank questionnaire. And yes, we have multiple things as sleep physicians. We can perform oximetry, capnography, limited studies. But in my opinion, it's very crucial, at least at the beginning, and in treatment-naive patients with IPF, and exactly after the diagnosis, to perform an in-lab PSG. And I and Sophia believe that actually we are physicians, and we are treating patients and not numbers, irrespective of the cost of a sleep study, which is very cheap in Greece. So I was very happy after that year that all the things I wanted, my aim was, okay, for the first time, OSA was recognized as a comorbidity in IPF. So physicians have the opportunity to send patients with IPF for a sleep study. And the gate was open, yes. Now we need more research in patients who have two things, OSA and IPF. But I never said that this is an overlap syndrome. It can coexist, but I never said that this is an overlap syndrome. So it's not only OSA. During all this research, we learned other things related to sleep macro and micro architecture, to the sleeping pattern of these patients, to nocturnal oxygenation parameters. So all investigators agree that there is a marked sleep macro and micro architecture alteration. So these people have increased stage 1 sleep, they have a decrease in REM sleep, a decrease in slow wave sleep, they have an increased arousal index. Related to the breathing pattern of these patients, there are positive and also negative studies. And the negative study is one. This was performed by Dr. McNicholas, Professor McNicholas, with 5 patients with IPF. And in our study, we found that patients with IPF have an increased respiratory rate during wakefulness. And this increased respiratory rate still exists during sleep and exaggerates even more during the rapid eye movement sleep. This rapid and shallow breathing pattern may cause episodic desaturation, may cause hypoventilation during REM sleep. And if I go to the small letters of the paper of Dr. McNicholas, probably the 5 patients were so anxious before the sleep studies, I don't know why. So they breathe a lot. So this is a limitation written in the small letter. So probably this is not a negative study. He's going to agree with us. Related to sleep oxygenation, old studies have shown that there is a correlation between mean oxygen saturation during wakefulness and sleep. And it's obvious that every time the patient goes to non-REM and even to REM sleep, it's going to decrease. In this study, they found that there was a lower decrease in oxygen desaturation when we compared sleep with exercise. Even though there is another good study from Greece, from Dr. Kostikas, who showed the opposite, namely that sleep desaturation is even more pronounced compared to exercise desaturation. So we have a problem. So we have to deal with the problem. We have to do something about sleep apnea in patients with IPF. And then we started with Sophia to think, is it possible to start CPAP in this patient? Could CPAP apply in those population? Should we do something in order to show if this is going to improve the quality of life, the quality of sleep, or even morbidity and mortality? We had several difficulties during CPAP titration. The main problem was nocturnal cough, claustrophobia, depression, the breathing pattern, the rapid and shallow breathing makes it very difficult to use CPAP. But even though we had to try, this was never published as a paper. It's only an abstract by Lancaster. But she was the first who found that in patients who are using CPAP, there may be an improvement in survival. And this was our study performed in Greece. So we have almost 100 patients treatment naive with CPAP, and we split them to good CPAP and poor CPAP compliance. And we have seen that actually those patients who were good CPAP compliance, they had an improvement in almost all indices of sleep quality and life quality. And there was an evidence, a small evidence, during the first 2 years that there was a decrease in mortality in these patients who are using CPAP. But I have to show the negative study. So this is a negative study that was published in CHEST in 2020. They have 160 patients. CPAP was prescribed in 82% of the patients. And they found that actually adherence to CPAP was not associated with any kind of improvement in mortality. Only in patients with supplemental oxygen showed something. But there are some limitations. Only less than 30% of the patients were adhering to CPAP. And they had to prefer, for the journal CHEST, they have to show data for only 1 month. So if I was the director of this sleep lab, I was very, very disappointed with my staff. It's unacceptable to have this rate. And it's unacceptable for a CPAP clinic to have data only for 1 month. It's CHEST. So, but there were not CPAP prescribers if there was not a CPAP inventor. So Dr. Sullivan was the CPAP inventor. And it was not my dream to be a CPAP prescriber. So this is not a paper in CHEST, but this is the email that Dr. Sullivan, the inventor, said me that, yes, he wants to congratulate me for my work and Sophia's work, yes, and for the effort we make every day, every night, in order to initiate CPAP in these patients. So this was good enough for us to continue our work because he is the inventor and not the prescriber. So it's mandatory for sleep physicians to have sleep clinics, to have technicians, to have psychologists. And the more the patients become familiar with CPAP, the more they are going to use the CPAP for more hours. And probably the main thing we have to think about is the hours of use. The more we use the CPAP, the more possible it is to reduce morbidity and mortality. 4 hours are good enough for sleepiness, but these people are not sleepy. We need more hours in order to reduce mortality. And actually, we are life students, irrespective of our age. And at least that's the way we have learned sleep medicine in the United States. There are pulmonologists. Pulmonologists are not sleep physicians. No way. This is another specialty. So pulmonologists should help people with IPF. Sleep physicians should also help people with IPF. Everyone has his own work to do. We treat patients. We have to do the best. But for sleep prescribers, for CPAP prescribers, this is a new trend. I think they have to read history and have to find their phenotype, the CPAP prescriber phenotype. Socrates said everything very, very well, thousands of years before. Thank you.
Thank you so much for this very interesting overview. Also, the time course you gave us. Are there any questions? Please. One second for the microphone.
Thank you for your excellent talk. But since there is a bidirectional pathophysiology, you show us a during your presentation about Professor McNichol said that the opposite, GERD, for example, may cause pulmonary fibrosis. So are there any studies about the opposite direction? In the population of breathing sleep disorders, is pulmonary fibrosis more frequent?
Yes, it is more frequent, but I have never said, and no one from these authors have said that there is not an overlap syndrome. I don't believe that there is also an overlap syndrome with COPD. And COPD guys are the pink puffer guys with the hyperinflation, but there are the obese guys. And the obese guys actually have a restrictive lung disease. So they belong in the same theory of the decreased lung volumes and the caudal traction of the trachea. I think, and actually, Professor McNicholas was inviting me to write this in chest. So he agrees. We are in the right direction. And he agrees with Professor Sullivan.
Yes, thank you.
Another question? Yeah.
So, hi, I am working with Sofia and Katerina in the University of Crete, and we actually have a grant that we're trying to analyze the macrophages of IPF and IPF with sleep apnea patients. And of course, the first question we wanted to answer is whether there is a bidirectional causative effect. Also, if, for example, there might be an inherent problem with the circadian genes of some patients, and that we know might also be involved in producing fibrosis or other inflammatory types of disease. I wanted to ask you, what do you think is the connection? I mean, can we say that a person with chronic OSA will have deranged circadian gene expression? And do you think it's worth looking at this more at the molecular level?
Yeah, sure. Try everything. If something wants really something, then he has to try. And I don't know how many years it's going to take you to solve this problem, but I think you are in the same direction. But remember the dark ages. No one really wants to have a sleep study in patients with IPF. Now you can perform, but I don't know. You have to find this. Great idea.
I have a methodological question. Over the time, the criteria of hypopnea or the definition of sleep apnea, obstructive sleep apnea, has changed several times. 3% desaturation, 4% desaturation, and so on. And this has a huge impact on the numbers we get at the end. So if we know that the patients with IPF, with severe IPF, have a lower oxygen saturation at baseline, that means that you come close to the steep part of the oxygen desaturation curve. Is it possible, or is it, what is your opinion? Is it, could it be a methodological problem that small changes of ventilation lead to a huge impact on desaturation and therefore increase the number of breathing disturbances?
Yes, sure. But we tried to take patients in the early phase of IPF and with only mild problems related to pulmonary function testing. If we try to do something in the late stages of the disease, probably we are going to do nothing. We have to start such patients with Alzheimer's. We have to start from the very beginning and to try this effort. If you have a patient who has progressive IPF and has low saturation, it's obvious that he's going to make huge desaturation during the night. But even more, I want to ask you something else. This patient has 25 breaths. So the duration of 10 seconds for apnea or for hypopnea is not for these guys who are sleepy, who have rapid and shallow breathing. So probably we underestimate the problem. And the rules we have used in Cleveland during that time are not the rules we are using right now.
Yeah, absolutely.
These are very strict rules during that time. That was the 4% rule. Now it's 3% rule, arousal, and the reduction in 30%.
Yeah.
So, sure.
Yeah. Thank you again. I think we have to go on. So, our next speaker is Athanasia Padanaka. It must be a pleasure to work in a university which is called Aristoteles University. So it's very good that you talk about sleep disordered breathing and cancer, a topic which is highly important and highly actual, because, for example, because of the discussion, Philips devices and so on, if there is anything, so cancer and sleep disordered breathing plays a role.
So I would like to thank the organizing committee, and especially Sofia, for the invitation and for my participation in this round table. And I will start with the fact that apart from obstructive sleep apnea, there are other sleep disorders that are associated with cancer risk. And as you can see, obesity is a factor that is related to increased oxidative stress and DNA damage and decreased DNA repair, but also other sleep disorders like insomnia, that is the most frequent sleep disorder nowadays, also is related to cancer, as it derives a decreased immunity, and also it impairs with melatonin and impairs clock genes. And so we should consider other sleep disorders apart from sleep apnea, but I'm going to talk especially for sleep apnea. So there are studies in both animals and humans that have found that there is an association between these two diseases, and they probably share some common pathophysiological mechanisms. So is there a relationship between these two diseases? So hypoxia plays an important role in regulating various stages for the tumor formation and progression, and hypoxia and inflammation coincide in several points in the biology of cancer. So, and it's already known that intermittent hypoxia has a different role in the transcriptional responses of several factors, and it differs from that of continuous hypoxia. So this raises the question if obstructive sleep apnea, and more specifically intermittent hypoxia, plays a role in modifying tumor genesis and tumor progression, and also if this disrupted or poor sleep quality also plays a role in tumor biology. So as you can see here, obstructive sleep apnea results in sleep fragmentation, and this results in the generation of reactive oxygen species, and also this causes the DNA instability, the increase of pro-inflammatory cytokines, and also leptin dysregulation. And sleep fragmentation also related to increased sympathetic activity. And again, intermittent hypoxia results in HIF activation, decreased immunosurveillance capacity, increased VEGFR and angiogenesis, and these are very closely related to the progression of cancer, its aggressiveness and invasiveness. So you can see it here in this older study for melanoma, where you see that intermittent hypoxia was led to higher metastasis in the lung. So these are very closely related. So you can see here in this relatively older meta-analysis, many animal model studies, and you can see that most of them are designed for melanoma. And of course, it is well known that intermittent hypoxia enhanced tumor growth progression, angiogenesis, and also metastasis. And on the other hand, there are many pathophysiological studies in cells, and of course, they have found that the expression of cytokines, VEGFR, and other genes, and HIF-1 alpha also relate to the intermittent hypoxia, and it was more severe in the models they have produced for sleep apnea. However, things are not very easy in humans. So contrary to the research in animal models and or cells, it's not very easy to have experiments in humans, because these patients also have other factors that play a role in cancer, like age, obesity, and the sleep duration. So you can see here an older study where you can see that the mortality and the cancer is associated with more severe disease. However, as it was expressed by the apnea index and also the time below of saturation below 90. However, there were other studies that did not have the same results. And here you can't see very well, but this is another meta-analysis, more studies, and these are studies in a population, human population, that assess the association between sleep apnea and cancer. And as you can see, they assessed different type of cancers, and the type of sleep study existed or sometimes did not. And if you read all these small letters, you can see that some of them have shown that there was a relation with the incidence of cancer, but others did not. And some of them showed that some types of cancer did have an association with sleep apnea, or other types of cancer did not. In this study that is more recent, they didn't find a significant association of also severity with cancer. However, the proportion of patients that had more severe sleep apnea had higher number of cancer sites relative to those that had not so severe disease. And here you can see the different type of cancers, and here you can see the indices of the severity of sleep apnea, hypopnea index, arousal index, the time below, with saturation below 90 ODI. And you can see that the more severe the disease, the higher the prevalence of cancer. Here, another more recent study. These are the percentage of tumors in sleep apnea patients. This is the incidence of the general population in China, and this is in the world. And you can see that all these cancers were more frequent in sleep apnea patients. This is something that we have done in the ASADA cohort, and we have found that female patients, the cancer prevalence was higher in females. And again, the most strong association with was for nocturnal hypoxia. We are planning to do a prospective study, so to have more strong results. And these are other studies that reported the effect of age on the association between sleep apnea and cancer. And you can see that in some of them, there was higher cancer incidence in younger patients, some of them in older patients, and some of them there was a difference between the different sites of cancer. Here is another study from the Spanish Sleep Network that you can see here that they divided the patients according to age, and they found that the association between cancer mortality and apnea-hypopnea index and hypoxemia was associated only in patients that were younger than 65 years. Here is another study from the group of Susan Redline. They showed that there is a site-specific cancer risk, but in this study they didn't have they had a subjective, a self-reported assessment of obstructive sleep apnea. They didn't have sleep studies, but they found that in older women, there were some types of cancer like bladder or kidney cancer here that were associated with sleep apnea. And in this table, you can see different types of cancer, and some of the studies. For breast cancer, there was a higher incidence of sleep apnea. For melanoma, I showed you before the studies on animals and cells. About central nervous system, there were some studies that showed a higher incidence in brain, but not in spinal cord tumors. In pancreas, the inconsistent data, and here prostate and colorectal higher prevalence of sleep apnea. So it depends to the type of study and to the type of cancer. And what about lung cancer? We are chest physicians, so we should care about lung a bit more. And you can see here in this recent meta-analysis that they didn't find a significant correlation with the mortality rate in lung cancer. However, this is from a different study, this table. And here you can see different studies that assessed lung cancer and its association to sleep apnea. Some of them found a higher incidence of sleep apnea in patients from lung cancer. Some of them found the same incidence, but the mortality or the tumor aggressiveness was greater in patients that suffered from sleep apnea. And some of them did not find any relation. However, there is data that cyclic hypoxia plays a role in cancer aggression, because it seems that it promotes angiogenesis, stemness, it increases metastasis, it increases inflammation and metabolic reprogramming, and also it plays a role in therapy resistance. So probably we need more studies to make this more clear. And this is something about other types of cancer, like colorectal cancer, and it seems that the effect of intermittent hypoxia from obstructive sleep apnea and fecal microbiota plays a role, because it seems that it activates the HIF-1 alpha and also the chronic inflammation pathways. So all these could play a role in the carcinogenesis of colorectal cancer. What about treatment? In this older study, it seems that the treatment of sleep apnea with CPAP could alter the transcriptional signatures in circulating leukocytes, meaning that it probably could change the expression of some genes that could be related to cancer. But in this more recent study, you can see that the effect of CPAP did not really differ to the all cancer incidence. However, if you can see here about adherence, it seems that in some types of cancer, the blue one is adherent, the yellow one, the red one is non-adherent. It seems that in some types of cancer, more adherent patients could have a better prognosis, but we need more studies to make this more clear. So for the end, I put this slide because in the beginning of my presentation, I talked about other types of sleep disorders like insomnia. And here you can see that several types of cancer were more prevalent, the incidence was higher in patients with insomnia. So we should keep that in mind for our patients. So if sleep apnea predisposes to cancer, the early diagnosis and treatment could lead to the prevention of this disease. So this is very, very important for the health policies for cancer prevention. Thank you.
Thank you very much, Athanasia. I think it's a very important topic. We cannot answer all questions, but I think it's very important to go on that way because it's so relevant for people. Other questions or comments?
Thank you.
Halabaros.
So the last slide, Haralambos, yeah. That's good. So the last slide, I'm really curious about parasomnias. What kind of parasomnias are related with increased incidence of cancer? Is it the REM related for Parkinson's disease, RBD, or the non-REMs?
They were not separated in the. They put it all together because the numbers were very, very small.
Yeah, it's right, but maybe autonomic dysfunction in this kind of parasomnias may play a role in the cancer development, if I recall well the paper, but they didn't separate REM to non-REM parasomnias or how to call it in English?
Yes, the synucleopathies and Parkinson's disease with RBD.
Yeah.
Additional questions? I would like to ask, most of the studies on sleep apnea focus on HI, ODI, so intermittent hypoxia and so on, which is logical, of course. However, if we see that there is also possible association with insomnia, that might give a hint that it's not only intermittent hypoxia or breathing disturbances, so possibly sleep disturbances. What do you think about that?
I agree with you because there are studies saying the disturbance of melatonin, of clock genes that are related to insomnia, and there are older studies in how is it for the airplanes that. Stewards that had higher breast cancer because they were traveling and they had circadian rhythm disorders. So there are things to do, and I think with the question that Dr. Mermigis had, the last one from I think that probably a very primary investigation in cells or in animals should be done in order to see what's going on in the even in the DNA, because there are studies.
Yeah. You have a last question?
Yes, thank you. Thank you for your excellent talk. I think that hypoxia is very important factor for cancer, and maybe we have to learn about the cell type of cancer every time. So we don't know. We have different aspects in the literature because of this. So I think that there are cell types in cancer which are resistant to hypoxia, and some other are not. So we have a lot.
And there are studies that show that some types of cancer are protected from these cancer are lower in patients with sleep apnea, but
because
you can't
cancer,
make safe conclusions.
Has the ability to construct another cancer cell type to survive.
Yes.
So
maybe it's the M2 macrophage theory.
Yes.
Yeah.
Thanks again, Athanasia. It was a great talk and very stimulating. Thank you. Our not last, final speaker of this symposium is Professor Kondili, again from Crete. And now we hear something about intensive care and sleep. I think you had, like many of us, a lot to do with other problems in the last years. But I think it's important to address sleep also.
Okay, thank you for the invitation. It is my time after this clinical issues to torch you, I think, with sleep in ICU. So we know that critically ill patients commonly experience poor sleep quality, expressed either as sleep fragmentation or abnormal sleep architecture. As for sleep fragmentation, we have from a previous study, we know that the sleep disruption index, number of arousals and awakenings, range from 30 to 50 events per hour. On the right side, you can see the normal hypnogram in normal subject, and the middle panel shows the 24 hours hypnogram in 3 ICU patients. What we know from several studies is that the patient, the critical ill patients, spend most of total sleep time in stage 1 and 2, and REM sleep accounts only for 6, and slow wave sleep only for 5% of total sleep time, as opposite to the normal of 25 and 20% respectively. Although we know that the total sleep time may be normal or even increase in critical ill patients, the distribution of sleep and wake is quite disrupted in those patients. Most of the time, the sleep occurs during the daytime. In this figure, you can see in 5 ICU patients, the distribution of sleep and wake. And what they found in this study, Friedman and co-workers, is that the total sleep time range from 1.7 to 19.4 per day. And during the 24 hours recording, the average, the mean number of sleep periods was 41, with an average length of 15 minutes. Apart from the disruption in sleep architecture, we know the last decade that critical ill patients commonly exhibit atypical sleep patterns that cannot be recognized using the usual scoring system. This is the atypical, one of these patterns, the atypical sleep, which is characterized by prolonged periods of high amplitude, continuous irregular delta activity, and abscess of K complexes and spindles. Another type of atypical pattern is the pathological wakefulness, which is characterized by the presence of theta and delta activity in behaviorally awake patients, and also the burst suppression, the well-known burst suppression, which is characterized by high voltage, slow and sharp waves, alternate with periods of depressed background activity. This sleep pattern is commonly seen in severe encephalopathy and also in patients with sedation with barbiturates. How to evaluate sleep in ICU? We have different methods to evaluate sleep in ICU. Although until recently, the polysomnography study was considering as the gold standard method. We know that there is a lot of limitation in assessment sleep in ICU. In order, polysomnography studies are difficult and sometimes it's time-consuming to perform in ICU. For technically accurate sleep studies, the continuous monitoring of the patient is required. Also due to abnormal distribution of sleep and wake around 24 hours, in order to capture with accuracy the sleep, the accurate sleep, to have an accurate sleep evaluation, at least 24 hours recordings are required, which is difficult, as you can understand, to performing in ICU or settings. Also, as mentioned previously, these patients commonly experience exhibit atypical sleep patterns that cannot be recognized using the common scoring system. The last 2 decades, 2 new methods have been emerged for sleep evaluation in ICU patients. These methods are based on power spectral analysis of EEG using the fast Fourier analysis, and these new methods of analysis have gained our knowledge for sleep in ICU patients. This is a study for about 10 years before from Duort from France, and you can see on the left side the overall EEG frequency in patients with normal wake EEG and those with pathological wakefulness. Patients with pathological wakefulness have significantly lower EEG frequency. And on the right side, you can see the spectral power in 4 different bands. Patients with pathological wakefulness have significantly higher power in delta and theta bands and lower in alpha and beta. On spectral analysis of the EEGs based on a new measure of sleep depth, the odds ratio product. Odds ratio product has been invented by Magdi Unic, which is a pioneer in sleep physiology. It is derived by the fast Fourier analysis of EEG at 3-second epochs, and it ranges from 0 to 20, which is the deep sleep, to 2.5, which is full wakefulness. Odds ratio is a continuous measure of sleep depth. This index odds ratio has been validated in large cohorts of patients, and has been shown that when it is lower than 1, predicts with higher than 95% accuracy the sleep, and when it is higher, it is between 1.8 to 2.5, predicts the wakefulness with accuracy of 95%. We have recently retrospectively analyzed previous studies in ICU or patients from our group, and in these figures you can see the distribution of 30-second epochs to 10 different deciles of odds ratio products from 0 to 2.5. Can we compare our results with those of one cohort of normal sleepers? Normal sleepers spend the most of 63 of the time with odds ratio product lower than 1, which is presents sleep, and only 7% in awake values. In contrast, in ICU patients, only 31% of the total sleep time is in odds ratio product lower than 1 with sleep, and 69% of the time is spent in unstable sleep and wakefulness. A part of this distributed architecture in odds ratio product, in a previous study from Dress about 3 years ago, they also shown that sometimes critical ill patients sometimes exhibit a different, a low correlation between the odds ratio product between the right and the left hemisphere. The intercorrelation coefficient between odds ratio product between the right and left is normal from 0.9 to 1. Lower values indicate regional differences in sleep depth, which might suggest that there is a disruption in the normal process that coordinate sleep throughout the brain. In some patients, they found that this correlation is quite low. It was found to be 1.1, which is indicate a complete dissociation between the right and the left hemisphere regarding the sleep depth. This dissociation in sleep depth between the two hemispheres resembles a physiological phenomenon, the so-called the unihemispheric sleep. Unihemispheric sleep is widely utilized by dolphins and related mammals, and also in birds when under physiological conditions that requires prolonged periods without sleep. As you can see here, there is one of the hemisphere is in sleep stage, and the other it is in awake. It is probably, we don't know, that this primitive adaptive mechanism, it is reactivated in human when under conditions where natural sleep is deemed to, from the subject to be as safe. What caused the poor quality sleep quality in ICU patients? This is multifactorial and including the It is multifactorial, including the pre-existing medical or chronic sleep disorders, the severity of illness, the ICU environment, alterations in circadian rhythm, the use of sedatives, and the mechanical ventilation. And we know that sepsis may affect sleep EEG pattern in ICU patients. This is the pattern of EEG that usually appear in patients with septic encephalopathy. In this study from Friedman, about 20 years before, the authors found that this pattern was appeared up to 8 hours before the patient demonstrate any symptom on clinical sign of sepsis. Many environment factors, ICU factors, may affect sleep, including the light. The patients are exposed to dim light during the day and bright light during the night. Patient care activities, diagnostic procedure, and the noise. We know that the level of noise, high level of noise, is present in ICU environments, or as high as 60 to 70 decibels all around the 24 hours. And sometimes peaks of sounds up to 100 decibels have been documented in some studies. This figure you can see an arousal following a peak sound to 70 decibels. What we know from different studies is that noise is responsible for up to 24% of sleep fragmentation in ICU patients. Circadian rhythms or abnormalities also may affect sleep in critical ill patients. We know from we know that two distinct forces regulate the wake and sleep cycles during 24-hour periods. The hemostatic and the circadian control. These two distinct factors are close coordinate in normal under normal conditions. This is the normal what happened. And this is on the bottom. No, it doesn't work. On the bottom panel, you can see hypothetical model of what may happen in ICU patients. There is a delay in circadian control with a lower amplitude and ongoing and continuous ongoing hemostatic force. The abnormal circadian timing in ICU patient is this result from alteration in the time givers, mainly the light. The patients are exposed to dim light during the night, to bright light during the night. Also, there is some alteration in non-light time givers. They don't have scheduled meals. They don't have physical activity. All this factor may cause a decrease in an alteration, an abnormal circadian timing. And from this study, about 10 years before, we know that there is a complete desynchronization of melatonin secretion in ICU patients. This is 24 hours. This is the normal secretion, and this is in individual secretion of melatonin in individual ICU patients. Mechanical ventilation may affect sleep by two main mechanisms. The first mechanism is by producing periodic breathing. We know that during the non-REM sleep, the respiration is dominated by the chemical feedback. What's the chemical feedback? Is the response of muscle pressure, respiratory muscle pressure, to alterations in PO2, pH, and mainly the PCO2. Non-REM sometimes unmasks a highly sensitive PCO2 or apneic thresholds, such that even a small and transient decrease in PCO2 below the FPR level may cause apnea. In patient non-mechanical ventilation, hyperventilation, which is caused by when we apply excessive ventilator assist, may cause hypocapnia and may lead to periodic breathing. Periodic breathing may affect sleep. In this study from our group, we have shown that patients that have periodic breathing compared to those without have significantly higher fragmentation index. Also, mechanical ventilation can affect sleep by in cases that there is a desynchronization between the patient and the ventilator. In this figure, you can see the arousal, two arousals following two types of patient ventilatory asynchrony, ineffective efforts, and double triggering. And in this study from Bosnia, about 15 years before, they found that there is a strong correlation between the number of asynchronies and the number of arousals in critical ill patients under assisted mechanical ventilation. Sedation also may affect sleep. We know that sleep and sedation have differences and similarities. Common sedation drugs used in ICU, widely used in ICU, may affect sleep. We know that midazolam, which is a GABA agonist, has a dose-response increase in EEG. It's a potent suppression of slow wave sleep and increase the S2 stage and spreadly activity. In two previous studies from our group, we have investigated the effect of two sedatives, propofol, it's a GABA agonist, and dexmedetomidine, this A2 agonist in sleep quality in ICU patients. And we have recently reanalyzed this data using the odds ratio product analysis. And what we found, this is the distribution to the different deciles of oxidation product in ICU patients before the sedation in normal sleepers. And we found that propofol and dexmedetomidine titrated to achieve a light sedation during the night shifts the sleep architectures towards to normal. Sleep abnormalities are exist well beyond the ICU settings. In this study from our group, we investigated the sleep architecture in ICU survivors at 2 time points. Sorry, this is not working, I think. At discharge and in ICU discharge. No. In ICU, at hospitals, no? At hospital discharge and 6 months later, and we found that there is only a slight improvement in sleep architecture in ICU survivors. Sleep abnormalities in ICU patients have long and short and long-term effects on patients' physiological well-being. We know that poor sleep quality may lead to delirium. We don't know which is the causative or the result, the delirium on the or sleep fragmentation, because both conditions are say common pathogenetic mechanism, risk factor, and symptoms. We know that in normal subjects, sleep deprivation is associated with cognitive dysfunction. Critical patient due to severe disrupted sleep quality are deemed to be as sleep deprived. We know that the patient, ICU survivors, commonly experience significant cognitive dysfunction. One reason, probably this cognitive dysfunction is attributed to memory defect. We know that in normals, the REM sleep and slow wave sleep and REM sleep are essential for the declarative and non-declarative memory. Probably because these patients have deprivation of REM and slow wave sleep, may have these memory defects. Also, we know that the memory defects from ICU, what happened in ICU, frequently lead to delusional memories, which is now considered as the main factor the main pathogenetic factor for post-traumatic distress syndrome in ICU patients. Also, we know that sleep deprivation may affect the course of mechanical ventilation in ICU patients. We have recently, the last 2 years, we have 2 studies that have shown that sleep deprivation in ICU is associated with a decrease in respiratory muscle endurance. And from this study, this clinical study from Thiel, about 5 years before, as you can see, the patients who exhibit atypical sleep compared to those with normal sleep has significant prolonged mechanical ventilation, and the same was for the patients that do not have REM sleep compared to those with preserved REM sleep. Those with no REM sleep have prolonged mechanical ventilation. So, in conclusion, critical ill patients experience poor sleep quality frequently. Critical ill patients frequently exhibit atypical sleep patterns. PSG, although is considered as the gold standard method, has limited feasibility in ICU patients, and poor sleep quality of ICU patients is multifactorial and may affect patients' physiological well-being. Thank you for your attention.
Thank you very much for this comprehensive overview of all aspects of sleep and ICU and also what comes afterwards. Thank you so much. Is there any important question, please?
Short one with a short answer because we have to.
Thank you so much. I have a question related to the whole procedure. Because I remember the time we have made PSGs inside the ICU, we have to check 2 grounds. We have to check the grounds of all the instruments, oximeters, ventilators. It was very tough for someone to perform a good sleep study inside the ICU. It was sometimes dangerous. And I remember well the time we actually want to find epilepsy with double banana montages. There was not a single PSG without an artifact. So how easy it is to perform sleep studies now in the ICU with all these artifacts and these problems?
It's not. It wasn't easy, and it's not. It is continues to easy. It is difficult, and it's quite difficult to have an accurate and have technically accurate studies. That's why you have to have the doctor and the technician continuous above the patient and device. Now we have some new devices. One of these was invented by Magdi Unique, and then we have where I have the honor to have some of these devices to make studies in ICU. That we have improved the way we perform ICU. It is a small device with one head unit and one head unit and one table, which is transfer the signals by Bluetooth, and we have managed to have excellent studies.
Technologies, that's great.
Yeah.
Well, we would like to thank all the speakers. It was an excellent session covering a broad range of sleep-breathing disorders, different aspects in respiratory diseases as well as in the ICU. Thank you.
Sorry.
No,
I
you were
thought
on time. You were on time. Thank you, Morphia, for this. And thank you all the participants. However, you have only 5 minutes to grab a coffee, and we will continue with 2 special lectures, and one by Professor Anita Simonds and the other one from Professor Marisa Bonsignore, and they will both deal with very interesting topics. So please be here sharply at 4. I know it's tough, but this is reality. Thank you. Thank you so much.
So, yeah. This is
until 5.
Until 5.
So we have 1 hour.
When is the closing?
The closing.
So, good afternoon, everybody again. First of all, I would like to really congratulate the organizers for putting together such an interesting program. I think it's worth for an international congress, and especially I like the interaction between sleep and breathing and respiratory diseases, and that's really very important for our field. Thank you so much.
We learned from the experts.
And one of the biggest experts in the field is now going to speak. Sophia already introduced Anita Simonds this morning. Anita from London. She's, as you know, very experienced in all fields of our specialty. And she will now talk about sleep and in neuromuscular diseases, the role of non-invasive ventilation, and especially very interesting lessons learned from the COVID area. Anita.
Thank you. Thank you very much, Winfried. And I agree, it's a fantastic program. It really covers so much of the sleep curriculum. I also congratulate you and all the audience on your endurance. It's very, very impressive. If anyone drops off to sleep, I will not feel bad about it. That's okay. You have a microsleep.
We have to apologize for the small attendance, but the hour is difficult and it's hot outside, etc., etc., etc.
Yeah, it would be the same in London. I understand completely. So 20 years ago, I think this topic of neuromuscular disease, NIV and sleep probably would be quite a niche area because there weren't that many people who were being treated. Over that last few decades, we have treated many more patients with neuromuscular disease and they survive longer. And the children with neuromuscular disease now survive to adulthood. So this is something we are seeing increasingly in adult respiratory medicine. I'm going to make this into a very practical, pragmatic session, just discussing really the assessment of these patients, the introduction of non-invasive ventilation and some of the outcomes. So as I say, we'll deal with the assessment, the initiation of non-invasive ventilation. I'll talk about sort of two polar groups, those children with neuromuscular disease and the older patients, for example, with Duchenne muscular dystrophy, and then I'll also focus on patients with ALS. We'll talk about comprehensive care. So assessment and addition of non-invasive ventilation is not the sole way of managing these patients. They need a very comprehensive package of care. And we'll talk about what happens during the progression of their condition, if it does progress, and the implication of new therapies. It's a very exciting time now in pediatric neuromuscular disease with many treatments coming along. And we have to work out how we integrate our management of their respiratory care and also the new treatments, which I'll talk about, particularly nusinersen and adenovirus delivered gene therapy, and then a little bit on home monitoring. So in terms of the assessment, what can we measure? Well, very obvious things, vital capacity we can measure in the clinic. Of course, they need to have bulbar function to be able to get a mouth seal. Same goes for measuring maximum inspiratory pressure, sniff inspiratory pressure, which can be easier for patients to do. And then some of the more exploratory areas, such as a diaphragm ultrasound, which is used in some units, although I think we don't have a complete feel for what it's demonstrating us over time. And then we'll talk about the ways that we can assess sleep-disordered breathing. The questions that we ask patients, and indeed this can be quite insidious when sleep-disordered breathing develops in patients. For example, with Duchenne muscular dystrophy, type 2 spinal muscular atrophy, or patients with acquired conditions such as ALS, in that the symptoms can be quite subtle. It may be just complaints about poor sleep quality. It may be nightmares because the initial sleep disturbance is usually in rapid eye movement sleep. That fits in a little bit about what we heard about sleep in ITU. Breathlessness is a feature, but obviously for individuals in a wheelchair, that breathlessness is not something that's happening on exertion, but it might happen, for example, on transfer from chair to bed, or, for example, the first appearance of breathlessness can be when the individual is eating. And then cough peak flow is a good measurement to do. Briefly, if it's less than 270 litres per minute, and this is somewhat arbitrary, then that individual is likely to develop problems clearing their secretions, and this is adult values at the time of a chest infection. If it's less than 130 litres per minute, they're bound to have problems clearing secretions. I mentioned respiratory muscle strength, and we've mentioned sleep studies. Just one catch in ALS patients. So this is looking at decline in sniff inspiratory pressure and the top graphs, and then vital capacity in the bottom graph. And whereas with children with neuromuscular disease or the inherited neuromuscular conditions, you usually see a gradual decline in vital capacity, so you're not usually taken by surprise. Rebecca Lyle in this study showed that vital capacity in ALS can be a gradual decline followed by a sudden decline, and that means you have to be careful because you may be thinking things are going okay, you have a vital capacity of maybe 80% predicted, but then there may be the sudden drop, which is different to those with other conditions. We've talked a bit about hypoventilation. There are actually quite a few definitions of hypoventilation. And you can see that you can, if you only have oximetry available to you, you might want to define it by oximetry measures. I don't think that's an adequate way to do it, but that gives you some kind of idea. Hypoventilation should really be defined by CO2 levels. You're not clearing your CO2, and so values such as peak transcutaneous or CO2 or CO2 above a certain level during a percentage of the recording time, or as you can see here, the bottom one that's often used too, a value above 55 millimeters of mercury for a period of 10 minutes, or that value exceeded of 50 millimeters of mercury for more than 10 minutes. In fact, in practice, when you look at studies, you can really see patterns, and this is quite a different pattern in an oximetry trace than you would see for an obstructive sleep apnea patient, although you might see it in an obesity hypoventilation patient. And if you're just looking at all you have available is oximetry, maybe home oximetry, for a child or adult, what is very typical is these periods of quite prolonged dips, and this is usually always in rapid eye movement sleep, as you can see from the graph below. Question always arises, if a patient at home or on a ward has normal oximetry, does that exclude sleep-disordered breathing in a neuromuscular patient? I think my answer would be it certainly excludes moderate or severe sleep-disordered breathing, but if the patient has hardly slept at all, or in someone with a very mild degree of nocturnal hyperventilation, you may be misled. I picked this paper too, on Poletti. This is in children with sleep-disordered breathing, but I think we should remember here that many of those children have obstructive sleep hypopnea syndrome, especially those who have craniofacial syndromes, Down syndrome children. So the events are hypopneas. This is not quite as easy to assess as an apnea, but this group showed that as opposed to doing something complex, there's something called the McGill score, where you look at thresholds for saturation and then you look at combination of dips in saturation. So it's quite time-consuming going through the traces. Just a cut-off of an ODI with dip rates of 3% or more actually was more efficient, as you can see from the air-rounded curve, in diagnosing these children with obstructive sleep hypopnea as opposed to something more complicated. So you can use it, but you kind of need to interpret it with intelligence. And the same really goes for transcutaneous CO2. For some years, this wasn't accepted very much, particularly in the US, but I think it is really, really helpful to be able to manage transcutaneous CO2 in neuromuscular patients. Of course, it's not telling you breath-to-breath variation in CO2, which Untitled CO2 would do, for example, but it tells you about trends over time. And I just happened to take this picture. This is a technician's room, and you can see the transcutaneous CO2 models are being charged up in the evening, ready for the technicians to take them onto the wards to do sleep studies on our neuromuscular patients and also assess the efficacy of the ventilation. So we find it very helpful. Again, you have to understand the advantages and limitations of using transcutaneous CO2, which I'm sure you do. These are the bland Altman plots you can see on the left side, looking at CO2 versus arterial values after 30 minutes, 4 hours, and 8 hours. And what they've said here, and you can see in the graph, used to be said, oh, there's a drift in transcutaneous CO2. It's not very accurate at the end of the night compared to the beginning of the night. But actually, there wasn't a significant dip in this work done by Hazenberg of the Dutch group. And they used transcutaneous CO2 in the hospital, and also the nurses take it out to do sleep studies at home in neuromuscular patients who find it very difficult to get into hospital. So I think it is useful. And when you combine oximetry and transcutaneous CO2, although this is not polysonography, you haven't got a whole lot of detail, it does tell you a lot about what you want to know. And so you can see here that let's just try this. You can see with the patient here breathing spontaneously, the REM-related dips. Oh, this one, yes. Okay, top one.
The top one,
yeah.
yes.
Got it. So REM-related dips as before, this gradual climb in CO2, but the additional peaks almost certainly during REM. And the second night, this has happened to be a Duchenne patient. They go on to NIV. Good news, they use the NIV the whole of the night. Patient felt much better in the morning. You see you've got reasonably good. This is just a little bit of artifact here, movement artifact as they adjust to the mask. Not perfect CO2 control, but a lot better than before. So these can be relatively simple ways of diagnosing and then assuring you've got more effective treatment. In inherited neuromuscular disease, remember I showed you those graphs of sniff inspiratory pressure and then vital capacity in ALS, where the decline in both of them wasn't the same. Actually, in the other conditions, the inherited conditions, inspiratory vital capacity here has quite good sensitivity and specificity in predicting when sleep-disordered breathing is starting to occur. And when vital capacity is less than 60% predicted, you would start to expect to see, whatever the condition is, you would expect to see a form of sleep-disordered breathing. When it's less than 40% predicted, more or less continuous hypoventilation across non-REM and REM, and then respiratory failure, diurnal respiratory failure, daytime respiratory failure, vital capacity is less than 20% predicted. In that group of patients, actually, sensitivity and specificity of vital capacity was better than PI max, which again is a simple thing to do in the clinic. It means you don't have to add more complexity. This was a study looking at the right timing to introduce non-invasive ventilation in quite a range of patients with neuromuscular disease. It wasn't just one condition, and the hypothesis for this study was that the correct time to start non-invasive ventilation was at the time that you started to see hypoventilation at night, as defined by those CO2 values, even though the CO2 and the PO2 was normal during the day. Prior to that, and I was speaking to a colleague earlier, we had many patients with neuromuscular disease, and we waited until they became hypercapnic during the day and then said, you must start on ventilation. This was too late. This was too late because they ended up in an uncontrolled way, being admitted to hospital at the time of chest infections, even being admitted to ITU. So this showed that not only did you get, as you would expect, better CO2 overnight, better mean saturation overnight on NIV, but much fewer of those patients decompensated in an uncontrolled way. And that and a range of other work has led to these algorithms for assessing patients. This one was actually developed for patients with spinal muscular atrophy, but it's relevant to a whole range of conditions, including Duchenne muscular dystrophy, congenital myopathies, congenital muscular dystrophy is a whole range. So the clinical assessment, as I mentioned, an assessment of inspiratory and expiratory muscle weakness, so vital capacity, cough, peak, flow, bulbar assessment, which means swallowing assessments, the cough, peak, flow, so you understand what's going on about cough, and then depending on the levels of vital capacity and symptoms, you can start to do sleep studies. Also, as I said, assess the combination of cough effectiveness, swallowing dysfunction, as both will combine and lead to chest infections. And obviously, you must intervene before this has happened, and there are all the kind of interventions down that side. And what happens when children with neuromuscular disorders start on NIV before the age of 16? Well, we were very grateful to be involved in managing a whole group of children with neuromuscular conditions who were referred to us initially from the Hammersmith Hospital, from Francesco Montoni's team, and then they moved to University College Hospital in Great Ormond Street in London, and they came from Great Ormond Street. So we gathered about 500 children who all started on non-invasive ventilation in the childhood years, and then we looked at their survival into adulthood, and we started to see these are actually non-neuromuscular patients with chest wall problems, beast hyperventilation syndromes, but these are arranged in neuromuscular conditions, and although there's some drops at the beginning, you can see that many of the conditions, so this is congenital myopathies, there is a stabilization. And once there is the stabilization, and this may be on nighttime ventilation or some nighttime and daytime ventilation, these children start to stay stable for long periods of time. And that's why you see them going into their 20s, their 30s, their 40s. I think some of you may be looking after these patients, but we have Duchenne muscular dystrophy men now who are living into middle age. I think my oldest one is about 54. And so a little bit like cystic fibrosis, congenital heart disease, we see a radical change in outlook, and these individuals who never used to survive into adulthood now do and live for quite significant periods of time. What about motor neuron disease or ALS? Well, obviously, a much more progressive condition. This was one of the original randomized studies showing that the outcome with NIV, so patients randomized to NIV compared to standard treatment was better, overall survival improved, obviously not as big an increase in survival, and the survival outcome was much better in those with milder bulbar involvement compared to those with moderate or severe bulbar involvement. And what they did show, however, is although bulbar involvement is a very big determinant of outcome, you can improve quality of life in the patients with bulbar disease. It's often said this is very difficult to start NIV in individuals with bulbar disease. It can be more problematic, but one should always try. And it's probably not as difficult as people used to say. And this is some nice work from Italy, just showing that it's attention to detail in neuromuscular disease when you're starting individuals on ventilation that really affects long-term survival. So non-treatment, those patients will die, and this is just over a year. If you treat them, but you treat them suboptimally, so they still have residual obstructive episodes, almost certainly due to bulbar problems, then you will impair the efficacy. If you haven't got the interface right, there's leaks, that will affect survival. But the more you deal with all these problems, and then you start thinking about their expiratory muscle strength, because NIV is only going to support the inspiratory muscles, doesn't do so much for the expiratory muscles. So this is where the cough assist techniques come in. So you start to add that to deal with chest infections, and then you can get longer survival. I think the question is, who needs a tracheostomy? Do you progress the tracheostomy in some patients, or others wish to just stay with non-invasive ventilation? You can have very protracted survival with tracheostomy ventilation, but it's a complex decision and a kind of personal decision amongst individualized decision amongst the patient, their family, and the medical team. I won't go into detail because you may well be experienced in this, but there's some sorts of algorithms really, or some kind of, there's a recipe for non-invasive ventilation. I would call it a recipe because it's not that scientific. But from this group, there's a suggestion of the kind of starting pressures, and then of course you want to adjust it to the patient, to the control of their oximetry and CO2, their comfort, whether there's mask leak, but just a suggestion of what's the ideal settings in terms of IPAP, EPAP, the backup rate, triggers, and so on. And some more practical considerations. I mean, you need to get the mask fit right. It's almost the kind of Achilles heel of ventilation, because there's no point being very adept, very clever at getting the settings right if the interface is uncomfortable for the individual or there's massive leak. Because why would the individual use it? So I think that's so important. And then some various tactics that you can use if the patient is still symptomatic to adjust the various settings. Getting the mask right, I mentioned you want to get get rid of leaks, but you don't want to get the pressure over the face so great that you end up with horrible pressure sores. There's quite a lot of work now going on with studies and also industries to improve interface design with these kind of meteorological pressure distribution maps, again, to fit to the individual face. I'm always told that there's 3D printing, which you're going to have very soon, and I've had quite a few engineering teams come to me saying, we'll develop this 3D printing for masks, so you have a personalised mask. I haven't actually seen it yet, but it's a promise for the future, because having standard masks, it's not going to solve the problem. Faces are incredibly different, and we need to adapt it to the patient, and also provide the ability, so if the patient has a coughing fit in the night, or even if they vomit in the night, they need to be able to take the mask off quickly. And although in some who've got no control of their hands and need a carer with them at night, they need the carer to stay with them. There are others that have some residual muscle strength, and so there are ways that they can quickly loop a finger in and take the mask off, or just take the mask off themselves to have a sip of water and enable them to have some autonomy. So that's another algorithm for the neuromuscular disease or ventilatory, or particularly ALS patients, rather similar to I showed you before, starting at the time of sleep disordered breathing with non-invasive ventilation, progressing sometimes to daytime non-invasive ventilation, adding cough assist treatments as required if the cough peak flow is low, and remembering palliative care and palliative support all the time, not end-of-life care, but people develop symptoms right from the start of the diagnosis, so they need symptom support over long periods of time, not just end-of-life care. You can measure cough peak flow in very small children very effectively. They're very good at doing it. And then you can apply these techniques. That's with the mechanical extubation. You can show increasing cough peak flow. This is a Duchenne patient who's just had a peg inserted under a general anaesthetic. He's very anxious. He didn't want a rig done. And this is just as he comes around from the anaesthetic, just making sure we've got his chest clear. He's actually on ICU, but he went back to the ward later on that evening. And that's a nice chart, if you want to look it up, of the physiotherapy teams who've, again, evolved a kind of chart for looking at what is the level of vital capacity, what is the level of cough peak flow, what are the interventions that you can do accordingly. Now, some of these patients progress, and so they may have their nocturnal hypoventilation controlled by non-invasive ventilation for a number of years, 7, 10 years, you might see in the Duchenne patients. And then as they progress, you might start to see these peaks in CO2 during the day, and the patient will sound a little bit tireder. They might be at college or university, or they might be in a job and say, my concentration levels are slipping in the afternoon, and if you monitor them during the day, you can see these peaks developing during the day. For those individuals, if they've got good control of their mouth muscles, you can use mouthpiece ventilation. It can be fitted to the back of the wheelchair. If they have some head movement, they can just move a little and be able to take some sips of breath to control the ventilation during the day. And that means they don't have to have the mask over the face during the day, and they can communicate with their friends, colleagues, and so on. So this can be very useful. There was high hopes that diaphragm pacing would work in neuromuscular disease. Particularly, this was a trial that was done a few years ago in motor neurone disease. Very small little pacemakers fitted under a very minimalist surgical procedure, so inserted into the diaphragm. So it's not phrenic nerve pacing. These are just electrodes into the diaphragm. But unfortunately, what this study showed was it was stopped early because there was worse outcome in the group who had the diaphragm pacing with ALS and the group who were in the control arm. That's probably because, in very simple terms, if you keep flogging muscles that are getting weaker, you may end up with a worse result. And so sadly, at the moment, using diaphragm pacing in that way is not the answer. This is some nice work from Paris where they've done, and there's a paper coming out in Thorax from this group on quality of life in these neuromuscular patients soon, which is a very good paper. But this was just, as I mentioned, what are the ways to diagnose nocturnal hypoventilation? And about 124 patients they had, actually most of them had Duchenne muscular dystrophy. You can see that they found the best predictor of the need for ventilation at night was actually nocturnal peak CO2. So that was interesting to hear from them. And they also showed something that I'm personally very glad to see data on, because it's showing that the better you get the control of the nocturnal hypoventilation, so the attention to detail, reassessing the patients, making sure that having started them on NIV, after 6 months, 1 year, 2 years, you are still controlling the CO2, you've still got the right ventilator settings, actually gives you a better outcome. And they divided patients to those who were suboptimally controlled, their hypoventilation, and those who were optimally controlled. And they had hypercapnia at night, if they were suboptimally controlled. And they had more admissions, cumulative admissions to ITU, and they had event-free survival was worse in those who had poorly controlled hypoventilation. So the take-home message being, continue to assess the efficacy of the control of hypoventilation. I'll go quite quickly now because I nearly finished. Obviously, a lot has happened with telemonitoring, and we've done loads more telemonitoring since the onset of COVID. You can download data and download oximetry data. You can download data from the ventilator, and that can tell you, it can help you problem solve. Patient is not feeling as well. Symptom control is less good. You can download from the ventilator and understand what's happening. Is it that their hypopneas are not controlled? Do they have leaks on the ventilator? You can understand with sort of careful analysis. And then we've done a whole lot of work with patients at home. A lot of them have shielded very effectively. So very few of the cohort of about 2,000 patients we have on non-invasive ventilation actually became infected with COVID. But all credit to them, because they looked after themselves very carefully at home and they didn't venture out. Of course, that has sort of psychological issues, but that's what happened during COVID. We prioritised patients with progressive disease to start them on NIV early, and did a lot of outreach work. So we had the teams going into the patient's home to try and reduce them coming into hospital, take up beds in hospital, and obviously they were concerned about coming in because of the infection risks. This was a study that we just published looking at the psychosocial impact of COVID and shielding on adults and children with neuromuscular disease. They had a questionnaire, and then they had a focus group interview, a long interview to identify themes. And the long and short of it, so there were 3/4 were adults, and 1/4 were children. Their parents were interviewed. As I mentioned, there's very low incidence of COVID, particularly in the first wave, although we had slightly more mild cases in the second wave. The big concerns for the patients were, would they be admitted to ITU if they got COVID? There was a big concern that because of this use of frailty scores, which actually are totally inappropriate for young people with neuromuscular disease, can be used in older patients, they were very concerned that they wouldn't be admitted to ITU. I don't think any person who needed to go to ITU was not admitted, as far as I know, but this was a big concern. There was a big concern about PPE being available for carers. And then infection control with this business of aerosol risk. We were told that some of our Duchenne patients who were on daytime ventilation, who were venturing out, going to shops, they were told they couldn't do it because they might be disseminating aerosol. In fact, we know now that that is not the case. The big risk of someone about aerosol generation, we can talk about this or not, is it's the infectivity of the patient. It's not to do with the ventilator. And so that risk that was really considered to be very great, I don't think it's the case. And obviously their anxieties ebbed according to the levels of COVID in the community, and are still doing that. Just a couple of words very quickly on the new treatments. Nusinersen is a very interesting treatment. It's an oligonucleotide. that increases the amount of SMN2 protein. And that means if you've got more SMN2 protein, then that is much better for strength. And this is in SMA1 patients. So these are infants who've never been able to sit. And you can see that not only did motor milestones improve, in the sham group, actually no one achieved any of the milestones compared to the nusinersen group. This is the same here. But the bottom line, the big takeaway is that the impact on survival, it's a combined endpoint of need for ventilation for more than 16 hours a day or death. So if you took that, and most of the patients that just went on ventilation 16 hours a day, the big impact was on the youngest children. So for those less than 12 weeks, you can see a very, very increased survival or need for ventilation compared to those treated older than 12 weeks. So you really need to start very early. It's also not clear whether there are differential effects on different muscle groups, possibly more on peripheral muscles like arms and legs more than diaphragm. That can cause some problems because if you increase the ability of the child to move around, then you're adding to the work of breathing. And then just a second on this. So this is gene therapy, hugely expensive. I think the single dose which you need is about 1.2 million pounds in the UK, so very expensive drug. But with the dosing, you can see the logic here in this trial was to say, if you got better results starting less than 3 months old, why not start them even earlier, as soon as you diagnose the patient? So this median age was 22 days and a very striking result. So this is an open label trial. But of these infants, very young, started on the gene therapy, they all sat. So they moved from the SMA1 category to SMA2. They started to walk. They don't need much ventilatory assistance and they don't need much in the way of pegs. We don't know what the arc of progress is. So does this mean that they're almost not going to need any ventilatory support long term, or does that mean that this improvement lasts for a while and then you have more neuronal fallout and the problem disappears? So we need to continue to monitor the patients. Quick word on high flow oxygen therapy. Non-invasive ventilation is really the treatment of choice for significant nocturnal hypoventilation, but not everyone can tolerate that. So high flow treatment, because it does a number of things as well as oxygenation, but it flushes out the upper airway dead space. There's a positive pressure effect, which may reduce the work of breathing, may be useful in people who don't tolerate NIV or have a mild degree of nocturnal hypoventilation, but there needs to be more studies. And so in summary, we want to identify high-risk patients, understand the pathophysiology, I mentioned the screening and assessment, confirm the efficacy of treatment long-term. Just because you've got it right at the beginning doesn't mean it continues to be right. Anticipate problems, so everyone needs an anticipatory care plan, palliate symptoms, and then COVID has had a significant effect, to some extent a beneficial effect. Thank you very much.
Thank you so much, Anita. It was very interesting. It was not only scientifically based, evidence-based, but also very practical. Thank you so much. And thank you also for the impressive final results. We have time for some questions because we have technical problems with Marisa.
Yes,
if you are ready for that.
She has problems with the Wi-Fi, keep falling down. We will see if we have here. Otherwise, we can spend some couple of minutes with some questions from the audience first.
Please.
Is there any cutoff from PCO2? Thank you for your lecture. This was excellent. Is there any cutoff of PCO2 to start the non-invasive mechanical ventilation in neuromuscular disorders?
Well, the French group gave those definitions. So they said a peak value of more than 55 millimeters of mercury for a period just raised over the normal range. I think it's a judgment issue. I'm not that keen on a very strict cutoff because I think it's to do with symptoms as well. I think this criteria of 45 millimeters of mercury is it's a bit late. Because we know when the PCO2 is 45 millimeters of mercury in these patients, there is a decrease in vital capacity to 40%. So probably But this is at night.
Yes.
This is at night.
Night.
So those people still have a normal level of CO2 during the day.
Okay,
But you're right with
this,
that. Yes, I
level,
agree.
it is during the night, not
Correct. Oh yes, I would not wait ever till they're hypercapnic during the day. 100% agree.
Katerina.
Anita, thank you so much for your excellent talk and for being with us once more. I would like to ask you if you have more data or under unpublished data, or if you know more data about frailty.
Frailty?
Yes, because I think it is an interesting issue, patients-reported outcome, and we need as respiratory community to evaluate more, not only the geriatric population, but in general in chronic respiratory diseases. And I would like your opinion about that. There was an interesting survey through the European Respiratory Society, and we also participated in that in our assembly. But I would like your opinion as a respiratory physician, because in other diseases, cardiology and other diseases areas, it is more evaluated. And I think it is important also during the pandemic.
I'm really glad you asked. I don't think the frailty score, as it's been generated, applies to this group, especially, it may do to the motor neuron disease elderly patients, because they often present in their 70s. So I'd be okay using it there. I do not think it applies to the younger patients with neuromuscular disease. And in fact, we had a big furore in the UK at the beginning of COVID, because the Royal College of Physicians said the frailty score needs to be used across the board to judge whether it's appropriate to admit people with COVID to ITU. There's this great concern that ITUs would be overwhelmed and so use the frailty score. It's not appropriate to do it in young people with neuromuscular disease. A number of the things like their mobility, their activity, they can't do anyway. They have total sort of floor effects in that, so it doesn't apply to them. And we had some of our patients even went on television to say, if you use the frailty score for me, this is my level, I will never get to ITU. And yet I'm doing a PhD, I work as an engineer, I've had no chest infections, all of those things. So I think you have to choose where you apply it. Definitely in geriatrics and in other groups, but not this one.
Anita, can I ask you a last question, short one? From a practical, thank you for your excellent presentation. From a practical point of view, what a respiratory physician, when evaluating a patient or making a consultations, so no, I will skip the question because we will not have time. Okay, thank you.
Thank you again, man.
Thank you. So you decide what you will say to me. Okay, so last no. Let me fulfill my question first, or no, the audience comes first, the participants, so you can pose the question to Anita.
How did you manage the patients that with ALS that start with non-bulbar involvement and you start with non-invasive mechanical ventilation, and after a time period they exhibit they have bulbar involvement? How long after you proceed to tracheostomy and invasive mechanical ventilation?
It's incredibly variable. They progress at different rates, and some of them present with bulbar symptoms, but it actually stays relatively stable. I've seen some patients who, because they're very fast-acting muscles, the bulbar muscles, going on NIV actually improves the swallowing for a period at any rate. So it's really difficult to answer your question when. I mean, some of them, if they're aspirating, you might want to put a peg in, a rig in, feed them by that route, so they're nil by mouth, but continue with non-invasive ventilation. But if despite that they're still getting aspiration, then it depends on the patient and the family. If they want to go for tracheostomy, we will go for tracheostomy. But I don't think you could say that's after 12 months or 24 months or anything.
it is difficult for the patient also.
Ευμορφία
Yes.
συνδέθηκε, οπότε... No, thank you so much, Anita. Eventually, we managed to have Marisa with us. Marisa doesn't need any introduction. We introduced her before in the previous session. She will speak about a very interesting... Okay, hi again, Marisa. Marisa, the floor is yours. We are looking forward to hearing about the big data analysis. A lot of discussion is currently about this big data analysis using the role of networks, and of course, one important network, the European Sleep Apnea Database. Many of us here are belonging to this network, and of course, you were one of the founders of ESADA. So, Anita, the floor is yours. Marisa, sorry. Yes, sorry about this.
I'm sorry, I had you be anxious, but I made it on time. So thank you again. And this is probably a more demanding task than the one this morning, because this is a look into the future, and I'll try to do my best to convince you that sleep medicine is probably one of the first areas of medicine where, besides big data, we are going to use a lot of data generated by CPAP machines and ventilators to get more insight, deeper insight into the problems we currently face in clinical practice. So to start with, we're talking about telemedicine and especially telemonitoring. That is a major source of the big data, best example in sleep medicine at least. But of course, the big data can be of any kind. So for telemedicine, we haven't previously, before COVID, there was an experience mainly in research setting, because telemedicine should be organized. It has some costs. It is not reimbursed easily by public services. There were also issues concerning personal data management and other legal issues. And also, we were kind of confused because there were a possible choice among different options, and also the choice of the model of care. COVID changed abruptly all this, because when it was impossible for patients to go to hospitals, and also there were safety measures, besides the fact that personnel was shifted from sleep services to the general ward due to the COVID emergency, then we got decided to start using it. We're forced by circumstances to use it. Also, another major concern was the fact that maybe old people are not able to use a smartphone, but indeed, even this problem was overcome, and many grandparents talked with their grandchildren on the phone. So if a technology is useful, people are quite fast in learning. In Europe, big data are not collected as in the US over the entire territory, because it is mostly national level, because public health systems are different from one country to another. So it's pretty hard to have a global view. In this, the French experience includes a national database of obstructive sleep apnea, and also the cohort of the Pays de la Loire. So they have probably more experience, and they have initiated that earlier than in other European countries. But what are we talking about when we talk about telemedicine? Now, what we are mostly interested right now is telemonitoring, as I said. That means transmission of data from the ventilator to a platform. But there are also other possibilities, for example, the video consultation. This is harder right now because it has problems of reimbursement, and also there are also technical problems to be solved. For example, the stethoscope, the electronic stethoscope exists for heart sounds, but not for pulmonary sounds, to my knowledge, yet. So, in addition, the other possibility is the transmission of medical data, so store and forward, and that could easily apply to diagnostic procedures like polygraphy or polysomnography. So, we're now concentrating on telemonitoring during my talk. There are areas of vulnerability in such a system of remote telemonitoring involving several areas. And especially here you see the online platform, the data reliability, the confidentiality, the access, but also some problems might be linked with transmission of data from the ventilator to the platform. And it will be possible, if it's not already, that the home care provider could modify the setup of the ventilator remotely or upon clinician indication. So there are different, and of course we need consent by the patient. There are some patients who live in locations that are hard to reach or difficult to connect. So we're not still solved all kinds of problems associated with telemonitoring. And the major problem is that each manufacturer has its own platform, and these platforms do not talk to each other. So the clinician up to now has to jump from one manufacturer platform to another. And also the criteria, for example, for detection of respiratory events is dependent on the algorithm of the PAP manufacturer. So there is a need of standardization of the signals. And what actually are we looking at? Well, the classic things we look at for PAP therapy, and that means compliance, that is has to be higher than 4 hours per night for over 70% of the nights, the presence of leaks, and this means problems with mask that have to be solved, and also effectiveness of the ventilation or the CPAP in maintaining, in resolving the respiratory events. So these are the things we have always looked at, but now we can have it in millions of patients. And indeed, this is an example. This is a study from the ResMed platform, over 2.5 million people in the States. You see that in the first 90 days, good compliance was in 75% of the patients. The overall mean daily usage was reached by 51%. And the median percentage of day used was 93%. However, if you look at the colors here, you see that there is a surprisingly low California, almost 60%, whereas in the Midwest, it gets higher, over 80%, with southern region overall being less compliant than northern region in the US. So the availability of such data that has never been possible before allows also to investigate on lifestyle factors or different habits among different populations, and this is also true in Europe. So the instrument is very powerful. Also, the possibility of looking at differences according, for example, to age and sex. These are almost 800,000 patients initiated on CPAP, and you see that women in red are on average less compliant than men, especially in the younger age groups between 80 and 40 years of age, but also in the elderly between 70 and 90 years of age. So women tend to use CPAP less than men. But the other thing is that the compliance in the first week is not representative of the actual use of CPAP, because this slowly declines over time up to 90 days. One reason why young people may not be using, may not be using the CPAP so effectively is that, for example, over the days of the week, there is a lower use of CPAP during weekends, possibly linked with the fact that the young people go out and or do very late at night on Saturday or Friday, whereas in older age groups, the behavior is more stable over the week. Such kind of data were very hard to put together previously. So these give useful indications for clinical management of the disease at the individual patient level. The lockdown in France was instead a good reason to increase CPAP compliance. And you see here that during the hard closure, from 15 March to 15 of April 2020, there was no vaccine available yet, and especially poorly adherent patients increased their average use by an average of 80 to 100 minutes. Whereas this, of course, was less important or not important at all in those using the machine more than 6 hours per night. This could have been due to the fear of the disease that was already known to have worse outcomes in obese people. And it is an interesting phenomenon that can be useful to know for everybody at the larger level. Children using PAP, positive airway pressure, are few compared to adults. And so this makes the analysis of big data in children, even though the numbers are lower, even more important. And so you see that the PAP termination, the PAP therapy termination occurs more often in children from 15 to 18 years of age. If the kid uses the patient engagement program, this is a strong factor towards abandoning the therapy. And the other thing is that the leak of the mask is a powerful factor for quitting therapy. Instead, the higher the pressure is used for therapy, the lower the likelihood of quitting the PAP therapy, and this probably reflects the severity of respiratory reasons why they were on PAP therapy. Another thing that big data allow is investigation on things that are relatively rare. I have a return of voices, not mine. I don't know if this can be fixed. So here, you know that there are certain patients who do have emergent central sleep apnea during treatment, especially at the beginning. But these account for about 3.5% of patients. So 3.5% out of 133,000 patients does make a reasonable number to investigate more clearly. And you see here, there are those who never have central sleep apnea, those who have it at the beginning and then this declines over time, those where it appears, it is emergent, so it appears early and then increases, and those who have persistent central sleep apnea. So these subgroups have a different outcome regarding CPAP use. And again, those who terminate therapy more likely are the youngest, between 40 and 50 years. Those who have a very high leak from the mask, so a significant factor is probably the uneasiness of wearing a mask with a powerful leak, but also transient central sleep apnea have a lower likelihood than those with emergent or persistent central sleep apnea. And this is a slide I borrowed from Jean-Louis. In these two groups, so the emergent and the persistent, problems can be solved by shifting from CPAP to ASC, to auto-servoventilation. And you see that this shift causes a sharp decrease of residual events, so essentially abolishes the central sleep apnea and also stabilizes the adherence. All these things are useful in clinical practice to know, but could not have been detected in smaller studies. The other possibility is to look at health inequities. This is a hot topic in the States. And you see here that those patients in the lowest socioeconomic level have a much higher possibility and likelihood of leaving the treatment compared to those between the other quartiles. So income and socioeconomic status are important variables. This is another study showing that the higher the Black and Hispanic composition of the neighborhood, the lower is the percentage of patients adherent to CPAP. So here we're looking at things that we were not used to think about before, even though the neighborhood means certainly not a high spatial resolution to really understand. So it is a pretty crude type of result that needs to be further explored with more precision. And the other thing, this is a comparison between compliance in US and in Brazil and in Mexico. The numbers in Brazil and Mexico are lower. Overall, there is a slightly lower adherence to PAP in Brazil and Mexico, but this is entirely explained by the lower use of the engagement tool, so the app. This is very important for the patient because he or she can check the status of therapy and can get instructions, suggestions through the app. And you see that independent of the underdeveloped or developed country, in those patients who use the app, the adherence is much higher than in those who don't use it. So, and this means that the app, the engagement tools for patients, is a very, very important thing for the future. So we should definitely turn to use that. So we have advantages and disadvantages. So the advantages is first opportunities to study previously unknown aspects of obstructive sleep apnea. The fact that with very high number of patients followed over time, we can dedicate some attention to small subsets. For example, a central sleep apnea study in OSA patients on CPAP. And also the fact that the platforms are the instruments by which also the patient can access his own data and engage in the management of the disease. Well, let's look some disadvantages. These data have provide no or very little information on the clinical characteristics of the patients. So from a clinical point of view, they miss important details. There are privacy and ethical issues, not to talk about data protection and security. That is increasingly important in our world, especially with the war, Russia, US, China. So we are in a dangerous world also in terms of data protection. And also we need to develop infrastructures for data sharing, because these data are probably more useful if they can be used at different levels, not only on at the research level, but also at the clinical level or the public health level. So Jean-Louis Pepin has published this very interesting summary. So, and this is a review in Respirology published in 2019. And you see here the clustering methods or OSA trajectories can be done on several types of data, including exercise, sleep habits, level of air pollution, so the exposure to air pollutants, cardiovascular variables, and this can be used to feed these data into an artificial intelligence program in order to do some deep learning. But what big data provide are some possible assumptions that have to be tested in cohorts of registries and then eventually in targeted clinical trials. So this is how personalized and precision medicine evolves. But you understand that the analysis of these big numbers require innovative methods or dynamic models. So there is a need of specialized ICT people who can handle and can give us how to handle these data. And in these cohorts and registries, we can put also the ASADA cohort. The ASADA is a large cohort in Europe that was established in 2007 during a cost action funded, so a networking program funded by the European Union. And we have absolutely no money. So we decided to put in patients with suspected sleep apnea. It's a big effort of goodwill by several academic centers. Now there are overall 39 contributing centers. This is a real world cohort. So some centers may quit, some others may arrive. Right now we have 29 actively recruiting. And we have over 55,000 visits in 34,000 patients, which means that we have started quite successfully to do longitudinal assessment, not only cross-sectional. So we are putting in the follow-up visits of these patients. And it was also recognized and funded as an ERS clinical research collaboration for two periods. Now we are still a clinical research collaboration of the ERS, but we unfortunately receive no further funding. Anyway, we are used to work without money. So because of this setting, and we had to cope with reality. So it was decided that each center would continue its own clinical routine, so both PSG and PG were allowed, but this has created some heterogeneity in sleep apnea severity criteria. We know that the polysomnography overestimates, so polygraphy underestimates AHI compared to polysomnography, but with 34,000 patients, we have enough patients studied by polysomnography and polygraphy, and we can also do separate analysis on these two groups. Controls, we have to do it with patients who turned out to be non-sleep apnea patients, even though they had suspected sleep apnea, so they are a relative control population. The large number allows analysis by age, sex, or sleep apnea severity. As I said, we did cross-section, but we are also increasingly doing longitudinal studies. And the features of the composition of the ESADA cohort, we believe, is relevant for public health and was one of the major reasons for the success of the EU Horizon 2020 project Sleep Revolution. And just to show you the weight of the ESADA in the general setting of the Sleep Revolution project consortium, you see how many sleep centers participate to the Sleep Revolution project. And actually, the Ghent University, that is out of the box, became part of ESADA too. So here we have a large representation of European patients, and this is a very interesting sample. We did a lot of studies in the upper part of, we have to cluster them because there are so many. We are very much interested in the prospective outcome study that's coordinated by Silke Ryan. We published studies on protocols, methodology, several cross-sectional studies, phenotypes, and also longitudinal studies and PAP outcomes. So we are perfectly in line with what is done in other parts of the world. And actually ours is the largest cohort in the world right now. But what are the reasons for success? Well, the reasons are that it is a very democratic setting, that we openly discuss both organization of the network and possible improvements of the network and research projects over 2-3 days at an annual meeting in the city of the different centers. But our, I think, best success was the involvement of young researchers that are working together with the founders. This has a very high educational aspect, but also for us, it's a hope that the cohort may survive our ending career for reasons of age, and that they will be able to take over in the future. And also the longitudinal studies, we keep recruiting new cases, but we do more follow-up visits. So this is important because longitudinal studies are actually those who count. So the conclusions are that big data have provided a wealth of information on previously unexplored aspects of sleep apnea in the real world, generating new hypotheses. But studies on big data do show methodological limitations. For example, as I said, clinical data are few. There is lack of geospatial resolution, such as in the neighborhood, different neighborhood study. And comorbidities are often assessed based on ICD codes. So from a clinical point of view, they are, as I said, pretty crude data. In addition, these big data studies raise problems regarding personal data safety and ethics, and also the informatic infrastructures that have to be set to handle and analyze this huge amount of data. And we do not have yet big data at European level because of the differences among national rules. So in Europe, we have mostly national big data, not international big data. And this is a problem we should address. And also, cohort studies are essential to test the hypotheses generated by big data studies. So this is my last slide. What will happen in the future? Well, large databases are already a reality, and this is important for public health policies, but this has to go back to translate into advantages for the single patient. And to do that, integration of data from different sources will be necessary, including lifestyle, exercise, information on other disease. But dealing with this will also need new statistical approaches. But this is a general problem in medicine, because every field of medicine is turning more or less to big data analysis. And I'd like to say goodbye to you by showing you the picture of our last meeting in Grenoble last April, a few months ago. It was cold, we were all covered, but we had a good time. We were very happy we could meet again after such a long time of online meetings. Thank you for your attention, and again, apologies for not being with you today.
Thank you so much, Marisa, for this excellent overview and important messages that you managed to pass effectively. However, the problem is that we don't have even for one question time, because the next session is already delayed by 20 minutes. So we will utilize your expertise lively next year with more big data analysis and published and maybe more results from these studies. Thank you so much for being with us and share all these important publications and data. Thank you, Marisa, and thank you.
I apologize for having you being late.
No. It's not. It's the usual story at the congresses. I apologize because we don't have a time for discussion, but we will do it next year. Thank you so much for being with us. Thank you, Marisa.
Bye.
Bye.
Have a good congress.
Thank
Bye.
you.
Bye, Winfrey.
Bye. Thank you.
Good afternoon. With no further delays, we will start, I think, an exciting session, and we will talk beyond ILDs, and we will cover systemic diseases and vasculature. I will first introduce my co-chair. This is a assistant professor at the University of Crete at the Department of Pediatrics, my friend and colleague, Chrysoula Perdikogianni, with a special interest and research in both immunology and hematology. And of course, as a first speaker is Professor Wells, that he will talk to us, also as Vice President of VASONG. The recent published data about pulmonary hypertension and sarcoidosis. Athol, the floor is yours.
Thank you very much, Katerina. I must again thank you for my presence here. It is as much a pleasure as it always is to visit Crete. And I can thank you for this title because my task is simply to go over a guideline statement with lots of nice pictures provided by the guideline group to address sarcoid-associated pulmonary hypertension. And this is the guideline statement I have centered this talk on. It's only just appeared. And so now let's work our way through the key points. So it used to be said that pulmonary hypertension and sarcoidosis is very rare, and figures often quoted of less than 5% based on all-comers studies. And actually in all patients with sarcoidosis in a very general clinic, that estimate is correct. But there's no doubt that in particular patient subgroups, the prevalence rises strikingly. Those patients with chronic exertional dyspnea, and inevitably, whatever lung disorder you look at, if you're listed for transplantation, there's a fair bet that you will have pulmonary hypertension or you won't be far away. These are the estimates, and you can see that most likely as you consider increasing, I'll just see if I can work this, increasing the subspecialized clinics with more severe pulmonary involvement, the prevalence rises from the roughly 5% in the often cited Japanese study higher. But you can see, and this is really very striking, if you have evaluation of dyspnea, and especially if it's refractory to anti-inflammatory treatment, that the prevalence of pulmonary hypertension is 50 to 60%, and not so very far below the prevalence in patients listed for transplantation. Now, where does sarcoid pH stand in the current classification? And you might have supposed that it would stand in category 2, pulmonary hypertension due to lung diseases and or hypoxia. But in point of fact, it stands in that ragbag classification group with unclear or multifactorial involvement. And the reason for this is the very many pathways to pulmonary hypertension in sarcoidosis, and these are broadly summarized in this table, broken down into vascular disease. So vasculitis rare, a granulomatous vasculitis, and just once in a while, pulmonary hypertension will resolve simply with anti-inflammatory treatment. But precapillary pH is more often relatively resistant to sarcoid-specific therapies. I'm going to talk a little on veno-occlusive disease. Pulmonary embolism more common in sarcoid than expected, so there's an increased prevalence. A large group where interstitial lung disease is driving pulmonary hypertension. And then you have these rare groups, massive enlargement of mediastinal nodes, fibrosing mediastinitis. If you pull what is known in various estimates, perhaps 5% of sarcoid pH will have at least a contribution and usually a dominant pathway from one of these two pathways. And then there's left heart disease. Now, just a few points. Histologically, granulomas appear both in the arterial and venous pulmonary vessels, and in a distinct subgroup, a veno-ablative process predominates. More than half of patients with sarcoid pH do have fibrotic lung disease, but 20% do not have ILD. Do speak up a little. You'll share everything with the auditorium. Rare causes include compression by nodes, as I've said, but I just want to focus on this series. It's an old series, 22 patients, with this sort of CT picture in the majority and this picture of interlobular septal thickening, and now in the biopsied cases in this series, and these were mostly explanted lungs at transplantation. What you saw was occlusion of the interlobular septal veins, and it is likely that there is more veno-occlusive involvement, even in a minority contribution, than we realize. And so this sort of appearance on a scan should always worry you a bit when you're thinking about targeted therapy in pulmonary hypertension, and above all, never overlook left heart disease. Now, you might think that cardiac sarcoid is going to be responsible. Actually, it's definitely a minority. You are really talking about coronary artery disease, and especially comorbidities related to too much steroid therapy. So I'm talking about diabetic, hypertensive, or both, contributing to cardiomyopathies. 20% of cases on average in sarcoid PH are due to left heart disease, and the outcomes are clearly better because you can find a driver of the pulmonary hypertension and treat it. And that's come through consistently. And then I guess it would be remiss not to mention obstructive sleep apnea as a potential contributor to sarcoid pulmonary hypertension. Mortality, 10-fold increased mortality compared to general sarcoid mortality. And I've listed factors adding or predicting mortality within patients with PH. Age comes out in every analysis you care to do about outcomes in sarcoid. A gas transfer of roughly 35 to 40% seems pivotal. On average, 6-minute walk distances are 350 meters in sarcoid pulmonary hypertension cohorts, and if you're below 300, that's an added risk factor, as is severe lung disease or severe functional impairment. But it won't surprise you that hemodynamic data indicating that it's going to end badly are centered on right ventricular dysfunction. So overall survival, I'll come to it. First of all, the risk factors for a bad outcome in pulmonary sarcoid are the risk factors for pulmonary hypertension. So this is a slide showing DLCO bands, and you can see that the band of below 40%, which corresponds very neatly to the risk factor for a bad outcome in PH, they mirror each other, indicating what a large contribution pH makes to a bad outcome in fibrotic lung pulmonary sarcoid. And this drives staging algorithms that are basically based on DLCO in 2 cohorts, pulmonary hypertension, making a major contribution. And I showed that because I wanted you to look at the survival at 5 years, which is of the order of 55%, and then compare that to the survivals reported in sarcoid PH cohorts. This is at 1 year, and you can see survival in these 5 series is of the order of 80%, dropping at 3 years to the mid-60s on average, and down to at or just below 50% at 5 years. Now let's move quickly to screening and diagnosis, and you'll be alerted by a number of associated factors with PH, if you like, they're shadows of pulmonary hypertension. And whether you're talking about echo, CMR you might be doing to exclude cardiac sarcoid, but it throws up evidence of pulmonary vasculopathy. cardiac stress, BNP, can be difficult to interpret, but especially if you have a rise to 10 times the upper limit of normal as a rough rule of thumb, you should increasingly suspect pulmonary hypertension, provided there's not an additional left heart problem. Dilatation of the pulmonary artery. I've mentioned some of the other that are risk factors for outcome, but major reduction in 6-minute walk or oxygen desaturation, and severe reduction in gas transfer below 40%, but also a disproportionate reduction to lung volume. So from this came the algorithm in this statement, and it's geared to the fact that echo is the key screening factor before you go to right heart study. Now, you could question that. You could be asking, should you group echo with the other things in a composite? But this is how these statements tend to be anchored. So who should undergo echocardiography? And if you're considering transplant, you should always screen with echocardiography. But you're going to get there in those cases by these other factors. So helpfully, and I'm not going to go through them all one by one in the interests of time, but you can see tabulated the factors that should drive you to performing echocardiography. And they range from clinical features, including failure of improvement in dyspnea, 6-minute walk or BNP data, severity of lung disease, ancillary findings on scans, reductions in DLCO without a change in FVC. Personally, I think what is missing for this is a KCO or a severe DLCO threshold. And using the scleroderma paradigm, one can argue that maybe that should be included. And this is then the recommended probability of pH based on echo. You will note that systolic pulmonary artery pressure has been removed. It's based on regurgitant velocity and or the presence of various echo signs of pulmonary hypertension. Again, I'm not going to go over them in detail. You can read the statement, but they vary from signs in the ventricles, pulmonary artery, and in venous return. But broadly, an intermediate likelihood is there if you reach a threshold of 2.8, or you have the presence of other echo signs. If you have both, that's high, or if you reach a threshold of 3.4, you don't need to look at the other echo signs. That's highly probable. So we move to what's often a difficult decision. Who should go to right heart catheter once you've actually completed the echo? Because we know that echo often tends to either seriously overestimate or seriously underestimate pulmonary artery pressures at right heart study, and in fibrotic lung disease especially, with negative intrathoracic pressures drawing blood into the lungs on inspiration, there will be a great deal more swing in pressures, and you may tend to overstate pulmonary pressures. And then, given that you absolutely have to do a right heart study if you intend to treat, because of the frequency with which you find veno-occlusive problems or occult cardiac problems, to avoid fatalities treating with pulmonary vasodilator. Because of that, it's really about, are you going to treat, or are you putting the patient forward for transplantation? And it can be very difficult to make a judgment on treatment, especially if there's severe lung disease. And we'll go on to that. But this is what is recommended in the document. So if you've got a high probability, and buried in that is the assumption that once you've excluded left heart disease, you will be treating, you proceed to right heart study. But with less likelihood, you're worried about very severe fibrotic lung disease. And here, you would still proceed to a right heart study if transplantation is being considered, but otherwise there's no algorithm. You absolutely have to be seen by a specialist with a decision made case by case on whether treatment is appropriate, and that's not easy. As you'll see, there aren't robust algorithms in this field. A lot of this is highly expertise-based. Inevitably, there's a cry for multidisciplinary evaluation. I suppose it's difficult these days to make a guideline statement of any kind in our field without a recommendation for multidisciplinary evaluation. How am I off for time? Am I okay?
Yes, yes.
Because I'm not too far away.
Yes.
And then we come to the difficult problem of whether there is, in fact, a post-capillary problem. Now, what would now be called a pulmonary artery wedge rather than a pulmonary capillary wedge. The official threshold is 15 millimeters, but we know this procedure can be difficult. We also know that there can be predominant pre-capillary involvement without post-capillary involvement, but there can be predominant pre-capillary involvement with post-capillary involvement that you don't detect. So even if you find the wedge is below 15, if there's a bad response with treatment, there's worsening, you have to come back in sarcoid and reconsider post-capillary obstruction. And sometimes you need left ventricular and diastolic pressures measured directly when the wedge is difficult to obtain. And sometimes a wedge of 13 to 15 does actually indicate that there's significant left heart involvement. And again, you have to reappraise that. So it's a very tricky area. I think we're getting close. And I think in the interests of time, I will go straight to the treatments. And I just invite you, first of all, to look at the number of patients in the various trials. There are but 2 placebo-controlled trials, a Rio-Sigwat trial with good responses, and a Bosanton study with improvements in hemodynamics, but no change in the 6-minute walk data. There are 3 prospective open-label studies, but this is limited data. You will agree on that. And what you can say is 2 things. There are no adverse outcomes. And this is unlike these agents used in ILD at large. And secondly, in most populations, you see beneficial trends. So what did this mean in terms of recommendations? Well, the committee felt that you simply could not recommend a specific drug based on data of this kind, but that given the trends, and I'll close with this slide shortly, given the trends and the feeling that pulmonary hypertension in sarcoid is likely to do better than pulmonary hypertension in the setting of other ILDs, a referral for case-by-case off-label use of these various agents is fully justified. And leaving this statement, this is the second to last slide, which is a summary of the overall approach in precapillary pulmonary hypertension, treated with oxygen diuretics as necessary, generally hoping for a response to sarcoid therapy, but this is honestly rare. And then considering carefully compression by nodes, and then case-by-case discussion with these agents, and again, this caveat on patients with an FVC of less than 50%. Committee couldn't decide about impairment of right ventricular function. Some members saw this as increasing urgency. Some saw it as a signal of less likely to have a worthwhile response. I think we need better data. So in summary, there is more optimism in sarcoid PH than PH-ILD in general. I think as much as the trends that I showed you, there's also the strong sense that you're much more likely to be able to prevent progression of fibrotic lung disease in sarcoid PH than in PH associated with other disorders. You do have to work through this multiplicity of triggers and causes. I've listed probably the most difficult issues, but in the end, when you reach this point, it remains case by case with pulmonary hypertension experts, and that's a good note to close on.
Athol, thank you so much. As we run out of time, and we will have more vasculature afterwards with Sergio Harari, Dr. Mitrouska, who is coordinating the Hellenic Thoracic Society group, will comment and will maybe have a very short question to Athol.
Okay, thank you, Katerina. I don't think that there is a room for comment. Here I am, okay. Thank you so much for the wonderful presentation. It was really an excellent one. So I don't think that I have to add something, but so far, any data that we have come from patients with an end-stage disease and patients that are on the waiting list for lung transplantation. But I think that here, and I totally agree with your last phrase in your last slide, that this is a complicated situation with pulmonary and heart disease, so we have to be very careful. And I think that this is the perfect field to practice evidence-based, personalized medicine. I think that this is what we have to keep in our mind for our patients' best interest.
Yes, I agree with you. There's been an emphasis on end-stage disease. The pulmonary hypertension registries are now, I think, increasingly addressing earlier disease. And my hope is that we see properly powered studies built on those engaged in registries and others with a special interest that actually gives us trials with patient numbers that cover the range of severity. There's no protocol in any of these treatment studies which allows you to say there's a certain severity that's been selected, that there's other features. For example, it's often unclear to what extent an element of veno-occlusion has been excluded and considered. We've got to standardize more than we do, and we've got to cover the spectrum of severity more than we do.
Yeah, thank you very much. Thank you.
So we have the pleasure to have our next speaker, Dr. Irini Varsamidi, I think, according to the program, who is a respiratory physician at the Department of Respiratory Medicine at the University Hospital of Heraklion, and who is going to present us this very interesting topic, vasculitis and the lung.
Yes, good afternoon to all of you. First of all, I would like to thank the organizing committee for this kind invitation to present some recent data about vasculitis in the lung, hopefully during the next 20 minutes. So, a very short introduction about systemic vasculitis. We all know that they are characterized, by inflammation of blood vessel walls leading to endothelial injury and tissue damage. 10 years ago, the revised consensus tried to categorize vasculitis mostly based on the size of the affected blood vessels, on the presence of the underlying autoimmunity, and whether it's idiopathic or secondary to an infected cause. As we pulmonologists know, systemic vasculitis involving mainly the lungs are those affecting small vessels, so they're ANCA-associated vasculitis. Of course, also other systemic vasculitis not associated with ANCA also affect the lung, especially Behçet disease and antiglomerular basement membrane antibodies disease. Regarding ANCA-associated vasculitis that we are going to talk more in this presentation, we have to say that they mostly affect lungs and kidneys, and they are the most widely studied forms of autoimmune vasculitis. ANCA-associated vasculitis are characterized by presence of ANCA antibodies. They are anti-neutrophil cytoplasmic antibodies located in the cytoplasmic granules of neutrophils and lysosomes of monocytes. The two major antigen targets are myeloperoxidase and proteinase 3 and are detected in the majority of AAV patients. Anti-PA3 are found in more than 85% of GPA patients and anti-MPO in 35 to 70% of MPA and in a more or less the same extent in EGPA patients. So the clinical presentation of the patient with vasculitis, as we all know, is highly variable, and so the diagnosis is exceptionally challenging. Really commonly, a biopsy of the involved organs is necessary for the diagnosis, and the choice of the biopsy site depends on the pattern of end organ involvement, on the accessibility of the biopsy site, of course, the morbidity associated with biopsy at a specific site, and the likelihood of obtaining a diagnostic tissue. The frequently biopsied sites include, of course, kidneys, upper airway, skin, and the lung. So this year, the American College of Rheumatology and European Alliance of Associations for Rheumatology published new classification criteria for those three ANCA-associated vasculitis that I'm going to present you shortly. The aim of this classification criteria is mainly to differentiate cases of those patients from similar types of vasculitis. And so let's start with MPA microscopic polyangiitis. As you can see, there's this table that we take into consideration clinical and laboratory data. We make the summary of these points, and finally, a score more than 5 give us the definition, the high probability that this is a patient with MPA. MPA, I don't know why the slides are going on by their own. Anyway, MPA is characterized by necrotizing vasculitis with little or no immune deposits. Poachy immune acid is known. Whereas the next AAV, granulomatosis with polyangiitis, GPA, formerly known as Wegener's granulomatosis, is characterized by necrotizing granulomatous inflammation involving, as you see on the table on the right, maybe mostly the upper and the lower respiratory tract. More than 60% of the patients present with sinusitis, nasal mucosa ulcers, and a vast majority of them have pulmonary manifestations like cavitated nodules and consolidations. In this table, combining clinical and laboratory and biopsy criteria again, a score more than 5 gives us the classification of GPA. The third AAV, EGPA, formerly known as Jerk-Strauss syndrome, is associated with, histologically, is associated with eosinophilic-rich necrotizing granulomatosis inflammation. Primary, I do nothing. I swear.
Magic.
Primary involving, as you see on the table again, the respiratory tract. Nasal polyposis is found in more than half of our patients. Asthma, more than 90%. And in this table, a score more than 6 gives us the classification, the definition of EGPA. I like this table because it presents the clinical manifestations of these three vasculitis that we just mentioned. And so we can see the main clinical manifestations, and we can compare the three entities. So we can see that upper airways upper airway findings are mostly in GPA and also in Jerk-Strauss in GPA, whereas more than 95% of the patients, as we said before, in Jerk-Strauss presented with asthma. Nodules, cavities, and infiltrates, as we are going to see later on also, is mostly found in GPA patients, whereas alveolar hemorrhage, that it's really interesting and important for us as physicians because it's a cause of mortality, is seen in 10 to 30% of patients with MPA, and in a lesser extent in patients with GPA, where it's rarely, almost never seen in GPA patients. What is the role of bronchoscopy and of BAL in the diagnosis in the course of the disease of our patients? First of all, bronchoscopy can help us diagnose diffuse alveolar hemorrhage. It can help us with sampling of the lower airways to detect a complicating respiratory infection, and it can also help us assess the large airways for endobronchial lesions. In case of ILD, that is mostly the case for MPA patients, we can usually see neutrophilia, and also we can see lymphocytosis and eosinophilia in approximately 1/5 of our patients. This is a schematic representation of the major findings on higher CT that are associated with several vasculitis. And this is a nice schema for us to have something in mind. However, we should not forget that radiology is not specific for vasculitis. For example, on the panel upper on the left, we can see the CT findings of a patient 75 years old. This is from our department, with anti-PR3 vasculitis presented with consolidation, nodules, and cavities. Whereas in the lower panel, we can see diffuse alveolar hemorrhage in one of our patients, 62 years old male, presented with MPO vasculitis. MPO vasculitis was also the case for the right panel of CT findings, where there was UIP and NSIP in 2 other patients. So a diagnosis is challenging, but when we manage to make the diagnosis and we have the patient with vasculitis, the next step we have to think about is what is the disease state. This is what make us to follow the treatment, to initiate the treatment. This is the guidelines that were published last year. So first of all, I want to mention that active disease means that we have new persistent or worsening clinical signs or symptoms that are attributed to vasculitis and not related to prior damage, whereas severe disease means that we have life or organ-threatening manifestations, commonly alveolar hemorrhage, glomerulonephritis, and more rarely central nervous system vasculitis, mononephritis multiplex, cardiac involvement, and mesenteric ischemia. Remission is also one of our goals, whereas sometimes there is refractory disease when we have persistent active disease despite an appropriate course of immunosuppressive therapy, and we have to be careful for patients that have relapses, so recurrence of active disease following a period of remission. Of course, the cornerstone of treatment, we all know it is immunosuppression, and we as physicians, we have to try to initiate as early as possible in order to induce remission, first goal. Second goal is to maintain remission and, of course, to avoid relapses. This is the algorithm that was presented in these guidelines about how to treat patients with GPA and MPA. Of course, I told you that these are 2 different and well-recognized entities. However, in many recommendations included these guidelines, they are considered together for this algorithm because most of the studies have enrolled both groups of patients, and so they present the results together. So I will try to go through these algorithms really shortly. First of all, for active and severe disease, GPA or MPA, rituximab has been shown to provide similar benefit to cyclophosphamide, so it is considered less toxic and is our first choice for medication. There was, let's say, a kind of debate the previous years, sorry, I do nothing, about the role of plasma exchange to remission induction therapy. And after 4 trials about plasma exchange, there was this recommendation against the routine addition of this practice. This is because of the higher risk for severe infection. However, the authors conclude that plasma exchange can be considered for patients at higher risk of progression to end-stage renal disease. So this recommendation, as I said, is supported by data from 4 trials. These are the 2 largest trials of plasma exchange that actually didn't show any effect on decreasing mortality. That's why this was the recommendation. However, we have to mention that in a more recent trial, combined data from these 2 trials showed that there is a probably decreased risk of end-stage renal disease in those patients. And so the conclusion maybe is that the benefit is pronounced in patients with higher risk of end-stage renal disease, although those trials showed no difference in mortality. Same for alveolar hemorrhage. These 2 trials showed that there were no differences in mortality or remission rates. So plasma exchange is not routinely recommended. However, it can be considered as a rescue therapy. Okay. Maybe they can help us because, okay.
Can someone change other than Irene?
Sabotage. Okay, I can go back and continue. It's okay, but I'm afraid it will happen again. Okay, it happens again. Bad spirit. Away from me. Thank you. No.
I will see your file.
What did they say?
Possibly you.
My file? Just a PowerPoint presentation.
By accident, you are doing some peculiar settings.
Okay, anyway. Oh my God. Okay, I will go on anyway. I will try to go on.
Without slides.
Without slides, just the algorithm and go on. Yes, you're right.
Presentations, one from other part of
Maybe. I'm not an expert, but anyway. Anyway, okay. So for but it's a problem.
we are out of
Sorry
time and...
Πηγαίνει μόνο του.
Ναι. Αν είναι κάποια ρύθμιση μπορούμε να την αλλάξουμε.
Αυτό θα πρέπει να
έχει if it's something that we can...
Λοιπόν, το πηγαίνετε μόνοι σας.
Εγώ δεν κάνω τίποτα από πριν.
Κολλήσει κάτι.
Ναι, ακριβώς. Όσο βιάζεσαι. Μα το ξέρω.
Ούτε στο view. Είναι normal. Όσο έχει κολλήσει το κουμπί και πάει μόνο του αυτό και σκογιούμε. Να βγάλουμε και αυτό. Θέλουμε.
Συνεχίζει να πηγαίνει μόνο του.
Very British. Very British. Very British.
Μπορούμε να το...
Ειρήνη. Ναι. Maybe we can, yes, we can stop and continue with the next session, which is connective tissue disorders and the lungs, because we are run out of time, and we will have, yes,
and
yes,
I will come
indeed.
back from the treatment
Tomorrow at mid-time, we will have more time to discuss about vasculitis and novel therapeutic approaches that we didn't have the time to discuss today.
We never mind now because. Πρέπει να προχωρήσουμε, Ειρήνη.
No, okay.
Ναι.
Just that I did nothing.
Maybe your conclusion. Yes. Ειρήνη, your
Okay, yes. I think now it's not. I think now it's better. At least I can try for.
No.
Okay.
The conclusion.
Okay, it's fine. It's fine. Okay, just the take-home messages, and if you want, we can discuss about it later. So, ANCA-associated vasculitis represent a heterogeneous group of systemic autoimmune diseases that are characterized by small vessel necrotizing vasculitis with systemic involvement, including pulmonary manifestations. I wanted to present the new recommendations for classification criteria and management. Anyway, lung involvement is common, we know that, and is associated with increased mortality. A couple of studies I wanted to show about MPA-associated interstitial lung disease and diffuse alveolar hemorrhage, that is the first cause of mortality in the ICU patients. Lung manifestations are very heterogeneous, as we saw, and require differentiated treatment approaches. Although ANCA has initially mostly been associated with vasculitis and alveolar hemorrhage in the lung, ANCA positivity, pulmonary fibrosis is now considered as a frequent and serious condition associated with ANCA positivity. I just wanted also to let you know about a study that is, I think it's completed about pirfenidone in MPO positivity in pulmonary fibrosis patients. That we all wait the results, and new trials targeting specific pulmonary disease manifestations are encouraged and may ultimately provide better individualized therapy and outcomes. Thank you, and sorry for this.
Yes, tomorrow we will more talk about MIRA study and the new approach that we have in our hands, mepolizumab in EGPA. And now, with no further delay, we will have Professor Bertsias from the University of Crete, that he will talk to us about connective tissue disorders in the lung in a complementary presentation with Argyris Zouveleikis, who does not need an introduction, and they will have the multidisciplinary approach from the part of rheumatologists and pulmonologists, something that we do in our daily practice. George, thank you so much for being here with us.
I would like to thank my professors, Tzanakis, Schiza, and Antoniou, for the opportunity to speak here. And this is indeed a very challenging task that Argyris and I undertake, and I will try to be quick. So I guess after Argyris also shared his part with me, the goal is to present some points to consider from my perspective as a rheumatologist on selected connective tissue diseases, to speak about the frequency, the clinical spectrum. I will emphasize on the diagnosis and the role of serological tests, and not so much on treatment. And the second part will be more on how we approach diagnostically interstitial lung diseases and disease in these diseases. So under the umbrella of connective tissue diseases, we refer to, actually, as a rheumatologist, we do not include rheumatoid arthritis in this classification, but rheumatoid arthritis is a very common autoimmune rheumatic disease, lupus, Sjögren's disease, sclerosis, and inflammatory myositis. So the interesting thing is that these diseases have shared pathogenic pathways like type 1 interferon. Innate immunity plays an important role, and there is, of course, autoreactivity and autoimmunity, and that's why we see autoantibodies in all these diseases. They share some clinical features like positive ANA, arthritis, but of course there are differences. And for the interest of time, I will focus on three diseases: rheumatoid arthritis, scleroderma, and inflammatory myositis. And I will start with rheumatoid arthritis, which is by far the most frequent among the connective tissue diseases. It actually affects more than 1% of the adult population, and this is very relevant to when we have a diagnostic approach to a patient with interstitial lung disease. We put rheumatoid arthritis high in our differential due to the fact that it is very prevalent. It can affect both genders and all age groups. Actually, you cannot exclude the diagnosis from young adulthood until, let's say, above the 80s even. So it typically presents with symmetric inflammatory polyarthritis, and in the majority of cases, patients can report the symptoms for several months or even years prior to the definitive diagnosis. Now, another thing is that the severity, however, of arthritis can vary a lot. You can have a patient with mild arthritis, the so-called lung dominant, let's say, CDD, ILD, or you can have a patient with a very severe debilitating rheumatoid arthritis. And we generally have a very low threshold to detect arthritis, especially when there is another major organ that suffers, like the lungs. So not always you will see a patient presented with this typical, let's say, textbook photo. Most of the times it will be a milder arthritis, like in this young woman that affects the PIPs, the proximal interphalangeal joints. So you need actually to do a careful clinical examination to ascertain the diagnosis. And there's a lot of discussion about classification criteria. Irini tried to show us the new classification criteria for vasculitis and arthritis. Of course, there are classification criteria. Remember, these are not for diagnosis. However, they can be helpful in the clinical setting. And one thing to notice here is, of course, autoantibodies are rheumatoid factor and anti-CCP, which play an important role, but still you can have the diagnosis of rheumatoid arthritis even without these autoantibodies. And the same for inflammatory markers. Approximately 30% of rheumatoid arthritis patients do not have high ESR or CRP. Another thing that we pay a lot of attention is the presence of bone erosions on X-rays. If we see typical bone erosions, then our first, second, and third, let's say, diagnosis is rheumatoid arthritis, because not many other diseases affecting also the lungs can cause this kind of erosions. Now, a little bit about rheumatoid factor. It has a modest sensitivity and specificity, especially at the early stages. So you can never exclude the diagnosis of rheumatoid based on a negative RF test. And the second, because we often discuss about cases in the hospital, if you see a positive RF, if it's not high abnormal, but it's also only borderline, remember to exclude other possible causes, infections, other connective tissue diseases, Sjogren's, even in the general population, and especially in smokers, you can have a high titer. And generally, it is not considered as a screening test. Now, the citrulinated peptide antibodies are more specific. So if you find high titer of these antibodies, the only diagnosis is rheumatoid arthritis. But again, they suffer a little bit in terms of sensitivity, again, especially for the early stages of the disease. So bottom line, approximately 50% of our patients, at least we have analyzed our cohort here in Crete, but this is replicated worldwide, are seronegative, as we say, so they don't have rheumatoid factor or CCP. And approximately 15% of patients can have one autoantibody and not the other. So in clinical practice, when you really search for the diagnosis, you need to ask for both tests. The other interesting concept, of course, that has evolved in rheumatology in general is the preclinical onset of this disease. So we know that autoantibodies can predate the diagnosis of both rheumatoid arthritis, but this is the same case also in lupus and other autoimmune diseases. As we reach to the point of diagnosis, you see that the titer rises, and this creates the possibility for preventative trials, but this has not reached to the point of clinical practice. Another thing that maybe you can also appreciate when you try to establish a diagnosis is the possibility that you find extra-articular manifestations. Typically, of course, nodules, episcleritis is fairly common in rheumatoid arthritis. You can have a history of pleural effusions, of pericarditis. So this, in a patient that has also arthritis and lung involvement, increases your probability that this is an underlying connective tissue disease like rheumatoid arthritis. Now, it's not uncommon, of course, and with the imaging methods that we have been using for many years now, it's becoming more prevalent as a comorbidity. So approximately 10% of patients have there is a lifetime risk of 10% that patients with rheumatoid arthritis will develop clinically significant rheumatoid ILD. And it has, of course, a significant impact on the patient, frequent hospitalizations, intensive therapies, etc. Who is at risk? Males, increasing age, smokers, those who have non-remitting disease, and those who have high titers of rheumatoid factor and anti-CCP antibodies. Now, there are other factors, and I believe that the department here has contributed to this knowledge that there are certain genotypes that contribute to this risk, and there are efforts to develop, let's say, risk predictive models that combine gender, levels of activity. This is the DAS28 that we use to measure activity, and the presence of certain risk alleles that can increase the possibility for subclinical, in this paper, ILD. Now I move on to another very severe and challenging disease. This is systemic sclerosis. It's not as common as rheumatoid. It is far more rare. You can see here the incidence. And it has a complex etiopathogenesis that involves immune system activation, vasculopathy, and excessive fibrosis. Now, there are many clinical, let's say, hallmarks. If you ever see a patient like this, it's very difficult to forget about these manifestations. Include very severe Raynaud's. They include, of course, skin fibrosis and sclerodermia and sclerodactyly that you can see on the internal part of the arms. But this is where you appreciate it most. Digital ulcers, of course, because of the severe vasculopathy, telangiectasias, and calcinosis. So these are very characteristic hallmarks for systemic sclerosis, and sometimes we don't even ask for, let's say, lab tests. If you see some of these findings in the patient, it's very likely that he or she has sclerosis. And of course, many patients with systemic sclerosis will develop ILD, or will progress, or their ILD will progress over the time. So we have learned a lot from large European cohorts like the U-STAR, where you see that on an annual basis, about a quarter of the patient, of the cohort, deteriorates its lung function, and the majority of patients might have a rapid involvement during the first 3 to 5 years. So this is a period of very careful and intensive follow-up, and they have managed to describe several phenotypes according to how stable or deteriorating the disease is. So we often distinguish scleroderma into limited and diffuse, but this is not always the case. So as I write, it is very useful for medical students or for didactic reasons, but sometimes patients can share characteristics, and we usually, let's say, consider adicentromer to be a characteristic of limited scleroderma. The majority will have ANA. Let's say a peril is that usually these have high titers of ANA. So the majority of scleroderma patients have over 640 titers. And another autoantibody that we do not measure in clinical practice, the RNA pol, is associated with severe disease. About the early diagnosis, 2 things to pay attention is the Raynaud's, of course, and the puffy fingers. So when you have early development of skin fibrosis, these 2 characteristics can guide you to the possibility of scleroderma. And another thing that we have been using in the clinic is that we perform capillaroscopy, and we are able to identify changes in the capillaries beneath the nail bed, and you can see the typical characteristics here with giant capillaries, especially when there is hemorrhage. These are very typical for scleroderma. So when we have a severe Raynaud's that has this kind of pattern, then we are really very close to the diagnosis of scleroderma. And this is why the new classification criteria have introduced capillaroscopy together with puffy fingers and of course the serological tests for the early detection of scleroderma. And I will finish with polymyositis and dermatomyositis, another group of connective tissue diseases that has very characteristic skin changes, like the Gottron signs or the mechanic's hand, of course. But we still rely on biopsy in order to put the diagnosis. But this has been challenged lately by the introduction, as you probably know, of the myositis autoantibodies, this panel that captures many different autoantibodies. And the interesting thing is that there is some kind of correlation with the presence of interstitial lung disease or with other phenotypic, let's say, characteristics. So the adisynthetase syndrome includes mostly ADIJO1, but also other autoantibodies, and these are very strongly correlated with lung disease. And the MDA5 correlates with both lung disease and skin disease. There are other autoantibodies that are correlated predominantly with skin disease. And also pay attention to these two autoantibodies against TIF1 gamma and NXP, because these are correlated with high risk for malignancy. So there is some form of correlation, but I will tell you about some of the pitfalls in paying too much attention to these autoantibodies. The first is that even if you do the whole panel of autoantibodies, the majority of patients with dermatomyositis will be negative for these autoantibodies. So this is the prevalence of each of the autoantibodies. By far, the most common is Jo1. This one here that you see is for inclusion body myositis, not an inflammatory, let's say, myositis. And also ANA are not always positive, especially patients with antibodies sometimes can have a negative immunofluorescent test, and this is sometimes technical, actually, artifact. Another thing is how you measure these autoantibodies. Now, the most, let's say, specific method is immunoblot, which, however, lacks sensitivity, and immunoprecipitation, which is very tedious. It's not easy to do. Now, the commercial kits that are around are okay, but they have not been standardized yet. And therefore, in the absence of a relevant clinical context, we should be careful not to overemphasize a low positive result with these myositis antibodies. Second is that myositis-specific antibodies are actually mutually exclusive. So you cannot have both MDA5, let's say, and TIF1 gamma. If you find peculiar results, you have to question the validity of the method. And second, okay, they are correlated with clinical phenotypes. However, if you look at the publications, the odds ratios are 1.5 to 2. So these are not very high, let's say, effect sizes, with a notable exception of TIF1 gamma, which increases by 10 times the risk for malignancy. And finally, we like immunosuppressive treatment. Why? Because we think that fibrosis is driven by aberrant immunology, and these are the options. And I will stop with a positive result, for example, as an example that we had with tocilizumab, which was actually tested for skin fibrosis, but the secondary endpoint, which was the FVC, showed benefit, and that's why it was approved in the United States, and we use it increasingly, actually, in our clinic. And now I will pass on to Argyrios, and maybe we will take the questions at the end.
Yes, if we have time, but we will not have. So Argyrios, thank you so much. We will further talk about scleroderma lung and novel treatment approaches by Anna Maria Hoffman on Sunday morning.
This is working. Okay, so I will, for the sake of time, I will try to be as fast as I can. That was an excellent talk. Thanks a lot for passing me the baton and for these two complementary presentations. So So you're all aware of this. We're going to talk mainly about systemic sclerosis, rheumatoid arthritis, and polymyositis. So the main questions that we have to address in this presentation, and we'll also address in the everyday clinical practice, is the first question is it common for a connective tissue disease to affect the lung? And yes, the answer is yes. And this is from a paper published in the New England Journal of Medicine in 2018, showing that about 20% of the cases that we're dealing in the everyday clinical practice, it has to do with connective tissue diseases. The next question is it pleomorphic? So, and the answer is yes, because as you can see here, the respiratory involvement in autoimmune diseases is pleomorphic. So we have direct pulmonary involvement, and we also have indirect pulmonary involvement, which is something really important to stress out, that most of these patients, they're immunocompromised. So we have to take into account the drug-induced respiratory involvement and the infections that these patients always, in the majority of cases, develop if we don't pay attention. And as you can see, you can appreciate in the right slide, you can see a patient, you can see patients with different types of involvement because of rheumatoid arthritis. You can see honeycombing, you can see traction bronchiectasis and SIP pattern. You can also see that rheumatoid arthritis really likes the airways, and it can cause bronchiectatic lesions, it can cause bronchitis, and also pericarditis and pleuritis, and also nodules. There you go again. We have to remember that also patients that have rheumatoid arthritis, they can also have indirect involvement because of DMARDs like methotrexate. But what I was taught when I was a student was that be cautious about methotrexate-induced lung, and it's like we have demonized methotrexate. However, what the recent literature has shown is that the methotrexate-induced interstitial lung disease is not a common side effect of methotrexate. Methotrexate is a really effective drug and a really safe drug, and this is an uncommon complication. And as you can appreciate from these retrospective cohorts, patients that had rheumatoid arthritis and they were under methotrexate and they had developed interstitial lung disease, maybe because of the systematic effects of methotrexate, they had better survival than patients with rheumatoid arthritis and interstitial lung disease without methotrexate treatment. So the next question is, does it matter to search for interstitial lung disease in these patients? And it has been shown before, and there's a lot of literature emerging at the moment that not only idiopathic pulmonary fibrosis can have progressive phenotype, and as you can see here, and Yorgos has shown before, that about 25 to 30% of patients with connective tissue disease associated interstitial lung disease, they're going to develop a progressive fibrosing phenotype. And what we call about how do we define this progressive pulmonary fibrosis phenotype is when we're dealing with a patient that has all three: clinical deterioration, physiological deterioration with an FVC decline more than 5%, DLCO more than 10%, and also radiological evidence of disease progression, as you can appreciate from these, as you can appreciate from these CAT scans, where we have increased traction bronchiectasis, more ground glass opacities, and also more honeycombing. And so the question is ILD essential? Of course it is essential, because it's a major cause of death. And as you can appreciate from this slide, patients that they have rheumatoid arthritis and develop interstitial lung disease, their 10-year mortality is about 60%, whereas patients without interstitial lung disease, their 10-year mortality is about 35%, almost less than almost half. And the same thing goes with systemic sclerosis. As you can appreciate from this slide, patients that they have systemic sclerosis and they have lung fibrosis, they have CT extent of lung fibrosis more than 25%, they have 8-fold higher mortality rates. And the same thing has to do with idiopathic inflammatory myopathies, and it has been stressed out by Professor Berchias that there's a lot of maybe overestimation of inflammatory myopathies associated with interstitial lung disease. I would like to call it autoimmune-related interstitial lung disease, maybe not an amyopathic type of interstitial lung disease, but however we call it, patients that they have a positive MDA5 antibody, they have the worst prognosis. Sometimes they present with bilateral antibiotic refractory bilateral infiltrates, the pattern of organizing pneumonia that I'm going to show you in the next slides. And these patients, they're antibiotic refractory. So you give antibiotics, they develop respiratory failure, and you have to send the myositis panel. And whatever, even if it's not specific, sometimes you're using the therapeutic criterion. These patients, they don't go well with broad spectrum antibiotics. You have to give rituximab, you have to give pulses of corticosteroids, and you have seen that in our everyday clinical practice. I'm not going to go through pathogenesis. You all are aware of the repetitive interior stimuli. It's the same thing that happens in patients with connective tissue disease, associated interstitial lung disease, with the difference that now the driving force is the loss of immune tolerance, the molecular mimicry, and the development of ACPA antibodies, that it has been shown that increased citrullinatation of antibodies like collagen, they lead to increased inflammation and alveolar epithelial cell apoptosis, and then we have denudation of the alveolar epithelium. And once we cross this line, then we have self-perpetuating fibrosis. That means that we have activation of fibroblasts. We move from the inflammatory to the fibrotic stage. We have activated fibroblasts, extracellular matrix deposition, and because of the stem cell exhaustion of the AT2 cells, then we have basal cells that they move from the bronchiolar epithelium to the alveolar epithelium to cover the denudation of the basement membrane and the alveolar epithelium. But these basal cells, they have the genetic code to give birth to bronchiolar epithelium. That's why we see bronchialization of the airways and the so-called proximalization of the distal airways. And these bronchiolar epithelium, they don't represent functional units. They don't represent units that they participate in the gas exchange. And there are also common genetics that I'm not going to go through. And this is an interesting paper that was published like a year ago showing that nintedanib, it gives some mechanistic answers why nintedanib works in patients with rheumatoid arthritis, interstitial lung disease. It maybe suppresses citrullinatation enzymes like PDA4, which is something really interesting in an experimental model of rheumatoid arthritis. How do we approach these patients? Of course, we have to have in mind that this looks like a busy slide, but it's not. It's the cornerstone of medicine, and it has to do with history, physical exam, and PFTs. History and physical exam, they have been developed well by George. So I'm going to focus on the major thing that has to do with the auscultation of the patient. Rheumatologists and also general practitioners, and I assume also pulmonologists, they have to auscultate the patient. If you listen to the end inspiratory crackles, the so-called Velcro type, that's a sign of early fibrosis, and we have to bear that in mind. Always look at the digital clamping. If it is present, then it's poor prognosis. How about the PFTs? So usually we have a restrictive pattern, but be aware of the disproportionality. When we have preserved lung volumes with disproportionate reduction of the DLCO, then that's a sign of combined pulmonary fibrosis and emphysema, which is more frequent in scleroderma patients. It has worse prognosis, and it also can lead you towards other extra articular manifestations associated with interstitial lung disease like pulmonary hypertension. 6-minute walking test, it's an easy, reproducible, informative marker. I'm not going to go through. You're all aware of the procedure. Less than 250, they have been used some cutoff points. The minimal significant difference, the MCID, in terms of reduction, it has been coined out by a paper by Ron Dubois in 24 meters. But this is also something that we see in the clinical practice. How about HRCT? That's a really nice table summarizing all the ILD manifestations, the type of ILD manifestations of connective tissue diseases. And you're all aware that usually rheumatoid arthritis is responsible for a UIP pattern, whereas when we see a fibrotic and SIP pattern, then it's mostly systemic sclerosis. And usually dermatomyositis, polymyositis affects the lung through an organizing pneumonia pattern. And however, the HRCT disease spectrum can be quite wide, starting from interstitial lung abnormalities to extensive fibrosis like honeycombing, as you can appreciate here. These are similar cases that I have shown you after, like the right corner, where you can appreciate that there's the tall sign areas of organizing pneumonia with fissuring of the hands, and also, as you can see here, this cracking and roughening of the distal hands, where you can see here that these are the so-called mechanic hands, and this patient had positive myositis panel. And the HRCT pattern, in some cases, and also time dictate treatment. What I'm going to show you here, you can see a patient with organizing pneumonia, bilateral consolidation, and this patient didn't respond well to antibiotics. He has a positive myositis panel. He did well with corticosteroids, pulses of corticosteroids and immunomodulation. And I'm sure that in the right panel, you're not going to give immunomodulation in these patients with has like a exuberant honeycombing, and there's lack of inflammation over there. But usually in the everyday clinical practice, there are a lot of gray zones, as you can see here. Many patients with fibrotic NSIP pattern and also thickening of the interlobular septa and reticulation can have both a mixed inflammatory and fibrotic phenotype. And I'm showing you here just to make the devil's advocate that we had about 40 cases of myositis, positive myositis panel patients, that they have developed this so-called antibiotic refractory bilateral infiltrates. They were first presented as pneumonia, but they didn't go well with antibiotics. And these patients, they had positive myositis panel. Some of them, they had positive MDAA5. And as you can see here, their prognosis was much poorer than patients with negative MDAA5. So that's why we have to be aware of the autoimmune related injury, interstitial lung injury in these patients. There's also some HRCT tips where when we see a feature of subpleural sparing with presence of bronchiectasis, traction bronchiectasis inside the ground glass, or maybe not, then usually this is, sometimes we call it idiopathic NSIP, but that's a working diagnosis. Usually there's an autoimmune disease underneath. That's why we have to search thoroughly for this patient for extra extra pulmonary manifestations. And this is a nice paper showing that there's a hypersensitivity pneumonitis pattern, the so-called mosaicism, and the head C sign. It's an umbrella, maybe it's an umbrella term that also involves autoimmune-related lung injury, like antisynthetase syndrome. That's why you have to search thoroughly those patients with an extensive serological profile, although the rheumatologists always say that there's no autoimmune disease, a specific connective tissue disease, if there are no manifestations, systemic manifestations. The four-corner sign, the anterolateral involvement with a posterior lower base involvement. In the majority of cases, it indicates the presence of an autoimmune disease. There's also hypersensitivity pneumonitis patients. They present with this pattern, and but we have to be aware that in many cases, patients with idiopathic pulmonary fibrosis, they can present with a four-corner sign. There's also the straight edge sign and the exuberant honeycombing. These usually they say that this is an involvement of NSIP pattern towards an inflammatory, towards a fibrotic destruction and architectural distortion of the lung with big lung cysts, multiple cysts. This is the exuberant honeycombing that when you see that, it's not an IPF case, but usually it is an scleroderma case that sometimes that denotes the presence of a burnout disease that will not evolve. So we have to bear this in mind. How about BAL? So BAL, usually it's been used to exclude infections. It's an important tool that we're using. And in some cases, it can also help us reevaluate the diagnosis, like it happened in papers from Morel and colleagues, that they have shown that almost 45% of patients that they had lymphocytosis and they were called IPF, they eventually had hypersensitivity pneumonitis. The same thing happens with patients with autoimmune disease. They present with bowel lymphocytosis more than 30%. Usually that's not an IPF case. Do you really need a lung biopsy? The answer is in between. So when this paper was published in the Blue Journal in 2016, the answer was no, because they were using non-elective surgical lung biopsies. That's not the case. If you have a patient that has a connective tissue disease, you don't need a biopsy, because these patients, if you make a non-elective procedure, then you may lead them into acute exacerbation. And the mortality is about 16%. And you can imagine that if it's an elective procedure, the mortality is about 1.7%, which is about equal to a lobectomy, which is acceptable. However, at the moment, we have, and the new guidelines have stressed out the importance of transbronchial lung cryobiopsy, where this is an alternative option that it can be used for histopathological diagnosis in patients with ILD of undetermined type. And in some cases, these patients represent cases of autoimmune disease. And it's also for research purposes. Tissue might lead us to a better phenotype of these patients, endotype those patients based on genetic and molecular profiles. Maybe that's the future. As you can see here, in lung cancer, we have more than 16 variants that have led us to 15 targeted drugs. However, in the fibrotic lung disease, there are about 20% of our cases, they can be explained by genetic predisposition. They have a family history of lung fibrosis. However, we have 0 targeted drugs. So maybe that can bother us in the future. So I'm going to finish with the treatment. So
1 minute, Argyris, please.
Yes, okay.
Yes.
So I'm just 14 minutes, but that's okay.
Yes, I know.
So we know now that cyclophosphamide has been used in SLS1 and 2 clinical trials. However, these were trials that they involved cellular NSIP patterns, not fibrotic NSIP patterns. And there are some trials that they are be using rituximab head-to-head with cyclophosphamide. That's the RESTAL trial that has been announced in the recent American Thoracic Society conference, showing that rituximab maybe was not superior to cyclophosphamide, but maybe had a better safety profile. And I'm going to pass that through. What I'm going to show you with that paper is that the knowledge was there almost 10 years ago, that Fischer, which is a rheumatologist, has shown that if a patient with connective tissue disease is under immunomodulation and it behaves, that pattern behaves like IPF, it has a progressive phenotype. Look what he was proposing. He was proposing consider treatment as for idiopathic pulmonary fibrosis. And we were waiting for that trial showing that there was a common genetic background in 2018, published in New England Journal of Medicine, stressing now that since these patients with rheumatoid arthritis and patients with IPF UIP pattern, since they have a common genetic background, why not giving them the same treatment? And then INBUILD trial came up, and we had the same benefit in terms of functional decline comparing to patients with IPF. And also, there was a really important study showing that you can combine mycophenolate mofetil immunomodulation in patients with systemic sclerosis with nintedanib, and you can block both pathways, the inflammatory and the fibrotic pathway. That's why in the recent guidelines for the treatment of patients with systemic sclerosis-associated interstitial lung disease, nintedanib was included in that in the therapeutic algorithm. However, pirfenidone was a victim of study design. I'm not going to go through that, but we had a positive therapeutic signal. However, the primary endpoint in both of these studies was negative for technical and for study design reasons. That's why in the recent PPF guidelines, nintedanib was the only treatment who was suggested who was recommended to be administered to patients with progressive fibrotic phenotype, including those with CDD ILDs. And I'm going to finish that just to point out that not all acute exacerbations are the same. Patients with connective tissue disease and with connective tissue disease, associated interstitial lung disease, they can have exacerbation of ILD. This trial has shown that in patients with IPF, cyclophosphamide, immunomodulation, and high dose of corticosteroids are detrimental for patients with IPF. But that's not the case in all of the acute exacerbations. So just let's bear that in mind. The most important thing is that these patients with connective tissue disease and ILD, they need an MDT approach. They need to be clinically evaluated every 3 to 6 months. We need to bear in mind, I didn't mention the pulmonary hypertension because of the sake of time, but we always need, especially patients with scleroderma and ACA positive antibodies, limited scleroderma. So these patients, they may develop pulmonary hypertension. That's why we need the contribution of the cardiologist. Monitor the FVC decline and DLCO decline. 6-minute walking test is a very valuable informative marker. And in the take-home messages, what we need to understand is that immunomodulation can reverse the reversible, which is inflammation, and antifibrotics stabilize the so-called irreversible. And always bear in mind the connective tissue disease, actually ILD can precede the diagnosis of connective tissue disease in about 10 to 15% of cases. And this is something that we have to bear in mind.
Next year, I promise you, we will have a special workshop.
I'm off. I'm 17
yes.
minutes.
And we will dedicate the whole morning. Yes, it is not your fault.
Okay.
Thank you so much.
20 minutes later.
Yes, yes. Rini, do we have Professor Manali online?
Καλησπέρα.
Ωραία.
Με ακούτε?
Ναι, σας ακούμε. Welcome. We have the pleasure to have with us Associate Professor Manali from the Second Department of Respiratory Medicine at Attikon University Hospital and the University of Athens, who is going to present us a very interesting topic of pediatric ILDs. So, welcome, Professor Manali, and a very kind request to be on time because we are
less than time, Frini, because you have only 10 minutes. Then you stay with us, but please, in 10 minutes.
I shall try to adapt the presentation in 10 minutes. I understand.
Yes.
In 10. In 10?
10 minutes,
okay,
yes.
so it's half the time. I shall try to do this.
It's an exercise. It's an exercise, 10 minutes that we do also.
Okay, okay, we shall do it. Yeah. We shall do it.
Yes,
so good afternoon from me too. I wish to all of you a nice month of July. And thank you very much for the presentation of a quite interesting topic in pediatrics interstitial lung diseases. Somebody could ask why an adult pulmonologist interested in adult interstitial lung disease presents such a topic. I would like to share with you that in my hospital, in the Attikon General University Hospital in Athens, as in many hospitals, I suppose, sometimes the pediatricians come to kindly ask for a consultation about very interesting cases of pediatric interstitial lung disease. And before making this presentation, I was trying to retrieve some of our cases, some of our patients. And I thought about a 19-year-old female patient with idiopathic pulmonary hemosiderosis who was diagnosed at the age of 5 years old, who had recurrent and a lot of relapses and a lot of recurrent hemoptysis. So we tried together to see what is going on. Another very young child, a 13-year-old female patient, autoimmune pulmonary alveolar proteinosis. It's an extremely rare case for children. In children, PAP is normally congenital in most of the times. It is so rare that we tried with our German colleagues to report the first 4 cases in the literature to our knowledge. And then other cases of systemic juvenile arthritis in a 4-year-old patient with finger glubbing and the interstitial lung disease pattern that you see on your screens. Some very rare syndromic forms of interstitial lung disease, a 10-month female patient that was born with hypothyroidism and developed severe respiratory failure and hypotonia. The pediatricians suspected of brain-lung thyroid syndrome, and we confirmed the diagnosis through our collaboration with the genetics department of the Trousseau Hospital in Paris. And finally, the transition from the pediatric to the adult care of children who have been diagnosed with interstitial lung disease, mostly related to mutations of the surfactant protein, and that survive to adulthood and need further care and come to us for further management. Sometimes the diagnosis is reconsidered reconsidered, and the disease is baptized again through new knowledge and new approaches. Of course, these pediatric interstitial lung diseases are very, very complex diseases, very difficult, and they need the collaboration with expert centers. Sometimes this is why with our pediatricians in Attikon Hospital, we participate in multidisciplinary teams in Paris, in France, in the Respifield network, and we discuss these cases in order to have the expert opinion for such ultra-rare diseases for the management of our patients. So what is pediatric ILDs, or more properly said, children's interstitial lung disease? Children interstitial lung disease encompasses a heterogeneous group of innate genetic, infectious and inflammatory diseases, quite different sometimes from those that we see in adulthood. What we have to make clear is that they cover an age range from infancy to late adolescence, and sometimes it's not only the interstitium that is involved in the disease, but also the parenchyma, the vessels, the epithelium, the airways, and the pleura are also involved. Child represents a very underdeveloped area of pulmonary research. You can see here the difference between the adult ILD publications and the child ILD publications. Of course, lately, this has become an area of very active research, and this seems to be changing through a lot of research, a lot of effort, and a lot of collaboration. Collaboration is very, very needed in this field. Why? Because child has a reported incidence of 1 to 4 per million of children, and the relevant experience regarding diagnosis and treatment is over very, very difficult to attain. You cannot tell that you're an expert in child since the prevalence is so low. So there is a European management platform for childhood interstitial lung diseases. It has been created by pediatricians all over Europe, as you may see, headed by Professor Matthias Griese in Munich in Germany. It is a platform allowing accurate diagnosis, allowing also patients to be included in randomized controlled trials of treatment and to translational studies of research. What does this classification include? It includes, as you may see here, 2 categories of diseases. Those that regard children less than 2 years old, the infants, and those that regard any kind of age in children, the B. It's the A and the B. The most representative, I would say the most common categories included in this classification regard as you may see here, the diseases that are related to surfactant processing and homeostasis, the mutations of surfactant, and the pulmonary alveolar proteinosis belongs to this category. Then we have the tachypnea syndromes in children, 18.5% as you may see, like the NIHI and the pulmonary interstitial glycogenesis. And finally, we have the big family of systemic diseases in children, like autoimmune rheumatic diseases like vasculopathy, sarcoidosis, histiocytosis, and so on. We have to keep in mind that the clinical presentation in child has 2 phenotypes. The one is very dramatic, very easily progressive to respiratory failure, and sometimes it leads to death. The other one is more slowly progressive, but relentless dyspnea, either at rest or with exercise intolerance in older children. The term child syndrome means that you have to start to search, you have to perform a diagnostic evaluation that is very, very tough and difficult, and then that you also have to exclude very common diseases that may present and mimic children interstitial lung disease, like cystic fibrosis, like heart disease, like immunosuppression, like primary ciliary dyskinesia, and recurrent aspiration in children. Let's keep in mind that in child, the most common symptoms, signs, is resting tachypnea and failure to thrive. And of course, we must have diffuse abnormalities on chest HRCT in order to think about child. It is very difficult in children to set a diagnosis based on CT. This is a paper, a very nice paper from the Royal Brompton, which is a very prestigious center in Europe regarding child. And you can see here experts from adult interstitial lung disease like Professor Wells and experts in children interstitial lung disease like Professor Andrew Bush, who have collaborated just to show that the inter-observer agreement in interstitial lung disease in children is very low and does not allow a safe diagnosis. So what we have to do, we have to take into consideration genetics, we have to take into consideration the results of BAL analysis, and many times we have to perform a biopsy. It's not an easy decision to make in children, but is a necessary one most of the times. And what I want to show you here is that the histology in children is quite different from histology in adults. We have desquamative interstitial pneumonia, non-specific interstitial pneumonia, and PAP patterns. I would like to say that none of the classification identified in children has identified pulmonary fibrosis like the one we know in adults. And here I want to show you the first classification that was performed with the first author, Gail Deutsch, which is a pathologist that has dedicated her life to child and has demonstrated that only 1 out of 99 children that were examined with child had signs of pulmonary fibrosis as we know it in adults. It was a child that had a mutation in surfactant protein C and had a fibrotic NSIP pattern. The same with Alexandra Rice, again from the Royal Brompton, that had shown that in 111 patients, very few, 2% in children less than 2 years, 7% in children 2 to 18 years, we have fibrotic lung disease in children. The same in the French study in which we participated, very, very few children in a very specialized center in Paris that have fibrotic lung disease. So it seems, a main message is that it seems that adult radiologic and histologic lung fibrosis patterns are not described in pediatric patients, and that UAP, the most common aspect of idiopathic PA in adults, is exceptionally or never observed in childhood. There is only 1 or 2 case reports in the literature. Here I'm showing one from Ilaria Campo in Italy, who demonstrated an interesting pedigree of ILD related to ABC alpha 3 mutations. And what did they show? A child 13 years old with such a destructive interstitial lung disease that had a UAP pattern in biopsy, and the older members of the family who had the same genotype had an NSIP pattern and a much milder disease. This is a surprise. This is an exemption. The majority of the cases in children is milder at a level of histology and of radiology. Another major question is, does the natural history of children with PF can evolve towards UAP-IPF, the one that we know in adults? The answer is probably no. The mechanisms in a lung that is growing may be different than the mechanisms to respond to a triggering factor, to a traumatizing effect than a lung that is grown up, mature, and has a lot of senescent lung tissue. The capacity for scareless repair is lost with age. And finally, maybe the activation of the extracellular matrix deposition is not so much activated in children. Of course, all this is speculation. We need a lot of research in order to prove all these theories. The outcome of pulmonary fibrosis in children is globally very poor. The majority of them, they die. Some of them are lung transplanted, but there are a lucky few that survive in adulthood and that they will need our care. In the interest of time, what I want to say is that we were very surprised to see that in most centers there is no established and consistent procedure to guarantee appropriate transfer of information and prepare the patient for transition to a new specialist and a new team from childhood to adulthood. So there is immediate action needed, and the evidence of diseases such as diabetes mellitus, bronchial asthma, and cystic fibrosis in children has clearly demonstrated that there is a need of transition programs in order to diminish morbidity and mortality. So the ERS has created a task force in which we participate in order to create the frame to prepare the transition of children with interstitial lung disease to adult care. This is a very important aspect, and we hope that with our work we will prepare adult pulmonologists to take care of the children with this very rare and dramatic, I would say, disease. So I thank you very much for your attention.
Rini, thank you so much. And as we run out of time, we will continue with you and with Boehringer Ingelheim Symposium. Σας ευχαριστώ πάρα πολύ που ήσασταν εδώ. Μείνετε μαζί μας. Θα συνεχίσουμε με 2 δορυφορικά συμπόζια με τον ξένο καλεσμένο μας, τον Σέρτζο Χαράρη, και αμέσως μετά στις 8 με το opening ceremony που θα έρθει και ο Υπουργός Υγείας, οπότε πρέπει να είμαστε πραγματικά στην ώρα μας.
7 η ώρα ξεκινάμε το δεύτερο satellite.
Ναι, εντάξει. Ναι, οπότε στις 8 είναι το opening ceremony. Ωραία. No. He's okay. I didn't say something for him. Okay. Announcement. Okay. Ευχαριστούμε πολύ την εταιρεία Boehringer Ingelheim που θα μας αφιερώσει την επόμενη μισή ώρα. Θα την κάνουμε λίγο πιο σύντομα, αφού έχουμε και την ίδια ομιλήτρια που δυστυχώς είναι διαδικτυακά. Θα μιλήσουμε για την πρώιμη διάγνωση στην ιδιοπαθή πνευμονική ίνωση. Η κυρία Μάναλη είναι αναπληρώτρια καθηγήτρια στο ΕΚΠΑ, στο Αττικό, και είναι χαρά μας να την ακούσουμε να μιλήσει για την πρώιμη διάγνωση της πνευμονικής ίνωσης. Έχει κάνει πολλή δουλειά στη γενετική. Η προηγούμενη ομιλία κατά κάποιο τρόπο συνδέεται από τα παιδιά πώς πρέπει να προχωρήσουμε και δεν θα μπορούσαμε να έχουμε καλύτερη ομιλήτρια. Φρίνη, σε παρακαλώ πάρα πολύ, αν μπορείς να το κάνεις όσο γίνεται πιο γρήγορα, γιατί είμαστε να το συμπιέσουμε.
Πολλές ασκλήσεις, αλλά θα προσπαθήσω. Απλώς σημασία έχει όλες οι ομιλίες που άκουσα μέχρι τώρα είναι τόσο όμορφες. Έχει αξία να τις χαιρόμαστε και να τις ακούμε. Αλλά τέλος πάντων, ο χρόνος τρέχει. Θέλω να σας ευχαριστήσω πάρα πολύ για την τιμητική πρόσκληση. Να ζητήσω για άλλη μια φορά συγγνώμη που δεν είμαι εκεί. Και να ευχαριστήσω και την εταιρεία Boehringer Ingelheim που μου δίνει για άλλη μια φορά τη δυνατότητα να αναφερθώ σε ένα θέμα που το θεωρώ πάρα πολύ ενδιαφέρον και πάρα πολύ σημαντικό. Την πρώιμη διάγνωση στην πνευμονική ίνωση. Όπως γνωρίζετε όλοι, η ιδιοπαθής πνευμονική ίνωση είναι η πιο καταστροφική, η πιο συχνή και η πιο απειλητική για τη ζωή από τις συνοπιές διάχυτες διάμεσες πνευμονοπάθειες, με μια φυσική ιστορία και με μια πορεία που πολλές φορές μπορεί να μην είναι δυνατό να την προβλέψουμε με ακρίβεια. Γνωρίζουμε όλοι όμως που ασχολούμαστε με το νόσημα αυτό ότι αργά ή γρήγορα θα εξελιχθεί, θα προκαλέσει σοβαρή αναπνευστική ανεπάρκεια και θα απειλήσει τη ζωή των ασθενών που πάσχουν από αυτή. Κλασικές μελέτες πολλά χρόνια πίσω είχαν δείξει ότι η ιδιοπαθής πνευμονική ίνωση ή κάθε μορφή διάχυτης διάμεσης πνευμονοπάθειας ινοποιού, όσο πιο ινοποιός είναι, τόσο χειρότερη πρόγνωση και επιβίωση έχει και όσο πιο εξελικτική είναι με βάση το λειτουργικό έλεγχο της αναπνοής, τόσο χειρότερη πρόγνωση έχει. Με βάση νομίζω όλα αυτά τα στοιχεία...
Δεν προχωράνε τα slides, μάλλον, γιατί μιλάει...
Δεν προχωράνε. Περιμένετε, θα κάνω stop share.
Ναι,
το έχουμε πει αυτό λίγο με τους τεχνικούς, με συγχωρείτε, και θα προσπαθήσω να ξαναμπω. Για να δούμε. Όχι.
Να βοηθήσουμε την κυρία Μάναλη.
Νομίζω 2 λεπτά θα τα καταφέρουμε, Κατερίνα. 1 λεπτό. Τώρα.
Ναι, τώρα είναι εντάξει.
Ωραία, τέλεια. Θαυμάσια. Αυτά λοιπόν είναι, αυτό είναι το προηγούμενο.
Πολύ, οπότε προχώρα από το σημείο, σε ακούγαμε πολύ καλά. Οπότε...
Άρα λοιπόν, στηριζόμενοι στα δεδομένα που παρουσιάσαμε πριν και στην εμπειρία μας, πάρα πολύ έχουμε αναφερθεί, νομίζω, σε αυτό το συνέδριο για αυτή τη νέα κατάταξη, για αυτή τη νέα ταξινόμηση που στην πραγματικότητα εντάσσει όλες τις συνοπιές και προοδευτικά εξελισσόμενες διάχυτες διάμεσες πνευμονοπάθειες σε μια ίδια κατηγορία που στην πραγματικότητα πρέπει να έχει την ίδια φροντίδα και πολλές φορές και την ίδια θεραπευτική αντιμετώπιση. Όταν αναφερόμαστε σε προοδευτικά εξελισσόμενες διάχυτες διάμεσες πνευμονοπάθειες, αναφερόμαστε στα νοσήματα εκείνα που είδατε πριν, ανήκουν σε διάφορες κατηγορίες, αυτοάνοσα ρευματικά, εξωγενής αλλεργική και ψελιδίτιδα, νοσήματα που σχετίζονται με φάρμακα, τα οποία παρουσιάζουν λειτουργική επιβάρυνση στον χρόνο με συγκεκριμένα κριτήρια, ακτινολογική επιβάρυνση και κλινική επιβάρυνση ή τον συνδυασμό όλων αυτών των στοιχείων. Πόσο συχνά συμβαίνει αυτό? Ακούσατε και τον Αργύριο Τζουβελέκη πριν από λίγο να σας λέει ότι ένα ποσοστό 18 με 32% στις οικογένειες αυτών των ινοποιών διάχυτων διάμεσων πνευμονοπαθειών θα παρουσιάσουν αυτό το προοδευτικό πρότυπο για το οποίο κάτι πρέπει να κάνουμε όσο το δυνατόν πιο γρήγορα. Το 2012 δημοσιεύτηκε η μελέτη του Πάνθυρα που κατέστησε σαφή την καταστροφική επίδραση της τριπλής ανοσοκατασταλτικής θεραπείας στις ινοποιές διάχυτες διάμεσες πνευμονοπάθειες, στην ιδιοπαθή πνευμονική ίνωση και το 2014 δημοσιεύτηκαν οι δύο μεγάλες μελέτες στο New England Journal of Medicine που έθεσαν στη διαθεσιμότητά μας δύο αντιεινωτικούς παράγοντες για την αντιμετώπιση αυτού του νοσήματος. Από τότε έχουν γίνει πολλές πρόοδοι, αλλά αν γυρίσουμε πάλι πίσω στο 2014 και αναζητήσουμε τα χαρακτηριστικά των ασθενών μας που συμπεριλαμβάνονται στις μελέτες αυτές, θα δούμε ότι πρόκειται για ασθενείς με ιδιοπαθή πνευμονική είνωση που έχουν μια άμεση τιμή διαχειτικής ικανότητας γύρω στο 45 με 47%. Το ίδιο στη μελέτη την Impulses, η οποία έφερε τον Nintedanib, επιβεβαίωσε την αποτελεσματικότητα του Nintedanib στην αντιμετώπιση αυτής της νόσου. Άρα, όταν διαβάζουμε αυτές τις μελέτες, πρέπει να γνωρίζουμε ότι η όποια επίδραση θετική που βλέπουμε στην επιβράδυνση της επιδείνωσης του λειτουργικού ελέγχου της αναπνοής σχετίζεται με αυτή την ομάδα, με αυτή τη βαρύτητα της πνευμονικής ίνωσης. Το ίδιο ισχύει και για τη μελέτη Sensis που σας έδειξε πριν από λίγο ο κύριος Ντουβελέκης. Οι ασθενείς με συστηματική σκλήρυνση, σκληρόδερμα και ίνωση που συμπεριλήφθησαν στη μελέτη και που φάνηκε ότι ωφελούνται από τη θεραπεία με Nintedanib έχουν μια διαχειτική ικανότητα με μια διάμεση τιμή γύρω στο 52,9%. Το ίδιο και στην μελέτη InBuild. Όλες οι ομάδες των προοδευτικά εξελισσόμενων διάχυτων διάμεσων πνευμονοπαθειών έχουν μια διαχειτική ικανότητα 45,3%. Και όπως ακούσατε χθες από τον καθηγητή, τον κύριο Wells, δεν υπάρχει πιο αντιπροσωπευτικός δείκτης που να δηλώνει τη βαρύτητα και το πόσο προοδευμένη είναι η νόσος από τη διαχειτική ικανότητα. Άρα λοιπόν αναρωτιέται κανείς τι θα συνέβαινε αν μπορούσαμε να αντιμετωπίσουμε τους ασθενείς μας με εινοποιώ διάχυτη διάμεση πνευμονοπάθεια πιο νωρίς. Για να συμβεί αυτό πρέπει να είμαστε σε θέση να τους διαγνώσουμε και πιο νωρίς, να τους διαγνώσουμε πρώιμα. Τα δεδομένα μας λένε ότι από τη στιγμή που ένας ασθενής με πνευμονική είνωση, εινοποιώ διάχυτη διάμεση πνευμονοπάθεια αναπτύσσει συμπτώματα της νόσου, μέχρι τη στιγμή που θα τεθεί η σωστή διάγνωση περνούν περίπου 2,5 χρόνια. Είναι ένα διάστημα πάρα πολύ σημαντικό για νοσήματα τα οποία έχουν μια διάμεση επιβίωση που φτάνει πολλές φορές στα 2,5 με 5 έτη. Φυσικά, κανείς δεν μπορεί να ξέρει πότε ακριβώς ξεκινάει μια διάχυτη διάμεση πνευμονοπάθεια, εκτός αν προοπτικά παρακολουθεί έναν ασθενή. Αλλά και πάλι τα 2,5 χρόνια είναι ένα μεγάλο διάστημα το οποίο οφείλουμε να βραχύνουμε. Είναι σημαντικό γιατί ένας ασθενής όσο πιο νωρίς διαγνώσκεται, τόσο πιο νωρίς μπορεί να λάβει και εξειδικευμένη φροντίδα. Έχει γίνει σαφές από τις μελέτες ότι η φροντίδα αυτών των ασθενών πρέπει να γίνεται σε εξειδικευμένα κέντρα. Γιατί? Για να τίθεται μια εξειδικευμένη και σωστή διάγνωση, για να μπορεί ο ασθενής να έχει πρόσβαση σε εξειδικευμένες θεραπείες με το σωστό τρόπο, για να αποφεύγει θεραπείες καταστροφικές που μπορεί να μην σχετίζονται με την διάγνωσή του και να τις λαμβάνει γιατί κάποιος έχει θέσει μια λανθασμένη διάγνωση και για να μπορεί να αντιμετωπίζει όλες τις συνοσυρότητες που μπορεί να επηρεάσουν την πορεία του νοσήματός του από πάρα πολύ νωρίς. Εμείς οι γιατροί λοιπόν που ασχολούμαστε με τις διάχυτες διάμεσες πνευμονοπάθειες πάρα πολλές φορές πρέπει να αντιμετωπίσουμε αυτή την πρόκληση, θα έλεγα, της καθυστερημένης διάγνωσης. Εγώ θα σας δείξω ένα περιστατικό από το ιατρείο μου, από το τακτικό ιατρείο που κάνω στο Αττικό Νοσοκομείο. Ένας κύριος 79 ετών, βλέπετε πόσο εκτεταμένη εινοποιώ διάχυτη διάμεση πνευμονοπάθεια έχει. Αυτός ο ασθενής για 6 χρόνια παρακολουθείται από πνευμονολόγο, εκτός νοσοκομείου φυσικά, πραγματοποιεί υπολογιστικές τομογραφίες θώρακος ανά έτος και λαμβάνει βροχοδιασταλτική αγωγή σαν να επρόκειτο για ένα αποφρακτικό νόσημα. Όταν η κατάσταση έφτασε σε πολύ δύσκολη φάση, ο ασθενής αυτός παραπέμφθηκε 6 χρόνια μετά από τα αρχικά ευρήματα, τα οποία ήταν απολύτως τυπικά για διάχυτη διάμεση πνευμονοπάθεια, στο εξειδικευμένο ιατρείο για να αναζητήσει με απόγνωση εξειδικευμένη βοήθεια. Αυτό είναι κάτι που συμβαίνει συχνά και πιστεύω ότι οφείλεται σε πάρα πολλούς παράγοντες. Αφενός μένουν στο γεγονός ότι ο ίδιος ο ασθενής πολλές φορές υποεκτιμά τα συμπτώματά του. Πιστεύει ότι η δύσπνοια είναι χαρακτηριστικό και στοιχείο αναμενόμενο στην ηλικία του ή ότι σχετίζεται με την καπνιστική συνήθεια που συχνά υπάρχει σε αυτούς τους ασθενείς, δεν θέλει να έρθει στο νοσοκομείο και προτιμά να έχει την παρακολούθηση όσο αντέχει, θα έλεγα εγώ, από τον δικό του γιατρό. Η δεύτερη αιτία είναι ότι πολλές φορές οι πνευμονολόγοι που παρακολουθούν αυτούς τους ασθενείς πιθανά να μην γνωρίζουν ότι ο ασθενής αυτός πάσχει από ένα εξειδικευμένο νόσημα, από ένα νόσημα που διαφέρει από την αποφρακτική πνευμονοπάθεια και το οποίο χρειάζεται εξειδικευμένη διερεύνηση και φροντίδα. Η δυσκολία που έχουν οι ασθενείς αυτοί πολλές φορές να έχουν ραντεβού στα εξειδικευμένα ιατρεία στα μεγάλα νοσοκομεία. Και εγώ θα θέσω και ένα άλλο θέμα, η συνεργασία ανάμεσα στην πρωτοβάθμια και την τεταρτοβάθμια ή τριτοβάθμια φροντίδα οφείλει στην πραγματικότητα να είναι άριστη. Εγώ το θεωρώ πάρα πολύ σημαντικό ο γιατρός που παρακολουθεί έναν ασθενή να έχει την άνεση να επικοινωνήσει με ένα εξειδικευμένο κέντρο και να γνωρίζει ότι θα συνεχίσει να παρακολουθεί τον ασθενή του με τις κατάλληλες οδηγίες, έτσι ώστε να μπορεί να παραπέμπει τον ασθενή του σε ένα κέντρο, να μαθαίνει από την εμπειρία του εξειδικευμένου κέντρου και να βελτιώνει την παροχή φροντίδας στον ασθενή αυτό. Να μην αναφερθούμε στην καταστροφή που προκάλεσε η επιδημία COVID-19, στη δυνατότητα που είχαν οι ασθενείς να προσεγγίσουν τα εξειδικευμένα κέντρα και τα μεγάλα νοσοκομεία, που όλα είχαν γίνει κέντρα αναφοράς για το COVID, είχαν κλείσει τα τακτικά τους ιατρεία και πολλές φορές λειτουργούσαν διαδικτυακά. Αυτό είναι κάτι που δεν μπορούσαμε να το αποφύγουμε δυστυχώς, αλλά που τώρα αρχίζει σιγά σιγά να υποχωρεί. Και θεωρώ ότι θα καλύψουμε τον χαμένο χρόνο. Αυτό που πρέπει να τονίσουμε είναι ότι η πρώιμη διάγνωση απαιτεί ένα μυαλό το οποίο να γνωρίζει την ύπαρξη του νοσήματος, να γνωρίζει πού να ψάξει. Όταν δει λοιπόν έναν ασθενή, ένας γιατρός, είτε αυτός είναι πνευμονολόγος, είτε γενικός γιατρός, είτε αγροτικός γιατρός, είτε καρδιολόγος, είτε παθολόγος, σε οποιοδήποτε επίπεδο φροντίδας υγείας, και τον δει να έχει βήχα, τον δει να έχει δύσπνοια χρόνια, προοδευτικά επιδεινούμενη, που δεν υποχωρεί με τις κλασικές θεραπείες, τις συνήθεις θεραπείες, και που είναι άνω των 60 ετών και καπνιστής, οφείλει να σκεφτεί ότι υπάρχει και μια άλλη κατηγορία νοσημάτων, οι προοδευτικά εξελισσόμενες συνοπίες διάχυτες διάμεσης πνευμονοπάθειας, τις οποίες πρέπει να διερευνήσει. Πώς? Η ακρόαση του πνεύμονα, το ακούσατε και πριν από τον κύριο Τζουβελέκη, η πιο ευαίσθητη, η πιο απλή εξέταση για να διαπιστώσουμε την πιθανή ύπαρξη πνευμονικής σύνοσης. Από εκεί και πέρα, η πληκτροδακτυλία, που δεν απαντά σε όλους τους ασθενείς, αλλά σε ένα πολύ σημαντικό ποσοστό, μπορεί, ειδικά όταν συνυπάρχει με τους βέλκρο, να μας κάνει να σκεφτούμε την ύπαρξη αυτού του νοσήματος, το καλό ιστορικό και η αξιολόγηση της χρονιότητας του βήχα και της δύσπνοιας, και φυσικά η απεικόνηση. Η απεικόνηση είναι πάρα πολύ εύκολο να πραγματοποιηθεί, ακόμα και αν δεν έχουμε μια υπολογιστική τομογραφία. Η ακτινογραφία θώρακος από μόνη της θέτει την υπόνοια, τη σοβαρή υπόνοια, καμιά φορά και τη διάγνωση της πνευμονικής σύνοσης. Η υπολογιστική τομογραφία θώρακος υψηλής ευκρίνειας με ειδικό πρωτόκολλο φυσικά θα επιβεβαιώσει τη διάγνωση ή θα μας απομακρύνει από αυτήν. Και από εκεί και πέρα, επειδή υπάρχουν και πάρα πολλά προγράμματα το τελευταίο διάστημα προληπτικής ιατρικής, προληπτικής προσέγγισης των ασθενών για καρκίνο του πνεύμονα ή παρακολούθησης μετά από τη λίμωξη COVID, έχουμε τη δυνατότητα να αξιολογήσουμε και ευρήματα παθολογικά στον διάμεσο ιστό, τα οποία μπορεί να είναι προάγγελοι κλινικά σημαντικής διάχυτης διάμεσης πνευμονοπάθειας, όπως είναι τα γνωστά μας I.Titopoulos. Τα I.Titopoulos, τα οποία τα έχουμε interstitial lung abnormalities, τα οποία αποκαλύπτονται πολλές φορές σε αυτούς τους ελέγχους, τους προληπτικούς, και πρέπει να ξέρουμε πώς θα τα προσεγγίσουμε και τι θα κάνουμε με αυτά. Υπάρχουν διάφορες κατηγορίες. Υπάρχουν αυτά τα οποία είναι, θα έλεγα, σε περιοχή απομακρυσμένη από την υποϊπεζοκοτική περιοχή και δεν έχουν και χαρακτηριστικά εινοποιού νόσου. Είναι άλλα τα οποία είναι υποϊπεζοκοτικά μη εινωτικά, και είναι και αυτά τα οποία είναι τα πλέον επικίνδυνα, θα έλεγα, και τα πλέον υποδηλωτικά πιθανής ανάπτυξης στο μέλλον νόσου εινοποιού, προοδευτικά εξελισσόμενης, που είναι αυτά τα οποία έχουν υποϊπεζοκοτική κατανομή και στοιχεία ίνωσης, όπως είναι η βρονχιεκτασίες εξέλιξεως, όπως είναι η κυρίθρα με περιορισμένη έκταση κτλ. Φυσικά πρέπει να γνωρίσουμε τον τρόπο με τον οποίο θα παρακολουθήσουμε έναν τέτοιον ασθενή. Συνήθως αυτά τα ευρήματα μπορεί να μην τα έχει ο πνευμονολόγος, να τα έχει ένας ογκολόγος, ένας καρδιολόγος, ένας παθολόγος. Τότε είναι πάρα πολύ σημαντικό οι γιατροί αυτοί να είναι ευαισθητοποιημένοι και να ξέρουν τον τρόπο με τον οποίο θα παραπέμψουν τον ασθενή σε ένα εξειδικευμένο πνευμονολόγο για να αξιολογήσει την κλινική εικόνα. Αν ο ασθενής με τα ευρήματα αυτά, που είναι συνήθως άνω των 60 ετών, έχει μια συμπτωματολογία, μπορεί να έχει βήχα, μπορεί να έχει δύσπνοια, μια συμπτωματολογία η οποία στο χρόνο εξελίσσεται και δεν υποχωρεί, είναι ένα βασικό χαρακτηριστικό. Αν τα ακτινολογικά πρότυπα παραπέμπουν σε εινοποιό διάχυτη διάμεση πνευμονοπάθεια, αν έχει άλλους παράγοντες κινδύνου, αν έχει εκθέσεις σημαντικές περιβαλλοντολογικές ή επαγγελματικές, αν ο ασθενής είναι καπνιστής, αν έχει θετικό οικογενειακό ιστορικό. Όλα αυτά μπορούν να μας κάνουν να σκεφτούμε ότι πρέπει να αξιολογήσουμε σοβαρά τα ευρήματα αυτά και να τα θεωρήσουμε σαν προάγγελους μιας πρώιμης εινοποιού διάχυτης διάμεσης πνευμονοπάθειας. μια πολύ ενδιαφέρουσα μελέτη που δημοσιεύτηκε στο CHEST το 2021 από ένα survey που πραγματοποιήθηκε σε πνευμονολόγους και ακτινολόγους έδειξε, εγώ εντυπωσιάστηκα από τα αποτελέσματα, οφείλω να σας πω, ότι οι περισσότεροι, ένα ποσοστό μέχρι και 90% των γιατρών αυτών είναι αρκετά ευαισθητοποιημένος στην αξιολόγηση των ευρημάτων αυτών στις υπολογιστικές τομογραφίες και στην σύσταση να παραπέμψουν τους ασθενείς αυτούς σε εξειδικευμένους πνευμονολόγους όταν βρουν αυτά τα ευρήματα. Εκτός λοιπόν από την κλινική εξέταση, την ακτινολογική εικόνα μετράει πάρα πολύ και η αναζήτηση για την πρώιμη διάγνωση εινοποιών διάμεσων πνευμονοπαθειών, σημείων ή συμπτωμάτων αυτοάνωσου ρευματικού νοσήματος, οι αρθραλγίες, το σύνδρομο Ρεϊνό, τα χέρια του μηχανικού, συγκεκριμένα εξανθήματα στο πρόσωπο, οικογενειακό ιστορικό ρευματικής νόσου, πρέπει να μας κάνουν να σκεφτούμε ότι ένας ασθενής μπορεί να είναι σε αυξημένο κίνδυνο να παρουσιάσει διάχυτη διάμεση πνευμονοπάθεια. Ακούσατε πριν από τους εξαιρετικούς συναδέλφους και τον ρευματολόγο μας και τον Αργύρη, τον Τζουβελέκη, πόσο η ρευματοειδής αρθρίτιδα και το σκληρόδερμα σχετίζονται σε σημαντικό βαθμό με την ανάπτυξη διάχυτης διάμεσης πνευμονοπάθειας. Και αν στο σκληρόδερμα υπάρχει σαφέστατη οδηγία κατά τη διάγνωση του ασθενούς να πραγματοποιείται υπολογιστική τομογραφία θώρακος, κάτι που μας διευκολύνει πάρα πολύ στην πρώιμη διάγνωση της νόσου, δεν ισχύει το ίδιο στη ρευματοειδή αρθρίτιδα. Εκεί, και με τις μελέτες που έχουμε κάνει τα τελευταία χρόνια με τους ρευματολόγους μας, βλέπουμε πολλές φορές ότι υπολείπεται η διερεύνηση προς αυτή την κατεύθυνση. Τα άτομα με ρευματοειδή αρθρίτιδα κανονικά πρέπει να υποβάλλονται και σε απεικονιστικό και σε κλινικό έλεγχο με ακρόαση του πνεύμονα, όπως είπαμε και πριν, με ένα καλό ιστορικό για τα συμπτώματα από το αναπνευστικό, για να διαπιστώσουμε έγκαιρα την διάχυτη διάμεση πνευμονοπάθεια που μπορεί να αναπτύσσεται στα πλαίσια ρευματοειδούς αρθρίτιδας. Είδατε και πριν, και σας δείχνω κι εγώ για άλλη μια φορά, ένα προγνωστικό σκορ που αναπτύχθηκε από την ομάδα του καθηγητή του Φιλίπ Μπιοντέ στο Παρίσι, που λαμβάνει υπόψη, όπως είπαμε, την ηλικία, λαμβάνει τα σκορ της ενεργότητας της νόσου, αλλά και γενετικές παραμέτρους για να προβλέψει ποια άτομα κινδυνεύουν σημαντικά από την ανάπτυξη πνευμονικής σύνοσης στα πλαίσια ρευματοειδούς αρθρίτιδας. Όταν παίρνουμε ένα ιστορικό, είναι πάρα πολύ σημαντικό να διερευνούμε όλες τις παραμέτρους που μπορεί να ενοχοποιηθούν για την ανάπτυξη διάχυτης διάμεσης πνευμονοπάθειας. Φάρμακα και τοξική, περιβαλλοντολογική και επαγγελματική παράγοντες. Πολλές φορές είναι πάρα πολύ δύσκολο και χρειάζεται πάρα πολλές ερωτήσεις ξανά και ξανά. Πρέπει με πολύ απλό τρόπο και πολλές φορές με μεγάλη φαντασία να κάνουμε τον ασθενή να καταλάβει και να μας αποκαλύψει πολλές φορές αν πραγματικά λαμβάνει κάποιο φάρμακο ή αν έχει οποιαδήποτε έκθεση που μπορεί να συσχετίζεται με την ανάπτυξη διάχυτης διάμεσης πνευμονοπάθειας, και τότε, αν υπάρχει ένα τέτοιο ιστορικό και ο ασθενής έχει συμπτώματα ή ακροαστικά ευρήματα, να προχωρήσουμε στη διερεύνηση για την πρώιμη διάγνωση της νόσου. Και φυσικά το είπαμε.
Μπορούμε να ολοκληρώνουμε, σε παρακαλώ πολύ.
Πόσος χρόνος έχει περάσει, νομίζω 1 τέταρτο.
Ναι, 2 λεπτά έχουμε.
1 τέταρτο. Ναι. Ωραία, επειδή είπατε μισή ώρα.
Ναι.
Πολύ ωραία. Θα προχωρήσω όσο μπορώ.
Δεν είπαμε μισή ώρα.
Λοιπόν, 1 λεπτό, γιατί πρέπει και να συγκεντρωθώ κιόλας, αλλά μιλήσαμε για τις οικογενείς μορφές της νόσου. Λοιπόν, θα σας δείξω κάποια παραδείγματα αντί να λέω λόγια. Ας προχωρήσω λοιπόν. Να σας δείξω παραδείγματα από το τακτικό ιατρείο, στο οποίο βλέπουμε συχνά ασθενείς που έχουν θετικό οικογενειακό ιστορικό. Βλέπετε εδώ λοιπόν μια γυναίκα 61 ετών, 40 πακέτα έτη, τελείως ασυμπτωματική, που ήρθε σε εμάς για να διερευνηθεί γιατί στην οικογένειά της έχει 4 συγγενείς με ιδιοπαθή πνευμονική είνωση. Και εδώ βλέπετε κάποια αρχόμενα στοιχεία. Ο λειτουργικός έλεγχος, 77% διαχειτική ικανότητα. Ένας άλλος άντρας 60 ετών, 10 πακέτα έτη, τελείως ασυμπτωματικός, χωρίς δύσπνοια. Βλέπετε εδώ διαχειτική ικανότητα 72% και αυτά τα ευρήματα. Τελείως ασυμπτωματικός, μόνο και μόνο με θετικό οικογενειακό ιστορικό. Και τέλος, άντρας 56 ετών, μη καπνιστής, ασυμπτωματικός, ο οποίος έχει μια διαχειτική ικανότητα 91,7%. Εδώ είναι και φορέας ενός γονιδίου που σχετίζεται με την τελομεράση, άρα έχει αυξημένο κίνδυνο. Μπορούμε να θεραπεύσουμε τους ασθενείς που έχουν πρώιμη νόσο. Δεν υπάρχουν δεδομένα. Υπάρχουν κάποιες ελάχιστες αναλύσεις στις μεγάλες μελέτες που έγιναν για την Τεντανίμπη αλλά και για την πυρφενιδόνη, που επιβεβαιώνουν ότι το όφελος μπορεί να είναι το ίδιο και στους ασθενείς που έχουν έναν καλό λειτουργικό έλεγχο της αναπνοής. Εν τούτης, είναι σαφές ότι υπάρχει τεράστια ανάγκη για μελέτες προς αυτή την κατεύθυνση. Θεωρούμε, υποψιαζόμαστε ότι η πρώιμη διάγνωση και η πρώιμη έναρξη θεραπείας θεραπείας θα έχουν πολύ θετικά αποτελέσματα στους αρρώστους μας, αλλά αυτό μένει να το αποδείξουμε και με καλά σχεδιασμένες προοπτικές και πολυκεντρικές μελέτες. Σας ευχαριστώ πάρα πολύ.
Ευχαριστούμε πολύ την εταιρεία Boehringer Ingelheim και τη Φρίνη. Να πούμε ότι το Nintedanib έχει έγκριση όχι μόνο στην ιδιοπαθή πνευμονική ίνωση, αλλά και στις προοδευτικές διάμεσες πνευμονοπάθειες. Οπότε έχουμε μία επιλογή θεραπευτική αυτή τη στιγμή στις συνοτικές διάμεσες πνευμονοπάθειες. Παραδίδω το βήμα στον καθηγητή και στον κύριο Τζουβελέκη για το δορυφορικό συμπόζιο της Μεναρίνη.
Με τη σειρά μας ευχαριστούμε την εταιρεία Μεναρίνη, η οποία μας παραχώρησε αυτή την χορηγία του δορυφορικού, την οποία τη δουλειά που έχει κάνει ο Αργύρης Τζουβελέκης με το μαγικό του τρόπο.
Είμαστε πάρα πολύ σύντομοι, ναι. Μια ομιλία μισής ώρας σε 10 λεπτά.
Θα μετατρέψει την ομιλία του από μισή ώρα σε 20 λεπτά.
20.
18.
18.
Countdown, 17, προχώρα.
Λοιπόν, βάζω και χρονόμετρο για να μην κλέψετε. Λοιπόν, ευχαριστώ και εγώ την Οργανωτική Επιτροπή, την εταιρεία Μεναρίνη. Θα μιλήσουμε για τριπλή θεραπεία στη χρόνια αποφρακτική πνευμονοπάθεια. Προχωράμε αυτά. Όλοι ξέρετε ότι η χρόνια αποφρακτική πνευμονοπάθεια τρίτη αιτία θανάτου σε ολόκληρο τον κόσμο. Η κύρια αιτία, η πιο κοστοβόρος αιτία είναι οι παροξύνσεις της νόσου. Αυτά είναι από τις τελευταίες κατευθυντήρες οδηγίες της Gold, όπου οι θάνατοι έχουν ανέλθει 5,5 εκατομμύρια σε ολόκληρο τον κόσμο και πολλοί μιλάμε για κορονοϊό. Έχουμε 6,5 εκατομμύρια θανάτους από τον κορονοϊό, περίπου 2,5 εκατομμύρια κάθε χρόνο από τον κορονοϊό, όμως έχουμε 8 εκατομμύρια από το κάπνισμα. Ίσως θα έπρεπε να επικεντρώσουμε περισσότερο στο πραγματικό πρόβλημα του δημόσιου συστήματος υγείας. Η επίπτωση της νόσου είναι περίπου 8,5%, αλλά ενδεχομένως να είναι πολύ μεγαλύτερη, γιατί πλέον στις νέες κατευθυντήριες οδηγίες έχουν μπει και νεότεροι ορισμοί οι οποίοι μιλάνε για πρώιμη χρόνια αποφρακτική πνευμονοπάθεια, για pre-COPD, παλιά Gold 0 ή μέρος αυτής, η οποία ουσιαστικά πρόκειται για ασθενείς οι οποίοι έχουν συμπτώματα, είναι καπνιστές, αλλά δεν έχουν airflow limitation. Και τι χρησιμοποιούμε εμείς ως πνευμονολόγοι για την εκτίμηση της βαρύτητας? Χρησιμοποιούμε ουσιαστικά αυτό εδώ πέρα τον αλγόριθμο, ο οποίος από την σπυρομέτρηση επεκτάθηκε και στα συμπτώματα, επεκτάθηκε και στις παροξύνσεις. Όμως πέρα από τις παροξύνσεις υπάρχουν και οι συνοσυρώτες. Είναι ένα τεράστιο κομμάτι το οποίο θα πρέπει να το προσεγγίζουμε ολιστικά. Και γιατί μιλάμε για παροξύνσεις? Γιατί οι παροξύνσεις είναι κάτι πάρα πολύ σημαντικό στην πορεία της νόσου του χρόνιου αποφρακτικού. Όπως βλέπετε τις μελέτες αυτές, μετά από μια παρόξη μπορεί ο FEV1 μάλλον να μην επιστρέψει ποτέ στα φυσιολογικά του επίπεδα. Επίσης έχουν αρνητική επίπτωση στην ποιότητα ζωής των ασθενών, αυξάνουν φυσικά την θνητότητα και μάλιστα όχι μόνο οι σοβαρές παροξύνσεις εκείνες οι οποίες οδηγούν στο νοσοκομείο, αλλά και μια μέτρια παρόξυνση όπου ο ασθενής θα χρειαστεί να πάρει από το στόμα του κορτικοστεροειδή ή μια αντιβίωση π.χ. αζυθρομικίνη και δυστυχώς περίπου το 80% αυτών από μελέτη που έχει γίνει στο Ηνωμένο Βασίλειο έχει φανεί ότι δεν αναφέρονται καν στους θεράποντες ιατρούς. Άρα είναι κάτι το οποίο θα πρέπει να μας απασχολήσει. Και επίσης οι ασθενείς με συνοσυρότητες, υπάρχει ένας φαύλος κύκλος μεταξύ συνοσυροτήτων και παροξύνσεων που δείχνουν ότι οι ασθενείς με συνοσυρότητες και κυρίως οι ασθενείς που έχουν καρδιαγγειακά νοσήματα, και ξέρουμε ότι οι ασθενείς με χρόνια αποφρακτική πνευμονοπάθεια έρχονται με το πακέτο αυτών των συνοσυροτήτων, κάνουν πιο συχνά παροξύνσεις. Ποια είναι η βασική στόχη της θεραπείας, φαρμακευτικής θεραπείας της ΧΑΠ? Είναι η αποτροπή των παροξύνσεων, η βελτίωση των συμπτωμάτων και φυσικά της ποιότητας ζωής, και μετέπειτα είναι η βελτίωση της σπυρομέτρησης, γιατί όπως γνωρίζουμε δεν υπάρχει γραμμική συσχέτιση της σπυρομέτρησης με τα συμπτώματα αλλά και τις παροξύνσεις. Και εδώ ένας μεγάλος νευροχειρουργός, είχε πει ο Τζέι Πότσεν, είχε πει ότι ο μόνος λόγος για να φτιάξουμε κατευθυντήριες οδηγίες, για να φτιάξουμε συστάσεις, είναι να αποφύγουμε τη σύγχυση. Δυστυχώς εμείς το καταφέρουμε αυτό με την Gold. Όπως βλέπετε εδώ πέρα ότι είναι ένας λαβύρινθος, ο οποίος ουσιαστικά μιλάει αν ο ασθενής ξεκινάς με ένα οποιοδήποτε βροχοδιασταλτικό, αν ο ασθενής έχει πλέον συμπτώματα προσθέτεις δεύτερο βροχοδιασταλτικό, π.χ. λάμα-λάμπα, και αν ο ασθενής κάνει πιο συχνές παροξύσεις προσθέτεις και ICS. Η αλήθεια είναι ότι αυτό το οποίο εφαρμόζουμε, και αν το θέλουμε να το απλοποιήσουμε και εφαρμόζουμε στην κλινική πράξη, είναι ότι όλοι οι ασθενείς με χρόνια αποφρακτική πνευμονοπάθεια, βάσει μελετών που θα σας δείξω συνέχεια, πρέπει να ξεκινάνε με λάμα, ειδικά στα πρώιμα στάδια της νόσου, ή ενδεχομένως κάποιοι λένε με λάμα-λάμπα, και στη συνέχεια ένα ποσοστό αυτών θα χρειαστεί και σπινόμενα κορτικοστεροειδή. Αυτό εδώ πέρα το αναφέρω γιατί είναι ένα πολύ ωραίο editorial του Φερνάντο Μαρτίνες που λέει ότι ίσως θα πρέπει σε ασθενείς με χρόνια αποφρακτική πνευμονοπάθεια να χορηγήσουμε διπλή βροχοδιασταλτική αγωγή από τα πρώιμα στάδια της νόσου. Και υπάρχει και μελέτη στο New England Journal of Medicine από Κινέζους με editorial του Κατσόλα που δείχνει δείχνει ότι οι ασθενείς οι οποίοι είναι Group A και στάδιο 1 κατά Gold κερδίζουν πολύ περισσότερο στον FEV1 εάν ξεκινήσουν λάμα-λάμπα από το group αυτό. Από εκεί και πέρα οι μελέτες έχουν δείξει ότι η λάμα-λάμπα και κυρίως η FLAME μελέτη έχει δείξει ότι η λάμα-λάμπα είναι ανώτερη του συνδυασμού λάμπα-ACS σε όλους τους ασθενείς. Η αλήθεια είναι πως η FLAME έδειξε ότι ναι μεν είναι ανώτερη στην αποτροπή των παροξύσεων, όμως όχι τόσο σε εκείνους οι οποίοι είναι πολύ συχνοί παροξυντές και οι οποίοι έχουν υψηλό αριθμό ιωσινοφύλων πάνω από 300, όχι τα 100 με 300 που χρησιμοποιεί και η Gold στις κατευθυντήριες οδηγίες, οπότε πρέπει να είμαστε προσεκτικοί. Επίσης, έδειξε από αυτήν εδώ την μεταανάλυση στην οποία συμμετείχε και ο κύριος Κωστίκας, δημοσιευμένη πριν από 4 χρόνια, όπου βλέπετε ότι όλες οι παροξύσεις δεν είναι το ίδιο. Φαίνεται λοιπόν ότι ο συνδυασμός λάμα-λάμπα είναι ευεργετικός για την αποτροπή των παροξύσεων σε ασθενείς οι οποίοι κάνουν παροξύσεις οι οποίες εξαρτώνται από τα αντιβιωτικά, περισσότερο λιμώδεις παροξύσεις και όχι παροξύσεις οι οποίες εξαρτώνται από τα περός κορτικοειδή, όπως βλέπετε εδώ πέρα από την Cox Regression Analysis. Πιο λάμα-λάμπα υπάρχουν πάρα πολλοί συνδυασμοί. Ουσιαστικά αυτό το οποίο ο βασικός παίχτης που λέει και ο κύριος Tzanakis είναι το τιοτρόπιο, όλοι το γνωρίσαμε από αρκετές μεγάλες μελέτες και από τη μελέτη Uplift, όπου ουσιαστικά η προσθήκη του τιοτροπίου έδειξε όχι μόνο βελτίωση στην σπυρομέτρηση, αλλά και βελτίωση στις παροξύνσεις, σε ανοιχτή τριπλή θεραπεία και επίσης σημαντική μελέτη η οποία έδειξε οριακή, αν και δεν ήταν στατιστικά σημαντική, βελτίωση της θνητότητας. Όμως υπάρχει και ένα συνδυασμός με κλειδίνιο βιλαντερόλη που είναι ο μοναδικός αυτή τη στιγμή που, αν και σε αυτή τη μικρή μελέτη, έδειξε τουλάχιστον, ήταν non-inferiority μελέτη, έδειξε τουλάχιστον ότι μπορεί να είναι ο συνδυασμός αυτός καλύτερος αναφορικά με την βελτίωση της αναπνευστικής λειτουργίας από το τιοτρόπιο και την ολαντατερόλη σε ασθενείς με χρόνια αποφρακτή πνευμονοπάθεια. Και γιατί συμβαίνει αυτό? Γιατί πρόκειται για δύο καινούργια μόρια, όπως είναι το ουμεκλειδίνιο, που είναι ουσιαστικά ένας ούλτρα λάμα, ο οποίος έχει πολύ υψηλή συγγένεια δέσμευσης, κυρίως με τους M3 υποδοχής που βρίσκονται στις λίες μυϊκές, είναι στον βρόχο και καθορίζουν το χολυνεργικό τόνο των βρόχων και έχει μια καθυστερημένη αποδέσμευση, τους δεσμεύει για μεγάλο χρονικό διάστημα και δεν δεσμεύει τους M2 υποδοχής, όπου φαίνεται ότι η δέσμευση αυτών των υποδοχέων, επειδή επεμβαίνει στην ακετιλοχολίνη, στο μονοπάτι της ακετιλοχολίνης, φαίνεται ότι προκαλεί επιπλέον βροχόσπασμο η δέσμευσή τους. Και υπάρχει και η βιλαντερόλη, με την οποία το μεκλειδίνιο συνδυάζεται αρμονικά, η οποία βιλαντερόλη είναι ένας ούλτρα λάμπα, όπου έχει συνεχόμενη δράση για 24 ώρες και το κυριότερο όλων, ειδικά σε αυτούς τους ασθενείς που, όπως ανέφερα και προηγουμένως και θα σας δείξω, συνοδεύονται από πολλά καρδιαγγειακά νοσήματα, φαίνεται ότι δεσμεύει εκλεκτικά τους Β2 υποδοχής και όχι τους Β1, με αποτέλεσμα να έχουμε λιγότερες παροξύσεις, κυρίως σε ασθενείς που έχουν κολπική μαρμαριγή, έχουν στεφανιαία νόσο, έχουν καρδιαγγειακά συμβάματα. Τι προκάλεσε όμως την ανάγκη για να έχουμε τριπλή θεραπεία στην καθημερινότητά μας και μάλιστα κλειστή τριπλή θεραπεία? Ουσιαστικά αυτό το οποίο φάνηκε και από προηγούμενες μελέτες, αυτό το εφαρμόζαμε στην καθημερινή κλινική πράξη. Δυστυχώς το εφαρμόζαμε με λάθος τρόπο, όπως βλέπετε εδώ πέρα στο Ηνωμένο Βασίλειο, κυρίως γενικοί γιατροί, όπου χορηγούσαν τριπλές θεραπείες σε ένα ποσοστό 19% σε ασθενείς που ήταν Gold A, σε ένα 28% σε ασθενείς που ήταν Gold B, το οποίο ήταν παντελώς λάθος. Αυτό το οποίο θα πρέπει να κάνουμε είναι να το χορηγήσουμε με βάση evidence-based ιατρική. Και αυτό το οποίο μας έδειξε η μελέτη FLAME είναι ότι υπάρχει ένα ποσοστό ασθενών περίπου 20 με 30%, ενδεχομένως στην κλινική πράξη να κυμαίνεται γύρω στο 20%, που παρά τη διπλή βροχοδιασταλτική αγωγή, τη maximum δηλαδή βροχοδιαστολή, συνεχίζουν να έχουν συμπτώματα και συνεχίζουν να κάνουν παροξύνσεις. Άρα αναγνωρίσαμε την ανάγκη. Και τρέξαν αρκετές μελέτες, πολύ σοβαρές μελέτες. Ουσιαστικά η πρώτη όμως μεγάλη μελέτη που πραγματικά συμπεριέλαβε ασθενείς Group D με 2 παραπάνω σοβαρές παροξύσεις, με FEV1 κάτω από 50%, 10.000 ασθενείς, ήταν η μελέτη Impact. Ακολούθησε και η μελέτη Ethos που βγαίνει τώρα, αλλά η πρώτη μεγάλη μελέτη ήταν η μελέτη Impact. Και η μελέτη Impact, δεν θα προχωρήσω στην, ουσιαστικά σύγκρινε την τριπλή θεραπεία με τους διπλούς συνδυασμούς λάμα-λάμπα ή λάμπα-ICS σε ασθενείς οι οποίοι είχαν FEV1 κάτω από 50%, πάνω από μία μέτρια παρόξηση ή πάνω από μία μέτρια παρόξηση ή μία σοβαρή παρόξυνση η οποία οδηγούσε στο νοσοκομείο με FEV1 κάτω από 50% και τι έκανε ουσιαστικά στην ίδια συσκευή βάλανε την φουροϊκή φλουτικαζόνη, η οποία έχει υψηλότερη συγγένεια δέσμευση με τους γλυκοκορτικοειδικούς υποδοχής και ξέρουμε ότι υπάρχει και ένα positive feedback loop μεταξύ των γλυκοκορτικοειδικών υποδοχείων αλλά και των Β2 υποδοχείων, δηλαδή τα κορτικοστεροειδή αυξάνουν τα επίπεδα των γλυκοκορτικοειδικών υποδοχείων και επίσης τα γλυκοκορτικοειδή αυξάνουν τα επίπεδα των Β2 υποδοχείων, άρα εμφανίζουν μια συνεργική δράση. Όπως ακριβώς αποδείχθηκε και στην κλινική πράξη, όπου στη μεγάλη αυτή μελέτη φάνηκε ότι υπήρχε βελτίωση στη σπυρομετρική λειτουργία, βελτίωση του FEV1 κατά 54 ml. Μπορεί κάποιος να πει ότι αυτό δεν είναι κλινικά σημαντικό γιατί είναι κάτω από τα 100 ml, όπως ορίζουμε το MCID, όμως συγκριτικά με άλλες μεγάλες μελέτες ήταν πολύ μεγαλύτερη η βελτίωση της σπυρομέτρησης, βελτίωση στην ποιότητα ζωής, με 41% πιθανότητα για κλινικά σημαντική βελτίωση της ποιότητας ζωής, όπως αυτή ορίζεται από το St. George's Research Questionnaire, με μείωση κατά 4 βαθμούς στη βαθμονόμησή του, και το σημαντικότερο όλο, το πρωτογενές καταληκτικό σημείο, ήταν θετικό, με 25% μείωση των παροξύνσεων στους ασθενείς οι οποίοι πραγματικά είχαν ανάγκη το φάρμακο. Και όχι μόνο αυτό, αλλά μείωση κατά 34% των σοβαρών παροξύνσεων, εκείνων δηλαδή των παροξύνσεων που οδηγούν τον ασθενή στο νοσοκομείο και μάλιστα με μία μόνο άπαξ ημερησίως θεραπεία. Πολύ μεγαλύτερο το ποσοστό από ανάλογες εγκριτικές μελέτες ανταγωνιστικών εταιριών και επίσης θα πρέπει, και σημαντικό και αυτό, ότι 21% βελτίωση των παροξύνσεων, των μέτριων παροξύνσεων, που όπως έδειξα και σε προηγούμενο slide, αρκεί μια μέτρια παρόξυνση για να οδηγήσει, για να αυξήσει την θνητότητα σε αυτούς τους ασθενείς. Βέβαια, οι υποαναλύσεις της μελέτης Impact μας έδωσαν πάρα πολλά σημαντικά θεραπευτικά σινιάλα. Και όπως βλέπετε εδώ πέρα, ότι φάνηκε ότι ο τριπλός συνδυασμός είχε κυρίως βελτίωση σε αυτούς τους ασθενείς οι οποίοι ήταν former smokers και όχι current smokers. Λοιπόν, όπως βλέπετε εδώ από τις καμπύλες. Αυτό οδήγησε ουσιαστικά στην Gold, η οποία θέσπισε το 2022 στις συστάσεις, έβαλε την τριπλή θεραπεία. Ποιοι ασθενείς πρέπει να λαμβάνουν τριπλή θεραπεία? Αυτοί που έχουν ιστορικό παροξύνσεων που οδηγούνται στο νοσοκομείο ή πάνω από δύο μέτριες παροξύνσεις, δηλαδή εκείνες οι οποίες χρειάζονται αντιβιωτική ή από του στόματος κορτικοστεροειδή, και έβαλε στο παιχνίδι και τα ιοσινόφυλλα στο αίμα πάνω από 300. Ουσιαστικά υπάρχει μία γκρίζα ζώνη με τα ιοσινόφυλλα 100-300. Δεν υπάρχει χρόνος αυτή τη στιγμή να το αναλύσουμε. Το ίδιο τονίζουν και οι ATS κατευθυντήριες οδηγίες. Αυτό είναι αρκετά busy slide. Απλά να σας τονίσω ότι και οι κατευθυντήριες οδηγίες ATS έχουν ακριβώς την ίδια προσέγγιση. Και οι κατευθυντήριες οδηγίες της ΝΙΣ ουσιαστικά σου λένε ότι αν ένας ασθενής συνεχίζει να έχει συμπτώματα και κάνει παροξύνσεις παρά τη μέγιστη βροχοδιαστολή, give it a trial, κάνε ένα trial με 3 μήνες trial με τριπλό συνδυασμό και εν συνεχεία, εάν ο ασθενής βελτιώνεται, το κρατάς. Εάν ο ασθενής δεν έχει βελτίωση, τότε επανααξιολογείς. Σημαντικό αυτό το οποίο έχει μπει στη φαρέτρα μας και γίνεται μεγάλος ντόρος είναι εάν η τριπλή θεραπεία βελτιώνει τη θνητότητα. Πάρα πολλές αναλύσεις, μετανάλυση εδώ από τον κύριο Κωστίκα, που ουσιαστικά από όλες τις μελέτες, και από την Impact και από την Ethos, αλλά και από τις προηγούμενες μελέτες με τον ανοιχτό τριπλό και από την Torch, αυτό το οποίο κρατάμε σαν συμπέρασμα είναι ότι μπορεί να φαίνεται ότι, ειδικά στην μελέτη Impact, ότι είχαμε μια βελτίωση της θνητότητας η οποία έφτανε το 28%, αν και η πρώτη μελέτη έδειξε ότι βελτίωνε τη θνητότητα 42%. Όμως θα πρέπει να ξέρουμε ότι οι μελέτες θνητότητας χρειάζονται πολύ περισσότερο χρόνο, στατιστικά δηλαδή, πολύ περισσότερα events, όχι μέσα σε ένα χρόνο να δούμε βελτίωση της θνητότητας από ένα φάρμακο, και φυσικά πρέπει να γίνει σωστό adjustment για συμπαρομαρτούντα νοσήματα ή άλλους παράγοντες που επηρεάζουν την θνητότητα. Ερώτηση: εάν η τριπλή θεραπεία που ενδεχομένως έχουμε στην καθημερινή πράξη επηρεάζει τις συνοσυρότητες των ασθενών? Και όπως ανέφερα και προηγουμένως, μια από τις κυριότερες συνοσυρότητες που έχουν οι ασθενείς με χρόνια αποφρακτική πνευμονοπάθεια είναι οι καρδιαγγειακές συνοσυρότητες. Και υπάρχουν μελέτες που δείχνουν, όπως η τελευταία αυτή μελέτη δημοσιευμένη στο Scientific Report στην Κορέα, real life evidence, που δείχνει ότι οι ασθενείς που βρίσκονται υπό τριπλή θεραπεία με χρόνια αποφρακτική πνευμονοπάθεια έχουν 32% λιγότερο κίνδυνο καρδιαγγειακών συμβαμάτων. θυμάτων, ενώ και άλλες αναλύσεις, όπως αυτή του Jürgen Westbos στο ERJ το 2018, που δείχνει ότι έχουμε μείωση της θνητότητας από μη αναπνευστικά αίτια, κάτι το οποίο έδειξε και η μελέτη Ethos μετά από την τριπλή θεραπεία. Το ίδιο ακριβώς, πάρα πολύ καλό προφίλ ασφάλειας στους ασθενείς με καρδιαγγειακά συμβάματα έδειξε και η μελέτη Impact. Τι γίνεται αν αφαιρέσω το κορτικοστεροειδές? Το αφαιρώ έτσι απλά το κορτικοστεροειδές? Η αλήθεια είναι πως η μελέτη Wisdom μας έδειξε ότι δεν υπάρχει διαφορά στη θνητότητα εάν αφαιρέσω το εισπνεώμενο κορτικοστεροειδές από αυτούς τους ασθενείς. Όμως όταν έγινε μεταανάλυση, η μεταανάλυση έδειξε πολύ καλά ότι εάν αφαιρέσω το εισπνεώμενο κορτικοστεροειδές από ασθενείς οι οποίοι είναι συχνοί παροξυντές και έχουν υψηλό αριθμό ιοσινοφύλων, τότε αυτοί οι ασθενείς έχουν υψηλότερη πιθανότητα να κάνουν παροξύνσεις. Και μην ξεχνάμε ότι όλες οι μελέτες έδειξαν ότι η απότομη απόσυρση των εισπνεωμένων κορτικοστεροειδών από αυτούς τους ασθενείς και έχει επίδραση στον FEV1, αλλά και επίδραση στην ποιότητα ζωής. Ενώ στη μελέτη Wisdom βλέπετε στο κάτω διάγραμμα ότι αν μειώσω τα κορτικοστεροειδή, ουσιαστικά δεν έχω κάποιο effect στην σπυρομέτρηση, δηλαδή αν από τα 500 μικρογραμμάρια προπιονικής φλουτικαζόνης πάω στα 250, κάτι το οποίο αντιστοιχεί με τα 100 μικρογραμμάρια φουροϊκής φλουτικαζόνης, ουσιαστικά δεν έχω επίδραση στον FEV1. Όμως, εάν τα διακόψω απότομα, βλέπετε ότι επηρεάζεται σημαντικά η σπυρομέτρηση, η οποία συνδέεται και με τα συμπτώματα. Άρα, αυτό το οποίο θα πρέπει να κρατήσουμε είναι ότι πρέπει να σκεφτούμε σε ποιον ασθενή θα βάλουμε εισπνεώμενα κορτικοστεροειδή, γιατί είναι πολύ πιο εύκολο να το ξεκινήσουμε, πολύ πιο δύσκολο να το σταματήσουμε. Μεγάλος δώρος αν τα εισπνεώμενα κορτικοστεροειδή προδιαθέτουν σε πνευμονίες. Αυτό το οποίο θα πρέπει να συγκρατήσουμε είναι αμφιλεγόμενα τα αποτελέσματα, αλλά κυρίως θα πρέπει να συγκρατήσουμε ότι σε πολλές από αυτές τις μελέτες δεν έγινε κανένα adjustment ούτε για vaccination, αλλά ούτε και για το κάπνισμα, που είναι δύο βασικοί παράγοντες ανεξάρτητοι για πρόκληση πνευμονιών. Και ας συγκρατήσουμε αυτό το ποσοστό, ότι ουσιαστικά με τον τριπλό συνδυασμό κερδίζουμε μία παρόξη για κάθε 4 ασθενείς, ενώ χάνουμε έναν ασθενή για κάθε 33. Ουσιαστικά έχουμε μία στις 33 περιπτώσεις να έχουμε πνευμονία. Τελειώνω με την σημασία της συσκευής, άπαξ ημερησίως. Σημαντικό το γεγονός ότι άπαξ ημερησίως είναι, όπως θα δείξω και συνέχεια από τη μελέτη Intrepid, μειώνει τα critical errors που κάνουν αυτοί οι ασθενείς και πιστέψτε με, από αυτό το review στο Respiratory Research βλέπετε ότι περίπου το 85% των ασθενών που είχαν χρόνια αποφρακτικά νοσήματα έκανε τουλάχιστον ένα critical error, το οποίο έπαιζε ρόλο στη βιοδιαθεσιμότητα του φαρμάκου, άρα και στον έλεγχο της νόσου. Και το τονίζει αυτό και η Gold. Και η συσκευή Ellipta ουσιαστικά έδειξε superiority στο compliance, ουσιαστικά στη συμμόρφωση του ασθενούς με την άπαξ ημερησίως χορήγηση, συγκριτικά με πάρα πολλές άλλες συσκευές, και αυτό ερμηνεύτηκε και κλινικά με real world δεδομένα, όπως έδειξε η μελέτη Intrepid, όπου όσο πιο compliant είναι ο ασθενής, τόσο καλύτερα παίρνει το φάρμακό του, άρα τόσο μεγαλύτερο κέρδος έχει στον FEV1. Και αυτό είναι κάτι πάρα πολύ σημαντικό, γιατί δοκιμάζουμε πάρα πολλές μοντέρνες θεραπείες, αλλά δεν αφιερώνουμε χρόνο στον ασθενή μας να του διδάξουμε την συσκευή, και ο ασθενής ο οποίος έχει μια φιλική προς αυτόν συσκευή και το παίρνει το φάρμακο άπαξ ημερησίως, έχει πολύ καλύτερη συμμόρφωση στην αγωγή, και είναι αυτό που λένε και οι Αμερικάνοι, το adherence είναι ένα low hanging fruit. Τελευταίο slide είναι αυτό το οποίο τα μαθήματα που πήραμε από την Impact ήταν ουσιαστικά ότι η τριπλή θεραπεία βελτιώνει τις παροξύνσεις, βελτιώνει την ποιότητα ζωής, βελτιώνει τη σπυρομέτρηση, όμως θα πρέπει να το δώσουμε στους κατάλληλους ασθενείς. Και τι μας λέει αυτό το διάγραμμα? Όλοι οι ασθενείς με ιοσινόφυλλα πάνω από 300, συνεχή συμπτώματα, αλλά και παροξύνσεις παρά τη μέγιστη βροχοδιαστολή, πρέπει να λαμβάνουν τριπλή αγωγή. Οι παροξύνσεις όμως δεν είναι όλες ίδιες. Η μελέτη Impact έδειξε ότι στους current smokers, αλλά και στους αυτούς οι οποίοι κάνουν παροξύνσεις που είναι περισσότερο λιμώδεις, antibiotic dependent, ίσως αυτοί να μην έχουν όφελος από την προσθήκη σπινωμένου κορτικοστεροειδούς. Δεν προσθέτουμε σπινωμένα κορτικοστεροειδή στη μέγιστη βροχοδιαστολή αν έχουμε έναν ασθενή που κάνει συχνές λοιμώξεις του αναπνευστικού, πνευμονίες, έχει βροχεκτασίες και ιοσινόφυλλα κάτω από 100. Γκρίζα ζώνη τα ιοσινόφυλλα 100-299, και φαίνεται ότι τα ICS έχουν ένα impact και στα καρδιαγγειακά νοσήματα. Ευχαριστώ πολύ.
Λοιπόν, μόνο να συνοψίσει τα πράγματα τόσο γρήγορα και να το προχωρήσει
17 λεπτά.
την ομιλία του τόσο πολύ. Είπε ότι τα δύο πρωτοστατικά είναι καλύτερα από το ένα. Τα δύο πρωτοστατικά ενδεχομένως υπερέχουν του LAV ICS, αλλά προφανώς είπε ότι η τριπλή θεραπεία υπερέχει όλα. Ευχαριστώ πολύ.
Και εγώ ευχαριστώ.
Και προχωράμε γρήγορα στην επόμενη, Έλα Κατερίνα, η οποία να είναι 25 λεπτά. Sergio? Where is Sergio? Sergio is here. You hide Sergio. Was with me, but I don't see him. He was here. I will. He's coming.
You have the slides. How do you put the slides?
I can start on the other.
But where did he go? Because I told him to be around. Okay. With a special entrance.
We say Banda Osiris.
Yes, we will have the opening lecture, and I have the pleasure to have in Crete, in Heraklion, my colleague and a mostly friend, Sergio Harari, professor of internal medicine at the University of Milan, very, very active in rare diseases, pulmonary hypertension, and European Respiratory Society. Sergio will do an overview in 20 minutes about novel treatment advances in the field of pulmonary hypertension. The floor is yours, and thank you so much for being with us in Iraq.
No. Thank you very much, Katrina, for the invitation, a nice introduction, and it's a pleasure and an honor to be here. So what I prepared for you is an overview of the new trials ongoing on PIH. So let me perhaps. So I have no disclosure regarding PIH. As you know, there are three major pathways already recognized in the pathogenesis of PIH, and on this pathway we have also possible treatments. So we have the endothelin pathway that lead to vasoconstriction and proliferation, and we have selective endothelin receptor antagonist and dual receptor endothelin receptor antagonist on this pathway. We have the pathway of nitric oxide, and nitric oxide regulates vasodilatation, anti-proliferation, and here we can interact with PD5 inhibitor like sildenafil, tadalafil, and stimulators of soluble guanylated cyclase like riociguat, and we have a pathway of prostacyclin, and here we can act with prostacyclin analogs, non-prostanoid IP receptor agonists like Selexipag, and the prostacyclin pathway lead to vasodilatation and anti-proliferation. So the three pathways are at the basis of the remodeling and vasoconstriction that are the fundamental histopathology of PIH. So what are the new possible treatment and new trial that are now ongoing? One is on macitentan, 75 milligrams, sorry.
You need a glass of water?
No, it's okay, thank you. The other one is on macitentan plus tadalafil in fixed dose, you know, the ambition trial. So this is a fixed combination dose. Another is on vardenafil dry powder inhalation, INL soluble guanylase cyclase stimulator, treprostinil dry powder, liposomal treprostinil inhaled, and a new drug, lalinepag. I will show you some of this data, of this trial. The one is, the first one I want to share with you is macitentan. Macitentan, as you know, is an oral dual endothelin receptor antagonist that is approved and used at the dosage of 10 milligram once a day. Studies are now investigating if the efficacy of macitentan is improved through maximal blockade of endothelin receptor B, which can potentially be achieved through a higher dose. In mouse model, macitentan at higher dose improve right ventricular function and reduce occlusive arteries lesion. In another model, it improves right ventricular systolic pressure. And a single dose administration of 300 milligram was well tolerated in healthy male subject. So the study is an interesting study comparing macitentan 75 milligram to macitentan 10 milligram in a patient with PIH in class 2 to 4. Is a prospective, multicenter, double-blind, double-dummy, randomized, active control parallel group. The primary endpoint is the time to first occurrence of centrally adjudicated morbidity or mortality event. And it is estimated to end at the end of 2023. So as you can see, you have an up titration to an up titration to to macitentan 37.5 and 75, and then you continue to 75. On the other arm, you have 10 milligram, and then they are shift to again to higher dose of macitentan. It's quite complicated to explain, but it's a double-blind, active control, triple dummy parallel group. So if you are in ERA, you can go in macitentan monotherapy. I'm moving to another study now. I'm moving to macitentan plus tadalafil in fixed dose. Is a study that has been based on the ambition study. So this is a study with a primary endpoint PVR at 16 weeks. And this is a particular study I was saying because if you are in ERA monotherapy, you can go to macitentan monotherapy plus placebo tadalafil or plus placebo in fixed doses, or in macitentan plus tadalafil in fixed doses. If you are in treatment naive, you can go in one of the three possible arms. If you are in PD5, you can go in macitentan tadalafil fixed dose or in tadalafil monotherapy plus placebo and macitentan placebo. And then they all shift to macitentan tadalafil in fixed dose. This is so the first two studies I show are quite conservative if you want. One is a higher doses of macitentan. The other one is a fixed dose of the association of macitentan and tadalafil. Now coming to the new possible treatment, one is Randerath, is an orally available non-prostanoid EP receptor agonist that it displays high binding affinity and selectivity for the human IP receptor. Safety and tolerability were well proven, and they require individualized titration up to a single patient. And as you can see in the study phase 2, it improved PVR and 6-minute walking distance. So in Randerath, there are two studies. One is on cardiopulmonary test in 193 patients, and the primary endpoint is peak VO2 at week 28. And the other one is about a primary endpoint of first adjudicated protocol to define clinical worsening event, and the number of patients estimated at 700, and as you can see, is versus placebo or versus background therapy. There are also new pathways that can be investigated with new drugs, and two promising therapeutic pathways are BM, morphomenogenic 2, and ACT3 and PGF. And the other pathway is the pathway of serotonin. So BMPR2 and TGF-beta are receptor superfamily signaling and are critical in maintaining normal pulmonary vascular homeostasis. And we do know that BMPR2 is a mutation that is present in up to 86% of familial PAH and 35% of idiopathic PAH, is associated with dysregulation BMPR2 as MAD158 pathway, elevated level of circulating activin and of growth differentiating factor contribute to an imbalance between anti and pro-proliferative signaling pathway. Increased pro-inflammatory cytokines downregulate BMPR2 and further contribute to PAH pathogenesis. So sotatercept is a novel, first-in-class fusion protein that acts by rebalancing signaling between pro and anti-proliferative pathways, thereby reversing the characteristic vascular remodeling seen in PAH. In preclinical studies, sotatercept treatment improved hemodynamics, right ventricular hypertrophy, right ventricular function, and anterior remodeling. In phase 2 Pulsar study that has been already published, sotatercept increased 6-minute walking distance and decreased PVR from baseline to week 24 in patients treated with 1, 2, or 3 approved PAH drug in background. So we have now 3 studies ongoing on sotatercept with different endpoints. One is the change from baseline peak VO2 with few patients enrolled. Another is the stellar, the change from baseline in 6-minute walking test, 284 patients, 166 patients, time to first morbidity and mortality, and the period, 662 patients estimated, time to clinical worsening from screening up to month 56. So really a very important investment in this drug. Another interesting pathway is PDGF and PDGF receptor that play a crucial role in embryonic lung development. And PDGF induces the proliferation and migration of smooth muscle cell and fibroblast. Overexpression of PDGF and PDGF receptor has been implicated in the development of PAH, and aberrant PDGF signaling occurs in PAH. Increased expression of PDGF and PDGF receptor has been observed in this patient, and overexpression drives pulmonary vascular remodeling, leading to further upregulation. Potential for reverse remodeling therapy by inhibiting PDGF receptor in PAH can be tested, and imatinib, that is a less selective tyrosine kinase inhibitor, could inhibit this pathway, but in the study that has been performed many years ago on imatinib PAH, it works, but with serious adverse event and with, in particular, subdural hematomas. So now the idea is to study imatinib inhaled. And the other is a new molecule, GB002, that is a small molecule that inhibits PDGF receptor. And there is ongoing phase 2 study evaluating this molecule inhaled in PAH patient in improving hemodynamic of this patient. Another interesting pathway is the pathway of serotonin. Serotonin is synthesized by tryptophan in 2 steps, and we can have it in gastrointestinal system, and we can have it also in pulmonary endothelial cell that express TPH1, that is tryptophan hydrolase 1, and produce 5-hydroxytryptamine, and both TPH1 expression and 5-hydroxytryptamine production are increased in pulmonary endothelial cell from patients with idiopathic pulmonary arterial hypertension. So we have two different compartments, the central nervous compartment and the periphery. And if we work with some drug on the periphery, we does not cross the blood-brain barrier. So the idea is that, in particular, Rodistrat, that is a new farm, is an orally available TPH1 inhibitor tested in phase 2 randomized control study, and it could act on this pathway. And the other point is that this pathway regulates vasoconstriction and proliferation, and serotonin-induced proliferation and vasoconstriction is leading to development of and progression of PAH through mechanism that regulate pulmonary arterial pressure and leads to stress on the right ventricular ventricle and lead to heart failure. So, Elevate is a multinational study using Rodistrat to evaluate the effect of Rodistrat on pulmonary vascular resistance in patients with PAH, also in background therapy, with 19 patients that should be enrolled in the next future. So, coming to the conclusion, very quickly, I try to give you an overview of the more interesting studies that are ongoing on this field. Phase 2-3 trials are ongoing for new approach targeting the well-established pathological pathways, like macitentan 75 mg, or the association macitentan and tadalafil at fixed dose. Research has identified a large number of novel PAH treatment targets in recent years, such as BMPR2, ACT3, PDGF receptor, and 5-hydroxytryptamine pathway. Several phase 2 and phase 3 programs are currently investigating efficacy and safety of novel treatment options in PAH, such as sotatercept, imatinib, and the molecule I told you, GB002. Prioritizing drug discovery and development, PAH remains an important goal for the future. And if there is any question, I'm here.
Co-chair Ioanna Mitrouska will do the discussion.
Thank you very much, Professor Harari, for being with us this afternoon. We hope that you will enjoy both the meeting and the blessed island. So I think that I don't know if we have time because we are almost ready to proceed. Okay. Thank you very much for your nice talk, and I think that it brings some kind of light or hope. Do you think that we are entering a decade that will bring light and hope for our poor PAH patients of any group?
I think PAH in the last 20 years had a great number of success, and the story of the disease and the story of patients have really changed. It is very interesting to see that despite the fact that 11 new drugs have been registered in the last 20 years for PAH, there are still a lot of things going on. So I think it's very interesting. And there is it has been done really a great work of basic science that represent the basis on which we can now develop new drugs, new active treatment, and also target new pathway.
Yeah, of course. We have an improved in the survival, a kind of improved the survival, but of course we have an improvement in the quality of life of this patient, but we still don't have a final treatment. So
we don't have a cure.
Yeah, exactly.
I agree.
It is a difficult disease, but is there any comment or question from the floor? Yes, please.
Professor Poletti.
Thank you,
Sergio, for your presentation and your talk. My question is, because you presented a trial on serotonin antagonist or serotonin drugs, related drugs, and we know that in COVID-19, probably when the disease switched from the mild to moderate to severe, we have an involvement of tryptophan pathway, serotonin. Do you think that this drug could be used also in this context?
Oh, this is a very interesting insight, Venerino. Really, I have no answer, but I think it could be interesting to evaluate also this possibility, at least in animal models. But I think it's a very interesting insight.
From my part, I would like, Sergio is expert in both ILD and PH, and as ILD physician, we are waiting the results of the treprostinil inhalation therapy in ILD, our IPF, and pulmonary hypertension. And as you have written the editorial with Professor Wells about the study of Professor Nathan, I would like your comment about that. Too good to be true.
May I add something?
Yes, of course.
It is a promising study.
Yes.
But I don't know. I would like your comment, Professor Wells.
No, go ahead.
Yes.
But?
You know, why do we have such a difference between iloprost and treprostinil? Both of them are prostacyclin analogs. So the results from the last study are very promising. For the group 3 PH, you mean, Katerina?
Yes, yes.
I think when I will let Atol comment, I think the study on treprostinil is a very interesting study, and for the first time, we had a positive result in PH ILD. There are also other things that need to be investigated. First of all, if it works in all patients. Second, if it's worked a long time, because it was a short time study. If it's really also effective or not on pulmonary function, but it looks like in the post-hoc analysis they published on Lancet. So I think it opened the door to also new possible investigation in this area. It said that I think we need more data on treprostinil, and the ongoing studies will probably give the final answer. Please, Atol.
Yes, Atol, yes, will like your comment. Yes, please.
Really much improve on your answer. I think we agreed in our editorial to be very measured about the FVC effect. So it's really quite exciting if we have vascular pathways to fibrosis that are being modulated. But I think we just have to wait for the follow-on study. There are too many caveats, and much as neither of us wanted to put a damper on this observation, I think we would agree that it's the next study that matters.
Agree, yes.
Okay.
Argyris?
Yes, Argyris.
Just a brief comment. Also, there's a major problem with these drugs in terms of price. We're talking about a drug that costs $20,000 approximately per month. And if we're talking about patients that they are above 65 and their survival is kind of diminished, then we're going to find a really hard time to reimburse these patients in the public health system.
This is always an ethical problem, but you should consider that a patient with PIH can cost more than €200,000 per year.
Much younger. I agree. There's a big ethical issue of it.
Argyris, you are right, but still there is a small amount, a small percentage of patients that deserve this high cost
this opportunity.
What I'm saying is that we have to be
very careful.
We have to be very cautious, and we need to
you are right.
evidence in order, if we want to apply a really expensive treatment with results that are not reaching.
There is still hope.
From the patient side,
Indeed. However, we have to say that FDA has been approved the drug, so the U.S. patients, yes,
We are waiting
are
for
having the
yeah.
possibility.
Yeah.
EMA has asked for the other study, so
we're waiting.
Yes, so we're waiting. And from the patient's aspect.
Now, there is also a problem regarding. Sorry, I will leave you. The device for inhaling treprostinil has been approved in US and Canada by FDA, but it's not approved by EMA.
Mm-hmm.
So now the need also to do a study involving Europe is also the need to approve the device. That's the reason why probably they will have the drug before.
And we are
Please.
not participating in the study.
My only comment as a patient is that this COVID time teach us that all the institutions can collaborate, speed up approbation when there is available made in one country or in one situation. As you said, in the US, there is an approbation, and we in Europe, we have ready to do another approbation. So I can think that these...
The rules are different from FDA to EMA.
I know.
Yeah.
But could be an occasion to think about it, because obviously there is cost on every path of approbation that we can raise down. The interest is of everyone, I think.
Professor Wells, would you like to add something?
The last comment and to conclude the session.
I'm uneasy about doctors being the regulators. I mean, the talk of you've got to be careful because it's expensive. I wouldn't be careful. I would actually use the drug if it's approved and funded, and if it isn't, then I can't use it. But I think we should pursue therapies wherever possible, bearing in mind that sooner or later they will become generic. We may also have pathways indicating those patients who are not successful with the therapy, meaning that the average cost across the disorder goes down. I don't think it's our role as doctors to be the regulators.
Okay,
so
I think we can close the meeting. Thank you all for being with us this afternoon. I think that everybody is here and we can proceed with the official opening of this meeting. So thank you very much. We can go on.
Περιμένουμε 3-4 λεπτά.
Στα 3-4 λεπτά.
Να βάλουμε το...
θα βάλουμε ένα βίντεο από τον κύριο Σταυρολίδη, που είναι καθηγητής αρχαιολογίας, επίτιμος πια από το Πανεπιστήμιο της Κρήτης. Όλοι τον ξέρετε. Είναι ίσως ο πιο διάσημος αρχαιολόγος, όχι μόνο στην Ελλάδα, αλλά νομίζω και πανευρωπαϊκά. Άρχισε από το Πανεπιστήμιο Κρήτης, τώρα είναι διευθυντής του Μουσείου της Ακρόπολης. Είναι φίλος μας. Δυστυχώς δεν μπόρεσε να είναι σήμερα μαζί μας, αλλά έχουμε τη χαρά να έχουμε λίγες εικόνες από τη δουλειά του. Και όλοι ξέρετε τη δουλειά που κάνει... Άλλο βάλανε. Εντάξει. Healing the Parthenon, λοιπόν.
Healing the Parthenon and the marmars in the British Museum.
From Professor Stambolidis.
So with
after the scientific part, we have a bit of cultural part, and afterwards the Greek mythology from Professor Tzanakis. So the Parthenon.
Πάντα.
Δεν ξέρω.
Μετά τις ιάρες.
Apologize for the English, but my speech could be the slides of my speech is in English. Apologize for the Greeks. And τους πολιτικούς τους ξέρετε, καθυστερεί λίγο ο Υπουργός, οπότε θα...
Ένα βίντεο.
Καλά, οι κριτικοί το ξέρουν. Για τους μη κριτικούς είναι αυτά.
Every picture is from Crete, so you have the combination of culture, of science, of archaeological issues, of museums, of mountains, of snow, and of sea.
Νομίζω ότι μπορούμε να ξεκινήσουμε. Ήρθε μαζί μας και είναι μεγάλη τιμή ο Υπουργός Υγείας, ο Θάνος ο Πλεύρης, ο οποίος είχε μια πολύ κουραστική μέρα. Τον ευχαριστούμε πάρα πολύ που είναι μαζί μας. Δυστυχώς ο Αρχιεπίσκοπος δεν ήρθε, προφανώς θα σπερνίζει ακόμα.
Μην λέτε τέτοια πράγματα, κύριε Tzanakis.
Δεν πειράζει. Είναι στη Βέρεια. Εκπροσωπώστε, εν πάση περιπτώσει.
Εντάξει.
Ξέρετε πόσο καλό είναι να κάθεσαι ανάμεσα σε δύο κυρίες, αλλά και πόσο δύσκολο είναι καμιά φορά. Το λέω αυτό γιατί χωρίς αυτό το επίπεδο και αυτή η οργάνωση δεν θα υπήρχε. Μπορώ να πω ότι έκαναν σχεδόν όλη τη βρώμικη δουλειά και τις ευχαριστώ πάρα πολύ καταρχήν. Αυτό ήθελα να σας πω σαν βασική κουβέντα που ήθελα να κάνω για την οργάνωση αυτού του θερινού σχολείου. Να ευχαριστήσω πάρα πολύ όλους τους χορηγούς, το πρακτορείο το οποίο μας υποστηρίζει και το οποίο στην ουσία, στο οποίο οφείλεται η τεχνική άρτια ροή του συνεδρίου αυτού, όλους εσάς που βρίσκετε εδώ, ιδιαίτερα από την υπόλοιπη Ελλάδα, αλλά και τους κριτικούς. Και ήθελα επίσης να ευχαριστήσω πάρα πολύ τους διεθνείς φίλους μας, την Ευρωπαϊκή Πνευμονολογική Εταιρεία, την Ελληνική Πνευμονολογική Εταιρεία για την υποστήριξή της σε όλη αυτή την οργάνωση και θα προχωρήσουμε αμέσως μετά με τους χαιρετισμούς, καλώντας τον Υπουργό Υγείας, τον κύριο Θάνο Πλεύρη, να χαιρετήσει το συνέδριο, να τον ευχαριστήσω για μια άλλη ακόμα φορά που παρά το πυκνό του πρόγραμμα είναι μαζί μας και να του ευχηθώ καλή περαιτέρω θητεία. Δουλεύει.
Θάνο είναι οκ.
Είναι οκ, εντάξει, τέλεια. Με μεγάλη χαρά, χθες που με πήρες τηλέφωνο, αποδέχτηκα την πρόσκληση. Είχαμε υπολογίσει αύριο έχουμε τον Ιατρικό Σύλλογο και σήμερα είχαμε μια πολύ σφιχτή μέρα. Γι' αυτό άλλωστε και είμαι σε casual εμφάνιση με την επίσκεψη στα νοσοκομεία μας. Αλλά με μεγάλη χαρά ήθελα να έρθω εδώ πέρα, αφενός για την εκτίμηση που τρέφω στο πρόσωπό σου αλλά και στο δικό σου πρόσωπο, σε όλους τους ανθρώπους που έχουν βρεθεί στο Εθνικό Σύστημα Υγείας αυτήν όλη τη δύσκολη περίοδο. Και ειδικά είναι πολύ ενδιαφέρον η προσπάθεια η οποία γίνεται για δεύτερη φορά και από ό,τι πληροφορήθηκα θα έχει μια συνέχεια από εδώ και πέρα, που έχει να κάνει με όλη αυτή τη συγκέντρωση που δημιουργεί η πνευμονολογική εταιρεία. Και όταν αναφερόμαστε στους πνευμονολόγους, αυτομάτως στο μυαλό μας έρχεται και όλη η σχέση η οποία υπάρχει με την πανδημία, και όχι μόνο με την πανδημία, με όλες τις λοιμώξεις που υπάρχουν στο αναπνευστικό. Ευελπιστούμε ότι από εδώ και πέρα και στην πίεση την οποία έχουμε αυτή τη στιγμή και όπως την βλέπουμε και στα μοντέλα, θα αυξηθεί ως ένα βαθμό, θα επεδοποιηθεί και θα έχουμε μετά και την αποκλιμάκωση, θα είμαστε όλοι ευτυχισμένοι όταν τον κύριο Tzanakis θα αρχίσουμε να μην τον βλέπουμε στα κανάλια. Άρα αυτό θα είναι μια καλή... Όσο δηλαδή εγώ ως Υπουργός Υγείας θα αρχίσω να μην βλέπω εσάς και τους συναδέλφους σας στα κανάλια και να τους βλέπω μόνο κοινωνικά με τις μουσικές που ακούσαμε πριν, θα είμαι ένας ευτυχισμένος Υπουργός Υγείας. Θέλω να σας ευχαριστήσω όλους. Καλή επιτυχία στις εργασίες τις οποίες θα γίνουν. Από εδώ και πέρα ευελπιστούμε και ότι τομές οι οποίες πρέπει να γίνουν, αλλά προβλήματα που πρέπει να λυθούν στο εθνικό μας σύστημα υγείας πρέπει να ξεκινήσουν. Είμαι ένας άνθρωπος που δεν ευρωπαίο τις καταστάσεις. Αντιλαμβάνομαι ότι έχουμε ένα πιεσμένο εθνικό σύστημα υγείας. Έχουμε γυναίκες και άντρες που όλο αυτό το διάστημα έχουν πιεστεί, είναι κουρασμένοι. Ακόμα και όταν βλέπουν να υπάρχει μια ύφεση στην πανδημία, έρχονται τα non-COVID περιστατικά να πιέσουν το σύστημα. Αυτό το ζούμε σε όλες τις περιφέρειες που πάμε. Οφείλω να πω ότι το Ηράκλειο είναι από τις τυχερές περιοχές με τα νοσοκομεία τα οποία έχει, αλλά προφανώς και εδώ πέρα η πίεση είναι πολλές φορές μεγαλύτερη ακριβώς λόγω των καλών νοσοκομείων και το Βενιζέλιο και το πανεπιστημιακό μας. Και από εδώ και πέρα ξεκινήσαμε από την πρωτοβάθμια να μπούμε σε μια διαδικασία κάποιων αλλαγών που ήδη ξεκινούν από τώρα, αλλά μην κοροϊδευόμαστε. Οι σοβαρές και οι μεγάλες τομές θα είναι όταν θα μπούμε δυνατά στη δευτεροβάθμια περίθαλψη και έχει να κάνει και με την αξιολόγηση των δομών μας και με καλύτερη ανάταξη των υπηρεσιών μας και να δούμε πώς το προσωπικό το οποίο υπηρετεί και θα αμοιβεται καλύτερα, αλλά θα έχει και άλλες δυνατότητες πέρα από τις στενές σχέσεις που έχει αυτή τη στιγμή, γιατί δυστυχώς η φυγή προς τον ιδιωτικό τομέα είναι μεγάλη. Θέλω να χαιρετήσω όλους όσους έχουν έρθει εδώ πέρα, ειδικά τους συναδέλφους σας που έχουν έρθει από την Ευρώπη και να απολαύσουν και την παραμονή τους στο Ηράκλειο. Εγώ δυστυχώς δεν την έχω απολαύσει ποτέ ως διακοπές εδώ πέρα στο Ηράκλειο, γιατί ως γαμπρός Χανιώτης έχω συγκεκριμένη περιοχή που μπορώ να κινούμε στην Κρήτη για διακοπές, αλλά τουλάχιστον μπορώ να το επισκέφτομαι κάνοντας τις επισκέψεις στα νοσοκομεία. Καλή επιτυχία στις εργασίες και ευχαριστώ πολύ για την πρόσκληση.
Να είστε καλά. Υπουργέ μου, στην έξοδο σου την έχει στήσει η κυρία Μπούτου, διευθύντρια από το Ιπποκράτιο, που θα σας πει ένα αίτημα σχετικά με την πνευμονολογική του Ιπποκρατίου. Σας παρακαλώ πολύ προσεκτικά.
Πρώτα την Κρήτη.
Αφροδίτη, στήστε την.
Και μετά θα σας δώσουμε ένα κατάλογο, Υπουργέ μου, επίσης.
Στα πρακτικά του συνεδρίου.
Όχι, για τον κατάλογο.
Όχι, είναι σημαντικό αυτό που λέω για αυτό το νοσοκομείο.
Πρώτα την Κρήτη τώρα.
Ναι. Λοιπόν,
ναι.
συνεχίζουμε. Εσείς οι πολιτικοί καμιά φορά είστε δύσκολοι. Γι' αυτό εμείς κάναμε ένα backup βίντεο, θα το προβάλλουμε αμέσως τώρα, από την αναπληρώτρια Υπουργό Υγείας, όχι μόνο γιατί είναι αναπληρώτρια Υπουργός, αλλά και γιατί είναι αγαπητή φίλη και βεβαίως πνευμονολόγος. Άνοιξε τα μάτια σου, Μίνα. Ωραία. Φωνή.
Ήχο.
Δεν έχουμε ήχο.
Είναι και αυτά τα τεχνικά, δεν πειράζει.
Suspense.
Έχουμε πια. Ναι. Ήρθε η Μπροκουδάκη.
Tzalkiadakis.
Πού είναι η Μπροκουδάκη, δεν είναι. Θα μου λέτε. Πού είναι η Μπροκουδάκη, δεν βλέπω.
Το παιδί είναι η Λένα, είναι εκεί.
Ζητούμε συγγνώμη για αυτή την μικρή καθυστέρηση, αλλά ξέρετε πολύ καλύτερα από εμάς τα προβλήματα της τεχνολογίας.
Να προχωρήσουμε ένα άλλο.
Αν δεν λύνεται άμεσα, θα έλεγα ότι μπορούμε να προχωρήσουμε και να το αφήσουμε στο τέλος, καλώντας τον Αντιπεριφερειάρχη υπεύθυνο σε θέματα υγείας, καλό φίλο και συνάδελφο, τον κύριο L.Vamvakas.
Πρόσεξε, Κύριε Υπουργέ, κυρία Διοικήτρια της Υγειονομικής Περιφέρειας, κύριε Υποδιοικητή, κύριε Διοικητή του Νοσοκομείου του Παγνή και αναπληρωτή διοικητά, κύριε Βουλευτά, κύριε Πρόεδρε του Ιατρικού Συλλόγου, δεν ξέρω αν ξέχασα κάποιο, αγαπητοί προσκεκλημένοι, δεν θα δει κύριε Αγαπίου, συγγνώμη, κύριε Αγαπίου, αγαπητοί αξιότιμοι συνεργάτες και συνεργάτησες, με μεγάλη μου τιμή και ιδιαίτερη χαρά σας καλωσορίζω και εγώ στην τελετή έναρξης του δεύτερου Διεθνούς Θερινού Σχολείου που υλοποιεί η Πανεπιστημιακή Πνευμονολογική Κλινική της Ιατρικής Σχολής του Πανεπιστημίου Κρήτης στην πόλη του Ηρακλείου. Θα ήθελα να ευχαριστήσω την Οργανωτική Επιτροπή για την τιμητική πρόσκληση να παραβρεθώ και να απευθύνω χαιρετισμό στη σημερινή τελετή και να μεταφέρω τις ευχαριστίες και τα συγχαρητήρια του Περιφερειάρχη Σταύρο Ναουτάκη, που δεν μπορεί να είναι εδώ σήμερα μαζί μου, γιατί ευρίσκεται σε μια εκδήλωση που διοργανώνει η Περιφέρεια και αφορά την κριτική διατροφή στο Ρέθμο αυτή την ώρα που πρέπει να γίνει η έναρξη αυτής της εκδήλωσης. Θα ήθελα να εκφράσω τα θερμά μου συγχαρητήρια στα μέλη της Οργανωτικής Επιτροπής, τους αγαπητούς καθηγητές, φίλους και συνεργάτες, τον κύριο Νίκο Tzanakis, τη Σοφία τη Schiza και την Κατερίνα την Αντωνίου για τη διοργάνωση αυτού του συνεδρίου του Θερινού Σχολείου στο Ηράκλειο. Ένα θερινό σχολείο που αποτελεί μια σημαντική πρωτοβουλία που θα συνεισφέρει στην ενίσχυση της επιστημονικής και ερευνητικής γνώσης σχετικά με τις τελευταίες εξελίξεις όσον αφορά τα αναπνευστικά νοσήματα και τις διαταραχές στον ύπνο, μέσα από την ανάπτυξη γόνιμων και συζητήσεων και προβληματισμών, οι οποίοι θα τεθούν μεταξύ γιατρών, ερευνητών, νοσηλευτών αλλά και των ασθενών. Υπάρχει αυτή η σημαντική καινοτομία στο συνέδριο, η δυνατότητα που παρέχει στους συμμετέχοντες και συμμετέχουσες να παρακολουθήσουν κλινικά και ερευνητικά φροντιστήρια αναφορικά με τις διαταραχές της αναπνοής στον ύπνο και τις διάμεσες πνευμονικές παθήσεις, καθώς και της παρουσίασης πρώτη φορά μετά τη δημοσίευσή του σε ειδική συνεδρίαση των Διεθνών Οδηγιών της Ευρωπαϊκής Πνευμονολογικής Εταιρείας για την αντιμετώπιση της COVID-λίμωξης. Σε αυτό το σημείο θα ήθελα και πάλι να ευχαριστήσω την Πνευμονολογική Κλινική, το διευθυντή της και όλα τα στελέχη της κλινικής, γιατρούς, νοσηλευτές, διοικητικό προσωπικό, για την πολύτιμη συνεισφορά τους στη μάχη κατά του κορονοϊού και ακόμα για τη συνεισφορά τους και την προσφορά τους και άρτια επιστημονική συνεισφορά τους στην αντιμετώπιση όλου του φάσματος των παθήσεων του αναπνευστικού συστήματος στην Κρήτη. Η Περιφέρεια Κρήτης στηρίζει έμπρακτα και ουσιαστικά το έργο του Πανεπιστημίου Κρήτης και όλων των δομών του συστήματος υγείας με τη διασφάλιση απαραίτητου βιοιατρικού και τεχνολογικού εξοπλισμού και την ανάπτυξη των κατάλληλων υποδομών για την ενίσχυση ακόμα και με επικουρικό προσωπικό. Ταυτόχρονα στηρίζει επιστημονικές ημερίδες, συνέδρια και εκδηλώσεις που προάγουν την επιστημονική γνώση και έρευνα και σχεδιάζει και υλοποιεί δράσεις και παρεμβάσεις με στόχο πάντα την προαγωγή και την ενημέρωση σχετικά με θέματα προστασία της δημόσιας υγείας. Και ακόμα έχει προχωρήσει σε προγραμματικές συμβάσεις και με το Ιατρική Σχολή. Μια από αυτές είναι και η προγραμματική σύμβαση για την ανάπτυξη του παρατηρητηρίου επιδημιολογικής ανάλυσης της δημόσιας υγείας της Περιφέρειας Κρήτης, του οποίου επικεφαλής είναι ο κ. Tzanakis, και τα αποτελέσματα αυτού του παρατηρητηρίου χρησιμοποιεί και έτσι τον ακούμε συνέχεια και μας ενημερώνει όχι μόνο στην Κρήτη, αλλά και γενικά σε όλη την Ελλάδα για αυτά που τρέχουν και τις εξελίξεις στην πανδημία του κορονοϊού. Δεν θα ήθελα να σας κουράσω παραπάνω. Σας ευχαριστώ και πάλι και καλή συνέχεια στο συνέδριό σας. Κύριε Υπουργέ, νομίζω ότι ο χρόνος σας είναι πολύτιμος. Σας ευχαριστούμε πάρα πολύ. 2 λεπτά στην κυρία Μπούτου όμως. Γεια σας. Μαζί μας ήταν και ο βουλευτής Ηρακλείου, ο κύριος Σενετάκης. Ευχαριστούμε πάρα πολύ.
Να φύγει.
Εντάξει, φεύγει ο κύριος Βαγουρανάκης, είναι μαζί μας όμως με το πνεύμα του στη συνέχεια. Ναι, σωστό, όχι, σας συγχωρούμε κύριε Βαγουρανάκη.
Έχουμε το βίντεο της Μίνας. Αν το έχουμε... Το έχουμε, ωραία.
It's a great pleasure to greet you all to this Cretan summer school organized by friends and colleagues Professor Tzanakis, Professor Schiza, and Professor Antoniou. It's a well-balanced program that has the best of everything in pulmonary medicine, and I honestly wish you every success. I'm really unhappy I'm not there with you. I hope you enjoy the meeting. I'm sure you will have great interactions. Every success to the meeting. Enjoy.
Ευχαριστούμε την Νίνα και μετά από την πείνα μας, την τόσο μάχημη γυναίκα στο Υπουργείο Υγείας και στην Ευρωπαϊκή Πνευμονολογική Εταιρεία, έχω τη χαρά να προλογίσω την κυρία Λένα Μπορμπουδάκη, τη Λένα μας, τη διηγήτρια της 7ης ΥΠΕ, με την οποία είχαμε τη χαρά να συνεργαστούμε και τόσο μας βοήθησε ιδιαίτερα στην περίοδο της πανδημίας. Λένα, καλώς όρισες.
Καλώς σας βρήκα. Δεν υπάρχει πιο όμορφο πράγμα από το να σε αποκαλούν με το μικρό σου όνομα. Λυπάμαι που δεν είναι εδώ ο Υπουργός, αν και τα έχουμε πει, τα συζητάμε όλη μέρα, θα είμαστε και τις επόμενες μέρες μαζί. Να πούμε το εξής, ότι εμείς στην υγειονομική περιφέρεια, μαζί με τους υποδιοικητές, τον κύριο Αγαπή και τον κύριο Παπαβασιλείου, έχουμε θέσει ένα στόχο, ότι μέσα σε αυτά τα χρόνια της πανδημίας, με την υποστήριξη και της περιφέρειας, είναι εδώ ο κύριος Αντιπεριφερειάρχης, και των διοικήσεων των νοσοκομείων και με τον διοικητή και τον αναπληρωτή διοικητή του Παγνή και όλων των νοσοκομείων μας, αυτό που θέλουμε είναι να ενισχύσουμε την δημόσια υγεία ακόμα και σε δύσκολες καταστάσεις. Αγαπητέ κύριε Τζανάκη, κυρία Αντωνίου, κυρία Σχίζα και όλοι οι πνευμονολόγοι τόσο του Παγνή όσο και όλων των νοσοκομείων της Κρήτης και της πρωτοβάθμιας αλλά και του ιδιωτικού τομέα, ένα μεγάλο ευχαριστώ από την υγειονομική περιφέρεια για όλη τη συνεργασία που έχουμε αυτά τα δύσκολα χρόνια της πανδημίας. Και ένα πολύ μεγάλο ευχαριστώ γιατί πέρα από τη δουλειά που κάνετε στις κλινικές, έχουμε μια εξαιρετική συνεργασία όπου μπορούμε να παρακολουθούμε, κύριε Τζανάκη, τους δείκτες με την καταγραφή. Είμαστε ιδιαίτερα ευτυχείς που η θνητότητα στην Κρήτη από COVID είναι σε εξαιρετικά επίπεδα. Αν δεν έχει αλλάξει κάτι, έχουμε τα επίπεδα της Δανίας. Και αυτό οφείλεται και στην ειδικότητα των πνευμονολόγων. Γνωρίζουμε τη σημαντικότητα και των κλινικών COVID πριν την εισαγωγή ενός περιστατικού στη μονάδα εντατικής θεραπείας και ξέρουμε ότι οι πνευμονολόγοι είστε η ειδικότητα που έχει υποστηρίξει περισσότερο από όλους και φυσικά και οι παθολόγοι αυτή τη διαχείριση. Να πούμε ότι θα είμαστε δίπλα σας, να πούμε ότι ευχαριστούμε που είστε δίπλα μας και νιώθουμε τη στήριξή σας και η υγειονομική περιφέρεια της Κρήτης είναι εδώ για να πρωτοπορήσουμε, κύριε Τζανάκη, όπως κάνουμε κάθε φορά, είτε αυτό είναι νοσηλεία, είτε είναι εμβολιασμοί, είτε είναι οτιδήποτε διασφαλίζει τη δημόσια υγεία στο νησί μας. Σας ευχαριστώ και εγώ θερμά. Να είστε καλά.
Τη χαρά και την τιμή να καλέσω για χαιρετισμό τον διοικητή του Παγνή και πάντα καθηγητή μου, τον κύριο G.Chalkiadakis.
Κύριε Αντιπεριφερειάρχα Υγείας, αγαπητέ Λάμπρο, κυρία Διοικήτρια της 7ης ΥΠΕ, κύριε Αναπληρωτά Διοικητά του Παγνή, αγαπητέ Στέλιο. Είναι ιδιαίτερη χαρά που είμαι απόψε κοντά σας και ευχαριστώ για την πρόσκληση, κύριε Τζανάκη. Η χαρά μου είναι ιδιαίτερη όμως, γιατί μεταξύ των τριών που κάθονται στο πόντιουμ, οι δύο κυρίες είναι μαθήτριές μου. Και αυτή είναι η ιδιαίτερη χαρά, ένας δάσκαλος να βλέπει τους μαθητές του να είναι στα υψηλότερα σκαλιά της επιστήμης και της ακαδημαϊκής καριέρας. Οπότε, Σοφία και Κατερίνα, μου δίνεται ιδιαίτερη χαρά και συγκίνηση. Τώρα, άφησα τελευταίο το διευθυντή της κλινικής, τον κύριο Τζανάκη, με τον οποίο έχουμε μια πολύ παλιά συνεργασία, την εποχή που αυτός ήταν επιμελητής του ΕΣΥ και εγώ ήμουν επίκουρος καθηγητής και τότε ξεκινούσαμε τα πρώτα θωρακοσκοπικά, τις πρώτες θωρακοσκοπικές επεμβάσεις. Και θέλω να πω ότι εμείς στην Κρήτη ήμασταν οι πρώτοι στην Ελλάδα που ξεκινήσαμε τις θωρακοσκοπήσεις, στην αρχή με μικρά βήματα για βιοψίες. Στη συνέχεια φτάσαμε στο σημείο να κάνουμε την πρώτη θωρακοσκοπική θυμεκτομή στην Ελλάδα και την εποχή εκείνη λίγα ήταν τα κέντρα στον κόσμο που κάναν θωρακοσκοπικές θυμεκτομές, την πρώτη θωρακοσκοπική λομπεκτομή και γενικά θωρακοσκοπικά νομίζω ότι το Ηράκλειο, το Πανεπιστημιακό Νοσοκομείο και η Ιατρική Σχολή ήταν πρωτοπόροι στα θωρακοσκοπικά στην Ελλάδα. Έχω τη χαρά λοιπόν να προλογίσω το συνέδριό σας. Με τον Νίκο τον Tzanakis έχουμε συνεχή επαφή, συνεργασία. Θα ξέρετε ίσως ότι είναι ο πρόεδρος, ο διευθυντής της Ιατρικής Υπηρεσίας και κάθε εβδομάδα έχουμε ένα meeting στο οποίο αναλύουμε τα του κορονοϊού. Αυτό ήταν κάτι το οποίο ξεκινήσαμε από το 2020. Κάθε Τρίτη λοιπόν η ομάδα, η οποία αποτελείται από πολλούς γιατρούς, από την νοσηλευτική υπηρεσία, την διοικητική υπηρεσία, αναλύουμε το τι γίνεται και ακούμε το φίλο μας τον Νίκο να μας λέει ποιες είναι οι προβλέψεις για την επόμενη εβδομάδα, τον επόμενο μήνα και έτσι ήμασταν έτοιμοι να αντιμετωπίσουμε οτιδήποτε υπάρχει. Εύχομαι λοιπόν στο συνέδριό σας, γιατί νομίζω ότι πλάτιασα πολύ, στο συνέδριό σας καλή επιτυχία και ό,τι καλύτερο. Ευχαριστώ.
Έχω τη χαρά να προλογίσω τον κύριο Κτeniadakis, τον συμμαθητή μου, αλλά όχι στην ίδια τάξη. Θα το ξεκαθαρίσουμε από το καπετανάκιο. Από το καπεταλάκιο.
Ήταν πολύ μικρότερη.
Και είναι χαρά μου να προλογίσω το Στέλιο μας, που είναι αναπληρωτής διοικητής στο Πανεπιστημιακό Νοσοκομείο.
Είναι μεγάλη μου χαρά να βρίσκομαι ανάμεσά σας, ανάμεσα στους συναδέλφους καταρχήν πνευμονολόγους, οι οποίοι έχουν δώσει ένα πολύ μεγάλο αγώνα. Να χαιρετήσουμε την διοικήτρια της ΥΠΕ, τον Αντιπεριφερειάρχη Υγείας, το διοικητή και καθηγητή μας εδώ και φυσικά φίλους και συναδέλφους και συμφοιτητές, εντάξει, την αγαπημένη ομάδα της πνευμονολογικής, η οποία η πνευμονολογική κλινική έχει στο Πανεπιστημιακό Νοσοκομείο έχει αποδείξει ότι και επιστημονικό έργο παράγει υψηλότατο, αλλά και πολύ σημαντικό έργο για την προαγωγή της υγείας στην Κρήτη γενικότερα. Να σας συγχαρώ όλους καταρχήν που βρίσκεστε εδώ και που συμμετέσχετε σε αυτό το δεύτερο καλοκαιρινό σχολείο. Ελπίζω αυτό το σχολείο να είναι μια μόνιμη δραστηριότητα για την πνευμονολογική εταιρεία και για την πνευμονολογική κλινική του Πανεπιστημιακού. Και νομίζω ότι είναι μια εξαιρετική ευκαιρία για όλους να χαρούν και την Κρήτη, αλλά και να ανταλλάξουν ιδέες και απόψεις πάνω σε τρομερά μεγάλα θέματα της ιατρικής, πέρα από τον κορονοϊό, και να μην μας μείνει ο κορονοϊός μόνο να συζητάμε και άλλα πράγματα και να μαθαίνουμε όσο μπορούμε περισσότερα. Σας ευχαριστώ και πάλι και καλή συνέχεια.
Έχω τη χαρά τώρα να καλέσω στο βήμα να μας καλωσορίσει τον πρόεδρο της Ελληνικής Πνευμονολογικής Εταιρείας, η οποία είναι δίπλα μας. Είναι εταιρεία κορμού της ειδικότητας. Κάτω από την πραγματική και οραματική του καθοδήγηση, η Ελληνική Πνευμονολογική Εταιρεία τα τελευταία 2 χρόνια έχει αναπαράξει ένα πολύ μεγάλο έργο και νομίζω και σε επιστημονικό επίπεδο και στα επίπεδα της αντιμετώπισης του κορονοϊού. Στέλιο.
Καλησπέρα σε όλους. Ευχαριστώ πάρα πολύ για την πρόσκληση. Εύχομαι καλή επιτυχία στις εργασίες του συνεδρίου. Νομίζω ότι η πνευμονολογία είναι μια ειδικότητα η οποία φάνηκε να πρωταγωνιστεί τα τελευταία χρόνια, αλλά δεν πιστεύω ότι χρειαζόταν ο COVID για να φανεί ο πρωταγωνιστικός της ρόλος. Τον είχε και τον έχει και θα τον έχει. Και είναι και μια ειδικότητα που μέσω της εταιρείας έχει κάνει 3 στόχους από τότε που αναλάβαμε. Ο ένας είναι η εκπαίδευση και αυτό το προσπαθούμε με πολύ μεγάλη προσπάθεια. Ήταν πολύ δύσκολη η εκπαίδευση τις πρώτες εποχές του κορονοϊού, αλλά χρειάστηκε νομίζω επιμονή και προσπάθεια για να συνεχιστεί. Το δεύτερο είναι η εξωστρέφεια. Και το τρίτο είναι η προσφορά στην κοινωνία. Γιατί οι επιστημονικές εταιρείες, χωρίς να προσφέρουν στην κοινωνία και χωρίς να είναι εξωστρεφείς, δεν μπορούν να κάνουν μόνο επιστημονικό έργο. Άρα είναι ένα από τα πιο σημαντικά κομμάτια. And I think taking the opportunity for our distinguished guests that we have with us today, and particularly those who were involved in the European Respiratory Society, I want just to mention that we are still collaborating with the ERS. We are one of the partners of the ERS. And just to remind for the audience that this year we organized one of the satellite symposium that ERS actually decided to organize and we received the honor, I think, and also the activity of organizing a satellite symposium in Greece. So in the future, we will still collaborating with the ERS, and we will try to extend this collaboration by promoting educational activities and also communication skills in terms of the European collaboration. Σας ευχαριστώ πάρα πολύ για την πρόσκληση και για τη συμμετοχή εδώ.
Εμείς γνωρίζετε στην Κρήτη αγαπούμε πάρα πολύ τους Μακεδόνες. Είναι μαζί μας λοιπόν ο πρόεδρος της εταιρείας νοσημάτων Θώρακος από τη Θεσσαλονίκη, ο κύριος I.Titopoulos. Τον παρακαλώ να προβεί σε ένα σύντομο χαιρετισμό.
Αγαπητοί φίλοι, αγαπητοί συνάδελφοι, είναι χαρά και τιμή μου που έχω κληθεί ως πρόεδρος της εταιρείας νοσημάτων Θώρακος Ελλάδος να μετέχω σε αυτό το συνέδριο, το πολύ ωραίο συνέδριο, και να χαιρετήσω τις εργασίες του, ενός συνεδρίου το οποίο αναβαθμίζει πάντα την ειδικότητα της πνευμονολογίας, και η ΕΝΘΕ είναι στο πλευρό της και όπως και σε κάθε άλλη παρόμοια δράση που έχει σαν στόχο να αναβαθμίζει την ειδικότητα. Ο κορονοϊός, ξέρετε, αυτά τα χρόνια μας δημιούργησε μια μεγάλη ευθύνη. Ανέδειξε την ειδικότητα, που η οποία πράγματι είναι μια ειδικότητα αιχμής, αλλά την ανέδειξε και είναι υποχρέωση όλων των εταιριών να την κρατήσουν και όταν αυτός θα φύγει και θα τον ξεχάσουμε. Και αυτό είναι μεγάλη ευθύνη όλων. Η ΕΝΘΕ λοιπόν με χαρά στηρίζει κάθε δυναμική από όπου προέρχεται από την Ελλάδα, η οποία έχει σαν στόχο αυτόν εδώ και θα βοηθήσει όλες τις παρόμοιες κινήσεις. Εμείς στο συγκεκριμένο συνέδριο αναδείξαμε την βοήθειά μας μέσα από την ιστοσελίδα μας, την αναδείξαμε στέλνοντας προσωπικά mail σε όλα τα mail μας, πάνω από 400 mail έχουν ενημερωθεί και εγώ προσωπικά ως πρόεδρος με τη φυσική μου παρουσία εδώ και πολλές μέρες για να στηρίξω το συνέδριο. Βέβαια ο αγαπητός κύριος Tzanakis μας παρέλειψε να μας αναφέρει, αλλά βέβαια βλέπετε η γλώσσα πολλές φορές ξεφεύγει από το μυαλό και δεν πειράζει, του το συγχωρώ. Αλλά δεν πειράζει, είναι εξίσου αγαπητός. It is a great congress full of science and discussing and above all making new friends. Σας ευχαριστώ πάρα πολύ. Κύριε καθηγητά, όποτε χρειαστείτε τη βοήθειά μας είμαστε στο πλευρό σας. Ευχαριστώ πολύ.
Okay.
Και τώρα είναι μεγάλη χαρά τη δική μου και της Κατερίνας και δική μου, να προλογίσουμε τον καθηγητή μας πρώτα απ' όλα και διευθυντή αυτής της κλινικής. Δεν νομίζω ότι χρειάζεται συστάσεις, αλλά περιμένουμε με αγωνία να ακούσουμε μία ομιλία όπως μόνο αυτός ξέρει να κάνει, συνδέοντας τις ρίζες μας πίσω στη μυθολογία με την ιατρική.
Όταν γυναίκες σας κάνουν κομπλιμέντα, να είστε πάρα πολύ προσεκτικοί το τι ακριβώς κρύβει όλο αυτό. Ευχαριστώ πάρα πολύ όμως, παρόλα αυτά. Σας το λέω αυτό με τις γυναίκες, διότι ο μύθος στηρίζεται σε μία γυναίκα στην ουσία. Apologize for the Greeks, but all my slides are in English, so you could follow, Venerino, the story. Okay. The myth of Eos and Tithonus. Ο μύθος της Ιούς και του Τιθονού. Ίσως, αν ρωτήσω κάποιους από εσάς, αν τον έχετε ποτέ διαβάσει και αν τον έχετε ακούσει, δεν ξέρω ποιοι από εσάς έχουν ασχοληθεί με αυτόν τον μύθο. Αλλά θα προσπαθήσω να σας πω γιατί τον επιλέξαμε και γιατί σε ένα ιατρικό συνέδριο. Η Ιός, λοιπόν, όπως γνωρίζετε, είναι η θεότητα της αυγής. Δουλειά της ήταν να ξυπνάει πρωί-πρωί, μόνο αυτή τη δουλειά είχε, να σηκώνεται με τον πυρσό της, είτε ανεβαίνοντας το άρμα της, και να διαλύει τα σκότη και τα μυστήρια της νύχτας. Κατήγετο από τους...
Δεν αλλάζουν τα slides,
Εσείς έχετε control, κύριε Tzanakis.
Ναι.
Αλλά αυτό είναι αλήθεια. Αλλά έχει ωραία slides.
Ήταν λοιπόν, είπαμε, μία ωραία κυρία, μονίμως νέα, της οποίας η ιδιότητα, η δουλειά ήταν αυτή. Κατήγετο από τους αρχαίγονους θεούς που είχαμε. Ξέρετε ότι δεν είχαμε το 12άθιο πάντα, πριν ήταν οι Τιτάνες. Τιτάνες ήταν ο Κρόνος, η Ρέα, ο Ιαπετός, αν θυμάμαι καλά. Τα παιδιά τους λοιπόν, κάποιοι από αυτούς γέννησαν παιδιά, διότι αντίθετα με τους δικούς μας θεούς σήμερα, αυτοί παντρεύονταν και αγαπούσαν και έκαναν παιδιά. Έκανε λοιπόν κάποιους από αυτούς, γέννησαν την Ιώ, η οποία μαζί με τα αδέλφια της, τον Ήλιο και τη Σελήνη, έκαναν τις δουλειές που όλοι γνωρίζουμε ότι έκαναν. Κάθε πρωί λοιπόν η Ιώ ξεκίναγε τη μέρα στην ουσία και ήταν πάρα πολύ σημαντική θεότητα γι' αυτό. Όμως, επειδή φλέρταρε τον Άρη, η Αφροδίτη που ήταν ο επίσημος αγαπημένος της, την καταράστηκε. Και τι κατάρα της έδωσε? Να μην είναι ποτέ, να μην εκπληρώσει ποτέ τον έρωτα με κάποιον άνθρωπο, αλλά μονίμως να κάνει αυτό που λέμε one night, το υπόλοιπο το ξέρετε.
Μπορείτε να το πείτε στα αγγλικά. One night stand.
Yes,
Italian.
Φανταστείτε την εικόνα. Η Υιός να σηκώνεται κάθε πρωί, να σηκώσει τη μέρα, αλλά παράλληλα να κοιτάζει πού θα βρει τον πιο όμορφο νεαρό για να τον φλερτάρει, να τον αρπάξει. Κάποια στιγμή λοιπόν έπεσε το μάτι της σε έναν υπέροχο νέο, μειώδη, τον Τίθονο, ήταν ένας πρίγκιπας από την Τρία, γιος του Λακεδαίμονα κλπ, ο οποίος ήταν εξαιρετικά όμορφος. Και βέβαια καταλαβαίνετε από εκεί και πέρα την ιστορία. Χρησιμοποιώντας τη δύναμή της Υιό, πήρε τον Τιθονό, σαν εραστή πλέον, πήγανε στην Αιθιοπία, όπου εκεί ζούσαν ευτυχισμένοι, μάλιστα γέννησαν 2 παιδιά, τον Εμάθιον που ήταν ο μετέπειτα βασιλιάς της Αιθιοπίας και σκοτώθηκε από τον Ηρακλή, και τον Μέμονα, ο οποίος ήταν με τους Τρόες, defender, ήταν αμυνόμενος και σκοτώθηκε από ποιον άλλον, τον Αχιλλέα. Αλλά η ιστορία ξεκινάει από εδώ. Επειδή λοιπόν αγαπιόντουσαν πάρα πολύ, η ιστορία αυτή έχει κάνει πολλούς καλλιτέχνες να γράψουν ποίηματα, να ζωγραφίσουν ακριβώς αυτή την ιστορία. Θα σας πω τώρα. Αυτοί λοιπόν, επειδή ζούσαν ευτυχισμένοι και αγαπιόντουσαν πάρα πολύ, είχαν ένα πολύ ωραίο βίο, κατάλαβαν κάποια στιγμή ότι αυτό δεν θα συνεχιστεί, διότι η θεά, η οποία ήταν αιώνια, ήταν αθάνατη, ενώ αυτός δεν ήταν αθάνατος, κάποια στιγμή θα επέρχεται το μοιραίο. Τότε λοιπόν πήγε η Υιός στον Δία και τον παρακάλεσε να δώσει αθανασία στον Τιθονό. Ο Δίας καταρχήν της είπε: αποκλείεται, φύγε μακριά. Αυτό είναι ανομαλία. Δεν είναι φυσιολογικό. Αλλά γνωρίζετε πόσο επίμονες είναι οι γυναίκες. Ειδικά οι θεές εκείνης της εποχής. Ήταν τόσο επίμονοι που ο Δίας κάποια στιγμή, άσε με ήσυχο, φύγε από εδώ, εντάξει, από αυτή τη στιγμή ο Τιθονός είναι αθάνατος. Και βέβαια έφυγε ευτυχισμένη η Υιό. Έκανε όμως ένα τεράστιο λάθος. Ότι δεν ζήτησε την ίδια στιγμή να τον κρατήσει νέο. Έτσι λοιπόν, ο Τιθονός μεν ζούσε, αλλά γινόταν γέρος και γέρος και γέρος, πιο γέρος από οποιονδήποτε ξέρετε γέρο, και ακόμα πιο γέρο στον κόσμο αυτό. Και βέβαια άρχισε μετά από λίγο να του πονάνε τα γόνατα, ό,τι κάνουν οι μάνες μας, οι παππούδες μας, τους θυμάστε, να μην μπορούν να σηκωθούν, να μην μπορούν να αυτοεξυπηρετηθούν και βεβαίως σε λίγο να μην μπορούν να μας γνωρίζουν καν. Έτσι λοιπόν ο Τιθονός στην ουσία έγινε ένας πολύ κακός γέρος, ο οποίος δεν ήταν καθόλου χρήσιμος για αυτά που γνωρίζετε ότι πρέπει να είναι χρήσιμος έχοντας μια γυναίκα δίπλα του. Έτσι λοιπόν υπήρχε ένα μίζερο τέλος όλη αυτή την ιστορία, καθώς η Υιός βέβαια τον απεχθανόταν πλέον και έτσι πάρα πολύ γρήγορα δεν μπορούσε καν να τον βλέπει και τι τον έκανε, πήγε και τον έβαλε στο υπόγειο, στο τρίτο υπόγειο του παλατιού της
Έξε τις πόρτες, τα παράθυρα για να μην τον ακούει καν. Όχι να τον βλέπει μόνο. Και έτσι ο Τithonus το μόνο που του έμεινε, όπως σε πάρα πολλούς γέρους που γνωρίζουμε που είναι ανοικοί, τους μένουν κάτι παράξενα συνήθειες, είτε να τραγουδούν, είτε να λένε μαντινάδες εδώ στην Κρήτη, δεν ξέρω τι. Έτσι λοιπόν, και ο Tithonus το μόνο που του έμεινε ήταν η φωνή του, με την οποία τραγουδούσε τον έρωτα και βεβαίως, θρηνώντας από τους πόνους και από όλα αυτά, παρακαλούσε τους θεούς επιτέλους να στείλουν τον θάνατό του. Έτσι λοιπόν ο Tithonus συνέχισε να τραγουδάει για χρόνια, έως ότου η Ιω, η οποία ήταν powerful, ήταν πολύ ισχυρή, τον μετέτρεψε σε τζίτζικα, πιστεύοντας ότι θα έρθει ο θάνατος με αυτόν τον τρόπο. Και όντως, ο τζίτζικα ζει σαν σκουλίκι 17 χρόνια στη γη, στο έδαφος, και μόνο ένα καλοκαίρι, βγαίνει στο δέντρο και τραγουδάει για την αγάπη, για τον έρωτα και πεθαίνει ενώ τραγουδάει. Έτσι τα τζιτζίκια θα πρέπει από εδώ και στο εξής, που θα θυμάστε για πάντα την ιστορία της Ιούς και του Τιθονού, θα σας θυμίζει για πάντα ότι η ζωή είναι εφήμερη, είναι γλυκιά και πρέπει να τη ζούμε όσο είμαστε υγιείς μέχρι την τελευταία στιγμή, γιατί ακριβώς είναι φευγαλαία. Η ιστορία ήταν τόσο σημαντική που έχει έτσι πάρα πολύ ενθαρρύνει καλλιτέχνες, όπως αυτός ο Βικτοριανός ποιητής, θεωρείται father of Victorian poetry. Αυτός λοιπόν ο Alfred Lord Tennyson έγραψε ένα εξαιρετικό ποίημα, σας προτείνω να το διαβάσετε, είναι πολύ μεγάλο, σας δείχνω μόνο την αρχή, που ακριβώς περιγράφει το μήνυμα που έχει αυτός ο μύθος. Τι θέλω όμως να σας πω πίσω από αυτό? Τι θέλω να σας πω? Γιατί διαλέξαμε αυτή την ιστορία? Τη διάλεξα για να σας πω ότι το βαθύτερο νόημα για μένα στην ιστορία αυτή είναι αυτό που λέμε η γύρανση του σώματός μας, το φθαρτό του σώματός μας. Και αφού μιλάμε γι' αυτό και είμαστε στο πνευμονολογικό συνέδριο, θα πρέπει να μιλήσουμε για αυτό που λέγεται η γύρανση του πνεύμονος. Βλέπετε λοιπόν πώς είναι οι κυψελίδες ενός ανθρώπου 42 ετών και πώς είναι οι κυψελίδες ενός ανθρώπου 85 ετών. Ακόμα περισσότερο αν θα δείτε έναν νεαρό 29 ετών πώς είναι οι πνευμονές του και έναν 100 χρονών μη καπνιστή, non-smoker, θα δείτε ότι μοιάζει καταπληκτικά με εμφύσιμα. Όμως αυτός δεν κάπνισε ποτέ, δεν είχε καμία έκθεση. Επομένως, αναπόφευκτα γεννάται το ερώτημα μήπως νοσήματα χρόνια όπως η COPD και IPF στην ουσία είναι νοσήματα που παθογενετικά τουλάχιστον συνδέονται με μηχανισμούς γύρανσης ή εν πάση περιπτώσει επιταχύνουν όλους τους μηχανισμούς γύρανσης. Και δεν είναι απόψε η αποστολή μου να σας αναλύσω επιστημονικά πάρα πολύ όλο αυτό το πράγμα, αλλά θα σας πω 2-3 πράγματα. Θυμηθείτε τα τελομερή και την βράχυνσή τους. Τι ρόλο παίζουν στη γύραση. Είπαμε μερικά πράγματα ήδη για την IPF. Τα epigenetics, που πόσο βλάπτουν όπως και στα δύο αυτά νοσήματα. Και βέβαια η δυσλειτουργία των επιθυλίων και των επιθυλιακών κυτάρων και των μυτοχονδρίων. Όλοι αυτοί οι μηχανισμοί που έχουν εκατοντάδες δημοσιεύσεις εμπλέκονται. Είναι και μηχανισμοί γύρανσης, αλλά είναι και μηχανισμοί αυτής της ίδιας της αρρώστιας, αυτών των χρόνιων νοσημάτων. Σε αυτό το μήνυμα πάει πολύ καλά μια θεωρία για την γύρανση, που είναι λεγόμενη ανταγωνιστική πλειοτροπία. Τι σημαίνει ανταγωνιστική πλειοτροπία? Σημαίνει ότι κάποιο γονίδιο, όχι την ιδιότητα, κάτω από κάποιες συνθήκες, στην αρχή της ζωής, να εκδηλώνει πολύ διαφορετική δράση από ότι μετά, στο επόμενο της ζωής. Ακριβώς λοιπόν τα δικά μας τα νοσήματα συνδέονται με αυτήν την θεωρία της ανταγωνιστικής πλειοτροπίας, που είναι πάρα πολύ σημαντική και είναι μία από τις κύριες θεωρίες της γύρανσης. Και έχω να σας πω μόνο μία ουσία που πιστεύω όλοι τη γνωρίζετε. το σύστημα του mTOR, που είναι μια κοινάση που εμπλέκεται σε δεκάδες πράγματα που έχουν να κάνει με τη γύρανση, αλλά και με την IPF και με τη COPD. Δεν θέλω να επεκταθώ σε όλα αυτά, αλλά να σας πω ότι ακριβώς αυτό το σύστημα λειτουργεί ωφέλιμα κατά την έναρξη της ζωής μας, όπως το βλέπετε, παράγοντας στην ουσία δίνοντας στα όργανά μας την καλύτερη δυνατή υγεία για να αναπαραχθούμε, για να ζήσουμε, για να εργαστούμε, και το ίδιο ακριβώς σύστημα στη μετέπειτά μας ζωή λειτουργεί τελείως βλαβερά. Ακριβώς τις ίδιες ενζυμικές διαδικασίες, ακριβώς την ίδια φλεγμονή θα παρατηρήσετε ότι γίνεται στα δικά μας χρόνια νοσήματα, και θα βρείτε πάρα πολλές δημοσιεύσεις αν θα βάλετε mTOR and IPF or mTOR and sarcoidosis, mTOR and COPD. Και βέβαια βρήκα μια μελέτη, Βενερίνο, η οποία πραγματικά δείχνει πάρα πολύ καλά, θα βρείτε αυτό στο European Journal με την IPF, αλλά ήθελα να σας δείξω αυτήν εδώ τη μελέτη, στην οποία έχει συμβάλει και κάποιος από εδώ μέσα. Βενερίνο, is yours. Years ago.
When I was young.
Yeah.
Younger.
Σε αυτήν λοιπόν την πολύ ωραία διαφάνεια φαίνονται ακριβώς όλα αυτά που σας είπα και πώς λειτουργούν και πώς στην ουσία διεκπεραιώνουν την νόσηση προς IPF και προς COPD, και πολλές φορές αυτά τα δύο πράγματα συνενώνονται και τότε μπορεί να έχουμε το CPFE. Έτσι λοιπόν, πραγματικά τελειώνοντας αυτή την ομιλία, θα ήθελα να σας πω ότι, και συνδέοντάς την με το μύθο της ιούς και του τυθωνού, ότι τελικά τα δικά μας χρόνια νοσήματα, και ίσως όλα τα χρόνια νοσήματα, δεν είναι τίποτα άλλο παρά μια επιταχυνόμενη ακριβώς γύρανση του σώματός μας, των ειδικών οργάνων και εμπροκειμένου του πνεύμονα. Και εδώ θα ήθελα να τελειώσω με το τελευταίο μου του slide, να σας πω ότι πριν από 100 χρόνια είχαμε 70 χρόνια επιβίωση. Χωρίζοντας αυτή την επιβίωση στο υγιές μέρος της ηλικίας μας και στο, ας το πούμε, νοσηρό μέρος της ηλικίας μας, έχουμε μια μαγική αναλογία. Magic ratio, που είναι το σύνολο, η διάρκεια της υγιούς ζωής μας προς το σύνολο της ζωής μας. Τι κάνουμε με τη σημερινή ιατρική? Κάνουμε το εξής. Αυξάνουμε την επιβίωση, δίνοντας φάρμακα όπως τα αντιεινωτικά, antifibrotics ή τα εισπνεώμενα, προσέχτε, αλλά μιμούμαστε το παράδειγμα του τυθωνού, χαλώντας αυτό τη μαγική αναλογία. Δηλαδή παράγουμε ανθρώπους που έχουν τη ζωή του τυθωνού για πολλά χρόνια. Ποιο πιστεύουμε ή ποιο πιστεύω, και το συνδέω με το παράδειγμα του τυθωνού και του μύθου αυτού, το όραμα που πρέπει να έχουμε όλοι μας, ότι θα πρέπει να λειτουργήσουμε κατά αυτόν τον τρόπο. Να παρατείνουμε τη ζωή μας χωρίς να χαλάσουμε αυτή τη μαγική αναλογία. Πώς θα το κάνουμε αυτό? Με την πρόληψη και με θεραπείες που θα κρατήσουν τον άνθρωπο υγιή, και φυσικά με θεραπείες που θα αυξήσουν την επιβίωσή του ενώ είναι ασθενής. Σε αυτή την περίπτωση θα αποφύγουμε το παράδειγμα του τυθωνού. Σας ευχαριστώ πολύ. Νομίζω... Thank you.
I was right then, Venerino, and that I wasn't. We didn't over-exacerbate, as our professor said previously. He was magic.
Okay. Ψέματα. Λοιπόν, εδώ τέλειωσε αυτή η εναρκτήρια ομιλία. Τώρα μπορούμε να μεταβαστούμε στα πούλμαν. Θα πάμε σε ένα πολύ ωραίο μέρος δίπλα στη θάλασσα, όπου θα ακούσουμε μουσική. Θα φάμε κρητικά φαγητά. We are going to eat pure Cretan food and live music. Thank you very much. Ευχαριστώ πολύ. Thank you. Thank you. I found your slide. Ευχαριστώ πολύ.
The European Respiratory Society is the largest scientific clinical organisation in respiratory medicine in Europe, with a growing membership from over 160 countries. Bringing together healthcare professionals and other experts working in respiratory medicine, united under a collective mission to promote lung health and alleviate suffering from respiratory disease. Advocating to reduce the burden of respiratory disease in Europe and producing science and unbiased education to share with healthcare professionals worldwide. We seek to tackle the current challenges in respiratory medicine across 8 respiratory disease groups. At the heart of everything we do are our members and our patients. Promoting funding and helping to drive scientific research through a variety of activities to advance respiratory medicine. Funding vital research projects, recognizing excellence, sharing and exploring new findings, and publishing one of the world's leading scientific journals in the field of respiratory disease. We create unbiased medical education and continuing professional development under the leadership of world-renowned experts in their field, harmonizing the standards and practice of respiratory medicines across Europe, helping thousands of healthcare professionals to improve their medical knowledge and skills, offering access to the highest quality online materials, and publishing learned educational journals and handbooks. We share knowledge, promote collaborations and best practice through ERS events and conferences. Increasingly investing in the latest technology to make cutting-edge education accessible and affordable to healthcare professionals worldwide. Across the 2 pillars of science and education, we are dedicated to encouraging researchers and healthcare professionals to improve their skills, increase their knowledge, advance their careers, and ultimately improve patient care. Our leaders and dedicated officers advocate for change in Europe on behalf of the society by raising awareness of lung health issues with politicians and the public. ERS and European Lung Foundation work closely with the EU and related institutions to ensure policies are based on science and patient needs. Through ELF, we work with patients, understanding their needs and hopes, involving them in research and guidelines, and supporting their active role in decisions concerning diagnosis